Okay, how's my audio? Can you hear me?
Yeah, now we can. Good.
I've got a microphone problem I got to fix someday.
So we can hear you now. We are ready to go.
All right, thank you for the encouragement, Senator. Good morning. This is State Representative Jonathan Steinberg. I am the House Chair of the Public Health Committee. We're here for a public hearing today, but before we get into that, I'd like to have remarks from my co-chair and our ranking members, and then briefly discuss sort of the rules for the road today. Senator Anwar.
Thank you so much, Representative Steinberg. Again, this is going to be an important conversation and hearing that we are having. I just ask people to be kind. I just ask people to use words that would
but
not.
I don't know how. Okay, so I don't see any.
Somebody
Kathleen,
needs to mute.
Good. Go ahead.
Thank you. Well,
but how?
Can we? Okay. Well, hopefully they're muted. So another message is stay muted and please be kind to people. Use words that would not hurt anybody's feeling. The people who are going to speak today feel passionately one way or the other, and it's important that we are careful in how we phrase the questions and how we phrase certain words, which can cause pain and more increased pain for people. So that's all I would ask, and we should all just listen more, hopefully, today. Thank you so much, Mr. Chair.
Thank you, Mr. Chair. Let's hear first from Representative Pettit. Good morning.
Good morning, Mr. Chairman. No major comments. I hope we can ask questions without launching into long soliloquies and get very terse yet pithy answers from the respondents, so as many people as possible are able to testify on this bill. Thank you, sir.
As they say, from your mouth to God's ears. Let's hope we have a very smooth ride today. Next up is Senator Wong.
Good morning, and thank you, Mr. Chair. This will be an emotional hearing, and we as a committee is going to ultimately cast a vote. And so I will offer that it shouldn't be a partisan one, nor should it be considered a right or wrong vote. For us today, it's really important to listen and support everyone who's testifying today.
Okay.
And those that are submitting testimonies. So I want to simply close by saying that I am very eager to hear all the viewpoints, and close by offering my thoughts and prayers for those who are experiencing painful health conditions and their family members who support and love them. We're thinking of you, and I'm eager to hear more about what this issue is about. Thank you, Mr. Chair.
Thank you, Senator, for those sentiments. Senator Summers, good morning.
Good morning. As you've heard people speak, I think this is going to be a highly emotionally charged hearing with very passionate testimony on both sides of this particular issue. I think the Public Health Committee, all of us on it, want what's best for the citizens of Connecticut. We don't want people to suffer. We may have different ideas on what's appropriate at the end of life, but I think it's important that we all hear all the viewpoints today. And I also think it's important that we as legislators don't feel the need to comment on people if we don't agree with them or we do agree with them. And hopefully we can spend most of our time listening today. So thank you everybody for being here.
Thank you, Senator. Let's talk for a minute about how we want to proceed. We have well over 100 people who have signed up to testify, and we'd like to hear from all of them. We have not imposed a time limit on today's hearing, but obviously the people who are towards the end of the list would really appreciate it if we could get to them before the wee hours, let's put it that way. So in discussions with the chairs and the rankings, we have chosen to encourage legislators to only ask one question of each person testifying. You may have an exception once in a blue moon, but that is our objective. We afford people testifying 3 minutes for their remarks. Any legislator can ask a question, and all we can say is we want to also limit the interaction so we can get to hear from everyone. So we're also suggesting that the interaction between legislators and people testifying should also be limited to an additional 3 minutes so that we can hear from others. If anybody objects to this way of moving forward, now's the time to express it. But we feel that it both honors our objective of hearing from everyone and also sponsoring a vigorous debate and conversation about the issues. Do I see anyone who strongly disagrees with that approach? If not, I will just remind those who are in line to testify, you know your number. You will be led into the waiting room as your time approaches. We ask that you be ready, but then when you come into the waiting room, that you stay muted until it's your time to speak. Most importantly, we ask respectfully that you adhere to the 3-minute limit that we're affording you to speak. If you run over by a sentence, that's okay. But if you continue to talk well beyond the 3 minutes, we'll be obliged to interrupt you, which is not good for either of us. So please respect the 3-minute limit. You may get further opportunity to amplify if you're asked a question by a legislator. But we're going to get through this most smoothly if everybody adheres to the rules. And I will thank you in advance for respecting that. If there's no other questions or business, we will start in. The first hour will be reserved for elected officials. The good news is we only, I think, have 7 on our list today, so maybe we'll get through that within the first hour. And then we will be hearing from members of the public, and we'll be here as long as we need to be. First up on our list is Senator Cassano, followed by Representative Cheeseman. Senator Cassano. We may be off to a flying start. Well, while we're waiting for Senator Cassano, good morning, Representative Cheeseman.
Good morning, Representative Steinberg. Good morning, everyone. I want to thank you for allowing me to testify before you today, Chair Steinberg and Anwar and ranking members Pettit and Summers and Senator Wong. I've been before you many times. Every time this bill has come up, you have my written testimony, and as ever, I won't recap that. There are many issues that I see raised with this, but what I want to talk about today is my incredible gratitude that this bill had not been passed during the pandemic. My concern is what happens to our vulnerable elderly. We saw them in nursing homes with no access to family members, with no access to the outside world. And I shudder to think how many of them might have opted for this way out. And I speak from the heart. I have a 95-year-old father. Thank God he was not in the nursing home when these restrictions were in place. We have so little care for the elderly in many ways. So few gerontologists, so few people to deal with the issues that arise when you are older. Every single day with my father is precious. And the idea that he might have been diagnosed with a treatable condition, but because of he's 94, he's had a good run. And if he chose through despair and depression to take his own life, because that's what it is, with no access to a family member, that would have been a tragedy. How many tragedies have been averted? How many family members can be with their loved ones because this was not an option? We need more palliative care. We need more mental health care. I know how passionate everyone feels on this side of the conversation, but surely our duty as human beings is to find a way to embrace everyone who is suffering and hold their hand on that journey and not make them feel the only way we can relieve their pain, their loss of autonomy, is by having them end their life. So that's my testimony today. As I say, you're going to hear from many people on both sides, but please, let's think of our most vulnerable, not just the disabled, not just those who are going to be here today, But people like my father, and I want him always to know that his option is not to end his life, but to be surrounded by family and good caregivers who will accompany him on that inevitable journey. So thank you so much today. And I know you will look at this so carefully. And that's it, guys.
Thank you, Representative. I think you make a very important point that we are on the brink of a silver tsunami. Connecticut is a grayer state than many, and we need to have adequate resources across the board. I do know we have some tremendously excellent palliative and hospice care in this state, and those options are definitely available for those. But I think we're going to probably need more, given how many baby boomers are going to have needs as we go forward. And that's a subject for further discussion. Next up is Representative Hughes, followed by Representative Barry.
It's State Representative Van Hughes. Thank you all for listening. I've attended more deaths than births. And like birth, death is a natural, universal, yet unique, sacred, and normal life process that we may or may not prepare for. But trauma, fear, and needless suffering do not have to be inevitable in the quality of death that those with progressive terminal disease face. It's time that we allow those who are preparing for their quality of death to have access to medical aid with their prescribing experienced physician, along with the privacy, protection, support, and sanctity to assure that quality of death that we offer those who are working on their quality of birth with their physician. They want to have agency, self-determination as to when and who they choose to prepare to die, that experience. And we have medical aid to assure the same quality of death with the protections that we can support medical aid of birth and quality of birth. So this legislation that I'm honored to co-sponsor does just that. I'm honored to yield my time to my constituent, James Naughton. And I don't know if he's here, but I'm yielding my time to him. Beverly, do you see him?
Mr. Naughton in the waiting room?
He's on now.
I do see him. He is in the waiting room. If he can just unmute and join us.
Hello, Representative Steinberg. I'm here.
Please continue. We got a little bit of time left.
Thank you. Yes. First of all, I want to thank all of the legislators on the Public Health Committee for having gotten this thing through last year. We failed 3 years ago when I first testified by one vote. Last year, I believe the vote was 24-9. It was a bipartisan vote. So thank you, all of you. Now we have to keep going, and I hope that you will get your colleagues to come along. There are two thoughts that I want to share with you. A friend of mine who is an ethicist sent me these quotes from two very thoughtful public servants, Governor Mario Cuomo in 1984 and Governor Jerry Brown from California in 2015. And I think it's these quotes are both very appropriate to what we're trying to get accomplished. Mario Cuomo said in 1984, he said, "In our pluralistic society, the arguments start when religious values are used to support positions which would impose on other people restrictions they find unacceptable. When should I argue to make my religious value your morality, my rule of conduct your limitation?" He delivered that in 1984 on the subject of things like abortion and end-of-life legislation to the University of Notre Dame. And in 2015, Jerry Brown said, "I do not know what I would do if I were dying in prolonged and excruciating pain. I am certain, however, that it would be a comfort to be able to consider the options afforded by this bill. And I would not deny that right to others. I think that pretty well says it. That's where we are right now. Because if people, for a religious reason or some other superstition or anything else, decide that they're not going to go along with this and not allow this to happen, they are restricting, to my way of thinking, the rights of people who are suffering. I know about that because I lost my wife after a 4-year battle with pancreatic cancer. And one morning she said to me, finally, after 4 years of heroically fighting it, she said, "Jimmy, I don't want to wake up anymore." And when she saw my reaction, she said, "Well, we've always known that this is a fatal disease." And that night when I climbed into bed with her, she woke up and she peered at me through the darkness and she said, "Oh, I thought I wasn't going to have to wake up anymore." And I got to tell you, at that moment, the feeling of helplessness that I felt, the feeling of failure, not being able to help her get what.
Excuse me, your 3 minutes is almost up. Please
Thank you.
summarize. Thank you.
Well, I'm through. I've said what I had to say, and I thank you very much for the opportunity to share it with you.
Thank you, Mr. Naughton. Just to be clear, elected officials as well are limited to 3 minutes, including if they delegate time to constituents. So let's stick with that. I believe Senator Haskell has a question for you.
Jim, thanks so much for your testimony, and Representative Hughes, thanks for ceding your time to our constituent. Just a quick question, Jim, because I know you've studied this in other states, and in quoting Jerry Brown, you used the word comfort. So I guess one question I have for you is, in other states that have a dignity in death option available to those with a terminal diagnosis, have we seen a lot of patients actually take up that option, or is it more a peace of mind sort of thing?
Well, are you asking if there are a lot of patients who have availed themselves of it? The answer is no, not very many. And of the people who have gone through the process and done all the legal work and gotten their paperwork in order and found the doctors and done everything, only maybe a third of those people actually avail themselves of it. But what we do know, Senator Haskell, and thanks for asking the question, is that it affords all of those people a tremendous lift psychologically. It lifts the fear. They can then go through the end of their lives without the fear that they are going to suffer intolerably. And that seems to me to be a huge benefit for them and for their families. Because as someone who's been through that, it's very difficult to watch your loved one when they get to that point without any other option but to suffer. Does that answer your question?
It does. Thank you, Jim. Thanks for your testimony and your advocacy and sharing your story with our committee.
Well, thanks for asking.
Are there any other questions for Representative Hughes or her constituent?
Could I just say thank you to Representative Hughes, who is my representative? Thank you very much, Ann.
I think you just did. That's great. If not, we'll move on to the next legislator, Representative Barry, followed by Representative Thomas.
Good morning, Representative Steinberg. My name is showing up as Herb Hoffman, who is my constituent. I'm not sure if he's on. So if we could just make sure he's on, that would be great. Kim Hoffman is my constituent, and I say is because even though she is no longer with us, her story, passion, and advocacy are here with us today. Kim fought tirelessly, passionately for this legislation. Because of her, I do not only support this legislation, but I will be one of its biggest proponents.
Call me 3 times.
To get it passed in her memory. Kim Hoffman was an angel on earth before she was an angel in heaven. And at this time, I would like to yield the remainder of my time to someone that knows that better than anyone, Herb Hoffman, Kim's father. If he is on.
Mr. Hoffman, are you on? I do not see him in the hearing room unless I've missed him.
I think we saw him earlier, so.
For some reason, my name is Herb Hoffman, but
Yeah, I'm looking for him, his name, his picture, anything, but I don't see it.
Rep. Steinberg, there is someone trying to connect to audio that I can see.
I see that too. It's been trying to connect for some time.
I think Representative Steinberg, there is a IT issue that we are having, because I also know that Steve Casano is trying to join in for the past long time. So there's a little bit of a lag that's going on. So we
All right,
just
so
have to-
perhaps we'll reserve a minute or two for Mr. Hoffman, should he be able to come in, because the technical issues are ours. Why don't we go to Representative Thomas? And I do see that Senator Casano has ultimately succeeded, so he'll come up after Representative Thomas.
Hi, good morning. Thank you very much. Like many of my colleagues, I am here representing a constituent, but that constituent happens to be my husband. He had to work today, so he requested that I read this in his stead. So I will proceed to do so. Dear chairs, ranking members, and members of the committee, I urge you to pass SB 88. My mother was relegated to a nursing home due to Parkinson's disease and eventually severe dementia. It was an abysmal existence with no path or option to improve her predicament. I can assure you, based on conversations with her in the past, she would have chosen to end her life on her own accord rather than suffer because it is the natural way. It was a drawn out and gut-wrenching process for my mom and our family. I tried to take a lessons learned approach to the situation after she passed away from contracting COVID-19 at the nursing home. The first is to do as much as I can to promote mental and physical health to hopefully reduce the likelihood of having similar mental and physical challenges as my mother. Secondly, to advocate for the individual freedom of ending your own life legally. Clearly, one can find the means to kill oneself in a manner that isn't dignified. It is an obligation of the society we currently live in to provide a legally dignified option for ending a life. There are other states that have successfully adopted similar laws, but I would implore those questioning such laws to look at the die with dignity options in Switzerland for how such a law can be successfully implemented. Thank you for listening. Gregory Parker. So thank you. Obviously, my husband's sentiments are echoed by me and our entire family after watching my mother-in-law go through what she went through. And I have co-sponsored this bill in the past. I am a co-sponsor again this year, and I really urge adoption by this committee. Thank you very much. Happy to answer questions.
Thank you, Representative Thomas, particularly for sharing your story. We know it takes a measure of courage sometimes to talk about family members in such difficult circumstances. It affects us all. Are there any questions for Representative Thomas? Seeing none, thank you for your testimony today. We appreciate it.
Thank you all for your service.
Thank you. Senator Casano, followed by Representative Anderson. Good morning.
Hope you can.
Thank you for persevering, Senator.
Yes, it's a different setup than my other committees. So, thank you for hearing this. I know you have a long day before you. I'm Steve Casano, State Senator from the 4th District. I'm the oldest of 9 children. I've lost my parents. I've lost 6 brothers. I've seen death in many different ways, from car accidents and violence to natural causes to illnesses and so on. Never have I been impacted by death as much as I was by meeting Kim Hoffman from Glastonbury. I met Kim on September 21st. My aide on September 20th told me that a woman wanted to talk to me about the death and dying bill. And so I called her and I said, well, I got to go to Glastonbury tomorrow, which was the 21st. And I went to Glastonbury. Well, every 2 weeks, Kim Hoffman and I sat on a bench next to the Riverfront Center in Glastonbury. Looked at the river and the woods and so on, how beautiful it was. And I watched it deteriorate over the months until she died. She had incredible spirit. She was a fighter. She wouldn't quit, and she didn't. But she lived in pain. It was incredible pain. The cancer that she had was destructive. I could just see her melt away. I look forward to seeing her, to be a part of her life and to make the end of her life a little better, because we just connected. At the same time, I felt anxiety and pain going there because I knew that she wasn't going to look as good as she did 2 weeks ago. If she had an option, she would not have gone through that kind of pain. It's an awkward position for us. We have the authority to provide the opportunity for people who want to use that opportunity to be assisted in dying. We're not making the decision for them individually. We're giving them the right to do that. And I would urge you to take care of those people in that situation, to allow them to have regulations so it's not abused, which is a challenge, I understand. You have before you with this bill something more difficult than anything I'm ever to have, public safety or transportation, whatever it might be. And so I don't envy your position, but I do ask, let people make those decisions themselves with a set of rules and regulations, and it would be a better world. Thank you.
Thank you, Senator. Appreciate your personal perspective. Very eloquently put. Next up is Representative Anderson, followed by Senator Winfield. Good morning, Representative Anderson.
Morning. Thank you, Mr. Chairman and members of the Public Health Committee. Please kill this bill, Senate Bill 88. The Hippocratic oath that is taken by physicians dates back 2,400 years. It prohibited physician-assisted suicide so that a doctor would focus on preserving the health and life of the patient. The U.S. removed this phrase in 1964, suggesting a change in mindset. SB 88 seems to be missing a provision that was in last year's bill, one that I believe is the law in the few states and DC that permit this practice. That provision is that the cause of death be listed as the underlying disease, not suicide. Should this become the practice, that would be a lie codified into law. In Connecticut, is it to be left to the medical examiner to decipher without guidance of law, or that be added to this bill? It seems that cause of death instructions need to be provided for. This bill will incentivize suicide as a course of treatment, as a means to reduce health insurance costs. This bill will harm life insurance carriers who cannot charge more or deny coverage to an individual who has signed a request for aid in dying. These are objective reasons to oppose this bill. Please permit me to give some emotional arguments. All of us have likely had someone close to us who would qualify for aid in dying under this bill. In 2012, I lost my first wife of over 24 years to stomach cancer. When first detected, it was stage 4 and she was given 3 months. But thanks to a great physician at Dana-Farber and aggressive treatment, she lived 3 years. During those 3 years, there were many precious family times with our 2 sons, as well as marital reconciliation. This was priceless. A doctor does not know when someone has less than 6 months to live. It is a guess. 1 week ago, I lost my mother at the age of 87. She suffered from advanced dementia and heart disease, but my father insisted on caring for her at home. She was declining and would likely have qualified for hospice. Last Wednesday, she and my father had lunch at the home of a friend. When my father left the table to retrieve something in the car, my mother said to that friend, "You know, I love that man." She did not say, and perhaps did not even remember her husband's name. That night, as he was helping her dress for bed, she passed away in his arms. I suggest to you that that was death with dignity. To summarize, here are reasons to oppose physician-assisted suicide. It undermines the physician-patient relationship. It undermines the law pertaining to cause of death. It undermines health insurance. It undermines life insurance. It undermines family relationships. Physician-assisted suicide is a leap into a very dark abyss. Please do not jump into that abyss. Thank you for listening.
Thank you, Representative, for your perspective. I should just point out that unfortunately, anybody suffering from dementia would not be eligible for availing themselves of this option because you have to have personal agency in making your own decision. So many people are simply not eligible for this option under this bill. Next up is Senator Winfield, followed by Representative Michelle. Good morning, Senator.
Good morning. So back in 2014, I became involved in this issue. I really wasn't seeking to be, but a question by a reporter during the special election dragged me into it. And I know throughout the day, we're gonna have people who are in opposition to this bill. I am for the bill. And I think some of the things that we're talking about aren't about the experience of the end of life. I think that's important to remember. 10 years ago, this coming July, my mother passed. My mother was, in a way, dying my whole life. If I told you the number of heart attacks she had, you probably wouldn't believe me. So I've had a lot of experience from the time I was a child with, the possibility of losing my mother. She struggled to stay alive all of that time. And it's important to me that she did, because all of that struggle, all of the work that the medical professionals put in, I have the 38 years I had with her. But at the end of her life, this woman, who's probably the strongest person I know, begged to die. But she couldn't. And so she died on an operating table. And when I got to the hospital on that beautiful Tuesday in July, I got to sit in the room with her and her husband, who would not leave that room. And the most indelible image I have of her is of her dead on that table with the tube sticking out of her mouth. I spent 38 years with her, and the thing I can remember the most is that my mother fought to stay alive. We joked she would have a heart attack, and we say, okay, so what are we going to do? We didn't think about her dying. We knew she was going to be okay because she struggled and somehow persevered. She wasn't somebody who would just give up her life. This is not just throwing people to the wayside. This is about that woman. We say, let's hear what people have to say, but then we don't listen to them. We don't listen to the experiences we have. We don't listen to the pain they have and the pain their families have. This bill is going to get in the way of familial relationships? No, it's not. No, it's not.
Senator, I'm sorry, your time is almost up. If you would summarize, thank you.
Wrap up. I just asked this committee, I know we come from different positions. I get it. I asked this committee, as you sit here today, to think about not only the technicalities of law, but the actual experience that people have watching a loved one die and not being able to do anything about it. Thank you.
Thank you, Senator, for your clearly very heartfelt remarks and from your personal experience. Thank you for sharing.
Thank you.
Next up is Representative Michelle, and then I believe we will turn to the public. Good morning, Representative Michelle.
Good morning, Mr. Chair. Esteemed chairs, vice chairs, and ranking members and members of the committee, I'm here today in front of you in support of Senate Bill 88, which has been, I believe, carefully worked on from a careful and strict and compassionate angle. I'm going to concede my time to Professor Chris Riddle, but before I do so, I just wanted to say that currently my father-in-law, who is 92, is a prisoner of his own body, and that he cannot command or control, and he's begging for peace and dignity, and expresses it every day. And I'm so sorry because I don't know what to say, because it's certainly nothing that I can do. So I ask the members of the committee to vote in favor of this bill and concede my time. Thank you, Mr. Chair.
Thank you. You have only a limited amount of time left, but please proceed, Professor.
Thank you. I'll keep it brief. As mentioned, I'm Chris Riddle. I'm a professor of ethics and director of the Applied Ethics Institute at Utica University. I've written extensively on disability rights, vulnerability, medical aid, and dying. I'm here today to speak in favor of this practice and to do so by addressing two potential criticisms that are going to emerge from some disability rights organizations that you'll hear from today. First, there's the claim that medical aid in dying does actual harm to people with disabilities. And the thought is if we permit aid in dying, people with disabilities are going to be killed or they're going to be pressured to kill themselves. To be clear, there's no evidence to suggest that this is the case. The Journal of Medical Ethics, which I take to be the leading journal in this field, states that in no uncertain terms, there's no heightened risk to vulnerable groups, and there is in fact no evidence of any disproportionate impact on patients in vulnerable groups whatsoever. But beyond that, I think that there's another claim that suggests that beyond the physical harm to people with disabilities, there's a possibility of us stigmatizing and perpetuating injustice by suggesting that some lives are not worth living. And I don't think that this is an accurate characterization. I also don't think there's evidence for this. It's difficult to measure social attitudes and how people with disabilities are perceived, but I suggest one way is to look at the level of services provided to people with disabilities and other vulnerable populations. And if we look at what states are doing well in providing health services and supportive services to people with disabilities and which ones are doing poorly, I think that we can see that this point is demonstrated. State level health expenditures associated with disability are on average higher in states that permit aid in dying than those who have not. So to be clear, what I'm claiming here is that if people with disabilities were devalued, disrespected, or thought not to live lives worth living as a result of these bills, surely funding of support services in states where aid in dying was legal would be less and not greater than those in states where medical aid in dying is legal. Finally, I also suggest that if we actually respect people with disabilities and we want to promote rights for the vulnerable and we want to promote dignity for all, suggesting that some people need to be protected from
I'm
themselves.
sorry, your time is almost up. If you could please summarize.
Thank you.
Thank you.
I don't think we need to suggest that people need to be protected from themselves. I think that is demeaning. I think we need to grant people the opportunity to make autonomous decisions that they're capable of making. Thank you. I'm happy to answer any questions that anyone might have.
Apparently we do, Professor. I'm not sure it's for you or for the representative, but Senator Anwar has a question.
Sure, thank you.
Thank you so much, Professor Riddle. Just because these laws have passed in some states, when I heard some of the advocates for disability rights, they had serious concerns. Do we have enough data right now to be able to see what has happened in the United States and other parts of the world?
I think we do. We've got a long history in some states, jurisdictions of this being permitted. We've certainly got a long history of it being permitted in other jurisdictions outside of the US. None of the data suggests, as I've pointed to, any increased vulnerability associated with people with disabilities, any adverse effects associated with it. It does not suggest disproportionate numbers of deaths. There appears to be no evidence to suggest any harm of the kind that individuals suggest might happen. Does that answer your question, though, or would you like to suitably follow up? Please. Yeah.
It does. There are a lot of anxieties for vulnerable communities, and that's part of the challenges that anybody who's vulnerable, who's not treated fairly in our society, they feel this is a way that they will be treated differently again. And that's the anxieties that I sense at times from people.
Sure. I mean, I do think it's worth noting that recent data does suggest that people with disabilities support this. There will be disability rights organizations that suggest that we ought to oppose it. But nonetheless, people with disabilities, and I encourage everyone in this call to actually listen to the experiences that people have so eloquently presented thus far, and will probably well into the day. There's no data to suggest that people with disabilities do not support this. And yes, there is a concern about vulnerable populations being subjected to harm. And I understand that. I think there's a long history of our health services failing a lot of people. And that's undeniable. But I think this bill and one similar to it have been modeled after others that have been designed to minimize or reduce these risks. And by all measures, they appear to be successful. Thank you.
Thank you, Senator. Representative Berger Chervala.
Thank you so much. Professor, you answered the initial question that I was going to ask about the disability community. Can you elaborate a little bit on disability rights organizations who do support aid in dying? If they exist, why do they support it?
Right. They do exist. There are some organizations locally, for example, I sit on the ethics board at the Resource Center for Independent Living. And perhaps unsurprisingly, organizations like this promote independence of thought and independence of action. So a lot of the organizations and people that support this bill are supporting it because they want people to be free to make choices pertaining to their own care. They're concerned about a overly paternalistic emphasis on protecting people from themselves. The Arc of New York, for example, as well, has come out suggesting that this ought to be a right that is guaranteed to anyone who's capable of making these decisions, precisely because of how important decisions pertaining to our own body and our own care are. Disabled or not, it sort of seems irrelevant provided an individual can pass the threshold of what's needed to be able to consent to care.
Thank you.
Thank you very much.
Before we let you go, Professor, just for a little clarification for my benefit. You spoke of the prospective fallacy in presuming that those with disabilities can't make decisions on their own, that they are inherently subject to coercion, not only from family members, doctors, insurance companies. It sounds very daunting to not only live a life with disability, but to be under supposedly constant pressure to seek to be a burden to others. Can you just amplify a little bit on why your understanding is that's not the case?
Sure. Thank you. So to be clear, I don't wish to suggest that it's not the case that the elderly as well, people with disabilities, many people, frankly, in society are devalued and perhaps, to put it strongly, constantly beaten down with ableist, racist, sexist, ageist dispositions or attitudes. I think that it would be foolish to deny that we're doing a good job promoting an inclusive environment. However, I think it would be equally as foolish to suggest that people are incapable of making decisions pertaining to their own care as a result of external influences being imposed upon them. I think we all have external influences pushing us in particular directions. And if one is capable of consenting to care, we must presume, just like we do with reference to any other forms of care that we currently permit, within the realm of medicine anyway, that these individuals are weighing the various things that go into making decisions and are ultimately doing what's in their best interest. To suggest otherwise, I think, is insulting, really, and this is not what you're saying, of course, but I think it's insulting to people to suggest that we need to protect them from themselves.
Thank you, Professor. Seeing no further questions, we want to thank you for your testimony today. We're approaching the end of our first hour. I understand Mr. Hoffman has finally succeeded in overcoming our IT obstacles. I understand we have roughly 2 minutes of the testimony left. Mr. Hoffman, if you'd like to speak roughly for 2 minutes.
Please unmute yourself, Mr. Hoffman.
Mr. Hoffman, we still can't hear you, please. Okay. We may still have technical difficulties. We can't hear you, Mr. Hoffman. I'm sorry. You know, we after a year or two of the pandemic, you think we would have all the technical parts figured out with Zoom calls. Apparently, we have not. We'll give Mr. Hoffman a few minutes to try to figure out what's going on with his audio, but we'll take Tracy Wodach next, followed by Kathy Ludlam. Good to see you, Tracy. Good morning.
Thank you, Representative Steinberg, Senator Anwar, and distinguished members of the Public Health Committee. My name is Tracy Wodach, President and CEO of the Connecticut Association for Healthcare at Home. I am also an RN with nearly 40 years experience in home health, hospice, long-term, and acute care. The Connecticut Association for Healthcare at Home is the united voice for the hospice providers in Connecticut. Our membership includes highly qualified, dedicated hospice provider experts who care for those facing terminal illness. I have been before you each year that the bill has been raised. Our members have a mix of positions on this issue. Some oppose, some neutral, some support. Regardless of stance, one message remains unanimous in that our association and its hospice providers are committed to the hospice philosophy, cherishing life until its natural end while reinforcing dignity, quality, and comfort for both the patient and their loved ones. After reading SB 88, I am pleased to see that most of our language suggestions from years past have finally been incorporated. Attending physician has been clarified. The bill now defines hospice and clarifies the differences between palliative care and hospice, as well as serious illness from terminal illness. 2 written requests have replaced 2 oral and 1 written. Removal of recommendation for cause of death to be listed as the underlying condition. More defined safeguards regarding unused medication destruction, and creation of a physician checklist form, data reporting requirements, and an annual report by the Connecticut Department of Public Health. What I don't see is the establishment of a statewide policy education task force to help guide policy development and educational support, which we still strongly support and ask to be included. On to the bill itself and whether it should be passed this year. It's true that the additional changes have made this bill a more solid piece of legislation. However, I ask the legislature to strongly consider the timing of this legislation, given the impact of the COVID pandemic over these past 2 years. Mental illness is at an all-time high. Both the federal and state governments are looking to provide extensive additional mental health supports to help people cope with severe illness, repercussions of COVID, and extensive grief and loss that has never been addressed. It would be a hard sell to pass SB 88, where a terminally ill patient must be competent and not suffering from depression or any other psychiatric or psychological disorder. Thank you for considering our association's testimony, and I'm happy to answer questions.
Thank you, Tracy, for your testimony and for being so specific. We'll certainly consider the concept of a council. I think it's a good one. But I also want to thank you and all those you represent for your amazing work during the pandemic. Sometimes I feel like you were almost the afterthought in terms of resources, but the people persevered, and we owe you a great debt of gratitude for being on the front lines of the crisis we've experienced. I see a question from Representative Berger Travalo.
Thank you very much, Rep. Steinberg. Thank you, Ms. Wodach. First of all, may I just say that as a hospice care worker and advocate, I honor you, because it's work that most of us are not equipped to do. So thank you for that. I do have a question regarding the difference between last year's testimony and this year's. Last year testimony, you testified that none of your members were supportive, where this year it seems that you stated clearly there are a mix of positions on this issue, some opposed, some neutral, some support. So could you talk a little bit about the space that has been created for an entirely different view, where aid in dying could maybe ease the fears of those suffering from a terminal illness? Can you speak to the difference between last year and this year?
Sure. Actually, I think to clarify, that testimony might not have been last year's, because for the last several years, the survey that I do with our members has shown probably about half in opposition and half neutral, with maybe a support here or there. And this year it's a little more mixed, a few more in support, but it's pretty much spread across. So I can tell you what is happening is, I think society in general, we are still seeing that hospice is the support that our hospice providers prefer as the method of care at end of life. However, they also recognize choice. And I think that that's probably the reason for the change. We do have a couple of national providers on our under our membership who have experienced the law in other states and have created extensive policies and support groups for their hospice staff. So I think that may be some of the support that you're seeing. But we still have the preference for hospice.
Thank you for that clarification, and preference and choice are definitely more part of your conversation right now, and I do appreciate that. Thank you.
Mm-hmm.
Thank you. It's certainly not our intent to in any way suggest that we don't have great hospice and palliative care services in the state, and they deserve further support. Representative Cavaros-DeGraw.
Thank you so much, and I echo my colleagues and their thanks for the work that you do. I've had family members utilize hospice, and when they say people are doing intense work of care and compassion, that's what we've seen. Is there anything preventing someone who wanted to be able to access medical aid in dying from also getting hospice care at the same time? Because I thought that I had heard in other states that hospice care actually goes up when they pass medical aid in dying.
No, there's nothing in this bill that prevents that. In fact, when you look at other states that have the law in place, I always refer to Oregon because that's the state that has had it in place the longest and has the most data collected. Their surveys their statistics year on year show that a large percentage of hospice, a large percentage of those seeking aid in dying are also on hospice.
Okay, thank you very much.
Thank you. Seeing no further questions, thank you, Tracy, for your testimony and your work. All right, we're going to have Kathy Ludlam. We're going to then try one more time after that with Mr. Hoffman, and then we will have Judy Principi. Kathy, good morning. Good to see you. Welcome.
Good morning, chairs and members of the Public Health Committee. Thank you for this opportunity to talk with you. My name is Kathy Ludlam, and I am one of the many leaders of Second Thoughts Connecticut, a disability rights organization opposed to assisted suicide. And I am here to state my opposition to SB 88. And I have submitted written testimony that I encourage you to read because it's a bit longer than what I can do right now. But the question at hand is not whether people can take their own lives. Suicide is not illegal. The question is how many other struggling people will follow their lead, pressured by society and assisted by the healthcare system to die. Every year when this bill comes up, I am here to testify against it. I have stood before you as a competent, creative, and successful professional who has had a good life while experiencing a high level of disability. Not this year. The shortage of direct care workers has reached a point where lives hang in the balance, including mine. These workers are significantly undercompensated. They are leaving the field by the hundreds because they cannot make ends meet and they do not feel respected or appreciated. And the immense value of the support they provide has been largely unrecognized. Every year before they shred all the records, Oregon documents why people are asking for the lethal prescriptions. And these are disability issues and issues faced by elders as well. People are worried about being less able to engage in activities, making life enjoyable. With the dedicated support of my assistants, I have lived on my own.
I'm sorry, Kathy, your time is almost up. If you could please summarize, thank you.
Okay, thank you. My point is, if you read through, less able to engage in activities making life enjoyable, losing autonomy, loss of dignity, burden on family, friends, and caregivers. These are all about my life right now. I qualify as terminal under the bill. Someone with anorexia would qualify as terminal under the bill. I ask you to read my entire testimony, and I ask you not to pass this legislation because a lot of people in despair are going to feel that this is a go-ahead to harm themselves, either through the bill, through the legislation program, or not.
Thank you, Kathy.
For your time, and I appreciate any questions.
We have a question moment. I just want to thank you for your testimony and for making the really important point that no matter how much thanks we offer our frontline healthcare workers, we have not said enough. And we have to recognize the problem of exhaustion, fatigue, burnout, but also lack of full appreciation. And I hope that some of the legislation we will pass this year will begin to address some of those issues. So thank you for saying so. Representative Pettit.
Thank you, Mr. Chairman. Thank you, Ms. Logan, for your testimony. If you could just reiterate again, for you as a person with disabilities and folks that you talk with, is the concern that you feel that people with disabilities will be encouraged to pursue this end, or are you concerned more about the precedent that it sets? Could you just clarify that for me? Thank you.
Sure, thank you for the question. No one makes a choice in a vacuum. All of us respond to the messages we get around us, either direct messages or implied messages. And in any of us, there's also the wish to not inconvenience other people. So there's also internal pressure as well. And what I'm suggesting in my testimony today is the tighter things get in terms of supports, the more pressure there is on those of us who might perceive ourselves as inconvenient to the people around us and to the society. And it seems to me that during a mental health crisis like we've never seen before, this is the wrong time to be proposing suicide as the answer to intractable. And I acknowledge there are intractable problems, but we need to work on the problems, not on things that promote despair. And that's, I think, why I'm here and why a lot of my colleagues also will be testifying against this bill. Thank you. Thank you.
Thank you. Seeing no further questions, Kathy, again, thank you for your testimony today.
Thank
We
you.
appreciate it. Next up, we're going to give it one last college try with Mr. Hoffman, followed by Judy Principi. Let's make it work. Come on.
Okay, can you hear me, Mr. Chairman?
Yes, thank you. Please proceed.
Okay, great. I appreciate your delaying for my correcting the technical problems. Mr. Chairman, Mr. Vice Chairman, members of the distinguished committee, my name is Herbert J. Hoffman, formerly of 222 William Street, East Glastonbury. I am a veteran, a retired clinical psychologist, and father of Kim Ella Hoffman. I believe most of you know Kim through her testimony before this committee, her personal contacts, her letters and articles in the print media, and her videos. After advocating for medical aid in dying throughout last year and doing her best to get to this hearing, she unfortunately died on January 18. Kim was a fierce communicator on this topic, and my testimony is not designed to relitigate her arguments. I am here to talk about what medical aid in dying means to me. I have an aggressive form of gastric carcinoma. I am terminal. I was diagnosed last August at the same time Kim was in her final months. Both my wife, mother of Kim, and Kim died extremely excruciatingly painful deaths. I have moved to California to be with my son, and where serendipitously, medical aid in dying is legal. I have just completed the process to get a prescription. My primary desire to access medical aid in dying is not depression. I am not suicidal. I have seen the devastating progression of cancer up close, and I'm very aware of what is ahead of me. For those who fear that the legislation will lead to abuses, the disability community and the faith community, I point out that that fear is unfounded. As Dr. Riddle indicated, in the 17 years since first enacted, the legislation has resulted in fewer than 5,000 individuals having filled the prescription, and only 30% have used it. Dr. Howard Thurman, noted theologian and civil rights leader, said, "Death is not the worst thing to happen to us."
Sorry, Mr. Hoffman, your time is almost up. If you could summarize.
I'll get there.
Thank you.
Thank you. Unmitigated pain and suffering is worse. That's death is not the worst thing to happen to us. Unmitigated pain and suffering is worse. Freedom. I want my freedom to end my life when and how I choose. Do not let your values take away my choice. I will not impinge on your values or your freedom. Do not impinge on my freedom. Kim said it, "I'd love for my end to be powerful and pain-free." As would I. Pass 88.
Thank you for your testimony here today, and thank you for your perseverance overcoming our technical issues. But most importantly, may I offer our condolences on your loss. I think we all got to know Kim via her testimony over the last couple of years. She was a very courageous, strong individual, and I think we all benefited from getting to know her a little bit. I have one quick question for you. You've mentioned that you have applied for the ability to avail yourself of the California law. Have you made up your mind yet whether or not you would avail yourself of it? And if not, what would be the considerations for that decision?
Okay. I will pay my $700 for the medication today. So in that sense, I've made up my mind. I have not set a specific date, though I have one in mind. And I don't know at that time whether I will follow through. I am holding that decision, not committing myself to it absolutely. And the reason for that is, one, it's going to be very important for me not to have brain fog, to be rational at the time I choose to die. And I'll have very few friends around me, family members, a couple family members mostly. And if I'm not able to, and I could miss that point, as I think many people do. So I will then not have just brain fog, I will have brain death. I will be comatose. I will not be able to interact. I prefer that not be my way out.
Thank you, Mr. Hoffman. Again, for your testimony today. We appreciate it. Next up is Judy Principi, followed by Elaine Kolb.
Good morning, Representative Steinberg, and good morning, members of the Public Health Committee. My name is Judy Principi. I'm from Burlington, Connecticut. I'm a lifelong Connecticut resident, born and raised here, and I'm here today to support SB 88. This is not my first time testifying before you. My first time was in 2015, a couple of years after my brother had passed from ALS. If any of you don't know what that is, or you've never experienced somebody passing from that, I encourage you to do some research and find out about it, because it is an awful way to go. I want to extend my condolences to Mr. Hoffman for the loss of Kim, and I want to appreciate everything that she has done while she was here to support an aid in dying. And I also want to reach out and thank Mr. Mazzone, Mike Mazzone, for everything he did while he was here on this earth. I met him during my testimony in 2015, and he was a wonderful man, and I just wanted to express those feelings today. But for me, myself, having been a lifelong Connecticut resident, I would hate to think that I would have to lose my home and my family here to go to another state that allows aid in dying, because that is not something I want to do. I want to be here, and I want to be able to have that option to go and leave this earth on my own terms. There really is no reason for pain and suffering at this point. You know, people should have that choice to end their life the way they want to. When they're terminally ill, you set the rules. I have faith in those rules. I don't think it's going to be abused the way other groups would like to have you think it will be. But that is what I want for me. My family knows that now. My husband knows full well what my wishes would be. And I just hope that you will take this into consideration, support this bill, and let's get it passed. Thank you so much.
Thank you for once again testifying before us. We appreciate it. I'll use this opportunity, Judy, to leverage one of your comments and encourage everyone to have conversations with family members, have an end-of-life plan with directives and the like, so that in the event that you're not able to exercise your own agency, your family members are very much aware of your wishes when you approach difficult end-of-life circumstances. So thank you for that. Next up is Elaine Kolb, followed by Maxfield Fay. Good morning, Elaine.
I'm waiting to get on.
You're on, Elaine. Please
Oh, okay. I
proceed.
can't see my picture. I didn't know. How could
I can't
know?
see it either, but if you wouldn't mind, please provide us
But
your testimony.
I don't get to have my picture on?
We'd love to have your picture on. We may be having technical difficulties. It seems to be the case this morning.
Well, then you've given other people consideration.
Yes, if you'd like to
And
come
I
back
would like
into
to be
the,
able to have my picture
I
as
think you're absolutely
testify
right.
like others have.
Sure. If you'd like, we could try to get you back into the waiting room again. So maybe
Please
next
do
time.
that. I want my picture. I want my time, and I want to be seen.
We understand. We apologize for the technical glitches that seem to be plaguing us this morning. I think the best thing for you to do is to log out of the room and then come back in again with the link that you've been provided. And we'll try to see if the
understand that
video
you
will
haven't
work.
asked anyone else to testify without being seen, so I will come back.
Okay, our apologies. This is, we seem to have more than our share of glitches this morning. All right, let's hear from Maxwell Fay, and assuming Ms. Kolb will be back with us shortly, Mr. Fay.
Hi, good morning, Public Health Committee. My name is Maxfield Fay, and I'm here to support Senate Bill 88, an act concerning aid in dying for terminally ill patients. I grew up in Farmington and moved to New York a couple years ago to pursue a career as a lawyer after studying at UConn Law. And I always say that I love everything about Connecticut, except we haven't passed this bill. So anyways, I support Senate Bill 88 because I've personally seen how ugly the end of a terminal illness can be, and the necessity of having an option for a controlled out once someone receives a terminal diagnosis for their sake and their families. I've been to a few of these before, so I'm well aware of the time constraint, and I'll get right into a personal anecdote that may shed light on this necessity. But before I start, I think it's important for all of you to note that these harrowing stories you will hear today could have been prevented with the passage of Senate Bill 88. And by voting to pass it during the session, you're doing your part in protecting Connecticut residents for years to come. 10 years ago, I lost my father to a long battle of prostate cancer. He was the epitome of dignified until the very end of his battle, when the cancer reared its ugly head and threw him into a painful fit of discomfort and agony. His last day on earth was painful to witness. As a 19-year-old, I sat at his bedside next to my mother, both squeezing his hand, and witnessed the last thing that he ever wanted us to witness. My last memories of my father consisted of him yelling in agony, unable to get comfortable and bleeding out, completely immune to any amount of medication that wouldn't render him unconscious. Keep in mind, this guy was a fighter. He fought prostate cancer for almost 2 decades, and a lot of people discovered that only by reading his obituary, and some of you even knew him personally. Because we didn't have a bill of this nature in place in 2012, Connecticut forced a 19-year-old boy to watch his father die an agonizing death against his will. And this was preventable. And it still is preventable for those of us who have loved ones in their lives. Connecticut Public Health Committee, you are the solution, because without your approval, our residents are unable to utilize this medication. And until you do something, these harrowing stories are going to continue to proliferate. By voting to pass this bill, you're allowing our terminally ill population to die with dignity if they so choose, and allowing their loved ones to witness their send-off on their desired terms. And I truly believe that death doesn't have to be ugly. That's why this bill is selfless. It seeks to bolster the autonomy of our Connecticut residents by allowing them the choice of ending their life.
Excuse me, Mr. Fay, your time is almost up. If you would summarize, thank you.
Absolutely, you got it. And it's selfless because it doesn't force anyone to do anything they don't want to do. There aren't any cases of misuse or abuse in the states that have taken the lead in passing a similar bill, and we have the opportunity to use these other bills as reassurance that this is what's right and what works. So thank you so much for your time, and I wish you the best of luck in your deliberations.
Thank you for your testimony. I believe Representative D'Amico has a question for you.
Yes, thank you, Mr. Chair. Thank you, Max, for coming to testify yet again. And I appreciate your frustration that that this is the, I don't know, third time, fourth time, sixth time that you've had to come and testify, and I appreciate your thoughtfulness. So I'm one of those people who had the good fortune of knowing your dad, and I think about him often, and the terrible way in which he left this world, and it wasn't fair to him or you or your mom. Or anyone. So my question for you, Max, is there anything in this bill, anything missing from this bill that you would like to see in there, or is there anything that you would like to see removed? I know as an attorney, you're a very thoughtful man and a very careful man. So curious to know your perspective.
Yeah, thank you so much, Representative D'Amico, and great to see your face. Hopefully I'll get to see you in person soon. I think this bill it's in its best form. You know, it's been molded over the course of the last, decade or so. As you said, this is not my first time here. You know, I've been doing this since I graduated college back in 2014. And I think that's given us time to mold this bill in a way that works for everyone. And I think the key provisions are all there. There's nothing I would change about it. I think like I had mentioned, we've had the great fortune to use other bills such as Oregon, Washington, in order to craft a bill that's safe, that works, that cuts down on any sort of cases of misuse, abuse, or coercion. And so we're not trailblazers. We're not by any means inventing the wheel here. We're just taking time to review these other bills that have been super successful, and we've crafted an amazing piece of legislation. And I think all the key provisions are there. That answers your question.
No, it does. Thank you, Max. I really appreciate you're doing this yet again. Thank you, Mr. Chair, for your indulgence.
Thank you, Representative. I have a quick question for you. You made mention of the fact that at a certain point, your father could not obtain relief despite the medications that were available. We have, I think, justifiably great pride in our palliative care capabilities in the state of Connecticut. But you seem to be describing an instance in which, even with our best intentions and the latest medical knowledge, that your father reached a point where that was not effective. Could you elaborate for a second?
Yeah, absolutely, Representative Steinberg. Thank you very much for your question. As you said, I have the utmost respect for our hospice care. We have an amazing system in Connecticut, and we loved our hospice nurse. I mean, she was amazing. She was there by his side helping throughout this whole process, and did an amazing job just giving him the relief that he needed up to that very end. And we were all just, there was nothing more we could do. It got to this point where we were so grateful that she was able to keep him comfortable for as long as she did. And I will always be extraordinarily grateful, and I feel very blessed that we had the opportunity for her to do that for my father for so long. But it gets to that point when these terminal illnesses, these cancers, just rear their ugly head, and it just wasn't effective anymore, and that's when we really lost him. And I know for a fact that's the last thing that he wanted my mother to see. That's the last thing he wanted me to see. And we just felt helpless. Those last, couple hours were just devastating because there was really nothing we could do. But again, this hospice nurse was incredible and up to that point. But the reality of the situation is there will come that point where it's no longer, you can't keep them in comfort anymore.
Again, thank you for your testimony today. We appreciate it. I have good news. We can all see Elaine Kolb at this point, which was worth all that effort. So Elaine, welcome, followed by Barbara Wilkoff. Elaine?
As many of you know, I've been at this for a long time. What you can't know is that I am currently, like thousands of other people, struggling with complex grief. Part of what is happening under this pandemic is that every single day, every week, thousands of people are dying. And guess who are the most prevalent. Guess what? People with pre-existing conditions and elders. And guess what? I'm both now. I'm 72. And I've had a whole bunch of people die. And a lot of them were fighting for life, and some of them were fighting to get services they qualified for, but they were on a waiting list, and they died. Now that's what the Public Health Committee should be dealing with. Passing something that enhances suicide? No. Ableism is a public health crisis in Connecticut, the United States, and throughout the world. The whole basis, look it up. The Euthanasia Society was started in the United States in 1938. And what the World Federation of Right to Die Societies, 45 organizations in 25 countries, they support euthanasia and the so-called compassion and choice, which is contempt and coercion for some of us. I get the right to say so, and other disabled people have the right to say so, and non-disabled, not yet disabled people do not get to say what is oppressive and dangerous and threatening to us. You do not have that right. I'm begging you. Please. I'm here to represent the people that are suffering and dying and are terrified right now because they can't get the help that they need, and they don't want to draw attention to themselves, because we will get put away in those horrible institutions that are death camps. And if you don't believe that, just look at the statistics. And I know I'm getting towards the end of my time now, but I just want you to know that this is bottom line. What they're doing here is they'll get their toe in, get something passed, and then they want to expand it. They've done it all over the country and all over the world.
I'm sorry, Ms. Cobb, your time is almost up.
I
If you would
understand. And I'm
summarize.
going to read
Thank
to you a poem, because that's what I do. Starved to death in Hartford, he fell between the cracks of a shredded social safety net hacked by budget attacks. Child Protective Services closed his case, they said. 1 more month of agony. That battered young man was dead. DCF inspectors never made it in, never saw that suffering boy, so black and blue and thin. At 17, he passed away. His body told the truth, festered, oozing, pressure sores on this bruised and battered youth. Every death by torture is a genocidal shame. Every life is special. Matthew Torado is his name, and some of us do know that we're expendable, and the system tells us so. And if you pass this, you support that system that kills us.
Thank you for your testimony. I will beg to differ. It is not our intention to in any
Doesn't
way
matter what your intention
disadvantage
is.
the, if I might speak, ma'am,
Go ahead.
disadvantage the disability community, and you can hear with great confidence that this committee is dedicated to addressing many of the healthcare access and shortcomings that have been exposed by the pandemic. And we have several bills that are intended to address this, not merely in the short term, but for the long term. And that we certainly do need to do much, much more for the disability community. And there are many dislocated by this pandemic for whom we are very much aware. So thank you for your testimony today. I don't see any questions, so thank you. We will move on next to Barbara Wilkov, followed by Davida Foy-Crabtree.
Hi, members of this committee. My name is Barbara Wilkov, and I am testifying in memory of my mother in support of SB 88, an act concerning aid in dying for terminally ill patients. I have submitted my full written testimony before the committee, and I would now like to share a bit of it with you. So my mother, Minnie Stein Wilkov, died on July 2nd, 2019. She was a longtime supporter of Compassion and Choices and deeply desired the passage of medical aid in dying legislation in this, our home state of Connecticut. This desire became personal when my mom was diagnosed with ovarian cancer in 2017. She wanted to be a voice for this cause and even dictated a letter to me before she died in hopes that it could be read by many, specifically Connecticut lawmakers. This letter was her final wish. She wrote, quote, "I am a political junkie, and this will be my last political letter since I'm in the process of dying a natural death from ovarian cancer. Despite all the painkillers and anti-nausea medicines, and even though I'm surrounded by all the love and care I could wish for, I am leaving this world in a torturous and miserable way that I would not wish on any caring human being. Please pass the Death with Dignity legislation here in Connecticut, promoted by Compassion and Choices. To deny people this choice is inhumane. I am dictating this because I am weak and cannot write the letter myself. I feel very strongly that I should have had the opportunity to choose when to say my final goodbyes. My suffering has caused undue and unnecessary suffering for my family. I wish I could have spared them the emotional pain associated with my terminal illness. Signed, Minnie Stein Wilkov, Stamford, Connecticut. Please take my mom's words and her final wish into consideration in passing this important bill. Thank you.
Thank you for your testimony, and please extend to your mother our heartfelt hope that that her remaining days are good ones and pleasant ones. We very much appreciate your story today. Are there any questions? If not, thank you for your testimony. Next, we have Davida Foy Crabtree, followed by Tessa Marquise, I'm not sure which.
Greetings to the members of the committee, and thank you so much for being present and for this bill. I am the Reverend Dr. Davida Foy Crabtree, a retired United Church of Christ minister, a Connecticut native, a current resident of Bloomfield. I am at heart a pastor, and in that role, I have been at bedside with countless people suffering mightily through the process of dying. I've been with them through their anguish as they ask their families and even their pastor to help them to die, to end their suffering. I know intimately their yearning and their pain. Their journey to the mystery of eternal life in our Christian teaching is unhelpfully extended sometimes by the power of medicine. Most come to a point at which they ask, why? Why do I have to linger in pain like this? Why can't you help me die? In the UCC, the oldest and largest Protestant denomination in Connecticut, we call each person to build their relationship with God as their own experience and faith leads them, and to do so in ways that are faithful to the scripture and to the Protestant Reformation. So in a time of dying, it is our conviction that the individual in their own conscience has not just the right, but the responsibility to make their own choices about life and death in the context of their prayer, their love of God, and their experience of God's love of them. We don't impose our faith practice on others, and we have a reasonable expectation that others will not try to impose their faith practices on us. Everyone should be free to practice their faith according to its teachings as they understand them, and according to their own relationship with God. In my mind, it is imperative that the legislature not intrude on the sacred, holy relationship of the person with God. Let each faith tradition teach as it will, but do not, as a legislature, prefer one faith tradition over another. Connecticut has a long history of wise legislation that, for instance, disestablished Congregationalism in 1818. And as a state, we've set aside other singular religious doctrines that used to govern birth control and freedom of conscience and same-gender marriage. That's what needs to happen now with medical aid in dying. I speak to you as a pastor, pleading on behalf of those suffering at the end of life.
I'm sorry, Reverend,
Please
you'll
do
have to
all
summarize.
for them to make it possible through this bill to give them the relief and peace they yearn for. It's a good bill. It has all the right guardrails in it. Vote it this year and see it through. Thank you. And I'd be glad to take your questions if you have any.
Thank you for your testimony. I appreciate your point, which recognizes Connecticut's long tradition of enabling freedom of choice in this regard, and for highlighting the fact that one can have strong personal religious beliefs and respect the different beliefs of others, which is what we're really talking about in this context. Are there any questions? If not, thank you for your testimony. Greatly appreciated. We next have Tessa Marquise or Marquise, I'm sorry for not being sure which, and followed by Ali Gray III. Tessa, I apologize for getting it wrong one way or the other.
Not a problem. It's Marquis, and you should be glad it's no longer Markowitz, because that's even harder. My name is Tessa Marquis. I'm a resident of Milford. I'm submitting testimony in support of SB 88. My testimony today is about compassion. In the interest of time and in consideration of the many others who will be speaking, I won't do the usual thank yous, but thank you all for being here and especially those who have co-sponsored the bill. I've been testifying and advocating for various versions of this act since 2014. My previous written testimony, along with today's, is online for all to see. Up to today, I've always spoken about the comfort and solace needed for others while dying, and about raising the legislature's understanding of the concept of choice, which includes access. That is still true, but today is different. My mother died 5 weeks ago. Today's hearing is, for me, much harder and much more raw. Today I'm angry, and I'm talking about appropriate anger, not Kubler-Ross's 5 stages of grief. I'm angry with the Connecticut legislature. I'm angry with the legislators and other entities that slow walk solutions which can ameliorate suffering. This particular bill is not about the inequality, inequity, unfairness, and cruelty involved in so many of our state's existing laws and structures. Today is about suffering inflicted on many by the stubborn, uncaring, and vicious inaction of the few. The Connecticut legislature's callous disregard for the suffering that accompanies the end of life is disgraceful. This begs, to me, the question of who each legislator actually represents. Is it self-serving organizations that make money from extending the suffering of people? The insurance companies, perhaps? Religious entities? Are your constituents only wealthy people who can end their lives at home without interference at will? Do we need to keep showing you photos? Here's a photo. Here's a photo of our dead and dying relatives and friends. Have you seen enough of that through COVID? Do you want to hear the polling numbers again? Real people in our state want this option. Everyone must have equal access to the full range of life choice options. An aid in dying law, even with one that leaves out so many people who will not qualify, is long needed tiny step towards civilization. This is a small thing to grant our terminally ill friends, families, neighbors, and at some point, whether you like to hear it or not, ourselves.
I'm sorry, Ms. Markey, please.
I'm gonna
summarize. Thank
talk even faster.
Thank you.
Residents of Connecticut must be permitted to make end-of-life care decisions based on their own belief systems, culture, and personal choice. Politicians like to accuse each other of kicking the can down the road. Politicians say they can't do much because of short session. Stop making excuses. Contrary to the obituaries, people are not going peacefully in their sleep. You must ensure that SB 88 moves forward this year. I'm willing to answer any of your questions to the best of my ability. Here's another picture. I'm the only one still living.
Thank you for your testimony and your passion. I will quibble with you. I do believe all we legislators, regardless of our personal opinions, have taken this issue very seriously. It's why it's come up year after year. We've seen opinions change, but I respect the points of view of all my colleagues and know that this for them is often a very difficult decision. Representative Gilchrist has a question, followed by Representative Kennedy.
Thank you, Mr. Chair. Not a question, just a quick comment. So good to see you, Tessa, and I'm really sorry for the loss of your mother.
Thank you. She had to starve herself to death.
Unfortunately, those are the options people have in the state of Connecticut currently. Representative Kennedy.
Thank you, Mr. Chairman. And Tessa, I want to offer my heartfelt condolences to you as well. I know you've been going back and forth with your mom, and I'm so terribly sorry for your loss. And I wish you well, and thank you for your passionate testimony today.
Thank you. Thank you, Representative Kennedy, for your vote, the positive last time.
Thank you, Mr. Chairman.
And Representative Steinberg, I'm not saying all legislatures, I'm saying the legislature as a whole. And I'm saying government as a whole does a disservice to the people who are their true constituents when, sorry, I'm imitating Gary. When they back up from making a decision and pushing and rely on regular people to come here and weep and re-explain over and over again why their uncle died from ALS from starvation, why people who have the dementia of old age cannot take effect of any of these bills that get passed. It's not relevant. We're talking about cancer and we're talking about suffering.
Thank you.
Thank you.
You know, this is our process. We consider bills every year, and this bill has been long-lived, and I certainly appreciate your frustration. Perhaps this is the year where we'll restore your confidence in the legislature. Certainly, there are many on this committee who have that as an objective. If there are no further questions, thank you again for your testimony. We will have Ali Gray III, followed by John Levin, I believe. Welcome, Ali.
Thank you. Thank you. Good morning. And I'm just thankful for this opportunity. I'm Pastor Ali Gray III, resident of Waterbury, Connecticut, a pastor, a coach, worked in the education field for 33 years, mental health with a retiree of the state of Connecticut. And I want to say that this bill should not pass. And my mother, who was my best friend, she died of cancer in 1993. And I enjoyed my life with her. She was my best friend. She had 5 children. And when she died, we were there with her as she breathed her last breath in our home. She was on hospice. And it was so precious to me, and I'll never forget it. Because that just reminded me how precious life is and how short life is. But I'm going to get right to the point right here. And I want to say this. Proponents of assisted suicide try to put a positive spin by terms like death with dignity. But death with dignity is still death. Assisted suicide is still suicide, and suicide is wrong. We live in what is sometimes described as a death of culture. Abortion on demand has been practiced for decades. Now some are seriously proposing infanticide, and euthanasia is promoted as a viable means of solving various social and financial problems. This focus on death as an answer to the world's problems is a total reversal of the biblical model. Death is an enemy 1 Corinthians 15:26. Life is a sacred gift from God, Genesis 2:7. When given the choice between life and death, God told Israel, choose life, Deuteronomy 30:19. Euthanasia spurns the gift and embraces the curse. The overriding truth that God is sovereign drives us to the conclusion that euthanasia, assisted suicide are wrong. We know that physical death is inevitable for us mortals. Psalms 89:48, Hebrews 9:27. However, God alone is sovereign over when and how a person's death occurs. Job testifies in Job 6:30-23. I know you will bring me down to death, to the place appointed for all the living. Ecclesiastes 8:8 declares, no man has the power over the wind to contain it, so no one has the power over the day of his death. God has the final say over death. See First Corinthians 15:26, 54:56, Hebrews 2:9, 14 and 15, Revelations 21:4. Euthanasia and assisted suicide are man's attempt to usurp the
I'm
authority
sorry,
of God.
Pastor, your time is almost up. If you would please summarize, thank you.
Yes, death is a natural occurrence. Sometimes God allows a person to suffer for a long time before death occurs. Other times, a person's suffering is cut short. No one enjoys suffering, but that does not make it right to determine that a person should die. Often God's purposes are made known through suffering. When times are good, be happy. But when they are bad, consider that God has made the one as well as the other. Ecclesiastes 7:14. Romans 5:3 teaches that tribulations bring about perseverance. God cares about those who cry out for death and wish to end their suffering. God gives purpose in life's end, even in the end. Only God knows what is best, and his timing, even in the matter of one's death, is perfect. Thank you, and I pray for you all, because we're all priceless originals created by God, made with a purpose and a destiny. He is the author, the giver, and the writer of our lives. He knows the first day we'll be born and breathe our first breath, and he knows when we'll breathe our last breath. And we think we can control life. Let me just say this. Let me say this last thing.
You're well over 3 minutes, sir.
If you think that you can control it or we can control it, let me see one of you stop breathing right now.
Please, sir, we're not going to engage in hypotheticals. Thank you for sharing your beliefs with us today. We very much appreciate it. I don't see any further questions, so we will move on next to John Levin, followed by John Warburg.
God
Mr.
bless
Levin.
you.
Hi, my name is John Levin. I live in Norwalk, Connecticut. I think it is very important for legislators to understand that many of the people who will benefit from this bill are people who, in fact, never will use the options afforded by it, but instead will simply gain comfort from the knowledge that those options will exist for them. People like my dad. My dad was a pediatrician. He practiced medicine for over 40 years in Los Angeles, where I grew up. He told me that he chose pediatrics because he knew his patients would almost always get better, no matter what. In his 80s, Dad had a series of strokes, which led to a significant decline in his health, combined with type 2 diabetes, renal failure, heart disease, prostate cancer, sepsis, endless urinary tract infections, and many functional declines, which I will not describe here, but they came with advanced declining age. His life was challenging. Dad could no longer walk, and he became bedridden, requiring nearly 24-hour care for things like feeding and toileting. But my dad also was the same person he always was, and he wanted to live. He loved watching movies and baseball games on TV. But as a doctor, he also knew exactly what was happening to his body, and he knew things would get worse. My dad also suffered from anxiety all his life, and he was deeply fearful of enduring an extended, painful death process. Should he face that, Dad wanted to have the ability to take medicine that could end his life quickly and painlessly. This was before California's End of Life Option Act, a law very similar to SB 88 before this committee now. As a doctor, Dad knew this medicine existed and had been used by others and was effective, and he felt strongly that he should have it in case he decided that he needed to use it. Dad begged his doctors as well as his still practicing physician friends, to provide him with a prescription, or alternatively, to just simply give him the drugs that he could keep for himself and use if he felt he needed to. Barred by law, they all refused. Dad grew frustrated and increasingly anxious. In every conversation with my sister and me, Dad demanded that we do what his doctors and friends would not: get him drugs that he could use to end his life, even if he never chose to use them. During one visit, as the same conversation continued, Dad begged me to drive to Tijuana, across the border in Mexico, to go to the dog track there, find the veterinarian, and offer to pay him cash for some of the medicine used to euthanize injured dogs. I was astounded my dad and our family had come to this point, but I wanted to be a dutiful son, ease his anxiety, and help my dad. I made that trip. When I finally got to the dog track and found the veterinarian, I explained to him my dad's situation and the purpose of my visit. He was the warmest, kindest man, and he was very sympathetic to our plight and to my request, but he refused to do so, both for legal reasons and
I'm
because
sorry, Mr. Levin, your time is almost up. If you would please summarize. Thank you.
Oh boy. Okay. Eventually, California passed its law in 2015, and my dad's anxiety vanished. He spoke with his doctors and knew that he would have that option. He went on, was in hospice for a long time. He watched his beloved Chicago Cubs win the World Series. He watched the Los Angeles Dodgers win the World Series, and he kept on living. He was satisfied that he was at least in control of his death, should he face one that he did not want to. Please understand, this law is not just for the benefit of terminally ill people enduring excruciating pain, but also for the living who, like my dad, want to live, but don't want to be forced to endure protracted pain and suffering at the end, if that is to be their fate. Thank you very much.
Thank you, Mr. Levin, for your testimony. I don't see any questions, so we'll move on to John Warburg, followed by number 22, Susanna Bennett. Mr. Warburg.
Thank you to the members of the Public Health Committee for hearing this bill and for giving me the opportunity to testify. My name is John Warburg. I live in Fairfield and I support SB 88. To echo Senator Wong at the beginning, this issue shouldn't be looked at as having a single right or wrong answer for everyone. It is truly a nonpartisan issue that comes down to personal choice. There will always be people who, if given the option of aid in dying, will choose not to use it, and there will be others who will. And I completely respect both choices, but I don't see how my choosing aid in dying at the end of my life impinges on the rights of those who would not choose it. With the law enacted, I am protected to choose, and they are protected not to choose. It's not an either-or situation. Everyone is protected, and I hope you will take this into account in your deliberations. With respect to the slippery slope argument, I just want to point out that the law has not been expanded in over 20 years in the US, and the scaremongering visions of death panels and child euthanasia painted by opponents have never come to fruition. Not only is the slippery slope argument patently false, but it's precisely this legislative body that has the power to stop such slippery slopes in the future. Ultimately, I hope that legislators will listen to the voters on this issue. The majority of Connecticut citizens, including majorities in both the disabled and faith communities, want a MAID option. So why deny them this right at the end of their life? I fully appreciate that as legislators, you sometimes have to protect the minority against the will of the majority. But no such conflict exists here. You can give both sides what they want. One, the right to use the law, the other, ironclad protections against it. There are multiple safeguards that protect both. Whether or not you choose to pass this law, the fact is that medical aid in dying is already effectively here, just a short drive away in New Jersey, Vermont, and Maine. But I don't want to have to move to be able to access this law. So I beg this committee and ultimately the entire General Assembly to please pass this bill so that no more terminally ill people in Connecticut have to suffer needlessly or resort to more violent, undignified ways of ending their life. Thank you for listening to my testimony.
Thank you so much for your testimony. I do not see any questions. We appreciate your testimony, Mr. Warburg. Next is Susanna Bennett, followed by Jill Hammerberg. Susanna, you there?
very much, members of the Public Health Committee, for hearing our testimony today and giving us the opportunity to speak. My name is Susanna Bennett. I am here in opposition to SB 88, and I will try to summarize my written testimony in the interest of time. Basically, I see that compassion and morality must always work in harmony. The two must be connected and cannot be disconnected in the interest of one over the other. So once we establish that choosing to end one's own life is acceptable in certain circumstances, we are destroying our own moral authority to say that choosing to end one's own life is wrong under any other circumstances. So we are undermining our authority to fight suicide in other circumstances. In my written testimony, I referenced the Netherlands as an example of how legalizing controlled forms of euthanasia and assisted suicide, which was done in 2001, has led to an increase in expansion of that type of euthanasia and assisted suicide, both in numbers and in demographics. In 2017, almost 1/4 of all deaths in the Netherlands were induced. In the National Review, Wesley Smith wrote about the high rates of induced death in the Netherlands, and he said, "The Dutch are not horrible, ghoulish people. They are logical. Once they accepted the premise that killing is an acceptable answer to suffering, they're now simply taking that belief precisely where it leads. Americans are not horrible, ghoulish people, and we also are logical. We will take this belief where it leads to accepting and encouraging other forms of suicide." Thank you.
Thank you so much for your testimony. Seeing no questions, we will move on to our next individual. That is Jill Hammerberg, followed by Victoria Elliott. Jill, I think I saw you a second ago. Ms. Hammerberg? There, you're there, number 24.
There. Okay.
There.
Yep.
You cannot see you yet.
Okay. Here I am. Sorry for the difficulty. Start the video.
Jill, we can hear you, but we cannot see you. If you want to turn your camera on, it's up to you. You have that choice.
Okay. Start video. I'd like to be seen. Okay. Okay. Okay.
There you are.
Okay.
Good.
All right.
Excellent.
Thank you. Good morning, members of the Joint Public Health Committee. I'm Jill Hammerberg, and I'm providing testimony in support of SB 88, an act concerning aid in dying for terminally ill adults. First of all, I would very much like to express my gratitude to you for listening and considering why this legislation is so important to many. My personal story begins with a broken promise to my husband of nearly 40 years. Our hero lived out the progression of prostate cancer for over 17 years, enduring surgeries with both traditional and experimental treatments. The most remarkable part of this time was that he never let it show. His outrageous sense of humor, work ethic, and love of his business, community, and family dominated his daily life. There was no room for fear. His rapscallion nature, coupled with his big heart, made him an irresistible force to reckon with in both work and play, which were intertwined. But the disease finally became a reality as his doctors shared the last MRIs with us a week before Christmas in 2011. No longer could he deny the inevitable cancer cells migration to his bones and liver, which had formed massive tumors. My sons and I received this news together with an odd calmness as our hero seemed at peace. He was given pain medication, a blood transfusion, and sent home with generous hospice care. I reached for his hand and I promised with a wry smile that he could at last relax. The accelerating pain that he had been experiencing would finally be lessened. For the next 6 weeks, we welcomed family and close friends for conversation, stories, laughs, tears, music, favorite movies, celebrating ordinary time that was anything but. It was a magic time in our lives, suspended and set apart from all else. When asked what his last wishes were, Mark replied, "Just this, hanging with you guys and our pups, Jill making bread and soup, boys taking me for rides in the Jeep around my town." His single request was to leave the windows open in our bedroom for his escape, and maybe the front door too, just in case. Our good friend and hospice nurse Ruth checked in with us as usual on what would be his last day. The vitals indicated that he would begin breaking down anytime. Keep a pile of dark towels by the bed. Prepare for the bleeding to begin.
Ms. Hammerberg, I'm sorry to interrupt. Your time is almost up. If you would
That same
summarize,
night,
please.
our hero woke up in excruciating pain. The unearthly sounds are with me every day. He became a drowning victim, fighting for each breath. The powerful medication given to me to administer when such time came provided little comfort. It seemed an eternity. Holding him close, trying to absorb some of the agony, I whispered, "I'm sorry, I broke my promise. I thought it would be enough." If my husband had had the prescription waiting on our bedside table, he would have used it on that last sunny day when we were all together. There would be no doubt there would have been a celebration with Hey Jude, Life Aquatic, Red Sox cap, maybe a Guinness and an open window. Instead, we carry the individual as well as the collective trauma of the indignity of his pain etched forever in our hearts. I ask you to support this bill that would authorize medical aid in dying for terminally ill adults. If passed with all the safeguards in place, the choice would offer comfort on many levels for all involved.
Over your
Please
time.
support the elimination of unnecessary prolonged suffering for our loved ones. Going forward,
You're over your time. There is a question. So Representative D'Amico, do you have a question for Ms. Hammerberg?
Yes, I do. Thank you, Mr. Chair. I will be brief. Jill, thank you for coming and testifying for yet another year. Your son testified earlier and did a marvelous job. I appreciate the fact that you brought back our hero to life for just a few moments this morning. I really appreciate that. So your son talked about the heroic and wonderful job that hospice did for your husband. But I take it that your perspective is that hospice, as good as it is and as heroic as they are, could not do the job the way it should have been done to relieve your husband. Is that what you're telling us? You're on.
you are correct. It was wonderful until it wasn't. It's just the degree of medication. And it took much too long. And there was no dignity involved. It was not good.
Okay. And the reason I asked is because we've had this, we had this discussion for several years now, and for some, hospice seems to be a sufficient prescription, shall we say, but for others that seems not to be the case. So I just wanted to get your perspective.
That's very good articulation. That's why I believe in the choice.
All right. Thank you. Appreciate it. Thank you, Mr. Chair. Thanks, Jill.
Thank you.
Thank you all.
Thank you, Mrs. Hammerberg, and then thank you for sharing your testimony. Next is Victoria Elliott, followed by Christy Yaros. Victoria.
Okay, I don't need to be seen. Do you hear me?
We can hear you, Victoria, but we cannot see you. So there's a button that is a camera. If you want to press that, you'll be able to see you.
I don't see where it is, and I don't really care about being seen particularly. Oh, start. So let's see if I took it. Oh, there it is. Oh, there I am. Okay.
You know.
Okay. Hi. So my name is Victoria Elliott. I have a home in Harwinton. I've had a home for 34 years here, originally from Oregon. The idea that I would have to go to Oregon in order to have my choice made is not acceptable to me because I consider Connecticut my home. So that's one thing. But really important, I think, all of those nice people who believe in palliative care, as the last woman expressed how it doesn't work, is that what palliative care ultimately, especially with really bad pain, is talking about drugging people until they don't know where they are. And Mr. Hoffman mentioned that he didn't want to have brain fog either, and he's in California, so he can have this choice. But the idea of drugging people till they can't see, think, even be in the room in order to control massive pain is really what we're talking about. And that's not dignified. And many of us don't want that. My other concern is I'm deeply concerned about religion. As one of your people went on and on, I don't want somebody to force me into their religion. And we do have religious choice in this country. And I want to have my religious choice. I don't want somebody else telling me that he knows what God wants. So I think that's very important. But I want to go back again. Everybody says palliative care is a solution. It's a solution for some people. It's not a solution for everyone. And I was a caregiver. I am a psychologist. I was a caregiver for someone who died of ALS. And believe me, there's nothing, it's incurable, and it's a terrible, terrible way to die. So I just think this is a really important bill. It's been around for a long time. All of the history of Oregon has shown that it has not been misused. And in fact, what's important is that so many people is to have a choice. And even when they have a choice, many people choose not to do it. So all of the fears and all of the fantasies that people express really have not panned out. And we have to be realistic about that. But again, palliative care is drugging people silly in many cases. And I don't think that's dignified. And I think it's ultimately cruel to the family members who have to watch it. That's all I have to say.
Thank you for your testimony. If I could just follow up a little bit. You referenced the Oregon law and their experience with it. It sounds like you've attempted to stay up to date with the information coming out of that state. Could you elaborate a little bit more in terms of what you were referring to in terms of outcomes?
Well, my understanding is that what is it, 30% of people, I'm not very numeric, get the numbers wrong, who choose to have the medicine don't use it. What's important is to have a feeling of choice. But for the people who do want to use it, that's been very important to them and to their family members. So I can't say much more about that, but I've been following it, what goes on in Oregon, and I go to Oregon once a year to visit. And I know people in certain circumstances, I haven't heard this be abused at all. So the fears, and I understand the fears, but I don't think because people are afraid it should control other people's freedom.
Thank you for that. Seeing no other questions, thank you for your testimony today. Next, we have number 26, Christy Yaros. I understand we're trying to get Nicholas Bafundo into the queue. May have some technical difficulties, for which we apologize. So Lise Dondi, you may want to be ready. But first, Christy Yaros, good morning.
Morning. Thank you for having me today. And thank you everybody for listening to some very emotional stories. I appreciate it. First, I want to say there's a distinction between suicide and assisted dying. And the fact that people keep bringing up it being suicide, I feel is disrespectful to those who have experienced losing someone to suicide, which I have, but I have also lost 2 people to COPD and heart failure and watched them die slowly. My mother-in-law died last year, but before that, she was dying for 3 years. Every time the hospital, she would end up in the hospital, they would call us. She was in New York. We'd have to drive 3 hours down and say our goodbyes. And then they'd fix her up a little bit and they'd send her back home. She was on hospice care. She had a great team. She had a doctor visit her. She had a nurse every day. She had a social worker talking to her. But every time she would get ill, they would send her back to the hospital and she would say, I want to die. I want to die. I'm done. She couldn't breathe. It's not about pain as much as she literally couldn't breathe. She couldn't take off the oxygen mask long enough to have a conversation with anybody. She couldn't take off the oxygen mask long enough to eat. She lost about 40 pounds. She couldn't eat anymore. No amount of the palliative care was going to change that. Her heart would continue to die, and she would continue to not be able to breathe until her brain would be deprived of oxygen, and that was just it. We dreaded receiving a call that she would have fallen and died in her apartment and we would have had to come get her. I know people have spoken about closure and having it on terms. I can't think of a better way than to have her choice and us be surrounding her and being final and that it, and not getting a phone call that she's gone, which is what we did have. She wanted to die. She never mentioned suicide, not once. There was enough morphine in her apartment that she probably could have done it 10 times over. I really feel the distinction between the suicide and assisted dying is important. Also, we allow our pets more compassion than we do our people. When our pets are at the end of their lives and we know that they no longer have a quality of life, we give them the compassion of ending it. Why can't our people have the same thing, a choice for themselves? And
Ms. Yaros, your time is almost
yeah,
up. If
that's
you
it.
would
I'm
please
good. I'm done. Thank you.
Thank you.
Right on time. Thank you for that. Very interesting point that we often treat our pets better than our loved ones. But it is a valid point in my view in terms of what compassion ought to look like. Representative Cavros DeGraw.
Thank you, Ms. Yaros, for being here today. As you are my constituent, I just wanted to thank you for being here, and also thank you for that distinction that you made between when people die by suicide versus medical aid in dying. Would you say, based on what you said, I think I know the answer, but would you say that your mother-in-law was depressed? Because it sounds as if perhaps not.
No, I mean, they had to drag her to the hospital sometimes because she did not want to go. And we tried to get like a power of attorney over her to help her make decisions. And nope, she was in her complete right mind. She was fine. At one point, the social worker even told us, like, she just wants to die, not because she was depressed, not because she was suicidal, but because she couldn't eat and she couldn't breathe. She couldn't talk. She couldn't make it to the bathroom without resting on the way there. She wouldn't let anybody come see her anymore because of the way that she was pretty vain and she couldn't put her makeup on anymore. So she didn't want anybody to come see her like that. Yeah.
So I think that in her case, it's not, people talk about quality of life. And I think that when we talk about it as an individual decision, it seems like for her, she felt that she wasn't having the quality of life.
She had told every time she would wake up in the hospital and we would be there, she would be disappointed that she had woken up, that she was there. That's why she didn't want them to take her to the hospital. When we lost power 2 summers ago, she had no oxygen. She had no air conditioning. She had no phone because it was the internet. They found her almost dead, and they had to drag her to the hospital and fix her up and send her back home again for it to happen all over again.
And just one last thing to the point of the palliative care, was the morphine provided by hospice, or why did she have that much?
Yes. So morphine also helps with your breathing when you have COPD. But as others have stated, there's only so much you can take and still be able to function as a human being. And she lived by herself, and she was very adamant about continuing to live by herself at 80 years old with her. But and not even sure she, like I said, there was so much in her apartment. I don't even think she was taking it when she was supposed to be.
Okay. Thank you very much for your testimony today. I'm very sorry for your family's loss.
Thank you
for being here and sharing your story.
Thank you, Representative. Though I did detect several questions in that last round of inquiry, but you handled it definitely within the 3 minutes. So we're going to congratulate you rather than chastise you. In any case, thank you for your testimony, Christy. Very much appreciated, particularly highlighting the point that it's not only necessarily about intractable pain that could have a huge impact on someone's last days. I think that's an important distinction. I understand that, thank you for your testimony. Nicholas Bafundo is in the room, and I had made a mistake. Not my first, I assure you, and not my last, I mean. Looking at the list, Tyrone Biniars is after Mr. Bafundo. So just to be clear on that point, and then we'll get to Ms. Dondi. My apologies. Mr. Bafundo, are you there? We seem to be struggling a little bit today. While he attempts to get on, if we can go to Tyrone, if you wouldn't mind, and we'll see if we can get back to Mr. Profundo in a moment. Welcome.
Hello. Dear Co-Chair Senator Abrams and Representative Steinberg, Vice Chair Senators Anwar Kushner and Representative Gilchrist, and other members of the Public Health Committee. Thank you for the opportunity to submit testimony in my strong support of SB 88. In March of 2016, my younger brother Clifford was diagnosed with a rare form of cancer called chondrosarcoma. There's no cure for that type of cancer he had. Clifford lived and worked in Tucson, Arizona. A few months after his diagnosis, he had extensive surgery at MD Anderson in Houston, Texas. The odds of removing all the cancer and remaining cancer-free were 50-50. He was hospitalized for 9 months, suffered several setbacks, and nearly died several times from complications. In May of 2017, after the cancer had returned, my brother left Houston and moved in with me. He continued his fight against cancer and lived for slightly more than 4 years. The extensive surgery and the slowly metastasizing tumors often caused him excruciating pain. Clifford required much medication to manage his high levels of pain. Clifford was someone who enjoyed life, living it on his terms and being independent. His loss of many aspects of independence profoundly impacted the quality of his life. Control over the end of his life and how that would happen were the final ways in which he could exercise autonomy. What he did not want was the drawn-out conclusion that chondrosarcoma was leading him to. In May of 2021, Clifford developed an infection that required brief hospitalization. He was discharged from the hospital to a nursing home, and he entered hospice care during the summer. By September, he was dead. Shortly after beginning hospice care, Clifford told me that if he still lived in Portland, Oregon, where he once lived, and where aid in dying for terminally ill patients is legal, he would opt to end his life that way. Once Clifford entered the hospital and nursing home settings, however, he lost all control over ending his life on his terms. SB 88 gives the terminally ill patient the ability to make a very personal decision with professional assistance. In 2021, as my brother had perhaps a few months remaining, the legislature yet again failed to enact an aid in dying bill. He and I followed the debates and were disappointed when it failed to become law. Now, after he died, not having the choice he wanted, I strongly encourage the legislature to enact SB 88 and make aid in dying for terminally ill patients a legal option for residents in Connecticut. Thank you.
Thank you for your testimony. I have a question for you. You've heard
Sure.
some of the testimony today, no doubt, which refers to the lack of absolute certainty about a terminal diagnosis. And in your brother's case, even with a devastating cancer, he, as you described, made it for 4 years. At what point during those 4 years do you think he might have availed himself of this? And what's your basic opinion with regard to the fact that through sheer will, sometimes people live well beyond their prognosis?
Well, in his situation, he had an unusual, rare type of chondrosarcoma. And when it was diagnosed, he was told that it's a terminal type of cancer. It doesn't respond well to chemo and radiation, and they can attempt to attack it with surgery. And if they get everything, great. And in his case, they didn't. So it was sort of this very slow progression to the inevitable. And I don't think he would take advantage of the option of like what this bill sort of presents until the very end. And he fought the good fight and did everything that he could. But at the end, he would have opted for something like this, probably had he had the option.
Thank you. I understand Representative Foster has a question for you.
Thank you, Chairman Steinberg. Tyrone, thank you for being here today. It is good to see you, and I'm so sorry it is for you to share this story. I've read yours and your daughter's testimony on this bill, and I have to say you're amongst 6 other constituents in our district who have similar tragic stories. A thread that I've noticed in common is that many folks are testifying after their loved ones have passed, not having this option, sharing that they're testifying to carry on their legacy and give future people the opportunity to avoid such suffering. One of the things that I am not hearing and I haven't seen in the testimony is that one of the components of those suffering that people have shared is that having family see them towards the end of their life in these stages is another part of the agony that they're experiencing at the end of their life. Would you mind, and I'm sorry because I know this is painful, but would you mind telling us a little bit about, I've heard this a little bit from Taylor, but a little bit about what that was like for you and your family?
Wow. I'll try not to get emotional. Fortunately, I work very close to where he was, and I would visit him every day, sometimes multiple times a day. But he sort of went from in May of last year to being able to get around in a wheelchair and do some things by himself to not being able to do anything for himself. And as the pain, which he'd been taking strong pain medications for years, and so they kept having to increase the dosages. And so the more, painkillers he took, the less he was able to function and his health kept declining. So it was a several month just sort of sliding to death. And, to see him go through that was difficult. I know there are people like myself who are talking on behalf of people who died, but I, as a citizen of Connecticut, want this option for myself. And I can't really speak for other people, but I would want it.
Thank you so much for being here today. And again, I'm so very sorry for your loss.
Thank you, Representative Foster.
Thank you, Representative Foster. And certainly we all concur in offering our condolences to you. Thank you for taking the time to testify today.
Thank you.
I understand that Mr. Profundo is still in the waiting room, but I'm not sure we can access him yet. We'll give him a second to try. And if Lise Dondi can be ready to go, we're going to give him a little bit of time. Again, we apologize for technical difficulties. I want to do a shout out to our staff, which has done an amazing job during the pandemic over the past couple of years, and really, has us down to as good as you can do it. But we are all subject to technical difficulties, and I know it's made it harder on everybody today. And I know they're doing everything they can to see if we can get everybody in according to the schedule we've put together today. Not seeing Mr. Profundo quite yet. Let's do Lise Dondi, followed by Sister Catherine Mary Clark.
Good morning, Chairman Steinberg and members of the Public Health Committee. My name is Lisa Dondi, and I'm here to testify in support of SB 88. I have been a longtime supporter of medical aid in dying, but last year, the importance of having a choice to end suffering went from the theoretical to the personal. My husband, Bill Kaplan, died this past October after a 2-year battle with pancreatic cancer. During the last 3 months of his life, the pain meds could not keep up with his pain, which had become excruciating. If you have ever seen someone you love suffer unimaginable pain, then you know the feeling of helplessness watching them in agony. Thus began our frustrating journey in and out of the ER in the middle of the night, lying in the hallway waiting for a hospital bed and relief to come from IV pain meds. While the palliative care cancer team worked to find the right formula of oral meds in order to send him home, he was back to the ER within a week or so when his pain broke through and the oral Narcotics could no longer control his suffering. This went on until it was decided to admit him to Connecticut Hospice once the doctor said his pain will only get worse. All he and we, his family, had to look forward to was excruciating pain or IV meds that would knock him out. This was not living, but rather cruel punishment for someone who was a kind, giving, moral, and loving husband, father, grandfather, teacher, poet, philosopher, and musician. To make matters worse, under Medicare rules, he was not allowed to stay at hospice until we could prove he could not be cared for at home. So he was discharged, and after a day and a half, his pain recurred with a vengeance that turned the experience into a nightmare for all of us. Finally, once the hospice nurse came and determined that oral meds would no longer work, he was taken at 2 a.m. by ambulance back to the hospice, where he was put into a deep sleep. 5 days later, he died in what we hope was comforted peace, all that he had ever wanted. What a blessing it would have been for him to know, while he was of sound mind, that he could have chosen medical aid in dying. He knew he faced more horrific pain that would need stronger and stronger meds to manage until he would be incapacitated. Rather, he could have died with his family with him. We would have been comforted that he was at peace and had been able to surround him with our love and goodbyes. Instead, we live with the trauma of witnessing his last few weeks as his abilities diminished and his pain increased, wondering why anyone is forced to suffer in such an inhumane way. Thank you, and I hope you will pass SB 88.
Thank you for your testimony, and may we offer our condolences on your loss. Another very affecting personal story, which gives us some understanding of the real choices people would like to have. Are there any questions? If not, again, thank you for your testimony. We appreciate it. I understand we continue to struggle with Mr. Bafundo, and when he is able to get in technically, we will give him an opportunity. But we have Sister Catherine Mary Clark. Good morning. Followed by Kristen Keska. I'm sorry, followed by Joan Kavanaugh. I apologize. Sister Catherine Mary.
Yes, good morning. Good morning, Representative Steinberg and Senator Abrams and the entire Public Health Committee. You have my written testimony, but I think I'm just going to go way off script. I wish I had the opportunity to speak personally to all of the people that I've been listening to. I'm speaking in opposition to SB 88. And I was going to say I would love the opportunity to speak personally with each of the people I've been listening to who have spoken in support of the bill. And I extend sincere sympathy and regret for the experiences that people have had in losing someone, in watching them suffer so profoundly. But I think what I feel inclined to speak to is, well, first I want to address the issue of the use of medications and palliative care. I'm from Franciscan Home Care and Hospice Care. I'm a clinical social worker. And of course, I've sat with hundreds and hundreds of individuals and their family members. And the dying process, needless to say, is not easy from any perspective. And I think what is most important and what we hold most dear is that it is tragic if someone doesn't have access to services which truly will support them both medically to allow them to have the medications they need to be comfortable. But I think obviously what's most difficult is the emotional implications of watching someone you love so dearly decline and eventually die. It's not going to be easy for me either. And needless to say, I am a Catholic sister, but that doesn't take away the human dimension. In fact, it incorporates the human dimension that there's something in the natural dying process, like every other natural process, that really does require process. And in that process, it's not for naught that people need to experience that gradual decline and really prepare on a deeper level. And what is extraordinary and beautiful is the way that that process can unfold, even if it's difficult. And I don't mean difficult in the sense of pain. is essentially no reason for someone to have to be in pain with proper services. That doesn't mean it's not painful to watch someone you love decline, but in the course of that process, the conversations, the reminiscence, the healing that happens on every level really is a gift to every person. And that's why we uphold the natural dying process. We are in a Christian
I'm
faith. Of course,
sorry.
we
I'm sorry, your
believe that.
time is almost up. If
Okay,
you
thank
summarize.
you.
Thank you, sister.
Yes, thank you too. Thank you. So I speak in opposition, and again, I'm uphold the dignity of the process.
Thank you, Sister. Senator Anwar has a question for you.
Thank you, sister, for the work that you do and you have been doing all these years. I wanted to ask you what I understand from the medications that individuals take, the people who are terminally ill. There's a lot of anxiety in the picture. And what we have seen in other states is that anxiety of not having a support at the last moment, because hospice is not 24/7, unfortunately, you know that too. And because of the lack of support available 24/7, there's an anxiety that what if in the middle of the night, 2 a.m., I need something and I don't have it. I would have that as a backup. That's what majority of the people do. And in hospice, it's all about providing comfort and anxiety control as well. And if this gives assurance to the people, what we have seen in other states, why would you be opposed to something that 95% or more of the times it is not even used? It's just there for their anxiety control and knowing that there is an assurance in the back pocket, if you will.
So not having someone available is, from our perspective and through our agencies, by virtue of signing someone onto hospice, there must be someone available to them 24 hours a day. We simply wouldn't take a patient on. We would encourage them to go someplace where there is support. So that simply isn't an option in that situation, simply isn't going to happen when we are providing hospice. There must be 24-hour presence of someone who is able to recognize the need for medication if the patient isn't able to specifically say, I need it, and give the medication. So from our perspective, that's absolutely essential. And I agree with you. The anxiety involved in the dying process, again, of course, there's anxiety. There's anxiety of loss of control, anxiety of so many things, anxiety of dying, the unknown, of entering the unknown, of being afraid of being in pain. Those are all issues that we try to address from emotional, psychological, spiritual perspective. And what can happen in those conversations, in the conversations both with myself, with our staff, with family members, that, to be perfectly honest, is part of the most extraordinary part of what we experience in our hospice program, because conversations, people come, that wouldn't normally have been there visiting, et cetera, conversations happen, relationships heal. There's no way to describe one particular way, because obviously every specific situation is unique to that person in the situation. And again, I don't say any of that lightly. It takes a lot of work to see someone through the way they really need to be held through the natural dying process. But it's, how do I say this in a delicate way? I don't want to be offensive in what I say about it, but it's an artificial sense of security to think that I can, I'm going to make everything okay if I have the option of just ending it all. We don't really find our peace by opting out that way. And again, I don't say that lightly, and I don't mean to say it in any way offensively. It's just that we're upholding the natural process, the organic process that can happen and that can bring others to another level of understanding and of peace, of coming to peace within oneself in a natural way.
Thank you so much. I would have more questions, but it'll take away from others. I respect what you do and what you're doing, I may not necessarily agree with everything, but that's a longer conversation. But thank you again for your time.
Yes, thank you too. Thank you.
We do have some additional questions for you, Sister. Representative Berger Gervallo, followed by Representative Claire DeStitria.
Thank you very much, Chairman. Thank you, Sister. I heard you say earlier that the services that are available and the status quo that you're defending is enough. And I do appreciate that you lead this conversation from your heart, and that is to be recognized as an important place to begin this conversation. But what concerns me is, for example, we heard from Max Fay. Mr. Fay has the best doctors, hospice, and care with a loving family, and still that was not enough. So what do you say to the families for whom the status quo that you're suggesting is just not enough?
Okay, I'm not sure I actually would have said that it was enough, or if I did, that's not necessarily what I meant. It's true that we need to enhance the ability to provide presence and support for people who are in this process and for their families. But I'm not sure I heard that person's testimony. I'm not sure what there wasn't enough of for him. So when people, was the person in pain or what was the situation? Because that depends on
tremendous pain and suffering, physical pain, emotional, all of it.
So if it was pain from the physical situation, then I grant you, I mean, sometimes there are situations, it's very unusual that we find that we encounter this, but if there are situations where we simply do not have the capacity to get the person out of pain, or there's need for symptom management, then we have no choice but to suggest to the family that they be taken to Connecticut Hospice in Branford and be able to get the medication that they need there, because there are limits to what we're able to provide in the home, but we do everything that we can to provide that. And if the pain is intensified by either emotional or spiritual discomfort or distress, then we try to address it from that point of view, either within for the person or within the family, or the environment, whatever the situation may be, if that answers your question.
Just to clarify, he did have access to hospice care and did have all of these things, and still the suffering was unbearable. So I appreciate your point of view, but it seems like we're looking at an either or, and I don't think it needs to be that way. Thank you very much.
You're welcome.
Thank you. Representative Claire DeStitria.
Thank you, Mr. Chair. Thank you, Sister Catherine Mary, for your testimony today. My question to you is, first question, have you had instances, and I'm sorry if someone already asked you this, where you had a patient in your care and you were not able to relieve their pain?
So I was just speaking to that. First of all, in very unusual situations, there have been a few situations where symptom management was a problem. It wasn't always necessarily just because of pain, because obviously there are situations where it's symptoms are not always just related to actual pain. But in those situations, then we have recommended and have facilitated the transfer of someone from their home, which is usually where this situation happens, to Connecticut Hospice, or to a place where they're able to provide the necessary medication intravenously or whatever it is. Again, there are limitations as to the quantities of medication that we're able to provide in the home. But those are very unusual situations, and they're difficult. There's no question. We do everything we can to avoid it coming to that point, but yes, it has happened on rare occasion.
Okay, and then I need clarification for this as well. So in hospice care in someone's home, you're not able to give the same medications that a hospital can give?
We don't give intravenous if the need is there for something that, more powerful or more direct or whatever. Yes, no, we are not able to provide that at home.
Now, is that just your organization, or is that palliative care, hospice in general? Is it different per different organizations?
I think I better be careful responding for all organizations, but I think that is the case. Other agencies can speak in and correct me if I'm inaccurate on
Okay,
that.
I'll ask that to someone else, but also, and we've heard people testify saying that they've had hospice care at home where it wasn't 24-hour and they couldn't get in touch with the nurse to get someone out to the house. So, I mean, this may be a separate conversation and a deeper conversation we have to have legislatively about the effects and what we're doing with our palliative care and hospice care moving forward for the state of Connecticut, separate from this.
Yeah.
But I thank you so much for your testimony today. Thank you, Mr. Chair.
Yeah, you're welcome. You're welcome. And I'll just say, those are situations that simply should not happen. If someone has hospice care being provided at home, we should be available 24 hours a day, 7 days a week, no matter what the situation is. So thank you.
Thank you.
Thank you. Senator Summers, followed by Representative Kavros DeGraw.
Yes, good morning, and thank you, Sister, for testifying today. I just had some clarifying questions. It's my understanding, and I think some of them have been answered, but I just want to be clear. In the testimony that we've heard in the past, it has been, that I've taken notes on, it has been pretty evident to me that many of the people who are testifying in support of this bill have had loved ones who have had a bad experience or an experience with hospice that they were not prepared for. There's this, I believe still there's this confusion about hospice at home as a family member, thinking that the person who's coming home with hospice care is going to get what you said, 24-hour care, nurse on call, and be able to manage the pain. And in speaking with the director of palliative care from Yale down here in New London, he has also said that's the same issue that they're finding, that people are not prepared for what hospice at home really is. And it has a great function and does a great job, but it does have limitations. Being able to provide IV services for very strong pain medication. And again, had indicated when you cross a certain pain threshold at the end of life, hospice in the hospital is much different. They can manage pain in a better way. So my question to you is, do you think it's appropriate, I do, to have a conversation about the ability for hospice at home to be able to strengthen their ability to provide medication, to expand their role, to look at insurance or requiring insurance to cover that 24-hour nursing care at the end of life at home, just like they would in hospice care in the hospital? I think of many of the people that have testified, even in the last year that we've heard this bill, the majority of them saw a loved one in hospice with an expectation that is different than what they experienced. And I was wondering if you could speak to that, because that leads us to a pathway of a bill we're hearing now that may not be, in many cases, the appropriate outcome if we could manage the end of life in a different way.
Yes, I very much agree with you. In fact, I'm on the governor's task force for end of life issues, and that's an area that absolutely does need to be addressed. And it is, we really work hard to try, our agency and all agencies really work hard to try to educate people as to exactly what palliative care is and what hospice is, which is, the culmination of the palliative dimension, and a conscious acknowledgement that there isn't anything more that that the medical world is able to do to improve the situation. And it's time to let nature take its course and to allow that to happen in the most productive and supportive way possible. one of the first things I say, I'm typically the first one to talk to the family. And I stress the importance of the conversation we had earlier, that there needs to be someone 24 hours available with the person, because that is not out there. We don't have the means to do that. We are a small agency, but there aren't many agencies that are able to just provide, I don't know if there are any agencies that are able to provide 24-hour presence covered by the Medicare hospice benefit or insurance. So yes, I agree with you. I think that would be a very good conversation for us to address, and specifically, quite honestly, in order to be able to avoid the bill that is at hand. So thank you for that question.
Thank you.
Thank you. Yes, it's been a topic of great discussion over the past year, figuring out how we can extend resources where they're most needed. A lot of conversations about workforce and programs that have shown to have success that we'd love to be able to scale up. So hopefully we'll put some real resources behind that this year. Representative Cavros-DeGraw.
Thank you. Thank you, sister, for being here today, and thank you for the work that you do with these families. I went to 4 years at Catholic high school, though not Catholic, and I know the great work of many, a sister of the Immaculate Heart. I was thinking about when you talked about the fact that it's rare, and my colleagues have sort of spoken to that, but I also was thinking about the piece that you said about the conversations that are able to be had towards the end of life with palliative care. I guess my question to you would be, when you have to transfer folks to the hospital because you're not able to manage their care in a home setting, my question would be, are they medicated for pain to the point that they are unconscious? Because certainly that would, I know that there's been a perspective on, so much morphine being given or whatever the drug might be, that it's not so much natural cause, naturally it's hastening. And do you find that these patients are still conscious in the hospital when they are receiving this pain care, to have those conversations, as you've said?
It depends on the situation. Yes, there are times when the morphine and or Ativan, whatever needs to be used for the symptom management. There are times it's hard to distinguish at times what is the disease progression and what is the impact of the medication on an individual's state of consciousness. So that's one discussion. But if I'm the one first going in and explaining the situation, then of course the nurse comes behind me and can answer any of those questions related to the medication, the use of medication. But as I always say, if someone needs the medication, not everyone needs the medication. If someone needs pain medication, we start at the lowest dose possible and work our way up according to the need of the patient. We do everything we can to avoid the person losing consciousness before nature takes that route. And that is for the sake of the person being able to enjoy, appreciate life, of course. To the point of people being transferred, again, it's a very unusual situation for us to need to transfer someone to a facility. But that too is unique to the situation. We provide hospice in the hospitals and in nursing homes. So sometimes they are conscious, and sometimes they're conscious until a matter of minutes before they die. Sometimes they are able to say, yes, I want to go to the hospital if it's going to help my pain. Sometimes they say, I'm in pain, keep working with me here, but I don't want to go anywhere. So it totally depends on the situation. And we do everything we can to both go with the needs and the desire of the patient and the family members and just work with them accordingly. And if someone wants to go to the hospital, of course we take them to the hospital or have them sent to the hospital. And again, sometimes they remain in a state of consciousness, and sometimes, they gradually enter a state of unconscious. And it's hard to distinguish what is the disease progression bringing them to a state of unconscious and what is caused by the morphine. Does that answer your question?
I think it does. I mean, I think it obviously depends on the illness,
Yeah.
you know, and in terms of what we've heard, I do think it's not that unusual, only because in terms of not being able to manage pain based on the 15 hours we heard last year. I know my colleagues have heard even more than I have, but, you know, talking about death, listening for a death rattle and having to medicate and that sort of thing. But I do thank you for your answer. That's helpful. Thank you.
Okay. Thank you.
Well, thank you, Representative, and thank you, Sister. You've really helped us quite a bit with understanding some of the nuances of medication administration and just the individual differences
Yes.
in every instance. And I'm sure we all agree we appreciate all the work that you do, and certainly do everything within your powers to help people through end of life as smoothly as possible. We really do appreciate you taking the time today.
Absolutely.
Before I go on to Joan Kavanaugh, who's been very patient up to this point, I just want to share with you an investigation we did about the IT circumstances. And lo and behold, as it turns out, Zoom has changed its policy from last year. And the reason why there may be some problems for people in the queue to get on, maybe because now, instead of being automatically promoted into the waiting room for testimony, you now have to click on a new button that says you need to be promoted as a panelist. You need to hit the blue button, join as panelist, and not the white button, stay as attendee. If anybody had done that, that may be the reason why they've been unable to actually get off mute and talk. So we're hoping that going forward, anybody experiencing that will take advantage of this additional information. Again, we are learning. This is our first public hearing this year. We were used to it being automatic in the past, which it was. And we're all frustrated that it's taking a little bit more effort, but we appreciate your patience. So next up is Joan Kavanaugh, followed by Kristen Keska.
Can you hear me?
Yes, we can.
Thank you. I'm also having some technical difficulties of my own, so I've been coming in and out of the internet. My name is Joan Kavanaugh, and I have been a member of Second Thoughts Connecticut since 2013. I'm also a member of Progressives Against Medical Assisted Suicide. And I cannot make an apology for the name, assisted suicide. I believe it's accurate. And I too have lost many loved ones to suicide, and in my life, cancer, AIDS, the diseases of old age, and some random accidents. And I just want to say death is hard. It is hard, no matter what you do, how you approach it. I believe in universal comprehensive healthcare, and that means equal access to quality healthcare for everyone, regardless of financial resources, age, pre-existing conditions, and physical or mental characteristics. I would add now, because of this discussion, very explicitly, 24/7 hospice care needs to be provided for people who are in that situation. And I believe and I hope that members of this committee are committed to that goal. The legalization of medical aid in dying, as you call it, would be a large and dangerous step in precisely the opposite direction. It would only further widen the cracks in the profit-driven and discriminatory medical system into which the most vulnerable among us are already falling. It offers us no solutions except death. The offensive phrase, death with dignity, used by supporters of this legislation suggests that the level of care required by many who are disabled, elderly, or ill, extremely ill, demeans a person and places intolerable emotional, financial, and/or physical burden on their families. This is a fundamental denial of our human connection and responsibility to one another, and I believe it's also a form of psychological aggression against anyone already struggling to come to terms with an illness. It is not surprising to me that the advocates of medical assisted suicide have a slogan called "My life, my death, and my choice." And that slogan was seen on a sign at a Trump rally in 2020 for people who refused to take precautions to stop the spread of COVID because it impinged upon their personal freedoms. I believe it's the same mentality. Not that I'm at all saying that the people who have suffered are expressing that mentality, but I think by and large, passage of this legislation would show that mentality. That's what it would be about. Proponents want us to believe, quote unquote, we would have heard about cases of abuse or coercion in the states where medical assisted suicide is already legal. But how would we begin to
Ms.
even?
Catherine, your time is almost up. If you would please summarize.
I will try to summarize. I've tried to get this down to 3 minutes. It's very hard. People who are being coerced are either going to be dead or living in fear and shame. And there are other avenues of coercion, which include what I've already said in my written testimony, external factors such as hospitals and caregivers, insurance pay for expensive treatment, the attitude of some healthcare providers that certain kinds of people could be better off dead, and from tired or duplicitous caregivers. I personally had to fight for my own mother's care, and I've described this in detail. It was traumatic. You can read it in my personal testimony and also in my previous year's testimony. And I hope you will do so because it is with me to this day. I'm going to conclude by saying that the concept of medical aid in dying is opposed to everything that healthcare should be about. Above all, we need to be able to trust our doctors, not to fear that somewhere in their medical arsenal is the option to terminate our lives. It is time to finally hear what disability justice activists have been saying all these years. I beg you, vote against SB 88 as though your lives depended on it, because many of ours literally do.
Thank you for your testimony and for your passion about the issue. I do not see any questions for you, so again, thank you. Next up, we have Kristen Keska, followed by James Farrell.
My younger sister saw a cardinal today. I did not truly understand what that meant until my mom died. She's here today using my voice to advocate in her memory. I, in return, wear her pearls, gaze at her photo, and yearn desperately for a hug from her, to hear her laugh, to see her smile. I wish you were all here today at the press conference before this hearing, when Kim Kaufman, a longtime Connecticut advocate for MAID, wife Joy spoke about her death 5 weeks ago and her nightly reliving of her passing. Each person in the conference speaking was brought to tears. Kim's wife, her father, Jim, Jen, and I. Then watching and listening to Senator Gary Winfield's story brought out my full sobs. 10 years later, he relives the tubes in his mom's mouth. I relive the horror of my mom drowning for 4 minutes from the inside out. This reinforces my observation that every time I discuss medical aid in dying with my family, friends, colleagues, and absolute strangers, there is one common denominator: emotion. Each person gets choked up in their own way, tears, shaking voice, and other clear signs of sadness or fear. And I'm hoping today is the last time any of us have to relive in front of the public the trauma of a painful passing of a loved one denied their version of peace. I'm hoping today is the last time Connecticut residents, sick and looking at the sand in their personal hourglass running out, having to beg for the passage of this law. I spoke about my mother's passing last year and have submitted written testimony describing all the painful details. My mother was scared of dying in pain. My mother made it clear for decades that she wanted MAID. My mother used her free will to choose hospice at home, which provided her some spiritual comfort. But the reality of hospice at home meant that my sisters, dad, and I became her doctors and nurses. Unlike Sister Catherine Mary Clark's experience, hospice care was not 24/7, but family care can be. As someone who watched almost all of last year's hearing and comparing it to this year, one thing has stood out. There are many more tears this year. Congress members, advocates, citizens reliving trauma and facing our sadness and fear to make this bill law, to support the right to choose, like almost a quarter of the nation gets to do. I am 38. I have a 7-year-old and 2-year-old, and heaven forbid I was to get sick today. I would fight like hell. I would go through every treatment and every experiment possible to live for my children and my husband. My 7-year-old is a spitfire like my mom. And just like my mom, I do not hold back when I talk about her. She hears me proofreading my speeches and talking to others about MAID and asks a lot of questions. She knows if I get sick, I would fight like hell. But she also understands that the battle is when I see her grow up and maybe she has married and has kids of her own like grandma did, I might not choose that battle. It brings me peace knowing that if this bill passes, I have options. I can fight for, or when terminal, I can peacefully pass.
I'm sorry, Ms. Keski, your time is almost
I will
up.
finish up.
Thank
If
you.
I choose, I won't drown. If I choose, I won't feel the pain of not being able to have a bowel movement for a week and a half. If I choose, I won't need my daughter to help a hospice nurse insert a urinary catheter. If I choose, I won't have to starve or dehydrate my body to speed up the death process. If I choose, I can guarantee having my family and friends who wish to be next to me at the moment of my passing surround me with their love and strength on my journey to heaven. 2022 is the year Connecticut will allow those few who wish to die on their own terms to do such. Before I go, I want you to hear my mom's voice. She recorded this audiobook on September 6, 21 days before her death.
There's such joy in knowing you and being your grandparent. You're such a lovely dream come true. Granddaughter, you make my whole world grand.
She confided with me that if she had a choice, Sunday, September 15th would have been her last day on earth. MAID is not an artificial sense of security. Legislators, please ask me any questions. For example, Representative DeGraw, I have a response to the end of life conversations with my mother that you asked Sister Catherine Mary Clark. I'm an open book.
Right. We will hopefully get to that in a moment. I just have to say, it's clear the Spitfires do run in your family.
You think so? My dog's a Spitfire. I've been practicing and making sure she wasn't going to bark for this, but she certainly did outside.
It didn't slow you down in the slightest. And thank you for all the testimony you provided. Senator Anwar has a question for you.
Go ahead.
Thank you so much for your testimony. I wanted to just ask you again, the hospice nurses do God's work.
Yes.
I have deep respect and love for them. Having said that, hospice is not perfect, as it was, at least it was communicated that hospice is there available 24/7 in any circumstances. Could you share your experience and thoughts about the weaknesses within the hospice system and also the anxieties and support that needed beyond that?
So I didn't really understand what hospice meant when my mother chose that option. We have all the insurance. It wasn't Medicaid or Medicare. She had all the options. She could have gone to the hospital. She could have fought more just for palliative care. But once her chemotherapy failed her for that extra few months, she decided that hospice at home was her decision. I thought it was going to be like she did when I was a child, she was a home healthcare worker, and that is 24-hour support for many people in the home healthcare industry. And I thought that's what it was going to be. And quickly those thoughts were dashed, and not negative way, because you're absolutely right. The people that came to our house, they are dedicated workers. I'm a teacher, and I feel the same way as the home hospice workers, that we are dedicated to our job. We are going to do what we need to help a student or a person pass peacefully and be comforted. And we're also stretched thin. And I don't think any law is going to change that, because people are always passing. And I would love to have had a 24-hour at home, but I don't think that's even possible, even with the best of laws and everyone that wants to be a hospice at home worker. So we were quickly trained with the gigantic novel of what to do for my mother. And I actually have pictures, and I wish I had my phone out, of the log I had to keep with my sisters and dad. We became the 24/7. We did the shifts. We gave her the medicine. We were told what to do if we had to give her more, or what symptoms we should be looking for in case of pain. We got all the morphine in the world to give her if we needed to. And if we had questions, this is where the 24/7 part does come in. We could call and they would pick up the phone, and they would always answer our phone call right away. And if they had to come, they would say, we'll be there in an hour or two. And so that's what hospice at home care came, is they trained us to do what nurses and doctors would be doing at the hospital, even though we are not trained at all. And I wasn't kidding. I did put that catheter into my mother. My mother and I are big people, and the nurse could not lift her enough. And so she said, who can help? And I said, I would, because I had done, I was my mom's beautician. I did her eyebrows and everything. So I was good with it. And I had to help lift her and insert the catheter so she could pee in the medical bed. And I also was the one that didn't realize I heard the death rattle. I think people were referencing part of my story last year. I did not know it was death rattle. I knew something had changed. This was the last day of her death. And I regret that, because when my sister came in for her shift with my father the next day and the hospice nurse said visit, she was like, your mom has hours to live. That's the telltale sign. And I never gave the medicine that they told us to give her when the death rattle came. I don't know if it was an because again, I saw her drowned. 4 minutes. We all saw her drown. My sisters and my dad saw the foam come out of her mouth. And I guess that medicine helps break that up. But I did not start giving it to her when we started hearing that noise at 7 p.m. at night. And she started getting it at 9 in the morning when the hospice nurse came. So again, I am grateful for hospice nurses, just like people are grateful for teachers. And then I know their struggle because it's my struggle on a daily basis and a different clientele. And I don't fault them for it at all because my mom chose that. She chose the peaceful passing at home, but there was no IVs. However, I did have a friend who testified last year who, when I told her that like a month ago, was like, my mom had an IV at home. So I don't know what was different about that. And I'm sure the more medicine could have been more effectively given to my mother if there was an IV, but I can just, you can see it in my face. She was back and I would put the dropper in her mouth and it would just dribble down. And this was for days before she died. And that was my experience with hospice at home.
Thank you. Thank you, Mr. Chair.
Thank you. Representative Capros-Tegra.
I'll be brief, but yes, I was referencing your story because your story and your mom's story has stayed with me for the full year since we heard it. I remember you were one of the late night testimonies.
Yeah.
And I can remember your dad was in the background. And so, you know, when people wonder, are legislators listening? We listen to all of these and we do remember them. So I would ask, you know, you said you wanted to share about conversations with your mom. If you want to share that, we would like to hear it.
So the last, I would say from Monday, Tuesday, Wednesday, Thursday, my mom died on a Friday. Having a conversation with my mom was few and far between. So if someone's saying that part of the death process is the healing from having conversations with your parents or whoever's passing, it's not going to happen in the whole time you're dying, the whole process of death, which could take days, weeks, months, to be honest. But there is a process. And I remember my mom growing up because she told me that she wanted medical aid and dying for decades. So it was no question. And it kind of got me upset when the last person who spoke had mentioned that it was like aggressive on not mine, but on our behalf, trying to convince someone this is what they want. My mom wanted it because she saw her dad waste away to nothing from pancreatic cancer. And she had told me that she regretted when her mother died, that her mother, because mother had some issues, never apologized for those issues when she was younger. She was my grandmother growing up, so I didn't know these issues personally. And so I know those conversations can happen, but they don't always, even when you take the natural passing. But for my personal experience, I felt the moment when my mom was a little bit more comforted when I was having a conversation with her because I was pregnant and she knew on my first pregnancy how much I suffered from postpartum depression. And I never admitted it to anyone and it was bad. And so I had already talked to my OBGYN about it and we already had made a game plan. I was strong. So 5 years later, I'm like, why didn't anyone ask me about my postpartum? And she was like, let's get you on medication. So I didn't realize I never told my mom this. And so probably a week before she passed, when she definitely was in her new hospice bed, I was talking to her. I'm like, by the way, Mama, you know, you don't have to be here for my baby's birth. Just so you know, because my mom was an advocate for mental health. I've already talked to the doctors. And as soon as I give birth, I'm going to go on antidepressants because I won't let that happen to me again. And I felt that she was relieved. I can't explain it more than that. She definitely talked to me. She said, I didn't know you had done that. And I'm like, oh, I'm surprised I didn't tell you. We tell each other everything. So that was my conversation with my mom. But that was when she had just gotten into the hospice bed. That was probably about 10 days before she died, maybe 9. Because as I remember, Monday, Tuesday, Wednesday, Thursday, the conversations were brief. Matter of fact, on Wednesday before she passed, the only thing I can remember her doing is we were making our annual pilgrimage to the Big E that she used to love and would go with us. And before she left, she told my older sister, which I'm quite jealous of, I love you. And that was the last thing I got from her on a Wednesday, 2 days before she died. So there's my conversation story.
Thank you so much for sharing that and for your testimony today.
Thank you.
Thank you, Kristen. You've given us a very complete, colorful picture of your experience, and we appreciate that. Next up is James Farrell, followed by Lorraine Zua. But before James speaks, I just want to give Mr. Bafundo one last opportunity. I explained before that you need to hit the blue button and indicate you're willing to be a panelist. We're going to give you one last chance to do that. We'll give you a little time to do so. But unfortunately, then, if you do not elect it, your opportunity will have passed. Thank you for understanding. James Farrell.
Thank you. This is James Farrell. I clicked that blue button, so I'm a panelist. Okay, I'm going to speak opposing Senate Bill 88. And, years ago, my mother, brothers, sister, brother-in-law, they met a normal death surrounded by loved ones, knowing it's the right way to live life to its natural end. Assisted suicide drugs, they're dangerous, they're painful. It's too harsh. It burns the patient's mouths and throats. The drug mix led to deaths that stretched out hours. And hours. Safeguards create problems, and abuse and are ineffective and often fail to protect patients. A clinical social worker, attending physicians, consulting party physicians, and telehealth determine if a patient is competent. Therefore, to say those with dementia would not be eligible under this bill is a lie, because as shown here, the consent may be given by others who may very well be biased. This bias is greed by diverse causes such as insurance company, health company, and heirs to the will. So it's painful, not a peaceful death. And some deaths may be inhumane. It's not good enough reason to change public policy into one that endangers vulnerable people, fundamentally changes our society. With counseling, mental anguish can be alleviated. And finally, fraudulent, biased doctors in Connecticut. There's a lot of fraud among them, and the elderly is especially acute. Residents are overwhelmingly disapprove of physicians prescribing fatal drugs for patients. So residents of Connecticut, they're opposed to it. Once passed, this legislation can be expanded and it could become uncontrollable, eliminating waiting periods, the 6-month terminal prognosis, allowing nurses and other medical providers to approve, participate in.
I'm sorry, Mr. Farrell, your time is almost up. If you would please summarize. Thank you.
10 more words. Residency requirements and expanding suicide laws to allow euthanasia. So it's risky business to pass this in the first place, because they can always make it worse, and they often do. And with that, honorable members of the committee, I've met some of you already, Senator Sommers and Representative Pettit, and a few others. So thank you very much for your time.
Thank you.
I have questions.
Thank you for your testimony. I don't see any questions. We'll move on to the next person, Lorraine Zwolak, followed by Lorraine. I saw you a second ago, Lorraine. There you are. Lorraine, number 34. Please go ahead. You can unmute yourself and you can turn your video on as well. I think Lorraine may be having some technical difficulties.
I see it. Here we go.
Okay, good. Hi, Lorraine.
Hi.
Please go ahead.
Okay, members of the committee, I am testifying in opposition to Senate Bill 88. I was a nurse specialist in hospice in a large home health agency for 10 years, and we took care of hundreds of patients. So we offered very good pain and symptom control in our agency. And in all those years and hundreds of patients, no one ever spoke of hastening their death. And, when their narcotics prescription was renewed and they got the whole prescription at once, if they had taken it, they could have certainly tried and probably succeeded in ending their lives. No one ever tried to do it. And my husband is a pulmonologist at a large urban hospital, and has been for 45 years. He takes care of people with end-stage lung diseases, and they are palliative care patients. They become hospice patients. And in his practice, no one has ever talked about hastening their death either. So a point I want to make is that, you know, there are many stories here in this testimony, and they're very sad, and it's upsetting to hear them. But this is selection bias here, because there are hundreds or thousands of people who aren't testifying, who are living with their illness. They're dying peacefully in hospice, and they're not here testifying. So I hope you will keep in mind that the right here in the testimony, the scale is not even, comparing the, you know, patients that want this and the patients that never ask for it. My issue with some of the testimony is that whether hospice was given for care 24/7. Yes, we were always available 24/7. The nurse was on call. She would come out to the house. If an issue arose in the night, we always had someone on call, and it was available. And pain medication, there's new ways and good ways of delivering that pain medication that were not available before. And you know, we did not have really an issue. We had hospice meetings every week discussing one of the big issues, pain control. We always tried to keep the pain level under a 3, and we managed to, by the basis of we were hearing at our hospice meetings. An issue I have with this bill is, I read it, you know, it seems like it has very good restrictions, but the problem can be, it can morph into other things when the restrictions are changed, as they've already changed them in California to lessen some of the restrictions.
I'm sorry,
on this.
Ms. Wallach, your time is almost up. If you please summarize.
Okay,
Thank
so
you.
I'm just, all right. So if the bill, eventually, if there's a change to this, you can change the route of administration of the pain meds, and then if it's changed to a parenteral route, IV, now you do have euthanasia. And euthanasia has been a runaway train in Belgium, the Netherlands, now Canada. Canada now has 2.5% of all deaths are euthanasia. That only started in 2016. And my final point is that I sent this in my written testimony. A study was done, a review of all US Medical and Surgical Society position statements revealed that of the organizations, there's over 150 they surveyed. Of all the organizations that had position statements, not one had a statement endorsing physician-assisted suicide. There's a citation for that in my testimony, because the large medical associations such as the American College of Physicians, I quote, does not support the legislation of physician-assisted suicide, the practice of which raises ethical, clinical, and other concerns. So if the people that are charged with the health of patients are saying this, I hope you will give this some consideration. Thank you.
Thank you so much for your testimony. I was going to ask you at the beginning of the testimony if you were related to Dr. Zwolak.
Yes.
He has been an amazing doctor, and one of the most thorough doctors I have come across. His notes would be like 12 to on the lower side, or 30 pages on the longer side for the occupational lung disease that he was working on. So
thank you.
Thank you for your testimony.
He also
And,
sent
I have-
testimony in opposition to this bill, by the way. He sent in written testimony in opposition.
We'll read that, every one of us. And Dr. Pettit has a question for you.
Thank you, Mr. Chair. Thank you, Mrs. Wallach, for your testimony and for your care. I have a complicated question. I wonder if you make some comments on palliative care versus hospice and the specific issues that have been raised as to whether intravenous medications are allowed during hospice, whether procedures such as fecal disimpaction are allowed, and if, in your opinion, there really needs to be changes in terms of the regulations surrounding palliative care and hospice care to improve it. So I wonder if you could comment on that. Thank you.
Well, what I no longer am practicing because I'm old now, but yes, disimpaction certainly was part of the care. I belong to a large website group on hospice, and certainly that happens. And also, when I was practicing, we had people that had forms of IV through a pump, pain med pumps, and I think they're CAD pumps. I think they have replaced this with a more use of the oral route or other routes, such as something called a Macy catheter, where they can even give the drugs rectally. And inpatient hospices, I was not in an inpatient hospice. I suppose they have access to other things, but hospice tries to not use invasive things because IVs can bother people too, feeding nasal gastric tubes and things. So we try to be as natural as possible but still controlling their pain. And the other issue about people being drugged to the point of oblivion, they go up on these pain medications gradually by a pain formula. So they get used to these large doses and they don't become comatose from them. But another point is 1/3 of people do die in a coma, and it is not from their pain meds.
Thank you so much. Thank you for your testimony. The next person, give my regards to Dr. Zwalik, please.
I will. Thank you.
And the next person is Al Smith. And through this conversation, may I ask Mr. Michael to please accept coming to this side of the conversation. You are in the attendees list. You've been asked to join the panelists. So click on the panelist and you can join. But as of right now, Al Smith is next and Stuart Steinman is going to be after that. Go ahead, Mr. Smith. Al? I do not see him on the list over here. While we're trying to track Mr. Smith, can we have Stuart Steinman? Stuart, you want to join?
Yes, thank you. Thank you very much. Senator Anwar, Senator Abrams, Representative Steinberg, and distinguished members of the Public Health Committee. My name is Stu Steinman. I'm here today to testify in support of Bill number 88, an act concerning aid in dying for terminally ill patients. I speak today in two capacities: as a board certified emergency physician and as a son who lost his mom to cancer this November. As a physician, I see a limit in our ability to adequately control pain and suffering in the final stages of terminal illness. A common misconception is that patients seek lethal medications as an easy way out or a way to commit suicide. Nothing could be farther from the truth. Data from Oregon and Washington show that only 76% of prescriptions are actually used. Loss of autonomy and loss of dignity are the top 2 out of 3 reasons people request aid in dying. There is vocal opposition in the disabled community. They fear that they will be pressured and coerced into accepting aid in dying. They fear their quality of life will be undervalued. They fear that insurance companies will use it to cut costs. There are many anecdotes about people who were mistreated under the pretext of right to die. It's crucial to note that not a single person has ever actually taken the lethal medication. The checks and balances work. Opponents argue that mistakes will be made. They're correct. The checks and balances in the law are so effective that all of the mistakes made have been in denying qualified patients medication. There are no cases of physicians prosecuted for inappropriately prescribing right-to-die medicines. Those who oppose this legislation maintain that aid in dying will deprive patients of the improved quality of life offered by palliative care and hospice. After Oregon passed the right to dying legislation, there was a marked increase in use of hospice and a marked increase in referrals to palliative care. A survey in 2020 showed that 75% of Connecticut residents, 69% of Catholics, 65% of disabled people, and 58% of physicians all supported aid in dying.
Do you know anything about Zoom?
Yeah,
a
little bit.
I'm sorry?
I second.
Can I keep
Please
going?
continue.
Oh, I'm sorry.
Yes.
Yeah, my mom was diagnosed with cancer in 2019. When all treatments, including immunotherapy, stopped working, she went into hospice. Thanks to my colleagues in palliative care, I was able to take my mom to California to say goodbye to her son, grandchildren, and newly born great-granddaughter. With aggressive pain management, she was able to attend her grandson's wedding. She was in pain, but she had a joy for life and had lots she wanted to do before she died. She bought holiday gifts for her grandchildren in late October.
Dr. Steinman, I'm sorry, your time is almost up. If you would summarize, please.
Yes, thank you very much.
Thank you.
In October, she bought presents for her grandchildren just in case. She died in November. Her grandchildren opened her presents in December. Then one day, she just couldn't get out of bed. Her severe pain turned into agony. Nothing controlled her pain. She lay in bed in a dazed stupor, pleading with me to end her suffering. She pleaded with her dead mother and sister to bring her to heaven. When she was too weak to talk, she just whimpered in pain. When she gained enough strength, she would go, "Stu, you're a doctor. Help me." Palliative care is not terminal care. There comes a point in someone's illness when palliative care prolongs a slow and painful death. It does not improve quality of life. I urge you to pass Bill 88 so that no one else has to suffer as mightily as my mom. I would like to thank the committee for giving me the opportunity to testify today, and I'll be more than happy to answer any questions. Thank you.
Thank you, Dr. Steinman. I appreciate your testimony, and all of us do. And thank you for reliving some of your pain to make sure that we understand this well. Can I just ask you a clarifying question? You've tried to separate palliative, hospice, and terminal care. Can you allude to the terminal part of it, if you could?
Yeah, terminal. My point being that there comes a point when palliative care and hospice no longer works, and people are actually dying, terminally ill and dying. And there's no treatment paradigm in hospice care or palliative care that addresses that fact, so that you can improve people's quality of life up to a point, but at some point, the disease outstrips the care. That's what I mean by terminal care. When when the pain medication makes somebody stuporous and yet does not control their pain. And she was on, I'm a physician. I had a palliative care doctor who would treat her at home. She had IVs, she had everything. And in spite of all that, she suffered like a dog.
Thank you so much. Thank you for reliving your pain and your clear words. I appreciate them. Thank you.
Thank you.
No other question. We will move on. I will actually ask Mr. Michael Daly, who has joined us over here, followed by George Warburg. So, Mr. Daly.
Can everybody hear? Can everybody hear me?
Very well.
Okay, thank you.
Can't see.
Good afternoon. My name is Mike Daly, and in the interest of full disclosure, I do want to state to the committee that I am the office manager of the Jordan Porco Foundation, which is a suicide prevention and young adult mental health organization. Today, I speak not for the organization, but for myself. We've heard from many healthcare people, we've heard from faith communities, and from others who have watched their loved ones die from terrible disease. I'd like to share my story, a person who struggled with the issue of a terrible disease. At 49, I was diagnosed with a rare form of cancer. My oncologist was not optimistic about my chances for a good outcome. And at the end of each appointment, she would say, "You have cancer, Mike." I found myself wrestling with many questions. What would my illness feel like? How am I strong enough to endure it bravely? How will I know when I begin dying? Will it be painful? What will be the financial effects of illness on my family? How do I prepare myself, my family, and my friends? Am I strong enough to endure this? How difficult will it be for my family to anticipate my needs and make decisions about my care? Is it fair to make them do this? Do I have the right to burden my family? How do I prepare for this? How do I do it bravely? How do I do it right? I decided that if I could not save my life, I would control my death. That helped me to think I might be able to actually die. I was planning and actually thought maybe I am strong enough to do this. At times, I even thought I might die well, if there's such a thing. Death became something that happened, and somehow the finality disappeared. I met with my priest, picked out my casket, made the arrangements for the wake, and even made arrangements for my cemetery plot. And when my death was planned, I thought, now what? When do I die? I found myself focusing on those questions again and again. Honestly, at times I thought it would be easier to have it over with. The planning made it inevitable. The planning made it real. The planning in some ways took away my hope. And I was on chemotherapy. I was feeling sick. I was in pain. I was unable to sleep. I was unable to eat. I had panic attacks. Life was not good. I had a good death plan, so why didn't it just happen? Death was not death. It was just a clinical break from what I was going through. Fortunately, none of my physicians mentioned suicide or offered to help me kill myself. I know what I would have decided, but I do not know if I was in the right frame of mind to rationally make that decision.
Excuse me, Mr. Daly, your time is almost up. If you please summarize. Thank you.
Okay. Fortunately, after a number of months, I changed treatment and was put in a more positive plan. The treatments continued longer than the doctor's predictions about the length of my life. The treatments kept going, and so did I. I was not dead when they told me I would be. They were wrong. I'm fortunate to be in remission. I've lived a lot longer than any doctor thought possible given my diagnosis and my treatment. And I will keep going. I live with fear of recurrence. I have lost balance, hearing as a result of treatments. Some days I get depressed. Should I ask for help committing suicide?
Thank you so much. Thank you. We appreciate your testimony and your congratulations on remission. We so have thankful for that. I don't see any questions. We are going to move on to the next individual.
Thank you.
Who is George Warburg, Jean Hartnett, and Luther Weeks after that. George Warburg, are you there?
Good afternoon. Thank
Hi,
you,
George.
members of the Public Health Committee, for hearing this bill and for giving me the chance to testify. My name is George Warburg, and I live in Hamden, Connecticut. I'm 94 years old and have supported the cause of medical aid in dying for over 30 years. I'm pleased it is now an option in 10 states, but I'm disappointed it is still not available in Connecticut. I've been blessed with a long and lucky life. I'm now essentially deaf and have recently been in and out of hospice care, and I'm mostly bedridden. But I'm fortunate to be able to live at home with the support of my family and marvelous caregivers. I still have much to live for and no intention of giving up life. At the same time, I've seen others at the end of their lives suffer cruelly, along with their families, simply to prolong what had become a tortured existence in their final weeks. They were prisoners of hospital beds, tied to machines, unable to perform normal activities for themselves, and in physical and mental distress, only minimally relieved by today's medical magic. Despite terminal illness and such suffering, those fellow citizens of ours in Connecticut did not have a merciful way out. Palliative care, of course, is a wonderful option for many, but I've seen firsthand how it is not a cure-all. While I am reconciled to my limited life expectancy, I fear my vulnerability to pointless misery if the Connecticut law is not reformed. I still have much to live for and plan to keep on living meaningfully for as long as it is granted me to do so. But without a medical aid in dying option, I can't be confident of bidding my family a properly grateful, peaceful farewell should my end-of-life suffering become unbearable. While in likelihood, I'd not use a medical aid in dying option if I had one, just knowing there was such a safeguard over my life's end would enhance what remains of my long life.
Excuse me, Mr. Warburg, your time is almost up. If you would please summarize.
And it would apparently be welcomed as merciful good sense by a clear majority of our fellow citizens in Connecticut. From my perspective, medical aid in dying is not about rejecting life, it's about embracing life to the fullest while I still can, and then letting go before its inevitable end. Evidently, this makes sense to more of us in Connecticut than just me, and I beg you, please, to pass the bill. Again, thank you.
Thank you. Thank you so much for your testimony. Truly appreciate it. And sorry you had to wait for a long time, but we appreciate you speaking your perspective. Next person I have is Luther Weeks. We don't have Jean Hartnett here, but Luther Weeks followed by Walter Frisch.
Chairs and members of the committee, my name is Luther Weeks, testifying for Secular Connecticut. We represent the interests of the 42% of Connecticut voters that are non-religious. Our positions are based on the U.S. Constitution's guarantee of separation of church and state, along with humanist values guided by science and reason. Perhaps you are familiar with the concept of pre-constitutional rights, which form the basis for our government. Many are declared and recognized in the Declaration of Independence. The entire legitimacy of the United States and Connecticut constitutions rest on the declarations that governments derive their just powers from the consent of the governed. There are other pre-constitutional rights. Among these are life, liberty, and the pursuit of happiness. It occurs to me that these certain unalienable rights apply today as we continue to hold steadfast to the promises and ideals of our democracy. Life, we have just one precious life, too precious for anyone else to choose how we live or limit in the end what our end will be. Liberty, we have a long tradition of avoiding limiting what others can do or ingest, as long as they do not directly harm others. The pursuit of happiness. The pursuit of happiness is perhaps the most obvious right that would be protected and provided by this bill. I was executor for the estate of my cousin who died of brain cancer. I sat with him on his last day of struggle in life. I did not know what his choice would have been, yet I would wish that he had that choice to end his life when he chose and how he chose, even if after due consideration, he chose not to exercise it. Diagnosed just 2 months earlier, he chose wisely for no curative treatment, conscious and able to make decisions until 2 days prior to natural death. Someone said this panel here is biased. I'm here to say that aid in dying is supported by 89% of secular Connecticut voters, 70% of Protestants, 69% of Catholics, and 65% of those with a disability. That is 75% of Connecticut voters overall. Please see page 2 of my written testimony for more statistics that will be of interest. Even if you personally would not make that choice, I urge you to support SB 88 in the name of democracy, human rights, the Declaration of Independence, and the majority of Connecticut voters who still yearn to breathe free and yes, to die free. Thank you.
Thank you so much for your testimony. I do not see any questions. We appreciate your testimony. The next person on our list is Kristen Barbeau and followed by Barbara Mancini. So Kristen Barbeau, you're next, Ms. Barbeau.
Hi there, can you hear me?
Very well. We cannot see you, but we can hear you.
Okay. Hi, my name is Kristen Barbeau. I thank each member of the Public Health Committee for taking the time to hear my personal story, which explains why I support SB 88. I know some of you personally, others I have yet to meet. To all of you, I would simply ask, why are we here in 2022? Why are we here in 2022? Why can't we honor our loved ones' wishes to avoid the extreme suffering of the last days of their life? This is not in God's hands any more than whether or not strep throat will kill you. We've used medical intervention to change the natural course of life for centuries. I was raised Catholic, and I can tell you that aid in dying is absolutely in line with my family's wishes, starting with my mom, who made it very clear to me that she didn't want to suffer near the end of her life. She specifically asked me to help expedite her death, but sadly, I could not honor her request. Each of my parents stopped eating and drinking after they became terminally ill. They simply had no desire for food, and the result was that we, as the family members, had to watch them starve to death. It was terrifying as we watched them experience confusion, frustration, anger, terrifying delusional visions, and terminal restlessness. All things that happen as your organs shut down due to malnutrition and dehydration. My father's terminal restlessness caused him to thrash about in the hospital bed so wildly that he broke a bone in his hand, which we were unable to repair or do anything about due to his unstable condition. So he lived with that pain for the remainder of his days. In his last days, he desperately described, these terminal visions that he was having, these delusions. He described seeing a hole open up in the floor and him falling into it, and he was absolutely terrified. My mother, during her terminal restlessness, tore out her catheter. Now, she had a full-time caregiver with her, and a catheter is something that is held in your bladder by a balloon and can only be removed unless the balloon is deflated. Imagine a balloon being yanked out in full force without being deflated. Her caregiver was there, but unable to prevent this from occurring. Hospice, they give you a pile of medications and a list of instructions, and they check on you a couple of times a day, but you're not you're not a medical professional.
Excuse me, Ms. Barbo, your time is almost up. If you please summarize. Thank you.
Okay. Have you read the obituaries that say the individual passed away peacefully, surrounded by family? This is a whitewashing of reality. You don't know what day or time your loved one is going to pass. You cannot know that. And having family surrounding them at the moment of death is a made-for-TV movie scene. It's not reality. I support SB 88 because I don't want to see another family go through the terror that I went through of watching their loved ones starve to death. This is not what my parents wanted, and it was torture in the true definition of the word. Please, legislators, listen to our pleas and pass this SB 88 for everyone in our state. Thank you.
Thank you so much for your testimony, and thank you for reliving your pain to share it with us. Next is Barbara Mancini, followed by Paula Panzarella. So Barbara Mancini.
Members of the committee, I'm Barbara Mancini of Philadelphia, and I support Senate Bill 88. I wrote a book entitled Cruel Death, Heartless Aftermath. It's a true story detailing how I was arrested and charged with aiding an attempted suicide for handing my dying 93-year-old father his legally prescribed morphine at his request. He was enrolled in home hospice care, but his pain was not properly managed, and he took much more than the recommended dose. When I told a hospice nurse what he'd done, she called 911. My father was breathing normally. He was able to follow commands and respond to questions. Yet, police ordered paramedics to take my father to the hospital for life-prolonging treatment, in complete defiance of his advance directive and his stated wishes. He endured 5 days of unwanted medical treatment, which tragically included mechanical ventilation and having his hands restrained. The anguish he experienced over my arrest compounded my father's misery. I endured a year-long prosecution before a judge rightly concluded that there was no merit to the charge against me, and the case was dismissed. While my ordeal occurred in Pennsylvania, similar prosecutions have happened in Connecticut. William Meyer of West Hartford, Harry Kiernan of Glastonbury, Hunt Williams of Cornwall, Thomas Meyer of Roxbury. They have previously told their stories to committees in the state legislature, and I have placed links to them in my written testimony. But the common thread in all these cases is that the people unjustly charged with crimes witnessed their loved ones' end-of-life suffering and agony. My family started that day in one place, and an indifferent and unjust system took my entire family to a harrowing place. That injustice could happen to any member of the committee or any of your constituents with a loved one, any one of them. Competent adults deserve options and agency at the end of life. Senate Bill 88 offers peace of mind and safeguards to the dying and their loved ones. I urge all committee members to read my story and to vote your support for Senate Bill 88. Thank you for allowing me to speak.
Thank you so much for your testimony. I wanted to thank you for staying within the time as well. Representative Steinberg.
Thank you, Mr. Chair. Barbara, thank you for your testimony today. I couldn't help but notice that you made mention of Bill Meyer, a former constituent of mine and colleague on Westport's representative town meeting. Frankly, Bill was the person who got me interested and educated on this subject when he asked me a good 10, 11 years ago to seek such legislation here in the state of Connecticut. Back in the day, his situation was front page news in the Hartford area because he was actually arrested and indicted for helping his father, who was apparently begging with him for assistance. And fortunately, that suit was dropped. But as you described, there are any number of instances right here in the state of Connecticut where people tried to do the right thing by their loved ones and found themselves arrested. And you don't have to be in absolute agreement with what we're trying to accomplish today to recognize that that is not an appropriate or fair outcome. And putting people in this kind of position where they want to help their loved ones, but are actually forbidden by law is problematic. But the one point I want to make, and this is a point that I think was mistakenly made by somebody who testified previously. You can't make a decision on behalf of your loved one. The loved one has to make the decision themselves. That's what this law is. No one else has agency to make that decision for you. We want to be clear on that point. Thank you, Mr. Chair.
Thank you, Representative Steinberg. Thank you so much for your testimony, Ms. Mancini. We will move on to the next step. I will have Barbara Panzarella speak, and I know after that on the list it's Ann Manuski, but I know Mr. Nicholas Bafundo had technical issues and could not come and speak, so he's finally been able to make it. So if Ann Manuski would give me permission later, we would love to have him speak before you so that we can clean up some of the technical issues that we've had earlier. With that, please, Ms. Panzarella, go ahead.
Thank you so much. My name is Paula Panzarella, and this hearing is one that many of us are grieving. It's very difficult and emotional on all sides of how we feel about SB 88. It's it's one that, listening to everybody, it brings back the flood of memories of the experiences that I've had. I've had 3 loved ones die. I was at their bedsides as they passed, one of liver cancer, one of COPD, congestive heart failure, and one of Alzheimer's. I was for 6 years, from 2014 till 2020, one of the 24-hour in-home caregivers for both my mother and my mother-in-law simultaneously. I'm against this bill, the Aid in Dying bill. I've seen so much, the medical system that we have now, pre-COVID. This is a system where there's not enough research for medical treatments, for ways to control pain for people, and there's far too many diseases that are still untreated. And long before the COVID pandemic, we have had overworked and understaffed caregivers, hospital workers, and family members have been, I have witnessed, both myself and with others, family members who were cajoled into disregarding their loved ones' wishes for treatment and told by doctors, well, this will only be one more hospital visit if we do treatment. You wouldn't let a dog suffer, would you? And why aren't you compassionate to your elder? Those were the words that doctors have said in the so-called family meetings, where they played siblings against each other to try to convince each other, well, no, this isn't the way it should be. Well, it should, it shouldn't. It's a very horrible time in the medical system, even probably worse now, where there's talk of care being rationed because things are so over the top. And I'm talking about pre-COVID times where that was going on. And for patients who were
Excuse
not
me,
in,
Ms. Panzarella, your time is almost up.
okay, for patients
Thank
who were
you.
not in pain, a little more than patients who were not in pain but needed treatment. The doctors were going against, wanted family members to go against the patient's own desires. So I just want to flip to 60, 70 years ago when it was considered acceptable in our society, when a doctor, OBGYN in the delivery room would see a baby that born that was not, quote, perfect, and tell the mother, oh, I'm very sorry, it was a stillborn. There was a large disrespect for the right for disabled people to even live. And so there's a lot of fear going in that the aid in
Thank you, Ms.
dying bill
Panzarella.
is going to lead to more disregard of life for others. And I really hope some of you ask me questions because I got incredibly tongue-tied, and I can talk a lot about hospice care and the Ativan morphine cocktail and the way people have been treated and what the aid in dying can mean with risks, you know, just as people
You, Ms.
can say,
Panzarella, for
I
your
choose not to
testimony.
wear a mask, it's my choice and my risk, that puts others at risk. And people who say, it is my life and I choose to end my life medically,
There's
and
a question for Ms.
that
Panzarella.
puts
Thank you so
others
much.
at risk.
Respecting others, we will just ask you to stop here. All right, moving on. I don't see any questions. We'll move on to the next person. I wanted to see if Ms. Minuski, it's okay. We can take Mr. Nicholas Bafundo before you. And Nicholas, go ahead if you could. And we've been trying to reach you earlier, and I think there were some technical issues. Mr. Bafundo. Going once, Mr. Bafundo. Well, you're here. Going twice. All right, I think going thrice. We'll come back to you, Ms. Minuski. Please go ahead. Ann Minuski. All right, Ann Minuski, you're next. All right, we'll move on to the next. Oh, no, you're there. Good.
Apologies. I'm also having technical difficulties.
We don't have enough bandwidth in the state right now to address all the emotions.
A bandwidth, yes, we need more of that. So good morning or good afternoon. Now I'm trying to get up my testimony. Good afternoon, Chairman Steinberg, Chairman Anwar, Chairman Adams, and members of the Public Health Committee. I begin to set with, I am so sorry to hear all those testifying today for they are still grieving for their loved ones. This is even more significant being that it is February of 2022 and that many of these individuals, I can only imagine, had to bury loved ones during COVID and could not be next to them, could not help them through their last time of life. I'm Ann Minuski. I'm the president of the Connecticut Republican Assembly, resident of Easton, Connecticut for 22 years, and also a former Connecticut licensed professional counselor. I'm very concerned with this bill. It's not about aid in dying. There's a fine line between suicide and aid in dying. We have palliative care in this state. We had palliative care almost 30 years ago when my own mother passed away. She passed away in Pennsylvania, but nonetheless, we have palliative care. And that's giving the right and dignity to those individuals who are in their final days, their final stages of life. And we should not do anything to subject a law in the state of Connecticut for aid in dying, which is really a suicide bill. Thank you.
Thank you so much for your testimony. Seeing no questions here at this time, we will move on to the next person on our list, which is Kyra Phillips, followed by PJ Schimmel. So Ms. Phillips.
Thank you. My name is Kira Phillips, and I'm here to talk about my mom, Claire Phillips, who died last year after a 3-year battle with multiple myeloma, which is a bone cancer. On June 3rd, she ended her life by shooting herself in the head in our backyard shed in the West End of Hartford. My dad, her husband of over 40 years, had to find her. The manner of my mom's death is unfathomable still, as she was the most peaceful, gentle, and kind person. She was the best mom I could ever have wished for. I was adopted from China as an infant, so every single privilege and opportunity I've been given in this life is thanks to her. To honor her, I'm speaking to you all today to advocate for my mom. She wished she could have utilized medical aid in dying and even discussed uprooting and moving to Vermont for 6 months. But the radiating spinal pain, chronic sickness, and fear she endured led her to desperation. The trauma that my dad and I have been affected by, from the 10 police officers and detective in our home that morning to having to hire a biohazard cleanup service, could have been avoided if medical aid in dying had been legal here. Losing a loved one to terminal illness is traumatic enough, even without prolonging suffering. Tragically, losing a loved one to terminal illness is also unavoidable for many families. However, losing a loved one with terminal illness to a violent and shocking suicide is avoidable, which is why I'm respectfully imploring you to please pass this bill. Thank you.
Thank you so much, Kara. Thank you for your courage to come and speak to us. And thank you for alluding to something that we have read in papers, we have known about and in other parts of the country, but also in Connecticut about the situation people find themselves in to make such difficult, drastic choices as well. And I'm so sorry for your loss. And thank you again for your courage. That hopefully will give us a glimpse into looking at all angles as we make our decisions. I have my colleague, Senator Haskell, who has raised his hand to ask you a question.
Thank you, Mr. Chair. And I just lowered my hand because you said everything I was going to say. I didn't have a question, Kira. I just wanted to thank you so much for sharing your story with our committee. We can't tell you how much we appreciate your candor and your honesty in reliving that terrible time. So thank you so much.
Thank you. Thank you, Kara. We'll move on to the next person. I don't see any other questions. Again, thank you from each and every one of us. Next person is PJ Schimmel, followed by Jim Tester. Mr. Schimmel.
Yes, my condolences to Kira, the previous speaker. My name is PJ Schimmel. I live in Norwalk. 5 years ago in April, my beloved wife, Morgan Zale, passed away. We had been together 36 years, and her death left a hole in my heart. She had been diagnosed with ovarian cancer in January, 7 years previous. In July of 2016, we were told that it had spread and she had only 3 to 8 months left to live. She was at peace with dying, though, even happy with the death sentence, because she suffered from several other conditions and her quality of life was low. She did not die of natural causes. She took her own life by VSED, voluntary stopping eating and drinking. She chose this course because she thought it was the only way left to her. She had no stomach for violent suicide, but she had tried to overdose in October on a mixture of drugs and alcohol. She had a very high tolerance for drugs, as it turned out, because after one of the saddest nights in my life, she was alive in the morning. I made her promise not to try any other methods that might leave her brain damaged, but not dead. She would have loved to travel to Vermont and take advantage of their right to die law, but her mental and physical conditions ruled that out. Watching her die of VSED, first at home and then at hospice, was one of the hardest things I have done. She lasted for 23 days without water or food. Seeing someone shrivel up and die of thirst is inhumane, but it was her wish, and I respected her decision, though it tortured me. She was a very strong-willed woman. I told everyone I met at hospice I would be there to testify when a right to die law came up in Connecticut. And I have been. This is, I think, my 4th time. Morgan wanted that law badly. Please help change the situation. Thank you.
Thank you so much. And I'm sorry you've had to relive your pain so many times. And we are hoping that we will not have to have you come again and testify if this committee moves forward with the decisions. Thank you again. I don't see any questions from anyone, so we'll move on to our next person on our list. It's Mr. Jim Tester, followed by Jeffrey Gardere. Mr. Tester. I don't see Mr. Tester here right now, so we'll move on to Jeffrey Gardere, followed by Reverend Canon Joe Estrada.
Thank you. Hello, everyone. Good day, Chair Steinberg, Anwar, Vice Chairs, Ranking Members, members of the Public Health Committee. My name is Jeff Gardere, as you know. I'm a board-certified clinical psychologist and an ordained minister, a professor at 2 medical schools, and I want to thank you, committee, for the opportunity to testify in front of you today and for having the courage to vote in support of similar legislation last year. I know that you've heard some testimony where there has been some conflation, in my humble opinion, of aid in dying and suicide, and you may be contemplating your own views about this and concerned about the interplay between these 2 issues. I want you to consider the following distinctions when you think about balancing your thoughts on medical aid in dying and concerns about suicide. Medical aid in dying is not suicide. For example, suicide is often carried out alone and in secrecy. Death is often violent and has a traumatic impact on families and communities. In contrast, medical aid in dying allows for a peaceful death at home where chosen loved ones can be present. Proper intervention can prevent suicide. Prohibiting medical aid in dying will not prevent death. It prolongs end-of-life suffering. And there are many factors that can lead to suicide, including mental health conditions, which likely renders them ineligible for medical aid in dying. And there is only one factor that can lead to medical aid in dying, and that is incurable terminal illness. And terminally ill individuals who do qualify and receive a prescription for aid in dying medication have been determined eligible by at least 2 medical providers who have found them capable of making their own medical decisions. So again, medical aid in dying is not suicide. And you don't have to take my word for it, even though I've been a practicing psychologist for 35 years. The American Association of Suicidology, an organization dedicated to preventing suicide, it issued a position statement in 2017 outlining 15 reasons why medical aid in dying is distinct from suicide. So in conclusion, lawmakers who are committed to reducing the incidence of suicide in their communities can support Senate Bill 88, the Aid in Dying for Terminally Ill Patients Act, without compromising their commitment to suicide prevention, which will allow qualified terminally ill adults to consult with their own trusted healthcare professionals to make decisions that are best for them and their families at the end of their lives. And I thank you for the time that you've given me. And thank you to everyone who has come before me, no matter what their opinion has been on medical aid in dying.
Thank you so much for your testimony. Can I ask a question? And you mentioned you're part of 2 medical schools. Do you think we can do a better job in medical schools for end-of-life care and understanding some of those aspects?
Yes, Senator Anwar, I think we can. And one of the things that I've started doing at the medical schools is in teaching end-of-life care issues. We see that there is a disparity, for example, with regard to advanced directives, especially with Black and Brown people. And so they don't have that kind of information or encourage or even trust the medical system enough to know about all of the options that may be available to them. So my work with medical students has been not only teaching them about cultural sensitivity and cultural competence and behavioral medicine, but also all of the different factors that come into the positives about medical aid in dying and the difference, of course, between suicide and medical aid in dying. There's not enough being done in medical schools. Thank you for that question. We can all do more. And I guarantee you, I will also do more.
Thank you so much. Anyone else has any questions? Because you're also part of the Compassionate Choices, I wanted to just ask you another question. There is an anxiety of the people who are in terminal illness, but there's an anxiety in the vulnerable in the community who have felt that they are not treated fairly. How, with yours wearing a psychology hat, how do we reconcile and then how are there protections in the bill?
Well, I think it's very important that people understand that we have not seen in the other states where the bill has been passed and where medical aid in dying has now become a medical practice and treatment, as a matter of fact, that there has been no overreach or overuse or any documented cases of someone abusing this. That's number one. But number two, even specific to your question, Senator, is the fact that, yes, there is an anxiety in the community. And I think a lot of that comes from the confusion as to what medical aid in dying is. Again, people conflating suicide and medical aid in dying. But I think a lot of it also, as a psychologist, people are afraid to talk about the end of life. They try to push that onto a geriatric population, when in fact, this is something that we all need to be involved in, not just as families, but also as a community. So what you are doing is very admirable in that you are opening a dialogue for everyone, no matter what their opinion may be about medical aid in dying, because it is a catharsis to be able to express what is on their hearts and minds, and for us to try to come together as a community in order to be there for people who are at the end of life.
Thank you so much. And I have Representative Burger Giovanni who has a question.
Thank you so much, Mr. Chair. You made a point about, how did you phrase it? Education on end-of-life care in communities of color. Could you actually speak to that a little bit more? Could you explain what you mean by the education?
Yes, certainly. One of the things that we know is that with Black and Brown populations, there are various health disparities. And we have found in working with Compassion and Choices that another health disparity is end-of-life information, especially when it comes to setting up living wills, having a health proxy, knowing about all the things that they should know about advanced directives. So what we've done, because the clergy, as in many communities, but in the Black and Brown community, holds a very special place with regard to leadership, that we have actually reached out not only to Black and Brown populations, but also to the clergy of the different religions within the Black and Brown population, Christian, Muslim, Jewish, to be able to get them to educate that community with regard to end-of-life care disparities. And as we talked about, in the medical schools, the medical school where I work, I make sure that when we talk about cultural sensitivity and cultural competence in working with underserved communities, that the future pharmacists, future physicians are able to learn how to build a better relationship with their patients so that they can educate them as to the importance of knowing about end-of-life treatment, and as well working with attorneys around encouraging people and having relationships with their clients and bringing up things such as having a living will.
I really appreciate that. The idea of educating to educate is critical here. So thank you.
Thank you.
Thank you. Thank you so much for your testimony and your time. We'll move on to the next person on our list, which is Mary Beth Abrams, followed by Kim Callanan. So Ms. Abrams.
Great. Can you see me?
Very well.
Great.
Yes.
My name is Mary Beth Abrams from Glastonbury, Connecticut, and I support SB 88. I'd like to show this picture. I don't know if it can be seen. It's a picture of me and one of my closest friends in the world, Kim Hoffman, who fought for aid in dying for years leading up to her death last month from cancer. But instead of talking about that, I'm going to focus instead on something universal, something that every single one of us here today has in common, and that is that we are all going to die. Some of us are going to die suddenly from an accident or some fatality, but many of us are going to know with certainty that our lives are rolling toward the end. And right now, none of us know how we're really going to feel when that time comes. We don't know what's going to be right for us. We don't know what our personal truth is going to be at that time. Today, we're taking turns saying what we think is right for people at the end of their lives. But I propose an alternative. Instead of arguing over who's right or wrong, let's proceed in a manner that respects each Connecticut resident's own truth regarding the end of their life. Given the fact that 75% of Connecticut residents support aid in dying, here's what respecting each other's truths might look like. In a state that respects each other's truths, the Catholic priest whose teachings prohibit aid in dying counsels his followers to steer clear of the practice. And in this same state, the Unitarian Universalist minister or the rabbi or the Christian or other religious leader can support their followers whose truths align with aid in dying. In a state that respects each other's truths, people with disabilities, 65% of whom support aid in dying, can speak for themselves with autonomy should they desire this practice, rather than be spoken for by certain leaders in their movement who are against the practice, not only for themselves, but for everyone. My friend Kim wanted the option of aid in dying because years earlier, she watched her mother die from cancer in extreme, agonizing pain because the morphine didn't work. And Kim was afraid that the same thing would happen to her. Something that I've learned is not uncommon, by the way. She had a lot of anxiety about this, and that's why she wanted the safety net of just knowing that those meds were available, just in case her pain got too intense. I don't know if Kim would have actually taken the meds. We'll never know because they weren't available. But this I do know. Had the option been there, the anxiety that consumed her at the end of her life would have been replaced with peace of mind. So let's not kid ourselves here. None of us know what our personal
Ms.
truth
Abrams,
is.
I'm sorry, your time is almost up. If you've
None of
summarized.
us know what our personal truth is going to be as we approach death. And we sure as heck don't know what it's going to be for the other 3.5 million Connecticut residents. But we can create legislation that respects each other's deeply personal truths, the same way that every single one of us here is going to want others to do for us when our time comes. Thank you.
Thank you so much for your testimony, and thank you for sharing about your friend Kim as well. Thank you. And I'm seeing no questions. We're going to move on to our next person on our list, which is Kim Callanan, followed by Tolly Miller. Ms. Callanan, thank you for your testimony.
Thank you. My name is Kim Callanan. Good morning or good afternoon at this point, members of the committee. I lead Compassion and Choices and the Compassion and Choices Action Network. And we work to improve end-of-life care, including hospice, palliative care, and medical aid in dying. So I can speak firsthand to the impact, the positive impact that passage of a bill such as this has in the other authorized states. Since Kim Hoffman has come up so many times, I wanted to be sure that people were aware that conservative columnist George Will featured her in a recent medical aid in dying article in the Washington Post. I would encourage you to look at it if you have not. It was a very powerful two-part series that I think addresses many of the questions that have come before this committee. I also wanted to address some of the statistics that have come forward. So about a little over 8,000 people have across all of the authorized jurisdictions, 10 states and Washington, D.C., in the time, 24 years since Oregon's been passed. Only 8,200 people have filled a prescription and about 5,100 have died ingesting it. So we're talking about a really small number of people. There was a conference that the National Academy of Science put together a couple of years ago, and a number of doctors came to that. And what the universal consensus was that the law worked to protect vulnerable populations, and that you really had to be an advocate for yourself to get through this 13-step process. So you have more than enough regulations in place in order to protect vulnerable populations. There's been a lot of conversations about if we could make hospice and palliative care better, that maybe then the need for this would go away. What I will say is that for the patients who want this as an option, it's not about a failure of hospice and palliative care. It's about that people have had the autonomy to make their own healthcare decisions their entire life. And now they're at their death, and all of a sudden the government is stripping away this final right that they're able to exercise. That, coupled with the fact that that prescription serves as peace of mind for them, is what they're looking for. The best hospice and palliative care can't solve that. People want this as an option, a very small number, but it is important for those people who really want it. And we know that when the law gets implemented, it improves hospice care and palliative care with better conversations between doctors and patients. So this is an opportunity to improve hospice and palliative care for everybody. It's not an either or, they work together.
Ms. Callahan, your time is almost up if you'd
Okay.
summarize. Thank you.
Great. I'll just sum by saying 85% of the people who choose this option are on hospice and palliative care, and they get tremendous peace of mind. Thank you for the opportunity to be here.
Thank you for your testimony. I have Representative Carpino who has a question for you.
Sure.
You're muted, Representative Carpino.
There we go, technical difficulties. I just have one question about compassion and choices, and I do appreciate that you spoke early on about choices. Does the organization have any agenda items or priorities associated with improving palliative care or hospice other than the medically induced death that we're talking about? Because I was on your website and I didn't see them pop up quickly.
We do actually, and I have 2 o'clock, I'm going on a call with a federal congressional briefing. But yes, we have, we support a federal policy agenda and have for quite some time, where there are a number of pieces of federal legislation that we've tried to advance to improve hospice and palliative care, to improve advanced directives and advanced care planning. So that is all a part of the work that we do.
Great, that's wonderful. But since we're here at the state level, that would be helpful for at least for myself being on this committee for a number of years and having had this conversation a number of times to learn more about. So if you could send either to the committee clerk or to one of the members or myself, I'm happy to share that. I'd love to learn a little bit more about your state initiatives about hospice and improving palliative care, since we're talking about state issues today, not federal.
Well, so the way that hospice, just to clarify, the way that hospice is paid for is through Medicare and Medicaid. So when we're working to improve it at the federal level, it benefits every state. And that's, part of what we're doing. So we don't have the capacity or the resources to go state by state and lobby for changes. We're lobbying for improvements that would benefit every state.
I understand exactly how it's funding, so I would appreciate hearing more about the choices that the organization is advocating for. Thank you.
Sure. Thank you.
Thank you. Next question is from Representative Burgos-Ualo.
Thank you once again for your time. First of all, I just want to take an opportunity to say so many of my colleagues are reaching out right now to say that there are so many really brave people telling their stories, and I just wanted a moment to acknowledge that. Directing to you now, Kim, does passage of aid and dying laws, because we hear this a lot from not just opposition, but people who are genuinely concerned, does this lead to refusals by insurance companies, life insurance companies?
No, there's actually a provision in the legislation that specifically says that you can't deny life insurance for a person who takes this as an option. But in addition to that, in all of the years that I've seen us advocating for this, the life insurance companies have never opposed it. We've actually had in some states quite a few come and testify in favor. What they basically say is the person's already going to die. They have a 6-month prognosis. It doesn't make a difference to them if they die a more compassionate death or if they die a natural death. It's the same payout for them.
I really appreciate you clearing that up. Thank you so much.
Thank you. And the next question is from Representative Cabras de Gra.
I guess I'm curious in terms of there's some question as to the actual process of this at the end. I know some people have said you have to take 90 pills or there's a procedural question as to how it actually takes place when someone is able to access medical aid in dying. Could you talk a little bit about that process?
Sure. So it starts where the person has to make the request themselves multiple times. And in the Connecticut bill, it's 2 written requests now. And they find their first doctor. And that's actually not an easy process. A person will start with their own doctor and hopefully that doctor will be supportive, but they may not. But they find the first doctor and then they have to get a second doctor that also confirms the prognosis. There's the written requests, and then you also have to have the witness forms that people fill out. So that whole process to get through is about 13 steps. And at the shortest, I mean, if a person lines it up in advance, has the doctor, waits the 15 days in between, the shortest that it's going to take someone to get through is 15 days. However, what we know from most states is from the time you get your first doctor's appointment, it's typically taking more like a month. And it could take someone several months in order to find that first doctor. People who know they want this option in advance are lining it up and are kind of ready, but otherwise it could take months. And as Representative Steinberg mentioned, many people unfortunately don't get through the process. So you get through the whole process, the prescription gets sent in, you pick up the prescription. A lot of people, about a third of people don't ever fill the prescription, but getting that prescription gives them peace of mind. When the time comes to fill the prescription, now it's not 60 pills. So that was way back in the day, it was 60 pills and you kind of undid them all yourself. But now the medication is given in a vial and you're mixing it with a small amount of liquid. So you're just taking something out, mixing it with liquid, stirring it up, and then the person has to drink it. And often at that point it's out of a straw because often they're not able to drink, but it just depends on what's wrong with the person. And then of course it's different, there's different medications for different people. It's just like any other medical procedure. So that's kind of, I would say, the vast majority of people, that's what it would look like.
Thank you for clarifying that, to just be sure we're all on the same page as to what it actually looks like. Thank you.
Yeah. And I should say most people fall asleep in about 30 minutes. And then the vast majority of people have died very peacefully in about 2 hours.
Thank you so much. Next is a question from Representative Gilchrist.
Thank you, Mr. Chair, and thank you so much, Kim, for being here and for your advocacy. I in no way equate this to suicide. I do see it as a compassionate choice. That said, we've heard from folks today who are speaking about this in those terms. And so want to know, based on your knowledge of what's happening in other states, has passage of this policy in any way increased suicide in those other states?
No, I mean, there's been absolutely no increase in suicide. And there have been some studies that actually demonstrate that there has been a reduction in people having violent suicides, like I think it was Kira who spoke about the really tragic thing that happened. So there was one study that came out of Oregon in the early years that showed that within like assisted suicides that you had a decrease in violent suicides that went down. But it was one study, it hasn't been thoroughly studied, but there's no evidence that this increases suicide in any way. And I will say the difference, the impact on the family, there was a few people who came and spoke earlier about how, the difference it is with a natural death versus, medical aid and dying. And I will say that that person has never been and experienced what medical aid and dying is all about, because this is an option that brings families together. They are going through the grief process in advance of somebody dying. They're having frank conversations about it. And there was another study that's been done that really shows that while everybody grieves when they lose a loved one, that people who, families that have been with loved ones through the medical aid and dying experience are grieving in a far less, because they had that closure and the completeness and the ability to say goodbye.
Thank you so much. Thank you, Mr. Chair.
Thank you. The next question is from Representative Claire Desdietra.
Thank you, Mr. Chairman. I have a couple of questions in regards to what happens to these medications if someone chooses not to use them. Is there a follow-up procedure? Does this go into a database where we're guaranteed that these meds will be returned either to a pharmacy, to the prescribing physician, or to a drug take-back program?
Yeah, so first of all, most people don't fill the prescription until they're ready to use it. So that prescription is peace of mind, but they're not actually filling the prescription until it gets used. But the drugs follow all the same protocols that, I mean, at the end of life, people are shipped tons of morphine and stuff with hospice. So there are every state and the DEA has drug take back programs, and the drugs are just delivered back as a part of those programs.
I understand we have the programs, but where's the check and balance of it? Because you've been prescribed your cocktail, your whatever it is you're going to take, you don't use it, you passed away. Who's to say where that medication goes after that? I mean, we hope the family would then take it and return it or dispose of it, but we have no guarantees what's going to happen with that medicine.
So I would say it follows the same process. It's no different. Families at the end of life are shipped buckets of morphine as a part of hospice. So whatever system Connecticut has to protect people for all of medical care is the same process that would happen for this. It's no different. So if you have concerns, this legislation should follow the standard of medical practice. I mean, at the end of life, if you've ever had someone or been a part of hospice care, but people have access to tons and tons of deadly drugs, and hospice takes them away in some states. In other states, they're put through drug take back programs, but the same process is followed with medical even dying. And I will say, in the other states, there has not been an issue. There has not been overdoses. There hasn't been anybody else using the medication. So, I understand where the concern is coming from, but it has not come out to be a problem in any of the other authorized states.
Okay, thank you. Thank you for answering my questions. Thank you, Mr. Chair.
Thank you so much. I think Representative Clarice Dieter asked one of the questions, have there been instances of unintentional overdoses by the medicines lying around? That was one question I had, and I think you just answered that that's not been the case. Can you just speak about the slippery slope? Because a lot of people have made the slippery slope argument. If you can clarify that. And you touched on the 13 steps as well in your testimony. Could you allude further on that?
Sure. Just in terms of the one other thing to add in terms of the medication and whether anyone has ever taken it, it's got a very bitter taste. And you have to take first something to hold the medication down, an anti-nausea, and then the medication, and you have to drink it all within a small period of time. So someone can't accidentally overdose on it. Like, it would be very hard for that to happen. So I did want to just add that into it. In terms of the 13-step process, so it's finding your first doctor, it's doing your written request, getting your multiple witness signatures, going to a second doctor, multiple witness signatures, going to the waiting the 15 days, going back to the doctor to do the final confirmation, but by the phone, then getting the pharmacist to go, and then picking up the prescription from the pharmacy. So it's a really, really rigorous process to have to get to. And we have to keep in mind that the person is terminally ill. So if you think about how hard it is for a person to just get a single doctor's appointment just in your normal life when you're healthy, you have to add on to that the fact that this person is terminally ill and they're having to go and make these appointments themselves or with the support of a loved one and make these requests over and over again. It's pretty tough. Like, someone has to really want this for it to happen. The idea that it could happen or that there's abuse or coercion is just really hard. The other thing that I would just add to is there was a lot of conversation about vulnerable populations. And I will say that this actually has far greater protections for them. If you think about our current end-of-life care system, this is putting the decision in the hands of the person. The person has to make the request multiple times. But if you think about how all other medication is done, if you're talking about palliative sedation, or you're talking about the delivery of pain medication, those are third parties making decisions. Even with an advanced directive, it's a third party making a decision on behalf of a person. So this has far greater protections because it only happens if the person makes the decision themselves. The person has to be able to take the medication themselves. So it really offers more protections within our healthcare system. And then your last question was,
slippery slope.
The slippery slope. Yeah. So, we have not seen a slippery slope here in the United States. I mean, first of all, a slippery slope is a fallacy because, we have a legislative body that everybody has to go in front in order to pass laws. And that's, how things work. So in terms of, there being any slippery slope for something to change, a person would need to come back before a legislative body for there to be changes to be made, which would have to consider them and decide that that's what they wanted. So that's, important to keep in mind. But in addition to that, the law's been in effect in Oregon for 24 years, and it's the same eligibility criteria that have been in place from the beginning till now. It's, a person has to be mentally capable, terminally ill, a prognosis of 6 months or less to live, and able to take the medication themselves. And that's been true for the past 24 years. And that's kind of the legislation that's advancing across this country. So I think the slippery slope is a fallacy. Both it hasn't been a reality here in the United States, but it also, the idea of a slippery slope in and of itself is a fallacy, because we have a legislative process that is considering what's in the best interest of constituents.
Thank you so much for your testimony. This was very helpful. I'm just going to ask one more question. I heard a number which said something like 76% were on hospice. I would have expected many more people to be on hospice before they would have asked.
It's 86% that are on hospice. And the reason actually that the remaining people are not on hospice is because they don't want to have to agree to forego treatments. So when you go on hospice care, as you know, because you're a doctor, you have to be willing to give up all treatments. And you still have a percentage of people who want the option of medical aid in dying, but want to try that one last treatment. And so actually, Brittany Menard, one of the most well-known cases, was an example of this. She was young. She knew she was going to die. There weren't options left, but she tried several clinical trials. And so she didn't want to give up on those clinical trials. So she got medical aid in dying, and she also continued. And part of why she wanted medical aid in dying was so that she could try that last treatment option and know that if that resulted in more pain and suffering, she had an option.
That last piece is even more profound, because it tells us the insight of a lot of people that they were still hoping to get a miracle cure, but they were also had that anxiety that if it doesn't work, that they have an option not to suffer at the end. And okay, this is very helpful. I truly appreciate you. It helped me also understand a number of nuances of some of these aspects. I appreciate that. Thank you for your testimony.
Yeah,
and
thanks for having me here today.
And the next person on our list is Tolly Miller, followed by Tim Appleton. Mr. Miller.
Hello. Members of the Public Health Committee, my name is Tolly Miller, and I'm testifying in support of SB 88. This is my 6th time testifying. I want to thank you all for your effort last year to, after 27 years, to finally report this bill out of committee. I hope that you and your fellow legislators can take it all the way to getting adopted this year. Too many people have waited too long, many dying without this option available. I'm just going to comment on a couple of my own personal experiences. I attended the death of a dear friend, Earlene Robinson, back in 2003, and her death taught me that even the best palliative care is not effective always. As a primary caretaker in her last few months, I watched her pain increase to excruciating levels. A fine hospice program was involved, and everything possible was done to alleviate her pain. However, once her kidney cancer had spread to her bones, the pain could not be controlled. I held her hand often as she screamed in agony, because her bones had become so porous that they would break when she even moved in bed. She was taken to a hospital through the hospice, given a direct line to bring pain meds to her as powerfully as possible, but her last 48 hours, she was still moaning and screaming in pain. The experience was shattering for me, her friends, and family. Even the hospice personnel acknowledged that there are cases where pain control is just not possible. While I have tremendous respect for hospice programs and palliative care staff that I've worked with, I learned that palliative care is not always able to control the worst pain. Then secondly, my beloved sister, Kate Miller, succumbed to ALS 1 year ago. When she was diagnosed, we talked about what she would need to do to have some control over her own dying. We talked about moving to Vermont, but it's simply not a reasonable option to leave one's family, friends, and doctors and you need to be close to home. She was tremendously courageous through her illness, but I know she would have had much less stress and fear about her own dying process if Connecticut had this legislation in place. She was at home on hospice care, but as others have testified, this did not mean someone from hospice was always there. The family became her caretakers, with her daughters giving her the morphine doses by injection as directed. In the end, her only choice was to stop water and nutrition to hasten her death, and that's not an easy way to die. In such unfortunate and dire situations as I've experienced firsthand, I don't want anyone telling me that I have no option but to suffer. That is both cruel and disrespectful. My God is merciful and compassionate. There's nothing edifying or peaceful about dying in excruciating pain. More than 75% of my fellow Connecticut citizens believe that this choice should be in our own hands. I urge you to support this critical legislation. Thank you, and I'm happy to answer any questions.
Thank you so much for your testimony. And seeing no questions, we'll move on to the next person on our list, which is Mr. Tim Appleton, followed by Christopher Rossetti. So, Mr. Appleton.
Good morning or good afternoon, chairs and members of the Public Health Committee. My name is Tim Appleton from South Windsor, Connecticut. I serve as campaign director for Compassion Choices Action Network, and I'm here today to lift the voices of tens of thousands of Connecticut supporters who seek expanded options at end of life, including aid in dying. I want to thank the members of the committee for raising this bill again this year and for creating this space today to hear the stories of our supporters at this hearing. One of the people you heard from last year, of course, we've heard her today, was Kim Hoffman. We've heard about her today, and Kim Hoffman, who spoke powerfully about the need for change, and that for people facing terminal illness like her, the status quo was simply not enough. Kim was so very many things to so very many people. She was a musician, a teacher, a guidance counselor, a social worker, and a coach, and so very much more. She was also living with stage 4 ovarian cancer. She told the committee last year, "I don't want sympathy." She simply wanted compassion with more options at end of life. And she was so thankful this committee heard her testimony and that of so many others and released this bill last year. As we know, however, the General Assembly was unsuccessful in its efforts to pass last year's bill, and here we are again for another year. One afternoon, Kim called me and she said she was on her way to meet with a leading opponent of aid in dying, someone who's already testified today. At her core, she was a social worker, and she always wanted to meet people where they were at, and I sure admired her for it. She called me 90 minutes later, very shaken, because this person suggested Kim could recklessly end her life using existing medications already prescribed to her, which would put her, her family, and others at great legal, physical, and emotional risk. This was deeply wounding to Kim. She said, "I don't understand how this person can fight against a legal means to end suffering and then look that same person in the eye and say, roll the dice and do it on your own." Kim said, "It's such an extreme level of hypocrisy and cruelty. I cannot make peace with it," she concluded. Within a month or so of that terrible experience, on January 18th, Kim died without this option, as you've already heard, after a difficult, painful journey. Although too late for Kim, the passage of this bill will certainly end the cruelty for people on difficult end-of-life journeys who are faced with rolling the dice, as suggested by some opponents, or needless pain and suffering as Kim had to endure. The state must do better. We can protect vulnerable populations. We can expand palliative and hospice care.
Mr. Appleton, I'm sorry, your time is almost up. If you would summarize. Thank you.
Yeah, sure. And we can offer aid in dying for people faced with terminal illness like Kim. Of course, it would be Kim's great hope this committee will again vote to release this bill. And although too late for Kim, not one more person will die as a result of the passage of this legislation, but far fewer like Kim will suffer. Thanks.
Thank you so much, Mr. Appleton, for your testimony. I have some questions from my colleagues. I have Representative Berger Giovanni for the question for you.
Thank you once again, Mr. Chair. Tim, thank you very much for your testimony, and particularly the story about Kim. It's disturbing, to say the least, to hear that that was offered as an option. Earlier testimonies have used statistics from Canada and the Netherlands to argue against the safety, efficacy, and legitimacy of this proposed legislation. Can you differentiate, for example, on the 2.5%, I think was claimed, deaths in Canada being euthanasia and the general distrust of the Dutch legislation? Can you contrast that with the realities of the existing laws here in the States, as well as with the proposed bill specifically here in Connecticut?
Thank you for the great question, Representative. When you were asking it, I was thinking about my grandmother, who often said, Europe and Canada are great places to visit, but I wouldn't want to live there. And in this particular case, the laws in effect in those countries are so much more permissive without the safeguards that exist in the United States laws that we're proposing here, that are across the United States and what we're proposing here in Connecticut. In those countries, chronic illness is considered a reason that you can access aid in dying laws. Of course, what we're describing here in Connecticut and across the country is that you have to have a terminal illness. A chronic illness is not a terminal illness, and that's the big distinction. And when opponents of aid in dying try to make these comparisons, they do so, I guess, to try to scare people, but it's not an apples to apples comparison. And like I said before, like I said before, they're very different laws. Our organization does not support laws like that, and we would never support those laws. And that's why the numbers are different.
Thank you for that. The apples to apples is important, and we have 20 plus years of history in the Oregon bill, the Oregon law. So that's certainly where we should begin to look when we're looking for.
I'd also add, would bolster what previous testifiers said before. In the entire history of this law, so very, very few people are able to, as just testified before, can go through the rigorous set of safeguards and successfully access the law. We're talking about a very, very small group of people who are seeking just one more option at end of life. Whether they choose to avail themselves of that option is completely up to them. But having the option provides great comfort to those who are faced with terminal illness.
Thank you. I'll let my colleagues take over with questioning. Appreciate your time.
Thank you so much. Thank you. Representative Foster.
Thank you so much for joining us today. This has become quite a contentious issue in my district. Lots of people sending me emails supporting and against. And what I find myself really compelled to communicate on is that the majority of folks who are in contact with me are carrying on what they believe is the legacy of a loved one that they've lost and the way that they've experienced life after the loss of that loved one. I have 3 constituents who have been sending me messages and emails throughout the day today, watching, saying, that's exactly what we saw, and it was terrible, and I wouldn't wish that on anyone, and that's exactly what a loved one went through. And I know some of my colleagues also have experienced watching the painful and suffering deaths at end of life of their loved ones. Do you think that there's any room, or would you recommend that there's any room or place for compromise in this? And how does this bill do that? Like, what do you think the safeguards are in place that make this a compromise that, the people who feel the fear of the slippery slope argument I know we're talking about, that we can sort of assuage those concerns, but also support those who really feel like this is the best way to honor the legacy of a loved one that they lost with a painful experience?
That's a great question, Representative. And I really want to thank you for recognizing that for so many people that have preceded me in testifying, what they've been asked to do, and as Representative Steinberg correctly said, this is part of the process, is to open up wounds that have yet to even fully heal. And for many of them, it's profoundly difficult, and they are so very brave to do so. And I so very much appreciate that. To your question about compromise, I would say that, as I said in my testimony, in states where aid in dying is authorized, like New Jersey, like Maine, like Vermont, states nearby to us, they have been able to figure out a way to protect vulnerable populations, to expand and help assist in more expansion of hospice and palliative care, as well as offering this one more option. And if the compromise exists, it's that we can do all of those things. We just need to have the political will to pass this law here in our state. And you have heard, you've heard today, person after person after person testify before this committee this year and last year and in other years. And they've made it very clear that the status quo for their families, for their loved ones, and for themselves, like for Kim last year, right? And for Mike Mazzone previous years. And prior to Mike, another beautiful soul, and Sarah Myers. These are all people who came before this committee that I got to know very well, who all died without this option, right? So I think we can do we should do all of those things that our opponents suggest. We should protect vulnerable populations, and we should expand hospice and palliative care. But we should also offer aid in dying. And, to my mind, Representative, that's the compromise. And then we would all benefit.
What I am sort of hearken to is that for so many people who have reached out to me after the bill died in judiciary last year, I have one constituent in particular whose mother passed, and he told me, "You failed my mom." And she suffered because the political will was lacking. And his experience was so painful to me to hear. And I can't even imagine for him to experience. But I just wonder, and I feel like you could quantify, how many people come to your organization to support your advocacy, but who aren't ready to open their wounds and share this publicly?
Thank you. Big part of my work is to support people who spend their final days advocating, like Kim. And another part of it is to provide supports for people who, as I said before, literally opened up wounds today. Some of the people that have testified today were helping in other ways and could never get to a place where they would have the courage to do what we're asking them to do today, to testify, because those wounds were so painful. And when they find that courage and they stand in their truth and share it with a legislative body like this one, filled with people who just want to do the right thing, whether you support aid in dying or not. I know that you didn't get elected to, do things wrong and, make bad choices. Everyone is trying to do the right thing. For them, it is such a powerful experience for them. And it's my hope that it furthers them along. Their testimonies would somehow further them along in the stages of grief that they're suffering. Some people I speak with, Representative, will describe an experience that happened 30 years ago as if it happened 3 days ago. And it's so powerful. And it's so deeply meaningful that they share these experiences of their final days with a loved one and put their trust in us to do so.
Thank you so much, Representative Foster. Thank you, Mr. Appleton, for answering some of those cool questions. Next is Representative Kavros-Tikeraw.
Thank you, Dr. Anwar, and thank you very much, Tim, for being here. And it sort of is a follow-up, honestly, to what Rep. Foster was talking about. Some of the emails that I think my colleagues and I have received have talked a lot about why do this now. We have just come off of nearly 1 million deaths nationally with COVID. We have a lot of people struggling with the grief of having lost a loved one who, despite the best efforts of our doctors and nurses, who probably were there in their final moments, the family members were not there in their final moments. I think there's, with all the mental health concerns around children, there's a lot of why would we pass this now? I think even a further concern, sort of related but unrelated is, shopping doctors. Like if someone wants to get this done and doesn't get the answer they want, that they could somehow, move on to other healthcare professionals to try to get it. Could you just speak to those concerns?
Sure. I guess I feel we are all of us, if this were 2 years ago, would be together having this conversation, Representative. We wouldn't be doing this via Zoom, and we wouldn't have the struggles with technology that many of us, including myself, have faced. I guess we have heard people say, of course, that, oh, now is not the time. And I guess my answer, I have a couple answers. Well, when would be the time? And especially for someone, there will be people testifying later on today who are faced with terminal cancers and need this option now. They will not have the ability, likely, to come back and testify before a public health committee next year. That is just a fact. And we've seen that over and over and over again. So, I would, one way I would answer it would be, when would be the time? I think now is the time, because what's clear, and I'm sure so many agree, that the pandemic has laid bare the profound tragedy of loved ones dying alone without the care and comfort of family members surrounding them. And what Aid in Dying does is, for a certain set of terminally ill, mentally capable people, avoids that completely. Now, I want to make sure, Representative, because I want, words are important, that someone who has COVID-19, because of the such aggressive illness that is, they would likely, most of them, although I'm not a physician, would not likely qualify for Aid in Dying at all, because the safeguards that exist. So I want to make, yes, it is laid bare the exactly what we don't want at the end of our lives. And we've seen it over and over and over on the news over the last 18 months, haven't we? Where it's a tough one, because my daughter is a nurse at an emergency department and has held the phone up to patients suffering with that illness, COVID-19, for their last words from a family member distant. And that's rough, isn't it? And we've heard that story before. And I never thought that, my kid, who's, now 23, 24 years old, would be doing that as a job. But that's what we've asked our healthcare providers to do. And that's terrible. For a certain set of patients, people like Kim Hoffman, people like Linda Bluestein, who will testify later on today, that can be all avoided.
Thank you so much. Thank you, Representative Cabral.
I'm sorry, Senator, was there another question? I think there was regarding.
I would say I'm only allowed one, but I had just sort of wrapped in the concern about doctor shopping. So.
Oh, yeah. Well, as Kim Callanan testified previously, it is very, very difficult to access Aid in Dying in the first place. And I know I'm not terminally ill, but I was referred to a ear, nose, and throat physician who couldn't see me for another 6 months. So for someone who is faced with a terminal illness with less than 6 months to live, who is, perhaps months or days away from death, the simple fact is that the illness that is killing these people far outstrips the ability for even for a patient to doctor shop at all. And, we've seen this. That would be a very, perhaps a valid concern if this were a debate we were having 24 years ago, in Oregon. This is some of the concerns they've had. But the experience in Oregon and other states has proved the concerns about this, as well as just about, as well as the other concerns opponents raise, has been completely unfounded. Thank you for your questions.
Thank you so much. Tim, again, I wanted you to clarify this further, because one of my colleagues gave a testimony saying that my colleague felt comfortable knowing that we did not pass the bill before the pandemic because the bill was going to be used to make decisions about people in the pandemic. And I know the bill, and there's nothing in the bill that would have any impact on that. Can you clarify that for me too?
Yeah, that's not accurate. And when you were asking your question, I was thinking about Kim, I got to know her very, very well at the end of her life. And the terribly unfortunate thing was I didn't get to know her before she was ill. I only knew her when she was most, when she was the sickest. And, she had made, she was undergoing trials and was doing everything she could to extend her life. But, she was desperate to live, but a disease was already killing her. And for those who, think somehow that another year's delay or would, provide a better path for an aid in dying bill, I would just counsel members of this committee and others in the legislature to understand that there are very real people that live in our state who need this option now, whether they are known to us or they're not known to us. Some of the people that have come to testify in the past have said, will say, I followed along this issue last year in the legislature, and when it didn't advance, that was when I realized I had to become active because I need this option for myself. I hear that quite often. So, time is an enemy for those who are facing terminal illness at end of life.
Thank you so much, Mr. Appleton, for your testimony. We appreciate that. I think this person on our list is Christopher Rossetti, followed by Susan Beck. And at this time, I will also have Representative Gilchrist to chair the public hearing. Thank you.
Great, thank you. Mr. Rossetti, go ahead.
Members of the Public Health Committee, my name is Christopher Rossetti, and I'm testifying in support of Raised Bill 88. Born in Bridgeport in 1953, I was raised in Stratford and Trumbull, attended high school in Fairfield, graduate school, and then law school at the University of Connecticut, and then practiced law in Metro Hartford, primarily in the probate field for 41 years. I reside in Avon, and I'm a registered Republican. The source of inspiration in law for the founding of the United States is the Declaration of Independence. That instrument, authored and signed by the founders of this republic, including several of the then leaders of Connecticut, recognized certain inalienable rights inherent in the people who constituted the republic: life, liberty, and the pursuit of happiness. These belong to the people. Government was formed to foster and protect them. There can be no doubt that implicit, but certainly implied by the three together, is the right of an adult to choose death and to receive aid in dying from those who would render it. No one can fully possess the rights to liberty and the pursuit of happiness unless they can also choose when to no longer pursue life. Raised Bill 88 would finally secure this important civil liberty in Connecticut. So aid in suicide has a long and noble tradition. As just one example, in classical Greece, the city-state even held stores of poison to make it available to those who wish to end their lives. Several members of this committee need to ask themselves, will you be guided by the principles of our government's founding documents that you have sworn to uphold, or rather by what the original inhabitants of this state ruefully called popery? At a time when the COVID-19 plague challenges our unprepared, understaffed, under-equipped, and undersupplied public health system, will you still succumb to the blandishments and false narratives of the hospice industries on this subject, who rake in fortunes from the taxpayers, in part prolonging the no longer happy lives of those who no longer wish to live? Will you allow the irrational and hysterical suppositions of certain proponents of the disabled to frustrate the reasonable and rational requests of those of sound mind who would decline expensive taxpayer-funded services to end further intolerable pain, and to pass in dignity. So in September of 2020, I was diagnosed with a rare form of eye cancer, for which there's currently no effective treatment.
Excuse me, Mr. Rossetti, your time is almost
I'm-
up, if you would
I'm
summarize.
finishing up, and which
Thank you.
typically ends in a slow death from liver failure. I see nothing glorious or redemptive in such a prolonged period of suffering antecedent to my death. Please act rationally and release this bill. Allow me and so many others, when they are beset by incurable late-stage illnesses, to die with the assistance of medical science at a time of our choosing and in a place we call home in peace. Thank you.
Thank you, Mr. Rossetti. I don't see any questions. Thank you for your time today.
Thank you.
Now we'll hear from Susan Beck, followed by Paul Bluestein.
Thank you very much, members of the committee, for this time to give my testimony. Approaching death is one of the most difficult things we'll ever do as human beings. However, it's been my experience that there are often unexpected fruits that come at this most difficult time at the end of a person's life, despite the suffering that's almost always involved. And in fact, such gifts may even be tied to the suffering in some mysterious way. So the first point I wish to make is that artificially cutting the dying process short will mean that some people will wind up missing out on these elements of deep significance, healing, and consolation for them and their families. 2 examples. The end of my mother's life gave my father an opportunity to reciprocate for the many years during his demanding career when she cared for all his needs. And I was often moved to tears watching him patiently and lovingly hand feed her day in and day out. It was, in a sense, a beautiful repayment of a debt he likely hadn't even been aware he owed. At the end of my mother-in-law's life, I witnessed a near miraculous lifting of deep-seated and long-standing resentment toward her deceased husband. This precious miracle of forgiveness and reconciliation was almost certainly born of the transformation that her final suffering wrought in her. Had an aid in dying option been available, and had they chosen it, the end of both these women's lives would have been much the poorer as a result. Now, if aid in dying had been available when my mother and my mother-in-law were approaching the end of their lives, I think it would have appealed to both of them based on things they often said. But where was that attraction coming from? I would argue that it was the result of depression. Although neither woman was ever clinically diagnosed, as is the case so often with those who suffer from depression, especially the elderly, the signs and symptoms were evident. Thoughts of death and wishing to die or even wanting to take one's life are common and prominent symptoms of depression. And this leads to my second point. This bill would inevitably result in people cutting short their lives simply because they were depressed. Now, you'll say this year's bill includes a new provision that's supposed to prevent this from happening. The provision would require referral to a mental health professional for any patient requesting a lethal prescription whose physician thinks they may be suffering from depression or another psychiatric condition. However, such a safeguard or supposed safeguard would be woefully ineffective. A similar safeguard is part of Oregon's Death with Dignity law. In 2020, less than 1% of patients in Oregon requesting a lethal prescription were referred for a psychological consultation. Yet the Cleveland Clinic estimates that as many as 33%.
Excuse me, Ms. Beck, your time is almost up. If you would summarize, thank you.
Yeah. The Cleveland Clinic estimates that as many as 33% of persons with a serious medical condition have symptoms of depression. Thus, it seems clear that at least some and possibly a considerable number of depressed patients are being missed by the Oregon law's safeguard and being enabled to end their lives. And the same would be true in Connecticut. Thank you.
Thank you, Ms. Beck. I don't see any questions. Thank you for your time today. Next, we'll hear from Paul Bluestein, followed by Reverend Estrada.
Good afternoon, members of the committee. My name is Dr. Paul Bluestein, and I'm speaking in support of SB 88. My wife, Linda Shannon Bluestein, has late-stage metastatic cancer. So for me, this is not an academic argument. This is a very personal issue. As you know, a medical aid in dying bill was passed by the Public Health Committee last year, but never made it to the General Assembly. Well, I'm confused. Why is a bill supported by 75% of the people in Connecticut and most doctors simply pushed aside year after year after year, even though 1 in 5 adults now live in a state where they can choose death with dignity? For too long, I've listened to opponents put forward misinformation and distortions of the truth, and there are at least 3 things I'd like to correct. First, the term assisted suicide is misleading and is being used to stigmatize the issue. People who commit suicide want to die. People who have a terminal illness want to live. They just don't have that choice anymore. Like my wife, they simply want to have a peaceful and dignified death. Second, some testimony seems to suggest that medical aid in dying is unnecessary because hospice and palliative care can manage any pain or suffering in the patient's last days. I wish that was true, but it's not. It's a cruel fiction, another of the big lies. Third, as a physician, I don't see this as any violation of any principle of medical practice. The Connecticut State Medical Society has withdrawn its opposition, and even the AMA has acknowledged that providing medical aid in dying in no way violates the code of medical ethics. Every care provider is free to follow the dictates of their own conscience. I'm asking you to please support this legislation and provide help and hope to terminally ill patients. I had hope when the Public Health Committee released a medical aid in dying bill last year, and I thank you for that. This year, I'm asking you to renew that hope. For those of you who support SB 88, I believe you are on the right side of medicine, the right side of history, and most importantly, the right side of humanity. For those who don't support SB 88, I'd ask you at least not to stand in the way of the choices
Dr.
of others.
Bluestein, please
Thank you.
summarize. Thank you.
Thank you, Dr. Bluestein. Sorry about your name. Thank you for being here and for your testimony. I do see that we have some questions. Chairman Steinberg.
Thank you, Madam Vice Chair. Doctor, I'd like to ask you a question because in past testimony, we've talked about the Hippocratic Oath. And I'm sure you would agree that in the hundreds, if not thousands of years since it was first uttered, medicine has changed somewhat. And that our ability to keep people alive with technology and other amazing, miraculous therapeutics is very different than at the time in which the Hippocratic Oath was written and first vowed. I'd like to believe that the Hippocratic Oath would take into account not only patient wishes, but what life is really about for these patients, and that perhaps a more nuanced interpretation of do no harm would incorporate the fact of not causing unnecessary, unending pain for patients if the physician can avoid it. Would you say that much like our living Constitution, that perhaps the Hippocratic Oath should be considered in light of medicine today?
Thank you for the question, Representative Steinberg. There are several things that perhaps people on the committee may not know about the Hippocratic Oath. The first is that it's largely been discarded by medical schools. Most medical schools in this country no longer have its graduates take the Hippocratic Oath. And part of the reason for that is that they recognize that it is far outdated. It begins with swearing an oath to several pagan gods. Secondly, it prohibits abortion, which, regardless of your political leanings, is legal in the United States. The this has been supplanted largely by a more modern oath. However, regardless of what oath is taken, and I did take it, the essence of this is, as you said, is do no harm. But allowing patients at the end of their life to suffer needlessly does harm. It does harm to the patient. It does harm to their loved ones, to their husband, to their wife, to their mother, to their father, to their sons, their daughters. It does harm. So anyone who imagines that disallowing medical aid in dying somehow is a preservation of a 2,500-year-old oath that is rarely used should think about that again. It does harm. And if the oath is to be upheld, then medical aid in dying should be an option available to patients.
Thank you, Madam Vice Chair.
Thank you. Representative Berger Jaballo.
Thank you, Madam Vice Chair. Dr. Bluestein, it's very nice to see you.
Nice to see you too.
I actually, Representative Steinberg brought up the first part of my question, which is about do no harm. And the reason that it is the question that I want to ask is because my colleagues, even those who express feeling in their gut that they are inclined to support this, they often invoke the idea of do no harm, but it ultimately comes down to a fear of passing this bill and what that means. What would you say to my colleagues who are afraid of passing this bill? What do you want them to know?
I think that in the same way that doctors follow their conscience and provide their best advice to their patients, let them do so in this case. Those who are opposed to the idea of medical aid in dying, let them not participate. Let them counsel their patients to not choose that option. Let the patient decide whether to follow that medical advice or not. No one is being coerced into anything here. This is another of the great lies, that there will be patients coerced, that there will be doctors coerced. How offensive could it be to think that as a practitioner, I would have been coerced by my patients to do something that my conscience told me not to do and was not in the best interest of my patient? How offensive could it, how more offensive could that be? Let those people, each of them, follow the dictates of their own conscience. If they choose not to participate, I have no issue with that. But don't stop me from participating. Don't stop my choice if that's the choice I make. What gives them the right to do that?
Thank you for that.
Thank
Thank you.
Thank you, Dr. Bluestein. I don't see any other questions. Thank you for your time today.
Thank you.
Next, we will hear from Reverend Estrada, followed by Katie Glenn. Reverend Estrada, please go ahead.
Public Health Committee members, it is with deep sadness and regret that residents in the state of Connecticut, of which the majority of us oppose the great evil of suicide and especially assisted suicide, have to continually uphold the natural and sacred teaching of life that is inscribed in our human nature against unnatural bills such as SB 88. As a Roman Catholic priest and as a private citizen, I wish to continue to make it known that SB 88 will only cause the temporal and spiritual downfall of our state and its deteriorating view of the true dignity and sacredness of life. Any of the sponsors of SB 88 who profess Catholicism or some form of Christianity know very well of the redemptive suffering of our Lord Jesus Christ on the cross. This was his greatest act for the redemption of mankind. Our Lord did not abandon or forego his sufferings, which is why our own pain and suffering is not worthless, but rather redemptive when united with Jesus Christ. So everyone in our society should not be made to feel that they are a burden to our community. And really, it is the life we must render back to God, as it is by him that we are created, according to the Constitution. And so SB 88 will only continue to perpetuate this error of cheapening our life, our soul, and our immortality. And so I ask really with utmost charity to the committee members, for the sake of their immortal souls and our souls, which we will have to render an account at the end of our lives, to our sovereign Lord and Judge, to never permit SB 88 to become a law. I offer my prayers and penances, especially during the upcoming Lenten season at the sacrifice of the Holy Mass, for all of you who have served our government, but especially to please reconsider not allowing this unfortunate bill, and that may God continue to enlighten you and convert your hearts. Thank you. May God bless you.
Thank you, Reverend Estrada. I don't see any questions. Thank you for your time today.
Thank you.
Next, we'll hear from Katie Glenn, followed by Stephen Lyon. Katie, please go ahead.
Can you hear me?
Yes, we can hear you.
Okay, good. I don't see myself on video, but I suppose that's fine. Members of the committee, I am a lawyer. I serve as president of Americans United for Life, and I have been working on the legal and human impact of this issue nationally and state by state for well over a decade. But I'm here on behalf of my friends, the people I care about, people who have been pressured towards death. States have the power to protect us, to protect the most valuable, vulnerable members of our communities, people like elder adults, people living with disabilities, the people that our policies and safety nets are supposed to support. Now, most states already do. Almost every state has a law to prevent you or me from helping someone else to die by suicide. And the Supreme Court agrees, saying that there is no right to assisted suicide in the Constitution and that states have an unqualified interest in the preservation of human life and preventing suicide and in studying, identifying, and treating its causes. In a state not far away from the Capitol there, I remember one day there were two bills being considered. The first on opioid overdose and how to combat that scourge, and the second on assisted suicide and how to not combat that scourge. Even those states that have legalized assisted suicide, they just decided to make an exception for one particular profession. And that's for good reason. So often we're told that the reason why people consider assisted suicide is pain or fear of pain. It is not. In the last 15 years, pain has never been in the top 5 reasons people asked for assisted suicide in Oregon. Fear of pain has not been in the top 5. So why? Hopelessness and fear of loss of autonomy and control. Studies show that depression is being overlooked. In this light, assisted suicide looks less like a good death in the face of unremitting pain and more like plain old suicide, something that we all work to prevent. Yet even the mental health so-called safeguard in this bill does not provide actual treatment, just a one-time evaluation to determine competence to consent. In Oregon in 2018, only 3 of the 168 patients were even referred for a psychiatric evaluation. And assisted suicide puts everyone at risk. States that have legalized aid in dying have seen their suicide rate go up. There is a new study available out of Europe to show that. But hey, apples to apples, let's look at the Oregon study available on the NIH site. How does legalization of physician-assisted suicide affect rates of suicide? It's by Jones et al. Highly recommend that. But it is especially dangerous for vulnerable and disenfranchised folks. Dr. Kevin Fitzpatrick, who himself was paraplegic and died of cancer, said, when non-disabled people say they despair of their future, suicide prevention is the default service we must provide. Disabled people, by contrast, feel the seductive, easy arm of the few supposedly trusted medical professionals around their shoulder. Someone who says, well, you've done enough. No one could blame you. Continue to protect the lives of all Connecticut citizens. Preserve human life, prevent suicide, and study, identify, and treat its causes. And for all of us, end isolation, build the bridges that make a difference. Thank you.
Thank you, Ms. Glenn. I don't see any questions. Thank you for your time today. Oh, wait, I do see questions. Please hold on. We'll hear from Dr. Pettit, followed by Representative McCarty. Dr. Pettit?
Thank you, Madam Chair. Thank you, Attorney, for your testimony. Just a question, I've gotten a number of texts from colleagues on this, and a comment on the death certificate and how other states have handled it and what you see are the issues in terms of the physician's responsibility with the filling out of a death certificate.
Sure. In California, for example, the then head of the California Coroners Association expressed deep concerns and published an open letter saying, asking questions. What do we do if we find someone? Do we have to test for this as well? Asking what the procedure would be. Now, I congratulate Connecticut for trying to address that and some of the other issues and really getting to the heart of the matter at hand. So it has shifted a little bit state by state, but nonetheless, the core issue remains the same. The core issue that assisted suicide puts vulnerable populations and really all individuals at risk.
The specific question that people have asked is whether the physician's at risk if they put down, say, end-stage lung cancer versus whatever the preparation was that the patient took. Any comment on that?
In Connecticut, I think we would have to see how that plays out. In most states, then you are required to put down lung cancer and not the suicide drug cocktail. In Connecticut, that kind of remains the same, but it's continuing to try to tweak it to get it through. The cause of death on the death certificate issue is not at play as much here as it has been in other states, for example, California. But again, when we get to the heart of the issue, whether or not this is good for the people of Connecticut, the answer is unequivocally no.
Thank you. Thank you, Madam Chair.
Thank you, Dr. Pettit. Representative McCarty.
Thank you very much, Madam Chair. Attorney, you made reference in your comments to the rise in suicide rates. I'm particularly interested, we know that the second leading cause of death here in Connecticut with children and young adults aged 15 to 24 is suicide itself. So I think you made reference, and I'm curious about research in your studies. Have you made any correlation with aid in dying and the rise of suicide rates within that group that I just mentioned, or within any group in the rise in suicide rate? And just wondering, is there research out there that shows a correlation with aid in dying and the higher prevalence of suicide rates?
There is. First of all, let me just go back to that previous question and clarify, because I mentioned that we don't know what's going to happen going forward in Connecticut. They did take out, the authors of this bill took out the falsifying the death certificate question, but it begs the question, what is going to be listed as the cause of death? No one knows, and the problem is still there. Speaking of problems that are still there, one of them is certainly the question of the increased suicide rate. We know from that article that I cited, How Does Legalization of Physician-Assisted Suicide Affect Rates of Suicide by Jones et al. It has demonstrated, and this is an Oregon-based study, so we are comparing apples to apples here, that once you control for all the various factors, socioeconomic factors, observable state and year effects, state-specific linear trends, legalizing physician-assisted suicide is associated with a 6.3% increase in total suicides. That is a statistically significant number, 95% confidence interval. And so the effect is largest in the individuals who are 65 years of age and up, one of the most vulnerable groups in our population, but it is observable in all age groups. And the introduction of physician-assisted suicide is not associated with a reduction in non-assisted suicide rates or with an increase in the mean age of non-assisted suicide. So what that means is that, again, the trend tracks over all age groups. It applies to all the various demographic groups. Suicide rates go up when assisted suicide is legalized. That is an Oregon-based study. There's also a new study out of Europe that demonstrates similar results, but I'm keeping with the Oregon-based study to keep it on American soil, so to speak.
Thank you for those comments. Very much appreciated. And I'd be interested to look at the European studies. So thank you.
Thank you, Representative McCarty. And thank you, Ms. Glenn. Thank you for your time.
Thank you.
Next, we'll hear from Shannon Sanford, followed by Stephen Lyon. Ms. Sanford, go ahead.
Hi, thank you. Good afternoon, Representative Steinberg, Senator Anwar, and honorable members of the Public Health Committee. Thank you for the opportunity to provide testimony today. I'm providing testimony in support of Senate Bill 80, an act concerning aid in dying for terminally ill patients. And again, I'd like to stress that a little bit. It's for terminally ill patients. I'm a registered nurse. My name is Shannon Sanford. I'm a registered nurse. My background is oncology, palliative care, and hospice. I currently teach. I'm an assistant professor of nursing over at Gateway Community College. And as you can see, I came from work. So unfortunately, I'm testifying in my car because I wasn't able to get back to my office or home in time. And while I had planned to give some written testimony that I'd prepared after the last speaker, who, with all due respect, I'd actually like to speak to her comments and use my time that way. I take great issue with the use of the term suicide interchangeably with aid in dying. So I'd like to use my time to speak to that if I can. Suicide and aid in dying are two terms that should not be used interchangeably. And I really want to drive home this point. The American Association of Suicidality recognizes that the practice of physician aid in dying is distinct from the behavior that's traditionally described as suicide. Suicide is a tragic event. And it's an event that, we as healthcare providers work very hard to prevent from happening. And aid in dying, patients who come to aid in dying are terminal. They come to aid in dying, not necessarily because they want to die, but quite often they very desperately want to live. And they want to live with the most quality of life they can for the longest time possible. But they know that the disease is going to take its natural course. And unfortunately, whether they do whatever they do, they're not going to prevent that. They're going to die in the end, and they don't want that, but that's going to happen. Patients who are suicidal, on the other hand, come to suicide with a lot of ambivalence about life and death, and they are not terminal. So there's a big distinction between suicide and aid in dying. An individual who's facing death usually has a lot of emotional bonds with their loved ones, and they have a deep sense of meaning as their life is coming to an end. So I really want us to be clear that suicide and aid in dying are very distinct things. Suicide kind of implies like a self-destruction, and ending one's life with the assistance of their physician, with their family at their side, is more of a self-preservation act and not one of self-destruction.
Excuse me, Ms. Sanford, your time is almost up if you'd summarize.
Okay.
Thank you. Thank you.
Also, the aid in dying bill has several safeguards against the impulsivity of the act, which is very different from someone who's suicidal and comes to it with a lot of impulsivity and ambivalence. And I just wanted to make that point because I think it's very important. I'm open to answering any questions anyone might have. And I also just want to mention we did take the language out of the bill in regards to the death certificate. So people are free to write what they want to on the death certificate because we don't have that language in the bill anymore. Thank you. And I'm open to answering any questions anyone might have.
Thank you so much, Ms. Sanford.
Thank you.
I don't see any questions. Thank you for your time today.
Okay, thank you.
Next, we'll hear from Stephen Lyon, followed by James Young. Mr. Lyon, go ahead.
Good afternoon, members of the committee. Thank you for your time. I am testifying today in opposition to Senate Bill 88, an act concerning aid in dying for terminally ill patients, because bills of this nature should be held until in-person testimony and lobbying of legislators has resumed. The judgment of medical professionals regarding terminally ill patients is uncertain at best. The use of death-causing drugs is underregulated, and because death should never be considered a cure or a solution for a problem. I have submitted written testimony, so I'm just going to highlight some of the areas I feel haven't been addressed as much today. There's been a strong emphasis today that individuals who are seeking aid in dying are special because it's a terminal illness. The problem with this legislation is that the 6-month terminal diagnosis requirement is a no treatment diagnosis. Per the proposed language, it means, quote, the final stage of an incurable and irreversible medical condition that an attending physician anticipates within reasonable medical judgment will produce a patient's death within 6 months if the progression of such condition follows its typical course. The problem with this is that it doesn't address treatment options or exclude chronic conditions. A patient with a particular type of diabetes would fit this category if they refuse to take insulin. It's a condition which is incurable and without intervention could result in death within 6 months. This could also apply to individuals taking heart medication, those on dialysis, and those with mental diseases who are compelled to self-harm or who have compulsions to participate in activities which result in death. This is one of the rare occasions where it is not an exaggeration to say that this is a matter of life and death. And that being the case, this legislative body has an obligation to make sure that any legislation of this type is narrowly tailored so that it cannot be abused in any way, nor expanded outside of the stated intent. I would also like to address, and I didn't put this in my written testimony as much, but people being unhappy with conflating assisted suicide with physician aid in dying. And I would argue that the logic remains the same. I'm not unsympathetic to the individuals that are going through. I have had people in my family who have gone through tough, painful end-of-life situations through cancer and other areas. And I also have people who I'm close to who have committed suicide. Ultimately, it's a despair and a belief that there is no hope for them. There is no value in their life. Why is someone who has...
Excuse me, Mr. Lyon, your time is almost up. If you'd summarize.
Thank you.
Thank you.
So, why is it more cruel to allow someone who's going to suffer with depression and hopelessness for the next 50 years of their life to not end their life than it is to allow someone who only has 6 months left? The logic remains the same. Death is not the answer. Thank you.
Thank you for your testimony, Mr. Lyon. I don't see any questions. Thank you for your time.
Thank you.
Next, we'll hear from James Young. Mr. Young, go ahead.
Yes, hi. I'd like to turn my video on, but I'm not sure how I can do that.
If you click in the box, there should be an option.
There we go. Okay. That's it.
We can see you.
Terrific. Thank you very much. Thank you, Representative Steinberg, other honored members of the committee. I'm James Young. I live in Mystic, Connecticut. I'm here to testify in conditional support of SB 88. And I'm honored to be here on behalf of the elder law section of the Connecticut Bar Association and its roughly 500 members. Our conditions for the support of the bill are, we think, relatively straightforward things. One of which is we think that caregivers should not be witnesses to the request for aid in dying. The second of which is we think that the doctors who certify the terminal nature of the illness should be independent. And finally, we think the consulting doctor, as well as the original attending doctor, should advise the patient of the availability of counseling. This is all as further detailed in the written testimony, which I have submitted. I've been before you on many prior occasions, I think going back to at least 2014, when the elder law section of the bar undertook an in-depth study of the aid in dying laws that were then in existence. There were only 3 states that allowed aid in dying then. We now know, of course, that there's roughly 10 now. I think the testimony that you've heard, at least to me, on this over the years, and there's been many hours of testimony, it sounds about the same now as it has over the prior years. So I think a question we can ask ourselves is, what have we learned from the passage of time, from 2014 and even before then? Well, I think what we've seen is that these laws are used by a relatively small number of people. The majority of them are over 65. The majority of them have cancer. The majority of them want to end their lives without having to endure and undergo the ravages of the natural disease system. As well as many others, I have had friends and colleagues who have endured this process. Some people don't want to put themselves or their families through that. I think also we have seen that these laws are not used to the disadvantage of the vulnerable or the disabled. If they were, the elder law section of the bar would not be here in conditional support of this bill. So with all due respect, we think Connecticut has waited long enough, and we now support the adoption of this bill with the 3 changes which I've addressed.
Thank you,
If you have
Mr.
any
Young.
questions, I'd be happy to try to answer them.
Thank you. I appreciate your testimony and time. We do have a question for Representative Carpino.
Thank you, ma'am. I just missed a comment that you started with. The Bar Association represents how many members now in Connecticut versus how many actual attorneys are in Connecticut? I don't know if you can answer that.
Okay. I'm here as a representative of the elder law section of the bar. The elder law section of the bar has about 500 members. The total number of the bar itself, I'm afraid I really can't provide you, but that's roughly the number of elder law members who specialize in this area of the law.
Thank you. I'll check with the
And may
judicial
I say
branch. I'm sure they can tell me.
Specialize is a coded word. I shouldn't say specialize, who have an emphasis and a focus on issues related to the elderly.
Thank you.
Thank you.
Great. We have a question from Dr. Anwar.
Thank you so much, Madam Chair. Mr. Young, I'd listened to your testimony, and in the conversations with some of my legislator friends, they have talked about a journey from being a no to a maybe to a yes. And I sense that your organization had similar journeys, because I can tell you the Connecticut State Medical Society was a no a few years ago, and they have become neutral. And then many of the members, if you talk to them privately, they'd say, well, they recognize that there's a need. What changed in your organization to get us to what you just said today?
Well, to address the specifics, and I may have the years somewhat off, but in the year 2014, the elder law section of the bar sought to adopt a legislative position, which requires the approval of the Connecticut Bar Association. There was a group of 5 of us from the elder law section. There was another section which frankly was hostile to the idea. And we had many meetings. We studied the law together, and we came together to this compromise position. The 3 conditions which I'm noting to you are perhaps not the position that either side would have wanted, but it's what we together came to after spending hours and hours studying the bill. So I think since then, there's been a continuing conversation in the bar, and the position has remained fairly much the same over time, that we feel that a few tweaks to the law should be made, that they should be, and we would hope they don't pose a material problem to adopting it. But I think the fact that the law has been in effect in Oregon since 1997, you can review the annual study that's done by the Bar Association, not the Bar Association, the Medical Association out there. I think there's just been a general increase in the desire to allow individuals to have the right of self-determination around these things, and that has led us to where we are.
Thank you so much. Your testimony was very helpful for me, and then also looking at how we can improve this further to make sure everybody's protected, and your statement that the vulnerable populations are protected, especially our disabled community, was also very helpful, because I know you look at it from a very focused angle as well. So appreciate that. Thank you so much. Thank you, Madam Chair.
Thank you. And thank you, Mr. Young, for your time.
Thank you very much.
Next, we'll hear from Kathy Flaherty, followed by Kathleen Vinci. Ms. Flaherty, please go ahead.
Good afternoon, members of the Public Health Committee. My name is Kathy Flaherty. I live in Newington. I'm a member of Second Thoughts Connecticut, and I'm here in my personal capacity only in opposition to SB 88. And I just heard Senator Anwar refer to people who've evolved from a no to a maybe to a yes. I'm one of those people who went from yes to maybe to no. And I did that by learning from my friends and colleagues in the disability community, not only in Connecticut, not only across America, but from Canada, because the things people are talking about, and this has been a very hard hearing to listen to. I've been listening since the beginning, And I know there are a lot more people to come, but I acknowledge the perspective of people who feel differently about this issue because I used to feel differently about this issue. My opposition does not come from my Catholic upbringing. If anything, I was in favor of choice because the church was against it. But what I learned from my friends and colleagues with disabilities about the challenges they live with every single day and wanting to live versus what people are talking about, the loss of autonomy, the loss of control. My dad went through that. My dad went through hospice in my house. I saw him become somebody who wasn't capable of taking care of himself. And that's what my dad was. If anything, he was the caretaker, he was the provider, and he became unable to do that. But hospice care did provide him the relief that he needed until he died, and I was there when he took his last breath. It's hard to see someone we love in pain. But when you set up a system that, by the way it runs, despite everything that everybody is saying, those systems devalue disabled lives, where people will say to people with disabilities, "You're so brave, I couldn't live like you. If I were like you, I would kill myself." And these are things that I have heard. These are things my friends have heard. It is very hard to become dependent on other people when you have lived your whole life up till that point independently. But the slippery slope is real. You notice that the people on the other side talk about the US. I want to tell you something. I will wrap this up now. I'm finishing now. Canada passed their bill for medical assistance in dying in 2016. In 2021, they expanded it. In 2023, it will include people with psychiatric disabilities. So in 7 years, you went from a limited bill to a bill that will allow people with depression to kill themselves with the help of a physician. It's physician-assisted suicide, even if we want to call it something different. I urge you to reject the bill. Thank you.
Thank you for your testimony, Ms. Flaherty. I don't see any questions. Thank you for your time today.
Thank you.
Next, we'll hear from Kathleen Vinci, followed by Reverend John Morehouse. Ms. Vinci?
Can you hear me?
Yes, go right ahead.
Okay. I'm going to divert from my written testimony to address some of the ideas that have been brought forth during this hearing. The taking of another person's life has always been considered wrong, including here in Connecticut. Otherwise, we wouldn't be here today. Many have talked about religion forcing ideas. I don't believe that. I believe it's much higher than that. Throughout the world, in advanced or more primitive societies, and through so many different cultures, with or without religion, the taking of another's life is considered wrong. It's much higher than that. It is placed in each of us, whether we believe in God or not. Point two, a lot has been spoken about pain, how it's unacceptable. No one denies that how difficult it is to watch or to go through pain, great pain. But it's all around us, from birth to death. War, accident injuries, childbirth, burn victims, parents having to watch their children go through horrible pain. But it's a fact of life. If we don't think it's right to kill people in these situations, what makes it right to kill those just because they're going to die soon? Another point, it was mentioned earlier that conversations, discussions, reconciliations, and forgivenesses often don't take place until the end. That was the case with my husband. He died last September of prostate cancer. The last week, all my family was here, and we did everything we could to help him through. He knew we did everything we could. There was a great comfort in knowing that. And I have seen firsthand that the compassion and attention of family members and hospice staff does a great good to give the love and the caring for those who are ill and to understand the dying process, despite the degree of pain, which brings me to my last point. Most of the people that have spoken today, many of them, have no idea about the afterlife.
Miss
And they
Vinci,
haven't
I'm
proved one way or
sorry,
the other.
your time is almost up. You have to summarize.
Thank you. I'll be
Thank
finished
you.
in just a few seconds. Not knowing about the afterlife, how do you know that you're not hurrying your loved one toward something worse than pain? This happened to my husband, and that's why I speak of it. 5 hours before he died, he made peace with God. Are you willing to take the chance that you're not stealing from them that opportunity on something you really don't know about well enough? Thank you all for listening.
Thank you for your testimony, Ms. Vinci, and I'm sorry for your loss.
Thank you.
I don't see any questions. Thank you for your time today.
You're welcome.
Next, we'll hear from Reverend John Morehouse, followed by Phyllis Ross. Reverend Morehouse, please go ahead.
Thank you, Mr. Chairman, other members of the Public Health Committee, and taking time, what must be a very long day for you to listen to this much testimony. I appreciate that very much. I speak in favor and support of this bill. I serve as the senior minister of the Unitarian Church in Westport, and I've been a parish minister for over 30 years, serving congregations across the country. In that time, I've sat at the bedsides of hundreds of dying people, some of them in my current congregation. In some rare cases, I've seen people slip out of life quietly and with little pain and with little fear, a so-called good death. But by far the more common death is one full of pain and fear. And while faith and love can make this painful journey easier, I have found that at the very end of life, it robs loved ones of the precious moments they need to say goodbye without the agony of dying. Terminal illness has only one outcome. Despite medicines and therapy, I've watched hundreds of people die in agony when there was no hope of them getting better. And many of those people sadly asked me why this was happening to them, why they couldn't just be allowed to leave this life. And the only meaningless point they had in living was that their body would continue to live on. Where was the meaning in that? And I have to say, as a minister and someone who deals with the religious almost every day of my life, I had no answers for them. In fact, I rarely find meaning in any kind of suffering. For me, God is love, and a loving God would not want anyone to suffer. So then why, I ask, do we need to prolong that suffering? We have the means and intelligence to help those dying horrible deaths to slip away with grace. We have the means for them to choose safely and with forethought a way to die with dignity. To deny this right to our fellow human beings is to deny a basic human right afforded to us by science and progress and our own intelligence. And the many times I've taken my pets to be put to sleep because they are old and suffering, I have remarked to my wife that we treat our dogs better than people at the end of life. If someone doesn't want to avail themselves of this right as a matter of religious belief, that's fine. Don't do it. No one is forcing anyone to choose this path. And those who take this path often do so with the love and support of their faith and their families and their communities. It's time to treat those at the end of life with dignity and grace. It's time to stop this needless suffering which tears at the fabric of love which holds us all. Thank you for your time.
Thank you so much, Reverend Morehouse. I don't see any questions. Thank you for your testimony.
Yeah.
Next, we will hear from Phyllis Ross, followed by Stephen Mendelson. Ms. Ross, go ahead.
Members of the Public Health Committee, are you hearing me?
Yes, we are.
Okay, I'm Phyllis Ross and I'm here to support SB 88. I watched my mother, diagnosed with terminal illness but sound of mind, end under hospice care, losing the life she had loved, no longer able to walk or dress herself, unable to sit up or feed herself, incontinent, in extreme pain, aides having to turn her in bed to prevent bed sores. Hospice could do little to help her other than administer opiates to lessen her pain, which made her less alert. She had totally lost her self-sufficiency and did not want to live any longer. No one should have to go through the torment she experienced. But there are no other options in Connecticut for terminally ill people in similar situations. There should be a way they can die peacefully. If you pass SB 88, you are giving them a human option that they don't have now. In 2021, the Public Health Committee did pass a medical aid in dying bill, which did not reach the full floor. I thank those of you who voted for that bill. And I also appreciate that some legislators thought the bill had merit, but had some reservations about it. This session, you have a chance to pass a bill that has addressed those concerns. It is extremely protective of those who want to have an end-of-life option and provides other concerned individuals strong safeguards. Let me underscore some things that were said today. 10 other states and Washington, D.C. have passed similar bills. In all the years those state laws have been in effect, there have been no abuses, no slippery slopes. Although these laws have been challenged in court, they have not been overturned. As said by others, a poll of Connecticut voters taken in 2021 showed that 75% of those surveyed supported medical aid in dying. Consider this: if you or someone you love were terminally ill and suffering, the right to choose medical aid in dying.
Excuse me, Ms. Ross, your time is almost up. If you would please summarize.
Okay, the right to choose medical aid in dying, to use it or not use it, would make all the difference in the world. Please vote for SB 88. Thank you.
Thank you, Ms. Ross. I don't see any questions. Thank you for your testimony and your time.
You're welcome.
Next, we'll hear from Stephen Mendelson, followed by Carrie Shaw. Mr. Mendelson, please go ahead.
Thank you. Co-chairs, members of the Public Health Committee. My name is Stephen Mendelson. I'm testifying in strong opposition to Senate Bill 88. I am, as I've noted year after year, I'm an autistic adult representing Second Thoughts Connecticut. I also serve on the board of the Euthanasia Prevention Coalition USA, and I was on the Connecticut Moles Task Force earlier in the past. I just want to say, basically, I hope you read my written testimony. I also want to associate myself with Kathy Ludlam's powerful testimony. I want to point out, again, the changes, was referred to the last speaker, the changes in the bill. I noticed them, but I also want to say they're essentially a shell game. Nothing essentially has changed from previous editions. You can't, no change in bill language can change the fact that some people are dying horrible deaths from DDMA, DDMA-PH, the latest drugs. The amitriptyline burns the throat. People are taking a long time to die, and we wouldn't even do this to our dogs.
Now,
we may have horrible, we may put our dogs down involuntarily and for horrible reasons, but at least we don't make them swallow experimental cocktails and make them vomit the drugs up. I noticed some other things. Again, the definition of terminal illness, which Kathy Ludlam mentioned earlier, and that Not only does she qualify for the lethal drugs, and she's, has a deadly mix, but also even more so now, people with anorexia who can live 60 more years, except that if they don't want nutrition, they're terminal and they're judgmentally competent. And I cite a psychiatrist to show exactly how dangerous this is for people with that particular diagnosis. I also want to point out very strongly, the bill still requires that the death certificate be falsified. Previous speaker and somebody responded, I think one of you legislators responded that now anything can be put on the death certificate. That's not exactly true. You took out 96B, but you left in 14C, which mandates that you cannot put homicide or suicide on the death certificate. According to the Office of the Chief Medical Examiner, the only other options you can put on would be accidental, natural, therapeutic combination, or undetermined. And thus, having ruled out homicide or suicide, therapeutic complication, accidental, and undetermined are also ruled out because the manner of death is both intentional and of known cause. You're thus left with requiring putting natural on the death certificate, which is a falsehood. And if you put natural as the manner of
Excuse me,
death,
Mr.
you would have
Mendelson,
to
your
put,
time is almost up. If you would
all right,
please
you would have
summarize.
to put the underlying terminal illness as the cause of death to have a consistent death certificate. So again, all the changes here are a shell game, and Kim Callahan is going to all these other states that have already passed it to gut the safeguards. Just look at what she's doing in Washington, Oregon, California, Hawaii, and Vermont. And that's what's coming here to Connecticut. And it may even be out of your hands because they're also going to court to bust the laws in these states. California is going to go to euthanasia. They're gutting
Thank you,
the
Mr. Mendelson. Thank you for your
Oregon.
testimony. Thank you for your testimony today. I don't see any questions. Thank you for your time.
I'll be glad to take over. Thank you, Vice Chair Gilchrist. Next up is number 74, Dan Diaz, followed by Carrie Shaw. Mr. Diaz?
Yes, hello, you can hear me okay?
Just fine.
Okay, so my name is Dan Diaz and I am Brittany Menard's husband. Brittany died on November 1st of 2014. She was only 29 years old. Brittany experienced a gentle death only because of medical aid in dying. Yes, my wife utilized the very program that we are here discussing today. I am testifying in support of SB 88. Brittany's case received significant attention because we had to move from our home in California. This is a photo of Brittany. We moved to Portland, Oregon so that she could access Oregon's law. Had we stayed in California, the brain tumor would have continued to torture her to death. And here's the interesting thing. While we were living in Portland for those 6 months, support for medical aid in dying back in our home state of California was 74%. Brittany would regularly ask me, Dan, what the hell are we doing in Oregon? Why aren't we in our own home right now? I see the same thing happening in Connecticut as we speak. Support for medical aid in dying in Connecticut is 75%. And yet terminally ill individuals there are in Brittany's same predicament, deciding if they should leave their homes for another state just so they can ensure their dying process will be gentle. When she died, there were only 4 states with this option. There are now 11 states. I've lived through this program. I've seen it firsthand with all of the rigid safeguards that are in place. The number of unfounded claims by the opponents is astonishing. I know this because Brittany had to navigate through all of those misrepresentations as she applied for this program. After applying for, qualifying for, and finally being granted that prescription, Brittany was able to truly focus on living her life, the life that she had left. And she recognized that all of the fear mongering and the intimidation tactics by the opponents, that those needed to be corrected. That's part of the reason Brittany spoke up. Once again, her words on this matter, I quote, "The opponents insist on using the term suicide, but there is absolutely no part of me that wants to die. I want to live, damn it, but this brain tumor is ending my life." At no point do the opponents offer an alternative, another remedy, or a solution, and they conveniently ignore the fact that modern medicine is not able to keep a person from suffering in all cases, end quote. And 7 years later, all of that is still the same. The opponent's campaign is based on fear. As a Catholic and as a Latino, I take great pride in the fact that 70% of Catholics nationwide also agree with this option. In closing,
Excuse me, Mr. Diaz, your time is almost up. If you would please summarize.
I'll close right now.
Thank you.
To those legislators who have voiced concern today, if you've not gotten a satisfactory answer, ask me. I've been through this. I can give you real answers, not just the hypotheticals. Thank you for the opportunity and for allowing me to share Brittany's story with you.
Well, sir, it looks like you're going to get some questions here. So let's go straight to Representative Gilchrist, followed by Representative Berger-Trujillo.
Thank you, Mr. Chair. Thank you, Mr. Diaz, for being here again this year. Brittany's life and death had a big impact on me. My 28-year-old friend had a brain tumor and died a year before your Brittany died. And so I remember following the coverage in the news. Just was hoping you could speak a little bit more to those final 6 months, if you could, and what having that option meant to Brittany and those who surrounded her.
For sure. Brittany was able to focus on the things that mattered to her. We pack up half our house into a U-Haul. We moved to Portland, Oregon. She finds a house for us to rent on Craigslist. Once we were established, I mean, the idea that anybody has to go through that was crazy. But once we were there, in addition to really focusing on living her life, we were able to do the research on any clinical trial that offered any glimmer of hope. So it's not one or the other. I mean, all of this is happening at the same time. Brittany has that medication. She puts it in the cupboard and her focus is on living. And I would say that the benefit to a terminally ill individuals is that it really emboldens her to live, because now, since she has that option, an option that that brain tumor in a sense cannot defeat, she can very aggressively go after, well, what clinical trials are out there? What do I qualify for? Recognizing that, and let's be honest, sometimes those clinical trials and what their remedies only produce more pain and suffering for that patient. But it really emboldened her to say that I can pursue those things because I know that if things get bad and modern medicine is not able to keep me comfortable, at least I'll have this option. The ability then to also include friends, family, her medical team, that was a huge gift from her to the rest of us. I recognize how selfless she was being, because her dying process was something that, I mean, well, heck, it got shared with the nation. That was not her goal. The media labeled her as the face of this medical aid and dying movement. Brittany's goal was to affect legislation. As I mentioned, there were only 4 states when she died. Her message was for legislators so that they could represent their constituents and you know, nobody else would have to leave home like we did. But it truly was like, and on the day that she died, within 5 minutes of taking that medication, Brittany fell asleep very peacefully. Within 30 minutes, her breathing slowed to the point where she passed away. You know, I held her in my arms. Her parents were in the room, 3 of her friends, my younger brother. That was the gentle dying process. We're all mortal. We live, we're born, we live our life, and then eventually we die. That dying process for Brittany, experiencing a good dying process for her was nothing more than the extension of having lived a good life. And she was not going to allow cancer to be in the driver's seat. She was not going to allow a brain tumor to dictate how much suffering she would have to endure. And that was also part of her message. You know, we only get to do it once. There's no dress rehearsal. When you are truly terminally ill and in your active dying process, to Brittany, that was a meaningful thing that she was not going to just roll the dice and let cancer dictate how things would go. So yeah, well, to know my wife and her loving, caring, but certainly determination, yeah, it just reflected who she was.
Thank you so very much for sharing that and for continuing on her advocacy.
Thank you, Representative. Representative Berger-Javala.
Thank you very much, Mr. Chairman. Thank you so much for being here once again. You speak so powerfully on the final moments of your wife's life. And you mentioned earlier the misinformation. So I appreciate that you addressed that, because we've heard a couple of different accounts of some pretty outrageous claims about what that looks like at the end. So I do appreciate in that gentle manner that you were able to kind of set that right for us. My question for you is, since a terminally ill individual in Connecticut does not have this option, they're in the exact same predicament that your wife was. And one of the chief arguments is go for the palliative care. What is your feeling on why terminal sedation was not okay for Brittany? Why is terminal sedation not a viable option in your eyes?
For sure. Well, and this is something that whenever a physician, I haven't found many, but I do find some. I mean, at this point, I've been to 18 different state capitals. I think I'm somewhere north of 950 legislators that I've spoken with. I've testified at hearings, and when I come across a physician who will make that claim that, oh, we can absolutely keep a person comfortable at end of life in 100% of the cases, for starters, that's not true. I will line up scores of medical directors from hospice care facilities, hospice care nurses, et cetera, that will say that is absolutely false. But what that physician might be referring to is the practice of terminal sedation. So terminal or palliative sedation, the medical practice of putting a person into a coma, withholding food, water until that person dies of essentially dehydration, starvation, their underlying disease. Brittany asked about it. We had this conversation. We did not want to leave our home. We wanted to stay in California. So she asked her physician, she says, well, so I'm otherwise healthy. I mean, other than this brain tumor. So how long is this going to take? The response is, well, oddly, due to the meds that she's on, the dexamethasone in particular for the brain swelling, she's retaining water. And they said, your dying process might last 10 days, 2 weeks. She said, would I be able to hear what's going on in the room? And the physician said, well, I mean, we can't say definitively one way or another, but yeah, you might. Brittany asked, well, let's say it's not uncommon with the size of the tumor that she had. What if I suffer a stroke? And I, partially or completely paralyzed, even though she's sedated, would she be aware of that? And the physician had to admit, it's like, we can't say for sure. So at the end of it, Brittany said, that sounds like literally living or dying. That would be a nightmare scenario. Nobody knows the film, the pictures that are going on in Brittany's mind. And yet there she, and by the way, she would want to be at home. So she would not want to be in a clinical setting. So that terminal sedation would occur at home, which means that the meds are administered orally, typically. In a clinical setting, it can be through an IV, but when it's at home, you have your protocol. And I've seen this play out firsthand. I've seen terminal sedation. Her name was Jennifer Glass. In her case, her dying process took 5 days because she was very weakened from the chemo and radiation that she had endured. But to her family, they're basically holding vigil. And here, I think her husband put it the best. The end result with terminal sedation is death. Let me say that again. The end result of terminal sedation or palliative sedation is that that person dies. The end result of medical aid in dying is also death. There is no difference. Harlan's words on this, that's Jennifer's husband, he said, Terminal sedation is the exact same thing as medical aid in dying. It's just in slow motion. They're not going to wake up the patient after 2 or 3 days and say, hey, how's this going for you? You feeling okay? They keep that person sedated until that person dies. For Brittany, her response was, doctor, I'm going to take that responsibility and that worry and that concern. It'll be up to me on the day that I decide that I have suffered enough. These seizures are only getting worse. The pain at the base of my skull is not going away, not even with the Dilaudid that's 4 times stronger than morphine. Brittany said, I will be the one. I'm the only one who can make that decision. And so for her, that is the difference and why we ended up leaving California, moved to Oregon, because terminal sedation was not going to be sufficient for her. The suffering that she was already experiencing was far too great. And she was fearful that despite being in a coma, medically induced, that they're keeping her sedation, that her dying process would still be horrible. And so that when physicians say, and in her words, the arrogance of a doctor, how dare they say that, oh, we can keep you comfortable. Basically, we keep you on a morphine drip sedated until you pass away, but they don't actually know what Brittany's experiencing. Again, she was a loving and caring person, but her determination, she says, no, doc, I'm not willing to roll the dice and have that as the way that things end for me.
Thank you so much for sharing that and for elaborating and being so willing to share such a personal piece, the most personal piece of your life. And I think that the palliative care argument is one that that ignores what it really means. And so for you to define that a little more strongly is
one thing. Let me just say though, hospice and palliative care are wonderful fields of medicine. And this was Brittany's, as much as I advocate for medical aid in dying, Brittany's message was, it was much broader than that. It was the acknowledgement that we do need to make improvements in end-of-life care. You know, like I said, the media, they sensationalized what they could. They latched onto the medical aid in dying aspect of it. Her message was much, much bigger than that. And it was that we do need to make those investments, but both these things happen at the same time. Making improvements in hospice and palliative care are things that we need to do as a society, but also allowing a person, there are going to be very few people in Brittany's predicament, but for those individuals, having this option means the world to them. And you know, the idea that, and again, in Brittany's words, this is not a religious issue. This is not a political issue. This is a medical issue. And just like any medical decision, that is a decision that belongs to the patient, working with the support of their family, within their own set of spiritual beliefs, and with their physicians on charting their best course. And the protections in place on this, Brittany felt incredibly protected going through this process. So I just want to be clear that to me, the people who work in hospice and palliative care, they are superheroes. But that does not mean that they are able to keep somebody like Brittany comfortable in 100% of the cases.
Agreed. Thank you very much. And to understand that it is not an either or situation where we're looking to be able to offer that option, the choice. So thank you.
Thank you, Representative, and thank you for illuminating some of the nuances with regard to the palliative care predicament in many cases. Mr. Diaz, it's clear to all of us that your Brittany was not depressed, not coerced. She exerted her own agency to the utmost, and she was just very lucky to have you as a partner to get through it with her. And we very much appreciate your testimony and your continued advocacy.
Thank you.
Seeing no further questions, we have Carrie Shaw followed by Lydia Bennett.
Hello, I don't know if you can hear me, but it says my video was stopped. I assume that's something you could restart.
I don't know if it's up to us. You might be able to do that yourself.
Okay.
I can't see what you see, so to speak.
Okay, so I'll speak without the video. My name is Carrie Shaw. I will talk to you on a personal level, but first I'm testifying today representing humanists and free thinkers of Fairfield County. which supports SB 88, medical aid in dying. 42% of Connecticut residents identify as non-religious, according to Gallup. The humanists and freethinkers of Fairfield County, of which I am president, represents humanists throughout Fairfield's 23 towns, which comprise 1/4 of Connecticut's population, and has adopted the policy position in favor of Bill 88. We note that it's not a religious issue either. There's no prohibition on aid in dying in either the Old or the New Testaments. According to a survey of likely 2022 general election voters in Connecticut, most Catholics, most Protestants, most Christians of any stripe, and most of those with no religious affiliation support medical aid in dying legislation. Now, on a personal level, there's something worse than dying. It's painful death. My brothers and I tried to keep my father alive in the best available health as long as we could, but when the time came, we had him on hospice. Despite being on hospice, he died by choking to death on food, known euphemistically in medical terminology as aspiration, a very common end of life. I do not want to die that way. If I wind up spending all my efforts on dialysis, I want medical aid in dying. If I get a disease which progressively causes loss of all muscular activity, I want medical aid in dying. If I get painful cancer death, subject to breakthrough pain despite medications, I want medical aid in dying. If the situation is hopeless and promises to eat up my life savings in medical bills instead of being able to bequeath them to my family, I want medical aid in dying. Please vote in favor of medical aid in dying, bring it to the General Assembly floor, and vote for it again. Thank you. It is personal.
Thank you for your testimony. Much appreciated. Thank you for being patient with us to this point today. I don't see any questions, so we'll thank you and move on next to Lydia Bennett, followed by, it looks like, probably all the way down to Nancy Allisberg, number 81. Welcome, Lydia.
Thank you. Members of the Public Health Committee, my name is Lydia Bennett, and I respectfully oppose SB 88. I would like to address a concept that is sometimes expressed related to the discussion on physician-assisted suicide. If you think it's wrong, well, you don't have to use it. The general idea presented is that if it's not going to affect me personally, I needn't oppose the bill. Likewise, why should I be all that concerned about this bill? It's not like millions of people are going to take advantage of it with disastrous consequences. Let the few who wish to control the time and manner of their death be free to do so. But my primary concern is not only about who will use it and who won't. It's about the societal implications that this bill brings to birth. Through the process of legislation, this bill asks society to approve something that up to now we have collectively agreed does more harm than good, choosing to end one's life. Not only that, the proposed bill is designed for terminally ill patients who are already in the process of dying. But one can easily begin to question why the option to die should be restricted to the terminally ill with 6 months to live. Why 6 months? What about others who have not received that prognosis yet suffer equally or even worse? Patients who would qualify for this bill seek to avoid weeks or months of suffering. But what about those who experience years of suffering? And why limit it to those that are terminally ill? Where's the compassion for those who are painfully bedridden due to an accident or injury? What about the elderly who have lived long, happy lives and their only future is one of weakness and decline? We think that we can set boundaries on this issue that we won't cross and that future generations won't cross. We think that we can say, no, physician-assisted suicide will stay only legal for these people who fit our requirements. But this bill by its nature asks Connecticut to give its assent to a morality that is relative in its measurement, unsteady in its nature, and dangerous in its implications. It sets a new standard in the way we view the end of life. It is now okay to choose to end your life if you are terminally ill with 6 months to live. If this bill passes, the succeeding generations will grow up with a different starting point in the way they view the end of life. We are doing a disservice to future generations by moving the moral landmarks, because once we demonstrate they can be moved, they will be moved again. So I respectfully ask you to consider the dangerous implications of this shift in the moral framework of society, and please oppose this bill. Thank you.
Thank you for your testimony today. I don't see any questions, though I do note that a couple of people who we thought weren't available have now come into the meeting room. So we will move next, I believe, to Robert Hale, followed by Carolyn Bennett. I'm sorry, maybe I was wrong about Robert Hale. I got the wrong number there. Excuse me, Carolyn Bennett, followed by Peter Wolfgang.
Members of the Public Health Committee, my name is Carolyn Bennett, and I ask you to please oppose SB 88. In preparing my testimony, I thought it would be instructive to look at what data is available from the state of Oregon, where physician-assisted suicide has been legal for more than 2 decades. In the state of Oregon's 2020 Data Summary Report of Physician-Assisted Suicide, they list the top end-of-life concerns. More than one reason may be listed, so the percentages overlap. Number 1, less able to engage in activities making life enjoyable, 94%. Losing autonomy, 93%. Loss of dignity, 72%. Burden on family, friends, or caregivers, 53%. Losing control of bodily functions, 38%. Inadequate pain control or concern about it, 33%. No distinction is made between those who are actually in pain or those who are concerned about it. While physical pain is often listed as a top reason we should support this bill, it is worth noting that Oregon's report reveals that physical pain or fear of it ranks at the bottom of the list. Instead, the top reasons are psychological ones. It is also worth noting that any of these reasons could also describe the life of a disabled individual. I read an interview on this topic with Johnny Erickson Tata, a quadriplegic who has spent more than 50 years in a wheelchair. She says, "We live in an entitlement culture where cost-benefit analysis is preeminent. And who suffers in such a society? It's the elderly. It's newborns with multiple disabilities. It's those in comas. It's people with chronic medical conditions." In closing, I would like to say that I believe this bill promotes a counterfeit kind of compassion. Johnny Erickson Tata points out that we would rather escape suffering than face it or live with it. The word compassion, at its Latin root, literally means suffer with. That is a hard thing to do. But as Johnny says, true compassion is journeying alongside a person who is despairing and ascribing positive meaning to their pain, bringing them up out of social isolation, journeying with them, and helping them resolve their issues. For these reasons, I ask you to reject SB 88. Thank you.
Thank you for your very eloquent testimony. Very much appreciate it. Next up is Peter Wolfgang, followed by Nancy Allisberg.
Members of the committee, thank you very much. I hope you can all hear me. I never did quite get used to Zoom. So my name is Peter Wolfgang. I am the president of Family Institute of Connecticut Action. I am testifying against SB 88, which is the assisted suicide bill. I've been listening to as much of the hearing today as I can. You have my written testimony. I'd like to take my 3 minutes, if I can, to just hit a couple points that have come up in the course of these hours. In fact, they've come up in previous sessions, previous years. They haven't always been addressed. One of them that I think really needs to be discussed is the legacy of Bill Meyer. At about 12:45 today, Barbara Mancini spoke and referenced Bill Meyer. He's a hero of the pro-assisted suicide side of this argument. I know that Chairman Steinberg has mentioned him many times, a constituent, a friend, the guy who got him involved in this issue. This issue has come before a public health committee several times, going back to 2013. And Bill Meyer was the star speaker in 2013. And I will never forget that. In all the years I've been at the Capitol testifying on various causes, Bill Meyer is, and this is a matter of public record, he's the guy who held the bag over his father's head until his father died. And this was an agreement between him and his father. That's what got him in legal trouble. What you don't hear about a lot is the testimony that he gave that day in 2013. He actually testified. Now, he and his father had this agreement ahead of time. He actually testified that when he held the bag down on his father's head, his father changed his mind. He actually tried to lift his son's hands, and his son held his hands down until his father died. And it was completely off message for our friends on the other side. And Terry Gerentana, this was before you, Representative Steinberg, she was the chairman at the time. She tried to get him back on message, and she was like, well, but this was very traumatic for you, wasn't it? And he was like, you can go back and look at this. He said, no, it was, I became famous. I was on 60 Minutes. Mike Wallace and I became friends. We used to vacation together. It was really kind of shocking. I mean, he made this gesture with his hands, and it was actually you can go to Nicole Stacy's written testimony. There's a photo of it. It appeared in CT News Junkie in The Current with his hands like this or like this, describing what he did with his dad. Now, the only other thing I want to say, too, so, some of your heroes, I don't know are necessarily heroes. The other thing is the nurse, Sharon Sanford, who said, people, regarding the death certificate, you guys took that provision out about falsifying the death certificate. Shannon Sanford said, she's an insider, she teaches, she's a nurse.
Mr. Wolfgang, the time is almost up. If you would please summarize.
Sure. The single most important line I've heard all today, Shannon Sanford said, regarding the death certificate, people are free to write what they want to on the death certificate. You took the provision out about falsifying the death certificate. That's the smoking gun right there, that it's still there. And I think, in the Public Health Committee and beyond, the other committees need to be aware of that single line from Shannon Sanford. Thank you.
Well, sir, I do not have a question for you, but I must state that I'm disappointed that your main argument was to disparage Bill Meyer and to raise a circumstance that has really little to do with how this bill would actually be implemented. No
I saw it with my own eyes. It's why the bill hasn't passed.
May I finish, sir? You'll have an opportunity to respond, but I hope you'll afford me the opportunity to finish my statement. May I finish? Thank you. The point I'm making is that you're suggesting that because of the action he was obliged to take, because there is no such law in the state of Connecticut, that is an argument against the very rigorous approach that we're taking with this bill. And I have to object to that because I think it's very misleading. You may have comment.
The reason why I think it's relevant, well, it's relevant in a couple ways. I mean, you often say it's because of him that you bring this bill up every year. I think it may be because of him that the bill hasn't passed for the last 9 years or so. But my concern is, however many safeguards that you think you have, I don't know that he's necessarily the hero that you take him to be. And my concern is that you're empowering some potentially very ghoulish behavior.
Well, first of all, sir, I've never called him a hero. He's somebody I've respected. We come from the opposite sides of the aisle, but we've always worked collaboratively. And he was a very good person, I will tell you that. I'm disappointed, and I think it's tragic that he felt obliged to try to fulfill his father's wishes in that manner. And that is why we're here talking today, because what we want to do is something very different. But so thank you for that. But I'm again disappointed that you choose to denigrate someone else as a means to make your argument.
I stand by it.
Representative Carpino.
Thank you, Mr. Chairman. And I'm sorry I have to do this, but I just want to remind members of the committee that this is a very emotional topic for, I think, all of us, regardless of where you are now, regardless of where you were, and regardless or where you will be when the committee takes its vote. So I just want to make sure that we are respectful to everybody who comes before us, regardless of what they say. Whereas I do not agree with many of the things I hear in this committee, depending on the day. I think it is an obligation that we owe to members of the public to hear them out and let them have their 3 minutes. So I know that this is a bit more emotional, than perhaps some of the other committees or some of the other hearings, but I just want to remind everyone, it is 3:30. We have many members of the public who are still slated to testify, and I hope that we can be respectful to each and every one of them.
Thank you for that's an excellent point, Representative. Certainly, everyone should respect that. We're always hoping that it doesn't become personal. Thank you for your statement. Taken under advisement. If there are no other comments or questions, we'll move on to the next speaker. Let's see, Nancy Allisberg, followed by Margaret Dorr.
Good afternoon, co-chairs Abrams, Steinberg, and members of the Public Health Committee. My name is Nancy Allisberg, and I am testifying on behalf of Second Thoughts Connecticut and Progressives Against Assisted Suicide in opposition to SB 88. I have been a civil rights lawyer for almost 40 years and have been a disability rights lawyer for over 20 of them. Until my retirement in 2018, I was the legal director of Disability Rights Connecticut. You've heard a lot today about how people with disabilities are devalued, and you've heard from people who dispute this fact. I shared one story in my written testimony with you that I think may help you understand how people with disabilities are at risk of death because they are devalued. And I hope you will read that written testimony. I wanted to give you two more stories. I once represented a 30-year-old woman who experienced a massive stroke after a heart transplant. She lost her ability to speak, but not her ability to write. Nevertheless, her family decided that she would not want to, quote, live like that, and ordered that the doctors no longer provide her with anti-rejection medication and no longer provide her with screenings to determine how her heart was functioning. When I met with her, she wrote to me clearly that she wanted to live, and she wanted all treatment to continue to maintain her new heart, which was functioning fine. The facility where she was living listened to the family and refused to provide that treatment. I had to go to probate court to order her family to consent to treatment, without which she would have died a very early death. She was not terminally ill, but was considered as such by her family and by her medical providers. I also represented a woman with a profound intellectual disability who had a history of aspiration pneumonias. After her most recent illness, her guardian, who was her brother, decided that she'd be better off dead. So he issued a do not resuscitate order, a do not feed, and a do not hydrate order. And as her guardian, the hospital was following her orders until I got involved. She was not terminally ill, but was considered as such by her medical providers because of her disability. I had to go to probate court yet again to get an order for her to receive hydration and nourishment. She returned to her group home and lived there happily for many more years. All these people would be dead if I had not represented their rights not to be killed. Whether these particular individuals would be covered by the bill, these stories can show you how people with disabilities are devalued. It is a real thing. Listen to the testimony.
Time is almost over. If you please summarize.
I will summarize. Thank you. Listen to the testimony you have heard today that assumes that living on a ventilator is reason enough to die, or that having to be turned in your bed so you don't get bed sores is a reason enough to die. That definition of quality of life, that bed sores and respirators are worthy of death, is based upon a life of privilege and, to be blunt, ableism. So I would respectfully request that you read my written testimony, which talks more about the devaluing of disability lives and to defeat physician-assisted suicide, raise bill number 88. Thank you very much.
Thank you for your testimony. Representative Pettit has a question.
Thank you, Mr. Chairman. Thank you, Attorney Allisberg. I wondered if you'd comment a little bit further from your point of view, whether the concern to the disability community is a fear for themselves or a fear of changing social mores that may change people's approach to how they're cared for, per se.
I think the social mores are already pretty clear that they are devalued. So I don't think it's a fear of changing those mores. I think they would love to see the mores changed so that their lives are viewed as having a quality of life that's worth preserving. So I think it's a fear. You heard from Kathy Ludlam earlier this morning, and I remember her telling me, as part of a case that I talk about in my written testimony, where she was hospitalized and was told, if I remember correctly, this is a number of years ago, but she was hospitalized and was encouraged to think about not pursuing treatment because of her disability. So it is something that people with disabilities live with and are afraid of. The doctors that they deal with when they might have an illness are not trained for the most part. They might be trained in pulmonology if it's a pulmonary condition, or in brain surgery if they have a brain tumor, but they're not changed, for example, in how to deal with disabilities like Kathy's. And so they don't know what can be done to help somebody lead a very viable life. There was an attorney who I knew in California, Carrie Ann Lucas, who had a profound disability, was living in a wheelchair, had adopted 5 kids with disabilities, was on a respirator, could not speak, but she lived a full life. She had a communication device, which most doctors would not know how to use, and she was able to continue her practice of law, continue raising her children. So it's those kinds of things that people in the medical profession, with all deference to you, Dr. Pettit, but don't see on an everyday basis. And it's something that the disability community lives with on an everyday basis. And that's why I think it's really important to give deference to what the disability community is saying and accept the reality of their lives. 1, that they have been devalued, and 2, that they can live high quality lives in a way that the rest of the population might not see as a high quality. I mean, how many times have we heard a story, if I was in a wheelchair, I'd want to kill myself? We see that all the time. So it's important to listen to that voice. Thank you for your question.
Thank you.
Thank you, Representative. Representative McCarty.
Thank you very much, Mr. Chairman, and thank you, Attorney Ellsberg, for your testimony. I'm just curious if you've had an opportunity, I'm sure, to go through the bill, and if you could comment possibly under the definition of comment. There are 2 lines in the bill that say that it would also include communicating through a person familiar with the patient's manner of communicating. And I'm wondering if your organization has had an opportunity to look at those lines.
Well, just to be clear, I'm not with Disability Rights Connecticut anymore. So it's with Second Thoughts Connecticut. I think that what concerns me, and I'll speak for myself if that's okay, what concerns me about that is the physicians who determine whether or not somebody is terminal is going to have relationships with, for example, people in the psychiatric community who they will refer people to. And so, without, again, impugning the medical profession, my father was a doctor and I was very proud of him as a doctor. But you go to who you know, you go to who you're comfortable with. And I think it's the same thing with communication ability. You may not understand how iPads can work wonders for people who might have communication disabilities, which is one of the populations I'm concerned about with this bill. So I think that there has to be a sea change in the way the disabled population is viewed by the medical profession. And you heard people talk today about how difficult it's been for them since the pandemic, getting the kind of providers they need just to be able to help them take care of their activities of daily life. And until those kinds of problems are solved, I think this kind of a bill that risks those people's lives is something that is dangerous, and that's where we start getting to the slippery slope.
Right, and thank you very much for amplifying, and I'm sorry that I mixed up that you were no longer with disability, right? But I appreciate your concern, and I think it is very important that we have all the necessary safeguards in place to protect our individuals with disabilities. So thank you.
And thank you very much. And if I may say one thing about the word safeguard, one of the things that concerns me so much about this bill is that there need to be so many safeguards. And to my way of thinking, that means that people know that there are problems. People know that there are dangers. And if you continually have to build in safeguard upon safeguard upon safeguard, to me, that says, maybe we should not be thinking about it that way. Maybe we should rethink this and come up with a system such as palliative care that doesn't require us to have to build in those kinds of safeguards because it's so easy for people to be taken advantage of.
Again, thank you very much for your viewpoint. Thank you, Mr. Chair. Thank you.
Thank you, Representative.
Thank you.
Thank you for your testimony.
Thank you very much.
Next up is Margaret Dorr, followed by, I'll figure it out. That would be Douglas Moe would be after Margaret. So please, Margaret, thank you for being here.
Thank you. So this is my first time speaking on Zoom, and I think I'm more nervous. I'm a lawyer. I think I'm more nervous than when being in court. So in any case, I am a licensed attorney and president of Choices and Illusion, which is a nonprofit corporation opposed to assisted suicide and euthanasia. I have personally testified in 20 US states, including Connecticut, and also internationally, and I'm speaking in opposition to Raise Bill 88. Yesterday, I submitted a formal analysis, which I have here, and if you don't have it, please let me know and I will send it again. It details problems with the proposed act, that it's not what it's sold to be. So I also encourage you to look at my website, which has another version of my analysis, which is at www.choiceillusion.org. Okay, so the proposed act seeks to legalize aid in dying. Aid in dying has been a euphemism for euthanasia since 1992, and that's in my materials. So that's what aid in dying means. You are legalizing euthanasia as well as assisted suicide. The act has a 6 months to live criteria. In real life, however, this is determined without treatment. So as an example, you may have heard this one before. I have a friend, Jeanette Hall, who was talked out of using assisted suicide in Oregon 20 years ago. And this is her poster. I need to get here. So there she is. So she was talked out of it. So when it's not limited to people near death. And so that's something that needs to be understood. Plus there have been proposals to expand in other states. I also wanted to talk about, there's an application process, you know, how it works. And then you get the lethal dose. Once it's in the house, there's no oversight at all. So 2 people can be there. One can leave alive, one can be dead, leave dead. The one that leaves alive can be an heir or a son. I'm an inheritance lawyer. I've seen the terrible things people do to each other. So anyway, you can kill dad. Dad's starting to get better. Oh, dad, you know, let's have a drink. You're getting better. Let's have a drink to that. You know, have a couple and then have a special drink with something in it. The person's dead. The death certificate will be falsified to reflect a natural death, no matter what, because under the act, it must be a natural death. And I explain that in my memo, why that's true. I also wanted to throw in just a few personal experiences I've had I'm from Washington State, and when our law was first passed, I had a number of people contact me. In the first case,
excuse me, Ms. Dorr, your time is almost up. If you please summarize. Thank you.
Well, the law allows that you're looking at allows involuntary death. And please read my memo to see why. And a lot of it is the lack of oversight of the death and the required falsification of the death certificate to make it natural. So then people can inherit. You know, it's an easy way to kill dad. And the middle class and above are the most at risk, which would be people like you. So if you pass this bill, you are opening yourself up to heirs and other creditors. So I guess
Thank you
that's
for
my
your
final thing to
testimony.
say.
Thank you for your testimony.
Thank
I
you.
don't see any questions. We'll move on. Next up is Douglas Moe, followed by Josh Pawelek.
Hi, I'm Doug Moe. I live in Easton, and I'm speaking in favor of Senate Bill 88. In January of 1997, my dad was admitted to Lord Chamberlain Hospice care. That admittance was subsequent to many months living at home with my mother taking care of him. He was dying from terminal colon cancer. And it reached a point where even with home nursing care, my mother just couldn't cope with the strain anymore. And so my dad was transferred to hospice care. About 3 or 4 days before he died, an event occurred which is seared into my memory, even though it's 25 years ago. My mom and I went to visit him. He was lying in his hospital bed, diapered, being spoon-fed, and he was generally unresponsive. We didn't even know if he was sure that we were even there. Well, anyway, when we got ready to go, my mother stepped outside the hospital room, and I was about ready to go out myself, when suddenly my father bolted up in bed, sitting upright, looked at me with his, I can still see those black eyes boring down on me, and he shouted at the top of his lungs in that hospital, his voice ringing up and down the hallway, "Help! Help! Help!" And I knew damn well what he meant. He wanted me to help him exit the world. He wanted out. He'd had enough. And I had to turn my back on my father.
There's no picture of me.
I had to turn my back on my father and walk out on him, knowing that I was leaving him in extremity. Fortunately, he died 3 or 4 days later. And what I'm saying is that all of us hope that we get the lucky number, that we go out in our sleep or we go quickly. But some of us are going to draw the wrong card, and we're going to have a prolonged illness, maybe with metastatic cancer. And we're going to be in that hospice bed, being diapered and fed, our mental state in a state of delirium because of the drugs that they're pouring into us in an attempt to control our pain. And
Excuse me, Mr. Moe, your time is almost up. I'd appreciate it.
I'll finish up, Kathleen.
Thank you.
Many people who oppose this bill now will rue the day that they turn their back on compassionate care for the dying. Please pass Senate Bill 88. Provide the mercy to residents of the state of Connecticut that were denied my father when he was on his deathbed. Let's be a little bit more merciful in the future, please. Thank you.
Thank you for your perspective and your sharing your story. Next up would be Josh Pawelek, followed by Ellen Abrams.
Hi, good afternoon, members of the Public Health Committee. I am the Reverend Josh Pawelek. I'm the minister of the Unitarian Universalist Society East in Manchester. I live in Glastonbury. Thank you for this opportunity to speak in support of SB 88 and medical aid and dying. One of the saddest situations I continually encounter in my ministry is this: a person with a terminal condition who desires to end their life with medical aid is prevented from doing so by law. As their disease runs its course, they slip into a sustained non-lucid state they never wished to be in, sometimes for months. Their family members then say to me, "This is not how our loved one wanted to die." And at this point, it is clear to all involved that the dying person has been stripped of their autonomy and their dignity. This is tragic. SB 88 seeks to address this tragedy in a safe, reasonable way, and I urge you to support it. Every day, there are people who receive news that there are no remaining medical interventions to treat a terminal illness that will inevitably and quickly end their life. Some of those people, after careful consideration of all the ramifications, find in themselves a strong desire to end their life with medical aid rather than let their disease run its course. There are many reasons for this desire, but the primary reason people seek aid in dying, at least in my experience, at the end stages of terminal illness, is because it assures them they will maintain their autonomy and dignity at the end of life. As a pastor who will inevitably be asked to serve as a witness to requests for medical aid in dying, should this bill become law, assuming the person in question meets the criteria described in this bill, I cannot imagine saying, no, I don't support you. For me to witness and support such a request and to be present at the time of death, if invited, would be an act of the most compassionate, loving ministry I can imagine. Some argue that simply allowing a disease to run its course, to allow a person's life to wind down naturally, is also death with dignity, and I certainly agree. Many, if not most people, choose such a death using palliative care or the services of hospice. We've heard a lot about that today. Their choice, the fact that they can make that choice, is evidence of their dignity and autonomy. As a pastor, I will always first counsel those under my care to strive for such a death rather than seek medical aid in dying. However, experience tells me there will inevitably be people who are better able to let their lives end naturally. They have the choice to end their life with medical aid. Having choice brings comfort, peace of mind, and a reduction of anxiety. Having choice sustains dignity and autonomy. Your favorable vote in support of SB 88 is more than a political act. It is an act of great compassion, care, and love. Thank you. Thank you for this opportunity.
Thank you, Reverend, for your sentiments. Very well put. Next up, I don't see any questions, so thank you for your testimony. Next up would be Ellen Abrams, followed by Linda Bluestein. Is Ms. Abrams available? Maybe I.
Hi, do you hear me?
Yes, we hear you. Thank you.
Good. Oh, good. Thank you to all members of the Public Health Committee. My name is Ellen Abrams. I am grateful for this opportunity to speak in favor of this bill on an issue that has taken on so much meaning for me as I watched beloved relatives and dear friends face the end of their days on this earth, medicated for a long period of time, unable to communicate with their loved ones, and unable to be at home because of agonizing discomfort. I have so much faith in this committee to make the change to give individuals a choice or an option at the end of life when further treatment is futile. To have this ability in Connecticut would be such a privilege. Having this choice at the end of one's life, still not available in Connecticut, requires that you have the energy to relocate to a state that provides this option, that you not be too ill to make the move, that you have the monetary funds and family support to do it. The choice made at the end of one's life is very personal. The privilege of having the option of medical aid in dying in Connecticut following a diagnosis of a terminal illness will enable me, now in my 80s, to have choice, to end my own suffering peacefully, to ease the prolonged suffering of family members and dear friends, and to stay near family in Connecticut and enable communication with those I love. That is what is important to me. I urge you to pass this current bill, SB 88, to give that personal option of medical aid in dying to every person in Connecticut and to me and to my loved ones, should they so choose when their time comes. Thank you.
Thank you very much for your testimony. And you were one of the few who was able to make it within the time limit. So we also appreciate that. Next up is Linda Bluestein, followed by the Reverend Dr. Carson Bull.
Members of the committee,
My name is Linda Shannon Bluestein, a resident of Bridgeport. I speak in support of SB 88. This bill is about me right now. I'm a patient with a life-limiting diagnosis currently in palliative care. I simply want the right to have a say in the timing and manner of my own death when my disease aggressively erodes the quality of life that is essential to me. Last March, when my doctor called with the results of a CAT scan, I was sure it would show nothing. My husband picked up the phone in the kitchen, talked, then silence. He walked into our bedroom. His eyes were red and tears were streaming down his face. It's not good. It's very bad. You have cancer. It's ovarian. It's late stage and it's already spread. He took me in his arms and we just stood there in the middle of our bedroom hugging one another for a long time. He was sobbing. I was in shock. 8 days later, he dropped me off at Smilo Cancer Hospital for surgery. 10 days in the hospital, a month to recover, and then a summer of chemotherapy followed. Next Monday, February 28th, I will have my 6-month scans to see if the cancer has reappeared. That's where my life is now, in cancer's waiting room, every 6 months. I've had almost a year to think about this. I've gotten my affairs in order, and I know what I want for my last day. I want to die at home with my family, including my dog Tucker beside me. I see us smiling as we retell family stories and maybe even play some music together. I want to have a long last shower in my own bathroom, put on my favorite PJs, slip into my own bed, and drink the apple juice cocktail containing my prescription, fall asleep, never to wake. We're strangers, you and I, and yet you have the power to decide how many more hours, days, or even weeks of intense suffering I must endure before I pass. Not one of you will be impacted or even aware of my passing. I implore you to move beyond any personal reservations you may have about my death and dying choices. They may not be yours, but they are mine. Personal, private, precious, and sacred to me. You may have the power to decide what I may or may not do at the end of my one precious life, but you don't have the right. Nevertheless, it's your turn to consider if compassionate choices in dying will be available to me and your constituents, maybe even your family, your friends.
I'm sorry, Ms. Bernstein, your time is almost up. If you
Thank
would
you. I invite your
summarize.
questions. I've said
Thank
everything.
you. Thank you.
Well, Ms. Bluestein, I don't have a question, but I want to thank you for your testimony, giving us the experience of someone who's exactly in this circumstance. And I'll just add that you seem to have given a lot of thought about how you want to go out on your own terms, and sounds pretty good. We have a couple questions for you.
Okay.
Representative Berger Cervallo, followed by Representative Kavros DeGraw.
Okay.
Hi, Linda. Thank you so much for sharing. And I do want to begin by saying that I'm already impacted by you. So let's not undercut that.
Okay, thank you. It was worth something then.
My question for you is, can you speak about being in the physical health that you're in, what you're currently experiencing? What is the idea of having to move to another state so that you can access this, go through the motions of finding a new home, moving in, establishing residency? What is that a daunting process, or is that just kind of an easy choice to make?
Oh, daunting and easy. Daunting, yes. Easy, no. I'm here because 3 years ago, I had breast cancer and malignant melanoma. This is my 3rd primary cancer. I know where my life is ending, folks. Put whatever you want in my death certificate. I know what's getting me. I'm following my mother, who also had 3 primary cancers. So this is serious. I met a woman in the Norma Freem Cancer Center in Fairfield, and we took Qigong classes together. She had lung cancer. On February 3rd of this year, Kathy, who I've been friends with for the last 3 years, wrote me her last email, and we've been in email contact every day. And she said, "Dearest Linda, in 2 hours, I take flight." Every day that Kathy had to live in Vermont, and this is what she said, "I'm going to leave a trail of breadcrumbs for you because this ain't easy, girl. This ain't easy, girlfriend," she said. She had to leave her home in Fairfield, down by Penfield Beach, drive herself to Vermont, find a place to rent. She sent herself some letters and some packages through Amazon so she could establish residency, re-register her car, get a driver's license, and register her vote. Then she had to have all her MSK scans and stuff sent to new doctors she had to find. Not easy. She was immediately accepted into hospice. She had less than 30% lung capacity by the time she got to Vermont. And then she had to find the witnesses who were not attached to her. She said, "Linda, this isn't easy. Pay attention to this, write this down." And she said, "I had to go to a coffee shop and sit and talk to somebody who was ordering a latte and convince them that I was in my right mind, because a lot of people didn't want to sign." And then she said, "I couldn't get a second person at the coffee shop, so I went shopping, and then I went to the guy who picked up my garbage. He said, 'No, I'm afraid the government will track me down.'" She went to a bookstore and talked to the owner of the bookstore, who agreed to sign her form. She said, "Linda, it's 15 days and then another 15 days and 2 people, and I got my Coles form signed." Finally, her family was together, and she found home hospice in the home of a man, Bill Kilgore, where her family could come and stay with her in his big Vermont home, her son and her daughter and her husband. And when she couldn't breathe much anymore, she said every day is like suffocating. She wrote me her last email. She said, "No more instructions for you, girlfriend. Pay attention, because this ain't easy. It's like voting in Texas. They say you have the right, but sometimes it's pretty damn hard to get that ballot." So we were friends until the end. All of our Qigong sisters were together when she had her little memorial service at the Penfield Pavilion in Fairfield. And there are hundreds of people there. The family thought maybe 25 people. They spent the next hour and a half just bringing in chairs because people wanted to say goodbye to Kathy. That's what I want. And Kathy left me instructions. Do I want to die in Vermont? No, hell no. I love my neighbors. I love my neighborhood. I love my home. I want to be here. But if I have to, I'll have to move to a more compassionate state. Let's just put it that way. But thank you for your question.
Thank you for your answer and for being so honest about it. And I would hate to have you to have to leave Connecticut. So thank you very, very much for being so brave.
Okay.
Thank you, Representative Cabarrus de Graaf.
Hi, Linda. I'm so grateful you're here today. I'm so grateful that we have this opportunity to hear from you, as we've heard from so many on both sides of this issue. I think one of the things, and I do have a question, but one of the things that I think means a lot having you here is you are so clearly full of life. And I think that has been missed in some of these conversations, is that you are so full of life and you would love to continue. And your wonderful husband testified earlier, and I'm sure you have wonderful children that you would love to be with, on and on and on.
And grandchildren. I want to stay with my granddaughters. I'm still tutoring them on Fridays. I mean, I have a life that I love.
Yeah.
Truly.
Yeah. And I think that that's a really important piece of this. Do you, I mean, as you stated, you know where this story is going. Yeah. You've read it before with other people. Do you have any concerns that, should you change your mind, that you would be in any way coerced if, that legislation like this was legal here?
No. My husband and my children, they want me with them as long as I can be with them. They're very clear. They've been with me on this all the way. They know what mom wants very clearly. She likes her coffee, she likes the dog, she likes things, but she also doesn't want them changing her diaper. She also doesn't want to be blotted out with pain medications so that she can't even sit up and talk to them and be with them. They want to hear their mom and their dad sit down with him with the guitar, me with the ukulele, and play and sing together. That's what they want too. But they also cannot bear what my disease is. This is my 3rd cancer, folks. Not my first rodeo. They don't want this taking any more from me than has already been taken. And I've been hacked up in the last few years.
Thank you again for your bravery today. It's really quite a lot, and you have had impact on, because I'm looking around the room and I'm not the only one choked up. So you've had impact today. Thank you.
Certainly have. Thank you again for your testimony. Very much appreciated. We will move on now to Reverend Dr. Carlson Bull, followed by Walter Nagel.
And Representative Steinberg, if you'd like to take a break, I am here.
Why don't we do that? Thank you so much for volunteering, Senator Kushner.
Go ahead. Is that Reverend Dr. Carlson Bull here? Are you ready to begin?
Yes, I'm here. I'm here. Can you hear me?
Yes, we can.
Good afternoon. My name is Reverend Dr. Jan Carlson Bull. I reside in Middletown, Connecticut, and I testify today in support of Senate Bill 88, Medical Aid in Dying. I speak as a Unitarian Universalist minister and as a friend of one for whom this bill is intensely personal. If God is love, God is also compassionate and merciful. This is the God I believe in. This is the God I share with my congregants. Life is a gift, so is a peaceful death. When any of us receive a terminal diagnosis that promises only a death of pain and suffering and possibly panic, where is compassion? Where is mercy when we breathe our last? Compassion and mercy are in your hands. As a minister, I can never forget the congregant who spoke again and again during a segment of worship for sharing joys and sorrows of his late wife and how she died. After a harrowing struggle with cancer, she wanted nothing more than to die, peacefully surrounded by her family. Connecticut had not yet legislated this option, and she died in horrific pain that her husband still carries. I still carry her husband's pain, helpless as I was to alleviate it. I have a dear friend who faces a similar end. In fact, she just spoke to you. Linda loves life. She does not want to die, that's clear. With a diagnosis of advanced stage cancer, she holds the dread of her last moments marked with intense suffering. I share her dread and her desperate hope for medical aid in dying at the time she chooses, surrounded by her loving family. It's anguishing to be a pastor or a friend and be helpless. I'm testifying before you, so I'm not helpless. In our worship services, we often sing these lyrics. When I breathe in love. When I breathe out peace. In the name of love and compassion, I implore you to support this bill by releasing it from committee as you did last year, and then encourage your colleagues on the Judiciary Committee to do the same. By doing so, you can help to ensure that all among us who struggle under a terminal diagnosis with the prospect of a painful death might instead have a choice, not be forced to, but have a choice in how we
Reverend, I'm sorry, your time is almost up. If you'd summarize.
In how we take that final breath, breathing in love, breathing out peace. Thank you, and I welcome your questions.
Thank you, Reverend Doctor. I don't see any hands. We thank you for your testimony today. Next up, we have Walter Nagel, 91. Is Walter here? Okay, I don't see Walter. If he arrives, we can come back to him, but I will next call number 92, Jean, and I'm going to slaughter your last name, Kananowitz.
Right, thank you. Distinguished members of the Public Health Committee,
My name is Jean Kanonowitz, and I am a resident of Connecticut. SB number 88, an act concerning aid in dying for terminally ill patients, should be opposed. This bill contains a fatal error implicit in its foundational guiding principle. The fatal error is that it is permissible under certain circumstances for a person to kill themselves by suicide, and that it is permissible for members of the healthcare profession under certain conditions to prescribe lethal drugs to be dispensed to persons in order for them to ingest the lethal drugs to kill themselves by suicide. Just for clarity, the definition of suicide in the Merriam-Webster dictionary is, quote, the act of killing oneself purposely, end of quote. This fatal error implicit in this bill is illuminated brilliantly by the commandment, you shall not kill, and by a central facet of the traditional medical ethics embodied in the phrase, first do no harm. This bill would corrupt the medical profession, whose ethical code calls on physicians to serve life and never to kill. Whatever its motives, the prescribing and dispensing of lethal drugs in aid in dying consists in putting an end to the lives of sick or dying persons. This is morally unacceptable. Quoting from the Catechism of the Catholic Church, quote, thus an act or omission, which of itself or by intention causes death in order to eliminate suffering, constitutes a murder gravely contrary to the dignity of the human person and to the respect due the living God, his creator. The error of judgment into which one can fall in good faith does not change the nature of this murderous act, which must be forbidden and excluded, end of quote. I implore our lawmakers in the state of Connecticut to increase the availability and utilization of palliative care services and to work to integrate palliative care into our healthcare system. Palliative care helps keep people pain-free while giving them the compassion and comfort they deserve. Palliative care principles are the principles of good care, whatever the illness or condition, whatever the stage or prognosis, whatever the age, gender, race, or creed of the patient. I put forward the guidance in this testimony.
Excuse me, Ms. Conowitz, your time is almost up. If you please summarize. Thank you.
Thank you. I put forward the guidance in this testimony, which includes the guidance of the Catholic Church on objective truth, in the hope that this guidance will inform your decisions. Thank you.
Thank you, and thank you for your testimony. I don't see any hands, so thank you for being here tonight. Next up, we have John Kelly, number 94. John, can you, if you can hear me, can you unmute yourself? I see you there. Thank you. Go ahead. We can hear you now.
Okay, yes. My name is John Kelly. I am the New England Regional Director for Not Dead Yet, the National Disability Rights Group Against Assisted Suicide. I am also the Director of Second Thoughts Massachusetts, the sister organization to Second Thoughts Connecticut. I became disabled at the age of 25, and it was an immediate social demotion. I was in the educated classes that we're seeing on this webinar today, and I understand where proponents are coming from. But one, we have not heard the phrase social class once today. The people who are pushing for this are overwhelmingly white, more educated, as we've seen in California, 94% white, non-Hispanic, which while the group only represents 39% of the population. And I can understand people thinking that they should be able to, in consultation with their doctor, decide to do this. But that's because they're used to being treated with respect by medicine. They get treated like an equal. Many of the people on this webinar have no idea what it's like to be treated badly, to be ignored, to have our requests dismissed. And, you know, many people oppose this. The polling that's being quoted is from Gallup, and the question is about euthanasia. That would you support doctors helping someone die by painless means if they have an incurable illness? The people in this webinar are, like society at large, conflating terminality with disability. It's conflated again in the Oregon reports, where again, people are talking about disability, about autonomy, about not being incontinent. And what's going on here is a bit of a class cultural war in which people are defining what it is that makes life worth living. For the white, highly educated proponents of this, it's about autonomy. It's about
Excuse me,
being able
Mr.
to
Kelly,
enjoy
your time is
activity.
almost up. Mr. Kelly, if you would summarize, thank you so much.
Okay, people tend to think of people's issues as in their bodies, when we know really that it's about ideas about disability, it's about prejudice, it's about discrimination. Black and brown people oppose this. The city of Lawrence in Massachusetts voted 69% against. Do not implement this over the objections of people who believe that connection with others is more important than personal autonomy. Thank you.
Thank you, Mr. Kelly. I do see a hand, Representative Carpino.
Thank you, Senator. I just had a question, Mr. Kelly, on your last point. You indicated that Lawrence, Massachusetts had taken a survey, or you cited some statistics. I was curious to learn in what context that survey was taken in one community. I know the Lawrence, Massachusetts community fairly well, and I just wanted to understand a little bit about who and when that survey was taken, so I could look into it.
Thank you very much for that question. That was the 2012 referendum on assisted suicide when it was up before the people. And if you go to the Second Thoughts website, we have a compilation of the voting. And if you look at the poorest towns, they're against. If you look at the wealthiest towns, they're in favor. And that goes to the broken healthcare system in this country. Even practitioners and proponents of euthanasia in Europe say that the United States must never have this because of the true lack of freedom in terms of choice. I mean, look at what happens when the choice is either going to a nursing home or staying at home with people who don't want to take care of you. Kathy Ludlam said so well, the pressures on us disabled people. I have people who have said to me that they would rather be dead than like me. We've heard people today talk about people who needed to die because they had a diaper, or they were incontinent, or they couldn't speak. They are describing disability. So I hope that the committee will really consider this and not have the state sponsor people's suicides because they feel lack of dignity, because they're incontinent, because they feel like a burden. It would be a stain on the state of Connecticut.
Thank you. We keep hearing about how other states have handled things, and we hear about a number of states over the past few hours. So I appreciate hearing about the referendum in Massachusetts. Thank you, ma'am.
Thank you. And I also see a hand up from Representative Cabros-DeGraw.
Since you did mention that referendum in Lawrence, how long ago was that? And do you have approximate demographics for that town in Massachusetts?
The referendum was in 2012.
Okay, and just approximate demographics by any chance?
Well, Lawrence is highly Latino and also has some Black people. The four most Latino cities in the state all voted heavily against. Wealthier, whiter towns voted in favor.
Okay, and perhaps maybe, and I say this because I know this is a religious issue, and I actually went to a Catholic high school that was primarily Latino outside of Washington, D.C. I'm sure that perhaps that also feeds into it as a religious objection to aid in dying due to the nature of the population, usually having a higher population of Catholics.
Yes, they may well be more Catholic, but this is also a cultural issue. The family connectedness, the respect for elders is there regardless of whether the family is overtly religious.
Yes, you know what, as a Greek American, Greek Italian American, I certainly can understand that ethnic connection. And, you know, everyone that we've ever cared for, we've had hospice in the house. So I've been profoundly influenced and as one of the, I think our previous testimony suggested, you know, the privilege of being with a loved one when they pass. So thank you for your testimony today.
Well, and the ethnic enclaves north and south of Boston also voted against it. Italians on the North Shore, Irish on the South.
Thank you, Mr. Kelly. And I don't see any other hands, so I'll move on to Mr. John Pike, number 95. Are you with us, Mr. Pike?
I am. Can you hear me okay?
Yes, I can. Go ahead.
Good afternoon, members of the committee.
Bam!
Okay, just a second. We need, okay, go ahead.
My name is John Pike, a licensed physician assistant in the state the last 38 years. I'm the Connecticut State Director for the American Academy of Medical Ethics, and I'm testifying in opposition to this bill. I've listened from the beginning to the testimony to see if this was mentioned, and not until the last person who spoke, who alluded to this Pew Research study that did show that in every single state where assisted suicide is legal, the vast majority of patients who killed themselves by lethal prescription are not Black, Indigenous, or people of color. He talked about the Massachusetts referendum, but when you go into Oregon in 2019, 96% were white. And in Washington, 96% were white. So predominantly white participants have been the driving force behind this practice. The consequence is that the system could impose this cheap assisted suicide option on populations who already fight to overcome unequal healthcare. You know, literature abounds with data, and you know this, showing the healthcare inequities among minorities. And this may further limit their care since insurance companies have already demonstrated their proclivity to deny life-saving treatment and instead offer assisted suicide to save costs. We had testimony in favor today from someone who didn't mention it, but has been a senior executive of a large medical insurance group in Connecticut and elsewhere, which might have prompted some questions about this practice. This law, as in other places, produces a value judgment, in my estimation, that someone's life isn't worth living. Enacting this dangerous legislation is never the final stop. Medical aid in dying will become mandatory aid in dying down the road, which defines the term mission creep and the very real possibility of slippery slope. It's not a cliche. We heard earlier from someone that these fears continue to be realized in Canada. Their assisted suicide law passed in 2019. At the end of 2020, over 21,000 people had ended their lives. That last year was up 17% and will continue to rise, especially since they have amended their legislation to expand access to people not nearing the natural end of their lives. Not exactly a small number of people using assisted suicide, as some have testified about today. And a lot of the data show that people choose to die because of just existential suffering connected with autonomy and enjoyment, but many measures like therapy, financial
Excuse me,
support.
Mr. Pike, your time is almost up. If you please summarize. Thank you.
Thanks very much, I will. It takes no great skill to kill a patient, but it takes consummate skill to provide good end of life. And we could provide adequate relief in their dying process instead of leading them to it. Suicide is a permanent solution to a temporary problem. Thanks so much. I appreciate your time.
Thank you. And I do see a hand, Senator Summers.
Yes, Mr. Pike, thank you for your testimony. What you said sparked a question that I had wanted to ask earlier, and I'm concerned about. As we are seeing the change in insurance models and compensation for physicians, I know that many are moving to a model where the physician is compensated based on how healthy his patient population or her health, or how healthy her patient population is in their practice, you know, and incentivized to obviously keep your patients healthy. When you said that aid in dying will become something that is going to be looked at, I can't remember exactly what you said, but you made it sound like it is a foregone conclusion that that will be something that will be happening, you know, based on our insurance models, so to speak. I can see that as a subliminal incentive on some level. If you're a physician caring for those at the end of life, that, you know, you, whether intentional or not, if your compensation is based on how healthy your patient population, do you see that becoming a conflict of interest as we move forward? And my second questions as a PA, some of the stuff in this bill, for example, I think it says that a social worker can make a determination of competency. I find that out of their scope of practice. I was wondering if you could speak to that.
Yeah, let me answer your first question. I don't know how much the physicians would get involved in that. Although, as you know, there are many halts that are put on what we do because of insurance companies saying no, yes. But what has happened in other states and out west is there have been people who have been denied treatment for their illness because of the cost of treatment, but they were offered the assisted suicide medication instead. So that has already been a precedent that has been set and could extend. Again, you talk about inequities in the healthcare system for minorities and otherwise, that could theoretically be extrapolated out to others to say, well, we can't give you this, but we'll offer that. In regards to your second question, as a PA, I have concerns that, and there are other states, New Mexico this last year passed a law that also allows PAs and NPs to also write those scripts. I have a concern. I don't want to be the person to even have that option, but I don't think that social workers, my wife's a social worker, so I guess I could maybe speak to that, but I don't think that they are qualified to say whether somebody is competent or not. I was actually a little concerned about the one person who testified a couple times ago, very poignant testimony, but she looked around for somebody in coffee shops to say that she was a witness. How did those people know in reality? How did they know that she was really competent to sign that? That just stuck out in my mind. But anyway, I'm not sure that, and I don't want to malign social workers at all, but I think it should be a psychiatrist or psychologist that would state whether they're competent or not. And I hope that the bill doesn't pass anyway, so we have to deal with it.
Well, my last question would be, and I'm going to be asking this of other clinicians too that come on, is I'm concerned about this cocktail, because the cocktail is not, it's a mixture of different drugs. It's not indicated by the FDA. It's not intended for that use. Yeah. And my concern is you mix a cocktail, and some of the diseases that we've heard from people on, they would not be able to take this cocktail themselves anyway, under the conditions of their particular disease. Yeah. And what happens when that cocktail doesn't work? Because it's not tested for that purpose. It's off label. A physician is writing really an illegal prescription. And you know, you could have a patient aspirate and if they're by themselves, they don't have to be with somebody. Those are really parts of this bill that are really concerning. And I would like to get your opinion as a clinician, what your thoughts are on that.
Well, to start with, the amount of drugs that are written for people to end their life are enormous. I mean, a huge amount more than what, if I gave a patient a prescription for a benzo, for instance, I mean, what they're given is a huge amount of medication. And sometimes people have trouble even taking all that, and then they end up vomiting. And there have been cases where people have not died in an hour. People have gone almost a whole day and a lot of suffering, or they vomited it back up. They couldn't take the medicine. So it's not necessarily the panacea that, oh yeah, I'll take this in an hour and a half or an hour, I'll be dead. That hasn't always panned out, not at all.
Okay, thank you for your answers. I appreciate them.
Thank you.
Thank you, Senator Summers, and I see Representative Berger-Zavala.
Thank you so much, Senator. I just have one quick question. I'm looking for your organization, Academy of Medical Ethics, and
yes.
I'm just curious, do you have any affiliation with the Medical Association, with any actual, is there any affiliation with any medical groups, or is this just an independent group?
We're a Christian organization. It's ethicalhealthcare.org, which you can go to on the website, and we are a DBA, if you will, of CMDA, Christian Medical and Dental Association, and we have state directors in every state, and we provide testimony on assisted suicide, but other issues as well. Abortion, right of conscience is a huge issue. So we provide things for that too.
Thank you. Are you finished, Representative? Yes. Okay, I see Representative Michelle Cook next.
Thank you, Senator. I wanted to thank everybody for their time and patience today. John, I do have just one quick question, and I know that this becomes a battle of what may be personal belief, but what others might believe is not right to have a conversation. But if we're discussing this in a manner that affects all people, we know that you have your view and others may have their views. So is it right, in your opinion, to say that the people that have their views cannot decide to do what they choose to do with themselves? Or is it a matter that other people should be able to tell them what they should or should not be able to do? I'm just trying to understand where you're coming from. And look, I'm a born and raised Baptist girl, so this is not a conversation about religion or me dictating to somebody what they should or shouldn't do. But I'm trying to understand, as a policymaker, should we not give people the right to choose as opposed to telling them what they can't do? I'm just trying to understand from your views.
No, I understand. And previous years when I've testified, and I didn't this time because I wanted to make these other points that I was making. But one of the points I always make is that what my concern is that as physicians or PAs, for time immemorial, we've been tasked to be healers. And now you're asking physicians to be the killers. You're asking physicians to be complicit in the deaths of patients. And that really, to me, it goes beyond what the free will we have as individuals, but it's more of what you're asking the medical profession to do. And I know there are people out there, and I don't agree with one person who said that the vast majority of physicians agree with that, because they don't. And vast majority would not want to participate, even if it's legal in the state. So it's really wrong to say that they agree with it. But it's really the perspective of asking the physician, or being against asking the physician to do this, as opposed to the whole idea of the free will of the person.
Senator, just one wrap up to that, please. And I promise I'll be quiet for many, many more hours. But to to go back just a second, and not to be controversial, but when my stepmom was dying of lung cancer, and I have spoken about this in our last couple of public hearings in regarding to this, you know, she only had 5.5 months of life once her diagnosis was, before she begged the doctor in the hospital to give her anything to take her out of the pain that she was in. And the struggle that I have with this is, on her nightstand was enough morphine prescribed by the doctor that she could have chosen at any given time to take that and end her life. So and this is where I really become very conflicted with this conversation, because modern medicine allows you as a provider, a medical provider, to prescribe ample amount of morphine to take away the pain, to make you feel comfortable. So so that's been given to a patient, and that is in their hands. But yet it's not okay if they choose to take it in a manner that directs their life to the way that they choose to direct it. And so for me, that's where I become very conflicted. Where is that balance? And I just don't know if that is our right as legislators to tell someone that they don't have that right. And at the same time, nobody should have to find themselves hiding, God forbid, with a gun in the middle of the woods to take their life in an undignified manner, because their pain and suffering is so bad, they don't have another choice. So I just find ourselves to be in a very peculiar position. And for us to be able to say it's got to be one side or the other, I find to be very difficult in the middle of this conversation. It's not a debate. I was just,
No, I understand.
But thank you.
It goes to the intent of what you're prescribing. Yeah, they're given enough morphine ostensibly to end their life, but that's not what it was intended. That's not what it was intended when it was given. I could give you a prescription for 30 or 40 sleeping pills, but I didn't give it to you intending for you to take and end your life. I gave them to you with the intent that you use them once a night, but could you take them and end your life? Of course, but that's not why I gave it to you. So I'm not being complicit if you decide to do that, as opposed to me giving you the medicine to end your life, where I am complicit.
Thank you. Thank you, Mr. Pike.
Thank you.
I don't see any other hands at this moment, so we'll move on. Thank you for your testimony. We'll move to Teresa, and I think it's back Huber, number 96. Teresa, are you with us? I see you there.
Good afternoon. Yes, I am.
Go right ahead.
Good afternoon, and thank you to the distinguished members of the palliative of the Public Health Committee. My name is Teresa Bakuber. I live in New Hartford. I am testifying today in opposition of SB 88. For nearly 38 years, I've served the communities of Connecticut as a registered nurse. I've worked bedside in our hospitals and nursing homes, carried the bag of a visiting nurse, conducted office hours as a church or parish nurse, and been by the bedside with many patients and families as their loved one made their final journey. As executive director of 3 hospices in Connecticut for the last 25 years, my teams and I have provided care and solace to countless patients and families, but there's been nothing like the last 2 years. The myriad psychological effects of COVID-19 has caused great concern. The depressed and mentally ill challenged of our state need stability following this tumultuous period. Over the years, hospice has done especially well in Connecticut, where hospice was born, where we have 23 hospices, including standalone and hospital-based inpatient units for patients and families who either can't or refuse to be at home at their journey's end, as well as several palliative care programs. Hospice is easily accessed to those having a prognosis of 6 months or less. It can be provided wherever the patient calls home, and it's important to note that there are 4 different levels of care: routine level of care, continuous home care, general inpatient level of care, and respite care, often misunderstood. The design of hospice is to aggressively manage symptoms while adding quality to each day through an interdisciplinary approach, addressing physical, emotional, and spiritual needs versus hastening death. Team members are armed with an arsenal of pharmaceutical and other palliative interventions designed to address any and all symptoms. Patients are empowered to make their celestial journey in peace and in comfort, maintaining the control of the situation with the guidance of their loved ones and their care team. Support to loved one continues up to 13 months following the death of a patient. When a loved one commits suicide, and this is what we're talking about here, assisted suicide, there are many unanswered questions and complex emotional fallout. There would be no 13 months of bereavement support for those left behind unless the patient was associated with the hospice. And I think we'd all agree that the state's mental health system is already experiencing challenges like no other time in recent history. I remain a full supporter of hospice for end-of-life care. Those that so many call angels, hospice and palliative care team members, provide aid in dying for terminally ill patients and families every day. Personally and professionally, I stand firmly opposed to SB 88. I thank you for your time, and I'm certainly happy to address any questions.
Thank you. I do not see any hands at this time, so thank you for your, I do see Representative McCarty.
Thank you very much, Senator. Just for a minute, I just wanted to comment, if I may, and ask Teresa. So today, we've been listening to a lot of testimony about hospice care, and we've heard varying views about, at the end of life, the pain management and care. Can you tell from your experience, and I think you mentioned you have a number of centers that you work in. Can you tell us if you have seen and if you have been able to control the pain management even at the very end stages of life?
I have, and it's interesting. As I was preparing for today, I was doing a lot of reflection over the last many years. And there's only one patient that comes to mind that we weren't able to get symptoms under control. It was a very young woman. She was 29 or 30, and she had terminal brain cancer. And the symptom that we weren't able to manage were her seizures. And I mean, it was traumatic, needless to say, for the family, for us to watch, because normally we're so expert at getting those symptoms so well managed. And I use the term aggressive symptom management because that's what we do. And there are hospices out there will, include things like radiation for palliation, even though the hospice Medicare benefit technically doesn't cover that, but there are hospices that will do that because it's the right thing to do.
If I may be so, to inquire with that individual that you mentioned that you could not help, what did that person then go out of sent over to the hospital, or how was that managed?
No, she was at home, actually.
Oh,
she was at home, and she was getting intravenous medications. And that's a question that had come up earlier today. There are some hospices that do intravenous medications at home. We're seeing less and less of that over the years because there's other options. You can do subcutaneous pumps. That tends to be very effective. One of the newer methods is what I think Lorraine Zawalik mentioned a little bit earlier, the Macy catheter, which once placed, it just stays in place. It's rectal tube where medications are put through that tube, very comfortable for the patient. Lots of topical gels that are compounded. And of course, the oral concentrates, which can work very well if they're used properly.
Okay, thank you very much. Thank you, Madam Chair.
Thank you, and I will recognize Representative Pettit.
Thank you, Madam Chair. Thank you, Mrs. Bach-Huber. I think you answered part of it. There was confusion in the discussion about palliative care and hospice care, so whether IV medication could be used when under hospice, and you've answered. It sounds like that is permissible in this era. So I guess I broaden it to are there significant deficiencies? I realize it's related, but not specifically on the bill. Are there deficiencies in hospice care that we need to be looking at to try to improve hospice care overall?
I think that, unfortunately, COVID has really done a number on staffing across the board. There's been a lot of burnout that we've seen, and we were already challenged as a state and as a nation, with those healthcare practitioners out there. So when we look at, I referenced the levels of care in hospice. two of the higher levels of care are general inpatient level of care, typically provided either in a nursing home, but more often provided in an inpatient center like down at Brantford, or St. Mary's Hospital has an inpatient center, or Danbury has a standalone inpatient center. Those will all provide the inpatient level of care, but continuous home care, which is that higher level of care when there's unmanaged symptoms, where that patient really needs that aggressive symptom management around the clock, that a patient can actually qualify for 24 hours of care. But it becomes challenging to staff that for a lot of agencies. You know, some of the larger agencies can do that a little bit easier, but if you've got a smaller agency, and I've worked at both, doing hospice, and you know, in the smaller agency, very, very challenging to cover that 24-hour care. And that's where we end up relying on the families, like we've heard about during the course of today's hearing.
Thank you. And I
Thank
see
you.
another. Oh, thank you. I thought you were done. I'm going to turn this back over to Representative Steinberg to call on Representative Cabral to
Do that. And thank you, Senator Kushner, for taking some time. Representative Kavros DeGraw.
Thank you so much. And thank you for testifying. I know we exchanged emails earlier this week. I thank you for all the work that you've done in hospice. And I think that did help clear up some of the conversation from earlier. But I just want to go back to the home piece, because that does seem to be where, both in the 15 hours last year and today, that does seem to be the piece where people experience the most of not having that symptom control. And then when you couple that with the number of people who want to die at home when they have these terminal illnesses, you know, we experience that. I think, as I've said in my own family, you know, it's most people want to be at home. So I guess if you could speak a little bit more to, if we are short, and you know, I guess thinking about both aid in dying and the palliative care, is there a way other than staffing to fix that? Because it just, you know, I think like one of the women who testified earlier said, like, she didn't know that she heard the sound she needed to hear to give the medication. So is that education? What is that missing piece?
It's a really great question. And, you know, in the state of Connecticut, where I always say where hospice is born, we've come a long way in terms of education, but there's still so many myths and so much misunderstanding out there. And working with our state association, Tracy Wodach kicked off, I think, at number 8 or so earlier today. You know, we've made great strides with that education, and also on the staffing front, we're really working hard to, you know, aggressively recruit and get the message out there about hospice and home care and that need that is out there, because truly there is that Medicare hospice benefit is a gem, and all the other benefits, the insurers and Medicaid mimic the Medicare hospice benefit. So when that person has that aggressive symptom management need, or a higher level of care, complex wounds or intravenous needs, that sort of thing, we really should be able to provide that to that patient and family. The only other thing that I would add is that the inpatient centers, they're very home-like. I know it's not home. I started the one at St. Mary's Hospital, you know, and there, when you walk into it, it's very peaceful and it's lovely. And again, it'll never replace home. But those are nice options. If in fact, the patient can't be at home. Patients do more than ever because of COVID. They don't want to go to an institution, it doesn't matter how nice it is. They want to be in the comfort of their own home.
Any other questions? Thank you, Representative. Representative Foster.
Thank you so much, Chairman Steinberg. And thank you, Teresa, so much for your time and your work. It's been moving to hear about how much comfort you've been able to offer families at their end of life. Today has been a really emotionally trying day, I think, for a lot of us to imagine ourselves in the shoes of so many people who have testified, and knowing that you can offer comfort is really helpful. Something that I have been struggling with and struggled with last year in this public testimony is the idea that knowing nurses who have worked in end of life care or do currently, this idea that palliative and hospice care does hasten end of life at times. So can you explain to me how you think that that is different than medical aid in dying?
So the difference is the intent. When we work in hospice and palliative care, we never intend to end the life of a patient. Our goal is to make that patient comfortable. So we have guidelines. If there's any, I know there's a couple clinicians with us this afternoon, but we have guidelines, that for certain number of respirations, you're supposed to withhold medication. And all those things kind of go out the window when it comes to end of life care in terms of making that patient comfortable. So if you've got a patient who's in pain or is having air hunger and you're providing morphine and Ativan to that patient and the respirations dip, I'm just using an example for you, dip to below 8, you wouldn't stop giving the medication if they're still uncomfortable, if they're still short of breath, if they're still in pain. So if that's the real difference. Our goal is not to hasten death. Our goal is to make that patient comfortable pretty much at all costs.
I appreciate that explanation. I guess that's sort of a challenging definition to navigate, I think, for many family members and advocates around this issue. So hearing your perspective is helpful.
And from a clinician standpoint, I will tell you, many clinicians grapple with this as well, because nobody wants to give that last dose of morphine, that last dose, and then that's an educational piece though, because we've heard a couple of times today that it's not the morphine that's ending the life of that patient. It's the disease that's ending the life of that patient. The patient's not going to go until they're ready. So,
I appreciate your explanations. I think I'm internally grappling a lot with contextualizing that with what all of the things that we're hearing. But I appreciate your explanations and I look forward to reading your testimony as well.
You're welcome. Thank you.
We have more questions for you. Next up is Representative Berger Gervalo.
Thank you so much. I'm going to just quickly kind of add on to what Representative Foster. Oh my, can you guys hear me?
Yes.
Okay.
And see
everything froze up, so I don't know. What Representative Foster was able to ask you, just to further take that down the road, should the goals of hospice care, so the goals that you have for you, which that should come at all costs was the term that you used, the comfort at all costs. Should the goals of hospice supersede the end of life goals of a patient? How do we rank this?
So it's all about the patient. So when we look at a patient and family, they're at the center of the care. They're driving the bus. So that's one of the first questions you ask. When you go in to see a patient, what's your goal for today? Or when you do the informed consent, what's your goal for the trajectory of care? But every day that would be a question when I was out there to do visits with patients, and it's all about what they want.
So what is the answer then if what they want is an end of life option that is not simply palliative care?
You mean to take their life?
Mm-hmm. The option that we're talking about here.
So I can't say that I have encountered that.
I know that's a tough question.
That's a tough question.
I'm not trying to put you in a hot seat. It just was sort of a natural question that follows your statement. So it's a tough question for sure. And somebody earlier mentioned all the medication. Oh, I think it was Representative Michelle maybe had mentioned that there's that much medication in a patient's home. And there's large doses of medications in a patient's home. And I guess if they were that interested in taking it to that next step, maybe that's what they would do. That would not come from us, obviously. Right, because then we're talking about suicide instead of medical aid in dying, which we've clearly drawn a distinction in throughout the day. So got it. Okay, thank you. I appreciate you answering some sticky questions, truly.
You're welcome.
Thank you. You really have answered a lot of sticky questions. You've also offered us a bit of a deep dive into the world of palliative care, which I think has benefited all the members of the committee, but in a way in which it was very accessible. So we appreciate that.
Welcome.
We're sometimes slow learners, so you did a really nice job.
Thank you.
If there are no further questions, we'll thank you for your testimony and we'll move on. Thank you to all those who have been waiting patiently. Next up is Bob Russo, followed by Jennifer Barahona. Excuse me.
Good. Can you hear me now? Yep.
Yes.
Yes. Representative Steinberg and other distinguished members of the committee. I'm Dr. Bob Russo. I'm now the Chief Medical Officer of the State Medical Society. Our society represents about 4,000 physicians practicing in Connecticut. I'm speaking personally in opposition to the bill as written. As you know, the State Medical Society has a neutral position. It's basically 4,000 physicians could never agree to anything, much less be unanimous one way or the other. But I think that much earlier today, someone asked this simple question, is now the time? And I think that the issue that's come out quite a bit today actually is maybe not now. And the reason not now is because if you look at when we first started this discussion, maybe back in 2013, there was a whole list of things that people wanted, and I'll use the term aid in dying, that was the reason for people choosing that. If you look at that list today, that list is flip-flopped quite a bit. And one of the reasons it's flip-flopped is the work of the state legislature and the governor. If you look at Connecticut with the Family Leave Act and the Paid Family Leave Act, it's been quite a boon to medicine and the ability for the family to be at home with sick and dying patients. I think that really has dropped that I'm going to be alone when I die or I'm going to be a financial burden to my family. It dropped that out of the top three. The other thing we've noticed today is that there's more fear than the reality. There's fear of dying, there's fear of pain, there's, in quotes, fear of the unknown. And I do think that this is a good time for us to work together on a positive side, taking what we've been able to do over the last so many years in paid family leave, in the advances in hospice. I mean, you all remember where in the beginning you had to swallow 60 pills and now it's a liquid, and there's other newer anti-anxiety drugs and secretion control. And I think Teresa did a tremendous job showing how their people work with patients, work with the team led by the physicians that actually make a difference. What we're afraid of is that as this picks up steam, as palliative care, and again, I'm a little bit hesitant because the words mean a lot to people, but we went from comfort care to palliative care, and now the word is palliative sedation. But I thought Teresa pointed it out very well when she said it's the intent. It isn't the intent.
Excuse me, Dr. Russo, your time is almost up. If you please summarize. Thank you. Thank you.
So if I can finish with the word intent, I think is very important. The physicians want to help. They want to be involved in the process. They want to be together with the family and the patient and to make the right decisions. What we don't want is people to make decisions that are hasty or ill-informed. And education is a very big problem for us now about the end of life. Thank you. And if there are questions, I'll.
Our doctor, Senator Summers has a question for you.
Thank you.
Yes, I guess it's almost good evening, Dr. Russo.
Yes.
I have some questions. I know that you said that the Med Society really had no opinion here in the state of Connecticut. But if you looked at the testimony that was submitted, there was a Dr. Donovan from Yale, who is the head of the hospice palliative care at Yale, who indicated that the National Medical Association says that physician-assisted suicide is fundamentally incompatible with what a doctor's role is, and that it is impossible to control and it poses a serious threat. And instead of physician-assisted assisted suicide or aid in dying, that the focus should really be on the needs of the patient at the end of life and improving palliative care, as does the American College of Physicians also says it does not support the legalization of physician-assisted suicide. And they consider the practice unethical because of clinical and other concerns. And also the Academy of Hospice and Palliative Care Medicine also agrees with that. So are you saying that in Connecticut, there's just, you can't agree, but nationally, the three largest organizations of medical experts are against physician-assisted suicide or, aid in dying. And that brings me to my next question, which is, I asked a PA this earlier, but one of the biggest concerns I'm hearing from physicians is, we can pass this. Yes, they have a choice not to be involved, but it really is contrary to them. They can help end suffering, but they don't want to take your life. They don't want to actually be an active part of taking somebody's life. And I'm concerned about a social worker being able to determine somebody's competency. And I'm also concerned about this drug cocktail, which is not indicated for use under FDA. It is not something that is proven, so to speak. There aren't clinical tests or case studies or trials that have been done on it. So we don't know what the correct dose is, what can happen to the patient. And we also don't really have custody of those drugs as they move through this process. Could you speak to any of those?
Yes. And again, remember, I'm not usually handicapped by 3 minutes, but the reality is I was trying to get out the idea that cooperation towards what the end of life is extremely important to doctors. We have no intention of abandoning a patient when they're dying. It's not in our makeup. It's not in our oaths. It's not in the way we treat people. And therefore, when we move to a neutral position, it's not that we don't care. We move to the neutral position to continue the conversation. We don't want to be pictured as opposed when so much good is happening now about the dying patient. We really do see these massive moves forward in medication and treatment care. I cannot tell you how important it is to unleash the hospice group, to let them do things for comfort, to stop the pain and suffering of patients near death. There's too many regulations around it. The concept that laws are going to practice medicine near death and dying is very difficult. The physician team, the nurses and hospice around them, those are the people that the family has faith in, and we have faith that we've been able to handle it. So it isn't, don't misunderstand state medical. State medical is very concerned about the concepts. What we're most concerned about is that this concept of taking medication that ends your life is not the end point, and it should not be the end point at this time. The other, as the organizations, as was mentioned much earlier today, there are probably 150 well-known medical societies and organizations in the country that do not support death and dying or physician-assisted suicide legislation. It's important to point out that Oregon started in 1997. We're now 15 years later, and only 10 states have got any legislation or court towards that. Of the top 100 wealthiest countries in the world, only 10 allow for this sort of thing. So this isn't a rush. We can work together, figure out how to help hospice, how to educate populations, especially when we get into the health equity issues. And I know that on Friday, you're also going to have further details about mental health. Mental health, you have to balance. You can't say, if you're depressed and young, we're going to spend millions of dollars to help you in mental health, and then take the elderly or the frail and the dying and say, if you're depressed, we have a simple solution for you. We need to work on this. We can't come to this endpoint this quick.
Well, thank you, Doctor, for highlighting our hearing on Friday. And we invite everybody to testify there on a very important bill. Representative Carpino has a question for you.
Thank you, Mr. Chairman. Dr. Russo, I can assure you that legislators probably agree less than doctors, if it makes you feel any better. One of the things I struggle with, and I have throughout these conversations, is the dosage of these medications being administered by non-medical professionals. And that is not a judgment on however one feels on this bill, but that has truly scared me. If I were in a position of needing these, or a dear family member, I'm convinced that no matter how well intentioned or how well educated or compassionate they are simply not qualified to be administering or help administering or watching me administer these medications in the event that something doesn't go as planned. So my question to you is twofold. Is there a reason that we repeatedly see a bill proposal that does not have medical professionals involved, or at least witnessing the final administration of these meds? And it may be related, have any of the medical associations in Connecticut or New England or even beyond that actually ask their members how many physicians want to take part or would be willing to take part in this process, either witnessing, administrating, or even writing the scripts? I'm really trying to get to facts to help me make a decision, if you can speak to any of those.
Yes, I can. Actually, there is a study in Connecticut when the Yale faculty was asked, medical faculty, excuse me, when the medical faculty was asked, did they support death and dying, aid in dying? And there was a majority that said yes. When they asked the second part of the question, which is, would you be there? Would you write the prescription? Just what you're asking. That number dropped down to 15%. And the reason is the uncomfortable process of working with patients and families, trying to save lives, and then, in quotes, giving up. There's a sense of, I'm abandoning the care when I'm telling you, you have to go to somebody else because it isn't in my ethics or it's not in my thought process to end your life by giving you medication. So yes, there are, and you all know push polling better than I do, there are ways of asking questions. And the question is, do you support somebody else's right to do anything? And then the answer comes out, the majority always, or mostly says yes. When asked what it means to you when it's that significant, which is the significance of, asking a family member or helping a family member go through these processes, that no one wants to get involved. It changes everything. There's a patient-physician bond that's built on trust that we're going to do everything we can to make you healthy. There are a lot of physicians that feel that bond is broken when you say, instead of going through hospice, and I have to say, like everybody before me has said, they're wonderful people. That when you're talking about education, about giving medication that, you hand it to a grandmother to give to a grandfather or something like that, there's danger in that. But these people work hard at making sure that that process works well. We all have the concerns you have, and that's that nightstand that's got a bottle on it that has the wrong meds or too much meds, or in the stress of doing it, somebody makes a mistake. Yes, but that's why we need to move forward. We move forward by not saying, don't have hospice, don't have palliative therapy or palliative sedation. It's, let's make it better. Let's educate it better, make it work.
Thank you. I find it interesting that is the only study here in Connecticut, since this is by far not the first time that we've had this. I'd be interested to see what the rest of the physicians, there are still other physicians in the state, at least today, that are not Yale affiliated. It's particularly on my side of the state, but thank you, Dr. Russo, for testifying.
I appreciate it. Thank you.
Lieutenant has another question for you, Doc.
Thank you, Mr. Chairman. Thank you, Dr. Russo, for your testimony. There's been a significant amount of people with disabilities who have testified today with their concerns about how this type of legislation would impact a large community of people with disabilities. I wonder if in your meetings or discussions with the medical side, other people, whether the issue of folks with disability vis-a-vis this type of legislation has come up, and if you have any thoughts or.
Yes, I do think that there's a worry about expansion. Sometimes, the slippery slope or the other issues that come up. And it always comes up that this bill stands alone and that there will not be any changes to the bill. But if you go back and look at Oregon, particularly because everybody uses that as an example, it's changed more than 19 times. When you go to the other side of the world in Europe and you look at Amsterdam, blindness is now considered a reason for death and dying, aid in dying. I keep wanting to say physician-assisted suicide, but in respect to those people that told so many heartfelt stories today, I'll use their terminology. But yes, I think that the handicapped population feels threatened because of all the other issues and their feeling about being down. And of course, what happened in Amsterdam just blew a hole through everybody's hopes when the two blind cobblers were able to commit suicide over blindness alone.
Thank you, Mr. Chairman.
Thank you, Representative. Senator Anwar.
Thank you so much, Mr. Chair, and thank you, Dr. Russo, for your testimony. Dr. Russo, have you been asked by a patient or have you prescribed any medicine for a patient at all?
No, my experience with hospice is with hospice. My background is not as a medical physician or a geriatrician. No, I haven't prescribed it. I've sat on the ethics boards. I've sat on the boards of the hospice. I've done, the usual thing within the hospital hierarchy, but I've not prescribed. To tell you the truth, I would not prescribe it.
Okay, and with respect to the hospice, have you ever had any family ever say that the medicines in hospice were not enough and their loved one may not have been as comfortable towards the end throughout your career?
No, in the quality assurance committees of the hospice in Brantford, and I worked with Calvary Hospital in the Bronx for years as one of the quality officers and things like that. And they do not have, of course, they're the top of the pyramid when it comes to terminal care. That issue does not come up. They titrate their medications.
And that's in the inpatient setting, right?
No, Calvary has both in and outpatient services, yes.
Okay, and so in your X amount of years of experience, not a single person ever has had a problem with pain or discomfort when they were at hospice?
Oh, no, I didn't say that.
That's what I heard.
I'm sorry. I thought you asked me if I'd ever given out the medication for somebody that was not being controlled.
No, that was the first question. The second question I was clarifying was that because what I'm hearing from people is that at the terminal moment, there is a challenge that people have. There's a significant amount of anxiety that people have, and then there's a concern about not having the resources in their home. And we heard from a number of family members where they feel that they're given a number of medications and then the nurse is only available on the phone to maybe help out theoretically at that time. So they are with their loved one without the training, going through the pain of losing their loved one. And so I did not hear a rosy picture from some of the people who have come in, but I heard that everything is perfectly going well from your experience.
No, you've misunderstood, I guess, what I'm saying. I think the process is there to handle it in the proper fashion. I'm trying to think of some survey or some study that was done where the family would say we weren't able to give them the medication at the proper time, or that they weren't properly sedated. I mean, under palliative sedation, there's usually a physician or a nurse or someone visiting Nurses Association doing it. Unless there's a rapid deterioration, I'm not sure. I'm not aware of a study that looks at the last hour that says the medication wasn't given properly by the family. I don't know how we'd know that if there wasn't a medical person available.
Okay, it's not, well, we have to take some of the things that people who have raised concern, the family members, at their face value and say, well, these family members have complained of a problem. So it's worthy to say, well, there is a problem, at least for those individuals. And in my some 26 years, I have seen some of the problems as well. Now, you talked about the Yale study, and I wanted to make sure I understood you correctly. You're suggesting that a majority of the physicians at Yale support this, but when they ask would they be the one administering it, that they would say no. Is that fair understanding that I have?
Yes, they were saying that they didn't want to do it.
But that does not take away from their recognition that there is a need. Would you say that that defies the concept that these doctors feel that there's a need?
No. And basically, what I've been asked in the past, why did the State Medical Society go from being opposed to this to now being neutral? And that is because there are a majority of physicians that support the need for better care in dying, whether or not it's positive or a positive act, such as giving them the medication, or palliative sedation. They all recognize that. When asked if they would write the prescription is when the number fell tremendously, because they didn't want to do it.
So, and I'll try to put this together. I'm so sorry. Thank you, Mr. Chair, for indulging me for a little bit, because I wanted to tease this out. I think the issue that we are dealing with in our state is that because it's not legal to do this, and frankly, as a state that is the first state which we should all take pride in, that in the entire country, the first hospice was set up in the state of Connecticut. So we should take a lot of pride in the fact that we are essentially one of the founders of hospice in the United States, and a lot of people had to go through a lot to be able to get that. But hospice has its imperfections, and that's why the number of patients who will need something like this is minuscule at best. And then that's what the numbers are showing. The fact that the physician community, the larger physician community, is in support of this. And in this morning and in another press conference, I said about this, the fact that if I was to be asked to do this, I don't know what the answer would be. It's most likely going to be a no. Having said that, but I do know that there's a need. And one of the reasons that people are concerned in the state of Connecticut of what needs to be done is because we are so far behind many of the other areas in the understanding of some of these challenges. And if we were to talk to the physicians in Oregon or even California, we may get a different understanding. And I know some people are anticipated to speak about their experience who have actually been doing this. So I would urge you and others to listen to that as well, to make sure that there is a better understanding of the needs, but also recognizing that the how does not automatically mean that there's no need. And I think your interpretation of the study may not have been fair, if you will.
Well, I think the interpretation is in the conclusion of the study. I think what you're pointing out is what I've been trying to point out, is a lot of work needs to be done. We need to figure out how these terminal events are going to happen and what needs to be done at that time. I don't think anybody's implied. In fact, if you read the medical students' op-ed piece in the Hartford Courant, they're all looking for encouragement about palliative care. We all are. We're trying to look for answers, but I don't think we were saying that the hospice is the end of these discussions by any means.
Okay, thank you so much. I truly appreciate your time and your testimony, Dr. Russo. Thank you.
Appreciate your question.
We're not done with you yet, Doctor. We have Representative McCarty, followed by Representative Zupkis.
Yes, thank you very much, Mr. Chair, and thank you, Dr. Russo, for your testimony today. Many of my points were just touched upon, but I did want to thank you for coming in and explaining the position of neutrality by the Medical Association, Connecticut Medical Association, but you made some comments near the end of your testimony that you thought we needed to really look at the tighter regulations and do more with education, and that it wasn't the right time. So I wanted to give you just a quick opportunity, if you'd like to talk a little more about what you see that we could do more in the education arena. Thank you.
Yeah, I think that actually Senator Summers brought up some of these issues, which is we're working with families that don't have the medical background or the expertise sometimes to understand. We also work with groups that have to understand what it takes to take care of a bedridden patient or a disabled patient in some form or shape. That's where the education needs to be bumped up, where it needs to be reconsidered. We talked earlier, I think, about disimpaction and some of these other things that hospice can or can't do. Some hospice can do IV, some can't. We need uniformity so we can study the results. We also need the feedback, what Dr. Anwar was asking about, studies that say really what is happening in the field, what's the reality of the last 24 hours of a patient's life and stuff. That's hard to do it from home because it's hard to ask patients or families of patients that just died those sort of sensitive questions. But that is the information that we need to study. Those are the educational backgrounds that we need to beef up. I strongly feel that way. If the students, medical students that wrote their essay said only about 14 to 15% are reaching deeply into the palliative care. That's a lot of work left to do before we start handing lethal doses of medicine to patients.
Thank you. Thank you very much, Dr. Russo. I really appreciate your comments. Thank you.
Thank you for the question.
Thank you, Representative. Representative Zupkis.
Thank you, Mr. Chair. Dr. Russo, I was actually, Representative McCarty was exactly my questions, the education, but also you mentioned about the regulations on palliative care and hospice. And so I'm really interested to find out what can we do, because as physicians, and as I'm thinking you, or what I thought you heard, I heard you say was that there's overregulation and it could be better for patients and for doctors in hospice care and all of that. And so I hear you saying you are for better care for end of life and not necessarily physician-assisted suicide. So would you just speak to, please, some of the regulations that we should do as legislators to work on?
Yes, I think that you tie the hands of a hospice when you set up a series of regulations that don't allow for individual care. For instance, Teresa earlier today mentioned some use radiation to, say, take a metastatic bone lesion to stop the pain. Most hospice aren't allowed to do that because it interferes, in quotes, with the treatment. Personal problem. I unfortunately had a cousin that was dying of lung cancer, and when you give morphine, the patients become extremely constipated. He became impacted, which is an extremely painful thing. The hospice and the visiting nurse said, in a terminal hospice patient, we're not allowed to manually disimpact. So when they left, I did. And the pain went away, and thankfully, he died a quiet death about 5 or 6 days later. But that's the sort of leeway that the hospice nurse, the visiting nurses, the team doctor, and whoever the team leaders are, they need to be able to change the rules so that comfort doesn't wind up over-medicating a patient, because as you know, pain level is what you get the medicine for. So when you drop below or above a 3, when you go above 3, you start getting meds. If there's a simple way of keeping you at 3, it's comforting. Let's not say you can't do this. If I'm not advocating that you do things that prolong life for the sake of prolonging life. I am advocating comfort care to make it easier for people.
Right. So I would appreciate, because this is all related to this bill, if you would send me or our clerk some of those things that should be fixed to make it all better. So I would
Yes.
ask if you could please soon, tomorrow, in the next couple of days, send it to the clerk. And I don't know if anyone else on this committee is interested, but I certainly am and would be interested in moving that forward. So thank you.
Absolutely. I'll get it to you by the end of the week, I promise.
Thank you.
Thank you. Representative Kennedy.
Thank you, Mr. Chairman. Late hand there. Dr. Russo, thank you so much for being here and answering the questions. We went back and forth a lot with hospice, and you have some great familiarity with Brantford Hospice. Just clarify for me, I'm pretty sure at hospice in Brantford, it's also a pain management for our patients. Isn't that not correct?
Yes.
Okay. I
Mhm.
just wanted to clarify that because it seemed that we were leaning to go there.
10 miles an hour. What the hell's wrong with you?
People can actually leave hospice with the right pain management. Is that not correct?
Yes.
I just wanted to clarify that. I actually was a patient volunteer at hospice for a number of years. So, and had a lot of hands-on care with patients there. So I just want to clarify some of the statements that were made. Dr. Russo, thank you so much for being here today. Really appreciate it and spending the
Yes,
day.
if I can point out something about the regulation. So as you realize, sometimes when you leave hospice, you can't go right back in if you've made a mistake. There's a pause that's regulated, which makes no sense. I mean, if you understand the stress that the family and the patients are under, they make a decision to come off hospice. If that's a wrong decision, you can't go back on tomorrow. There's a pause. That's the sort of regulation that I think is in the way.
Thank you so much for sharing that. I really appreciate that. Mr. Chairman, thank you so much for your indulgence.
Not at all. And again, thank you, Doctor. I think everyone would agree that there's opportunity for updating many of our regulations. And if you could direct us to improvements, I think we'd really appreciate it. The good news is that healthcare's got a major focus in the legislature this year. So it's an opportunity to get some things right.
Good. See you on Friday.
Thank you. I'm guessing Jennifer thought she'd be going a little while ago. That's the way it happens around here.
That's right. I'm texting my friends, keep my kids a little longer. That's all right. Thank you. Good afternoon. My name is Jennifer Barahona. I live in Fairfield, and I'm here in strong support of HB 88. Many of you have heard me testify about aid and dying support many times over the last several years, and reliving the most difficult moments of my life every year is frankly exhausting, and today is actually harder than last year. But I have witnessed the horror of a prolonged death without relief. So to the previous two speakers, I'm happy to entertain questions about that experience, but I will not stop until we have the same rights afforded to the 10 other states across this country. I'm incredibly grateful to this committee for passing this out, and for those 24 or so of you that supported this bill last year. I'm asking you to do better this time. You do even a little more. Representative Steinberg, I know you sent Kim's letter out to your colleagues, and I appreciate that. That's the kind of advocacy we need to get this over the hump. I do not want to ever testify on this bill again, please. Year after year, I sit through testimony where I hear people tell you how strong our palliative care system is and that they can guarantee a pain-free, or only one person, as the previous person said, in the whole life. This is not a hospice or palliative care versus medical aid and dying. It is a both. I'm here to tell you it's just not true that we can always control pain. My mother died a horrific death from ALS less than a year after her symptoms began, and it was hard for us to describe just how horrible that was. I have a piece of paper here. You probably can't read it, but the very last thing she put pen to paper is, "Would you do my eulogy?" After that, she relied on a speaking device and wrote, "This isn't what I would consider life, and I hope the end comes quickly." It did not come quickly for her, and as her healthcare proxy, I fulfilled her wish to stop taking nutrition through her feeding tube on September 1st of 2009. We were told we likely had a few days. I called my brother. He came from England. My other 4 siblings, the 6 of us, spent 2.5 weeks by her bedside. She died on September 18th. After 18 days of no food and hydration, moaning, her limbs turning black, her eyes pleading with me. The last motor function she could control was her eyelids, and when she could no longer control that, I couldn't do the 20 questions game of what pain she was having, and left side, right side, sharp, dull. She just writhed in agony for 18 days while I held her hand, saying, I'm sorry, it will be over soon. It's okay to let go for an inhumanely long time. And she was the most remarkable mother, and I miss her so much. And I didn't get to share motherhood with her. And I hate that the 35 years of incredible memories I do have of her are often overshadowed by the horrific way that her life ended. She was a staunch Catholic. She very likely would have not chosen this option for her. Maybe if she knew how brutal it would get, maybe she would have. But what I can say without a shadow of a doubt is that she would want others to have the choice. And she recognized that not everyone shares the same faith and belief system that she may have, and that there's a reason for a separation of church and state. So I'll just wrap up by saying, when I tell people my story, I often get, I can't imagine how difficult that was. Well, I'm asking you to take a moment right now to just actually imagine and think of the person you love the most suffering for weeks, days, months, whatever it may be, and pleading with you to help them, and having and being powerless to do so, having nothing to do but what I did, which was hold her black hand, no circulation, black hand, and just whisper loving thoughts for her for 18 days. The power is in your hands to give people another option, one where they can have a humane and dignified and well-planned transition.
I'm sorry,
in
Ms.
final
Barbarona,
moments
please
surrounded by
summarize.
my
Thank
last
you.
sentence, not pain and fear, but by love and comfort. I'll also say I'm a licensed clinical social worker and happy to entertain questions that I heard previous on that as well. So thank you very much.
Thank you, Jennifer, for once again sharing your story, which is puts a lot in perspective. We have some questions for you, Senator Wong, followed by Representative Berger-Travallo.
Thank you, Mr. Chair. It has been a draining day, and Jen, thanks for sharing your emotional story. I remembered it last year, and I think one of my regrets in this entire hearing is that we're forcing so many people to go through their emotional stories so quickly. You having done that in 3 minutes is amazing, and thank you. I do have a question in regards to talking about the care during hospice and the differential between home care and hospice care. The issue of palliative care has come up many times in this public hearing. Can you elaborate a little bit what your thoughts are on that issue?
Yeah, thank you so much for that question, Senator. You know, my father died in hospice 3 years before we lost my mom, you know, just a few weeks before my wedding. And he, you know, had an aggressive cancer, and we were at Rosenthal Hospice in Stamford, which has since closed, and we had a beautiful experience. And I would say my point of this isn't an either or. I am a firm believer in hospice care. I have advocated for hospice and palliative care. That is part of the equation. My father didn't need medical aid in dying. He died as what I call as kind of ideal as you can get. It was going fine until it wasn't, and then within days it was Easter Sunday. He's, you know, called for my mother, and he was gone, you know, about 48 hours later, and he was not in pain. We were at Rosenthal. His pain was managed. I held his hand. He took a last breath, and it was one of the most beautiful moments of my life to be there with him in that moment. And and there we were 3 years later in the exact same hospice.
Oh, fuck.
Whoop. Someone needs to be muted. That's all right. That all happens even a couple years into a Zoom. That's fine. So, you know, my mother was in the exact same Rosenthal Hospice. We went there for respite care because she was in her home, and we had a live-in caregiver with her. She had been abused by 2 or 3 caregivers. She couldn't speak. She had no way to communicate verbally, but was able to write through her Dynavox device, and we had to fire a couple caregivers. That was a nightmare. We finally did get her someone, but she didn't trust anyone else. So when the caregiver took a week off, we brought her to Rosenthal for a respite stay, but she deteriorated so quickly on the ride over that she decided, you know, we decided together that she would take the feeding tube, the plug out of her stomach, would stop taking nutrition. So we had a great previous hospice experience. The question earlier, one of the representatives asked about not having a medical person administer the medications at home, and that was of concern. But for home hospice, we ask run-of-the-mill people to do all sorts of medication management. parents, grandparents, sisters, brothers, home hospice, you have someone come and check in, a nurse, and can call and be on a hotline. But that was very nerve-wracking for us. In fact, I lobbied hard when Rosenthal was going to close because I didn't feel comfortable being that person for my mother in our own home. So I felt very comfortable being in a residential hospice for her care. And I'm very sorry that option is not available to as many people. So, but they couldn't manage her care. And there was a doctor, I remember saying, and I think I said this last year to you, Senator, that the temptation to just put a pillow over her head, and God forgive me for saying that, but after 2.5 weeks, I thought, this is just, I said to the doctor next to me, she said, I've been there, I was there with my own father, and it's just the worst feeling that there's just nothing you can do. I don't know what was causing her pain. They suspected that the feeding tube that was no longer accepting the nutrition starts kind of like collapsing in on itself, kind of. They couldn't really describe it, but that it kind of stopped serving its purpose, so it maybe starts causing pain. But we didn't know that, and she wanted to be lucid. But what choice did I have, right? She wanted to be lucid, but she was in agony, so I just the pain pump. But at a certain point, it stops you. You can't press the pain pump anymore. You've hit as many doses as you can. And then I would have to wait until I could do it again while watching her suffer. And it was just brutal. With my dad, four of my brothers and sisters and I were by his side with my mom holding his hand. It was a beautiful moment with her. I said, I think last year it was my brother's turn on her cot in the room the night before I had gone home. And she was dead in the morning. Nobody was holding her hand when she passed. Nobody was, she was just such an amazing mother to the 6 of us, just helped us through every difficult moment. And we weren't able to do the same for her. She died by herself in pain.
Jen, I'm so sorry for your loss again. It never goes away, and ALS is such a terrible, terrible disease. I want to thank you for your past work on behalf of the Sandy Hook Community Foundation, and now you're working with a Norwalk education achievement community group. So I want to ask this question from a standpoint of one of the individuals testified, talked about the social economic disparity and some of the social equity disparity in regards to access and decision making. What do you say to that from the standpoint that the disproportionate population that is looking to do this and the disproportionate people that are testifying in support of this? Does it really capture a community and socioeconomic, racial, or social equity group that this is a select group that's making this decision-making process and having the ability to do so?
Yeah, that's a good question. Thank you. I unfortunately, because I am, working full time, I've been popping in and out of the hearing today, so I didn't hear some of the line of questioning around that. So I don't know that I feel fully equipped to answer that. Only that, in my own personal network, which is quite diverse, I know that there's pretty universal support of this. And again, I know, a friend of mine is, one of my closest friends is Haitian, and in support of this, not for herself, but for others, just as my mother would have been. That so I know there's vast cultural differences and beliefs around this, religious or otherwise. And so again, I just believe it's the person's option, and let's give them the option. But I'm sorry, I don't feel like I can speak much more on that.
Well, I appreciate that. I thank you for your work on behalf of the community, and thank you, Mr. Chair, for the indulgence of the 2 questions. And again, Jen, thank you very, very much for sharing your personal and painful story, and to do it so quickly. I wish we could give more time to so many of the people that are making the effort to share their very emotional stories. Thank you, Mr. Chair. Thank you, Jen.
Thank you.
Thank you, Senator. Representative Berger-Gervala.
Thank you so much, Mr. Chair. Hi, Jennifer. Thank you so much for being here once again. And I feel like I need to apologize for making you do this once again. So I truly am sorry to help. that we're forcing you to relive this trauma over and over. So my question for you, are you familiar with the most recent ballot initiative in Colorado?
Yes, I am. The one that was supported 2-1 by voters. Yes, I am.
That's the one. Would you mind sharing what you know about that, please?
That's what I know. That it was supported 2-1, and my understanding is polls in Connecticut show even more so, upwards of 70 or more Connecticut residents in support of this measure.
Yeah, that is definitely the information that we have too. I do also just want to say, when I was looking through the list of those who were testifying today, I did not recognize you by name, but as soon as I heard your voice, I remembered your story and I knew exactly where you were going to go and who you were going to talk about and how much your mom meant to you. And so once again, I really, truly appreciate you being here with us. Thank you.
Thank you. Thank you. It's super emotional. I am a social worker, as I mentioned. So I deal with a lot of pain, but it's tough to relive your own. And I want to say to the previous speaker who said, there's not a rush to do this. I think you've heard, there's not a rush if you're not dying. And fortunately, if you don't feel like a rush, you're in a very privileged position of not needing this. And what kills me is just how many people aren't here today that were here in previous years because they had to die a painful death without this option. And I just feel, since if I may, the comments about the social work profession to me show a bit of a lack of understanding about the profession of social work itself, and that social workers are called on as experts in any number of areas, including the judicial process and court hearings and otherwise. And to me, it's the equivalent of saying, well, a nurse isn't sufficient to care for a patient at the end of the life. Only a medical doctor would be. To me, that's the equivalent of saying a social worker might not be qualified to deem someone competent or not. Only a psychiatrist. I worked at Bridgeport Hospital, and I called a psychiatrist once who said, "What'd you call me for? That kid's crazy," and turned on his heel and left. I was dealing with a suicidal 10-year-old boy. I was dealing with the mother who just had a stillborn. I was the one. So, social workers aren't the caseworkers of 100 years ago. They're licensed by the state of Connecticut and have rigorous standards in order to diagnose and treat individuals. And often most places, family service agencies, et cetera, have very little psychiatric services, and they're only there to provide medication after the social worker has done a thorough assessment. So I just felt like I wanted to point that out too.
Social workers may also be psychic, because I knew I couldn't ask a second question, but that was exactly where I wanted. So, thank you again for everything that you've done for us all.
Thank you.
I'm not sure where the psychics fall in our committee or not, but it does have at least the side beginning. Thank you, Jennifer, once again. Extremely affecting testimony. We appreciate your taking the time and giving us a fresh perspective on your story. Next up, we have Gregory Schimmer, followed by Ted Tumicki.
Thank you, Representative Steinberg. My name is Gregory Schimmer, and I want to thank everybody on the committee and everybody who works for the committee and everybody who's testified in the committee today on either side of the argument for their testimony and their thoughts and their hard work. This is not an easy subject, as we all have found out. So my mother died of lung cancer in 2015. My wife died of brain cancer in 2018. I testified about this last year, and I don't need to tell you how amazing my mother, Susan Schimmer, was. She was a business leader. She was a community leader. She didn't need to die that way. She did. My wife, Tracy Gamer Fanning, died of brain cancer. She was a co-founder of the Connecticut Brain Tumor Alliance. She was a consultant to the American Internal Board of Medicine, and has worked with doctors and patients all throughout the state of Connecticut. They have done a lot, right? So I don't need to rehash that. You guys can Google them and see who they are. And it was terrible to see what happened. But what I want to point out is this year, is that in my opinion, and through my experience, that life is a God-given right. It is, but so also is free will. And that truly is the greatest gift that God has given us. And the fact that the ability to choose for ourselves is in fact what we are arguing about today. Tracy and I talked about this ad nauseum. She didn't want to be a vegetable. She didn't want to not be able to move or eat or be able to breathe without help. She wanted to live while she was here. And she made me promise, and I did my best to keep that promise together, as many of us have, many of our caregivers have. The bottom line is that it's easier to die, right? We as the caregivers who have been here after the fact and seen what's happened, that's where the true difficulty is in living past it. One of the things I wish they had told me about before she had passed away was death throes. So this is what happens when you're not able to swallow anymore, when you're literally choking on your phlegm, right? And you look like you're choking and you're dying in front of your family. That is suffering, not just simply for the person who's dying, but the person who's watching them die. I didn't want to see that. I didn't want to see my mother do that. My wife's mother had to watch that happen. So I don't want to hear about slippery slopes. I don't want to hear about how this law can be used as evil or wrong. The bottom line is that give those people a choice. I'm allowed to put down my dog if they have a bad leg. I'm allowed to put down my horse if they have an infection. And yet my wife with brain cancer, who is suffering in a bed and defecating herself and unable to speak, is not allowed to die. That is where my argument and my difficulty is. I hear things about it's a temporary problem. No, it's not. It's a permanent solution for a temporary problem. That's such a trite thing to say, quite honestly, because cancer is not a temporary problem. ALS is not a temporary problem. The bottom line is that it's all about choice, and palliative care is giving alleviation to suffering. That's what palliative care is, and that's what this will do.
Excuse me, Mr. Shimmer, your time
Yes,
is
please.
almost up. If
Thank you very much. So in
would-
that, I would offer myself for questions and talk about this in obviously an emotional way, because this is an emotional discussion, and that's what I would offer to my testimony to this committee. And thank you.
Thank you. Representative Kavros DeGraw.
Greg, I thank you for being here again. And, full disclosure, I'm friends with you, friends with Tracy. And I think that, in a lot of ways, you protected all of us from knowing how bad it was at the end. Now, she obviously had hospice care, but we've heard a lot today about home hospice at the hospital, palliative care, what it does, what it doesn't do. To your experience, where was it helpful and what were its shortcomings?
To be fair, so we were lucky enough to have hospice care at home. Let me put this in a finer point. We were lucky enough to.
I apologize. We're trying to find out who has him muted. There we go. Okay, please continue.
Okay. We were lucky enough to be able to afford private palliative care. We did have help with Masonic care. We did have help with other things, but we were lucky enough to be able to afford palliative care. And even then it was difficult. So the nurse that came in, she would come in usually between, 8 in the morning till about 3 in the afternoon. And when she came in, holy mother, it was lovely to have her because it really took a lot of pressure off. But she wasn't there at night. She wasn't there at 3 in the morning when Tracy was doing this or just having hallucinations and things like it. I mean, it was awful. I feel for people, and this sounds like from a point of privilege, which it is. I feel sad for people who have to do this all the time for their loved ones who cannot afford palliative care, who cannot afford nurses to come and help them, because it's expensive too. It is a painfully expensive experience, and we got very lucky. So they were helpful and they took a lot of pressure off, especially at home. But I do feel for people who cannot afford that on a regular basis.
Thank you again, and I'll stop there and let my colleagues go ahead.
She loved you, Eleni. Thank you.
Thank you, Representative. Representative Gilchrist.
Thank you, Mr. Chair. So good to see you, Greg. Thank you for being here again this year. Throughout the day, we've heard from folks who question this term terminal illness. And in particular, they've been speaking about the fact that when someone is diagnosed with cancer, they kind of set up this scenario that someone would be diagnosed with cancer and then they'd make this decision to have death with dignity. And then, oh, lo and behold, they could have been saved. And so knowing Tracy and her experience, I was hoping that you could share Tracy's diagnosis because it was pretty terminal from the beginning, correct?
Right.
And then she did beat the odds. And so maybe you could talk to what that like that no, like there wouldn't have been, she wouldn't have chosen this early on. I don't know if you could speak to it.
Yeah, of course. So if I remember the law, or at least the proposed bill correctly, if you are given 6 months or less to live, you would be a candidate for this particular scenario. So Tracy would have never actually been a candidate for this. However, we talked about this ad nauseum. She was given 3 to 5 years to die in 2006. She managed to make it all the way to 2018, but it was largely because, again, of the fortunateness, the privilege that we had. We knew doctors up and down the East Coast. We knew doctors at Duke and Yale, et cetera, and we were lucky to have that, and we were very fortunate, and that largely added to it. That said, we did live our lives every 90 days. So Tracy would have an MRI every 90 days, and it was like scratching a scratch ticket where we were like, okay, what about now? What about now? What about now? And it would be tenuous. It would be scary. But it was funny, like as the years went on, 2007, 2008, 2012, we were fortunate enough to get married in 2013. After a while, it almost seemed rote, right? The last 90 days that we had, it felt like we were in trouble. She started to show signs. She started to show issues. We were going down to Yale for her MRI, and we felt like we were literally going to the principal's office because we were going to get in trouble. And we were right. Her tumor doubled like that, like super fast. So that happened on September 4th. She died as of October 26th. I thank God for every moment for her. I thank God for every time I was with her. I thank God for that short amount of time. I know people now, I know brain tumor and brain cancer patients now who are going through this, not 6 weeks, not 4 weeks, but months, years. And oh my God, it is an exhausting experience to be a patient, guys. It is exhausting. Anybody who has ever seen somebody suffer, people like myself, people, I know you had a friend that passed away. I mean, it is exhausting to be a patient. So at some point, it gives a little bit of relief. It gives a little bit, just knowing that you can do something else. It really takes the pressure off. I'm not saying they do it. I'm not saying I endorse that they do it. I'm saying because they have the choice, it takes the pressure off, and it might actually increase their quality of life and therefore quantity.
Thank you, Greg.
Thank you, Representative. And thank you again, Greg, for your testimony today. We appreciate it. Moving along now, we will move to Ted Tumicki, followed by Larry Rizzolo. Welcome, Ted.
Thank you, Representative Steinberg, and good evening. I'm Father Ted Tumicki. I am a pastor, moral theologian, and canon lawyer, son, brother, and uncle. I also serve on the ethics committee of Bacchus Hospital in Norwich. I live in Jewett City in Griswold, and I am speaking against Senate Bill 88, and I am representing myself. I have submitted written testimony. There are many reasons why I oppose assisted suicide in general and this bill in particular, but I'm going to hit on 3 points. The first, in regard to the mechanics and language of the bill, I note that a patient's choice would not have to be respected and murder could be facilitated. Under this proposed law, a person could request and receive the lethal overdose of medication and change his or her mind and not choose to take it, but then someone else could mix it with her juice or other liquid and give it to the person or put it in their feeding tube against his or her choice. No one would know if the person was murdered. How do you propose to enforce such a law to make sure the proper person dies in the legally prescribed manner? The second point is there is still a lack of meaningful oversight. While the bill does state that the sale of leftover drugs would be a felony, there is no way of ensuring the drugs are disposed of properly. We are not talking about the routine distribution of medications to treat or cure disease or illness. What the bill describes is the distribution of medications whose sole purpose is to kill. It does not make sense to treat such medication the same as painkillers after surgery. Why is there still no oversight for dispensing lethal dosages and collecting leftover amounts of deliberately lethal amounts of medication? Words comprising a law do not enforce themselves. The third point is, from a more relational viewpoint, passage of this bill will create two classes of people. those who live lives worth living and thus worth defending, treating, and saving. And second, those whose lives are no longer worth living and thus are not worth defending, treating, or saving. During this pandemic, discussions have been ongoing of how to treat people with scarce resources and who gets those scarce resources. If this bill passes, requests for aid in dying and consequent and subsequent possession of lethal medication could too easily become factors in determining whether or not the qualified patient receives medical resources, scarce or not. I further note that two terminally ill Oregon residents discovered that their insurances would not pay for them to prolong their lives, but would pay for them to end their lives with assisted suicide, and this under a law with supposed safeguards. There is nothing in Senate Bill 88 that would prevent such a scenario from happening in Connecticut. Please vote against this bill. Thank you.
Thank you so much for your testimony. Seeing no question, we'll move on to the next person. Thank you for your time today as well. The next person on our list is Larry Rizzolo, followed by Robert Ventrella. Mr. Rizzolo.
Thank you for the opportunity to testify today. My name is Lawrence Rizzolo. I'm a professor emeritus at the Yale University School of Medicine, but these opinions are my own, not those of Yale necessarily. SB 88 offers patients the hope that they can live their remaining days. What do I mean by live? Palliative care gives patients the hope that they might live the remaining days in relative comfort, enjoy time with family and friends, resolve the grief of strained relationships, and die in peace. Palliative care should always be the first line of care. Aid in dying should be available for those rare cases where palliative care falls short. SB 88 offers those rare patients the hope that they too can live. In states where this is legal, patients usually die a natural death. Why? This option restores a sense of autonomy. As patients slowly lose control of so much of their life, they can control this. Restoring autonomy is the gift of life. Consider my friends Bill and Mary. It's not their real names. Bill suffered from ALS, a death by 1,000 cuts. First, you lose the use of your legs, then your arms, then your voice, the ability to swallow, and so on. All the while, your mind remains sharp. Bill wanted to live until swallowing was no longer possible. After that, he would be trapped in his body, unable to live with dignity. Because of current laws, his clinicians abandoned him because they couldn't about this issue. Bill sought help from an underground network. Sullen with the fear that he would not succeed, his marriage suffered. After convincing a provider of their sincerity, Bill and Mary received the counseling and the means that they needed. Bill's immediate reaction was to go outside and tend his neglected garden. In other words, he helped things grow, an affirmation of life. His personality was restored. Mary said she got her husband back. They lived joyously until the end. Why should government take Bill's life away? Wouldn't it have been better if Bill's clinicians could offer him the full range of acute and palliative care, including an aid in dying option? Should government put in time-tested safeguards like so many other states? Shouldn't trained clinicians have been allowed to walk with Bill to the end instead of casting him aside? And those are his words, not mine, casting him aside to fend for himself. You are entering the domain of the doctor-patient relationship. I respectfully ask that you follow a major principle of that relationship. Put the patient first by setting your moral and religious views aside. Grant patients the respect, the autonomy to make this most intimate decision.
Excuse me, Mr. Rizzolo, your time is almost up. If you'd summarize, please. Thank you.
Please enact SB 88 and take government out of this sacred space. Thank you.
Thank you, Professor. I have Representative John Michael Parker who would like to ask you a question. Representative Parker.
Thank you, Dr. Anwar. Thanks, Larry. It's nice to see you here again.
Good to see you.
And I want to thank everyone else who's testified so courageously today, and all my colleagues for their thoughtful questions. Grateful for this experience. Larry, I just wonder if you could speak a bit more about your experience with palliative care at Yale. And as we've been talking about all day, and even through these last few testimonies, really get into that gray zone about the difference between palliative care and aid in dying.
Sure. Thank you for that. So palliative care at Yale, when it was first really became a serious part of the curriculum some 20 years ago, we designed something that would last the 4 years because it's such a multifaceted issue, caring for the elderly, and especially at the time of life. And so every course that could have something to say about it, we tried to put it into those courses. So much more effective than having one palliative care course. And the principles of the program that we would emphasize are two basic things. One is bringing the patient to a place of autonomy. In other words, if you're in terrible pain, it's like having someone point a gun at your head, and you're really not making an autonomous decision. On the other hand, if it's possible and you can alleviate that pain, put them in a place where they're relatively comfortable, then they can make a more autonomous decision. I know that's very difficult, despite the great advances in palliative care. It doesn't always work. And so in my friend's story, he was in a place of autonomy. He knew exactly what was going to happen to him. He knew exactly when it was the last time he could take a pill. And it was designed that he took his own pill. Some elaborate device was set up that he could do that. But consider another friend. You all probably have one like this. She had breast cancer, and she had gone through chemotherapy. And every time a drug didn't work, they'd switch to another drug. And she was able to live for quite a while, until finally they ran out of medications. So they offered her a choice. We can try some last-ditch effort here, and you go through the pain of chemotherapy, or we can just stop. And she chose to stop. And she, like my friend, was able to live the end of her life with her family in relative comfort with the hospice, with the palliative care. They essentially made the same decision, right? A decision that allowed them to live the rest of their lives. And that brings me to the second fundamental principle, was this is all about the patient. It's not about your opinion. It's not about, and I'm speaking about the physician, but I could just as well be speaking about you. It's not your morality. It's not your ethics. It's not your anything. It's all about the patient. And that's what we train our medical students to do, the ethic we train them for. But if I may, I'd like to take one other small story, a little more.
Professor,
yes.
We don't want to take away, because there are a lot of other people there too, and we have other people who want to ask you questions. If you want to wrap up your response, we hope to keep the response within 3 minutes, please.
Well, I appreciate your tolerance. And when my mother was dying of Alzheimer's disease, she ultimately had pneumonia, and I was sitting there with the nurse who my mother gave the death rattle, which I know from my training is nothing to worry about. But he said, "Oh, I could take care of that. Let me increase the morphine." And he knew what he was doing, and I knew what he was doing, and we each knew that the other knew what was happening. He essentially made it so that her end came a little more quickly. That was a humane thing. And my point of telling all these stories is, you guys legislate in black and white, but we live in the world of gray. And that's what's so hard here. All I'm asking you to do is give people the choice. Let people decide who they should be, their advisors. The ultimate choice is theirs. But thank you for your indulgence.
Thank you so much. And Representative Pettit, you have a question as well.
Thank you, Mr. Chair. Thank you, Professor Rizzolo. If you think this question is unfair, you can defer. But when you talk about patient autonomy, what's come through throughout the entire day, there's a number of situations where it's very difficult for the patients to self-administer. ALS, difficulty swallowing, brain tumors, seizures, etc. How do you think you would approach that from a practical or legislative point of view in terms of if people have to self-administer and are at a big disadvantage in sort of administering the drug?
Well, I suppose the way I would approach that is to have the ability for their caregiver, whether it's their loved one, their physician, their social worker, their whoever, to honor their wishes and help them. My friends and our minister wouldn't tell this story. I knew the story because I knew them personally, but they broke the law and they had to live holding this themselves. They can only tell their most trusted friends because they broke the law. And I don't feel we should be putting people in that position of breaking the law when they're trying to follow the wishes of their loved one, having known that palliative care and everything else was exhausted. So that's as far as I can go with that.
I thank you for the response. Thank you, Mr. Chair.
Thank you, Professor Rizzolo. I want to ask you a question. It's a bigger question, but if you can keep the response shorter. I mean,
I'll
you're
try.
a medical doctor, and
Yeah. Go ahead.
you're a medical doctor, and you've come to a pretty strong position that you have. And can you tell me, how did you come to this, and was this a journey? And can we at least humbly recognize that people change over time with their understanding of what's going on?
It was a journey. Let me say, first of all, I'm a PhD, I'm an anatomist, and anatomy is the first place many medical students see a dead body, let alone touch it and dissect it. So it was an ideal place to begin this discussion. In our committee, we had physicians come and say, well, we should talk about aid in dying. And the committee, by and large, didn't buy that. We were all about developing this new field of palliative care and very strong an opinion of that. But what changed my mind was the story of Bill and Mary. I walked with them through this period. It was a real eye-opener to me. This, instead of being a theoretical thing, yes, we should have palliative care, we should make it as good as we can. This became a real-life situation, and it didn't fit the box very well. And that's why I said, you know, you legislate in black and white, but we actually live in a grays. Our lives are gray, and we need to be able to give caregivers the flexibility to do this on a case-by-case basis.
Thank you so much. We truly appreciate your testimony and your words tonight. Thank you.
Thank you, and I appreciate your indulgence.
We'll move on to our next speaker, which is Mr. Robert Fantarella, followed by Joan Vendetti. Mr. Fantarella, thank you for your patience and thank you for your anticipated testimony.
Hi, thank you very much for having me. Thanks for all your time today. I'm speaking to you in support of SB 88, medical aid in dying. There are many terminal illnesses where passing this law would let a dying person make the decision of when they personally get to the point that enough is enough. I've personally witnessed several examples of a particular disease, ALS, which has come up a lot today, and what it does to a person. I live in the town of Orange with a population of about 13,500. Just in our small town alone, I've lost 3 friends to ALS. I watched my lifelong childhood friend fight this disease. He was only in his 40s. He was a single man living alone. After he could not physically live on his own anymore, he went to assisted living. After he got too immobilized for assisted living, he went to hospice to die. The problem was he was in hospice for about 6 months, not dying. So he was there so long that they wanted to make him leave. He lied there in his bed daily, having visitors come say their final goodbye to see him for the last time. They would weep. My friend lying in his bed would try to console them. He would tell them it was all right and he wasn't in pain. Well, he lied. I was with him a lot. He did this through texting with his eyes through some kind of retina scan, because at that point he couldn't speak anymore. I just say, imagine that. He struggled to lie to people to make them feel good while he was dying. It was like he was living through and watching his own wake. He finally died in hospice. It was about 6 months later. So he was an incredibly strong guy. He didn't want anybody to feel bad. He wouldn't let anyone see how scared he was. But to this day, it haunts me for what he had to endure. If this law was around, the aid in dying, he would have had another option, and options are needed for terminally ill people. Another friend who passed from ALS had children. His biggest fear, worse than dying, was his children, especially the younger ones, having to watch him die. So to witness the physical toll the horrible disease takes on his body, day by day, getting harder to breathe until he could no longer breathe at all. He went from a strong, healthy man to someone resembling a malnourished, feeble old man, and he was only in his 50s. He felt that his children watching him slowly get paralysis of muscles, not being able to talk or chew or drink, was going to torture them. It seemed to him that not only was he going to die, but he was going to torture his own kids by making them watch it until the bitter end. And he could do nothing about it except lie there and go through his own torture until he died, a slow, painful, miserable death. And that's exactly what happened. My thought is that criminals are treated better than this. This is not fair. Options are fair. So please pass this bill so these good people have choices of how much pain and suffering they choose to endure before their terminal illness kills them. So these good people don't have to be tortured like some barbaric punishment because they have a terminal illness. And it's all because of bureaucratic nonsense, just help bring peace. That's what it all needs to be done. There's so many people speaking on here that feel their positions are somewhat, because of their positions, are more important than the actual people dying. Like all professions.
Mr. Fantarella, I'm sorry, your time is almost up. Would like to summarize.
I have it. Summing it up, there's good doctors, there's bad doctors. There's good priests, there's bad priests, and there's good politicians, and there's bad politicians. They have to come together for the goodness of everybody else. Thank you for your time.
Thank you so much. I will probably use your last statement in a speech at some point, and I'll try to give you credit for that too. Thank you for that. I have Representative Kennedy who wants to ask you a question.
Certainly.
Thank you, Mr. Chairman. And actually, really quickly, Bobby, I just want to say hello. It's been a number of years. I think some of the people you spoke with are actually some of my classmates. It's unfortunate in a small town, as you said, of Orange, which I grew up in as well, that we had so many people die of ALS. And I watched my lifelong friend from the 6th grade and exactly what you went through. So I appreciate you telling your story today. ALS is a wretched disease. But thank you for sharing your story today. Thank you, Mr.
Thank
Chairman.
you. I appreciate it.
Thank you. Thank you, Representative, and thank you, Mr. Fantarella. We should probably find out why so many people had ALS in the community. That would be another conversation, but it's worthy to look at the toxins and some of the things that we sometimes worry about. But I truly appreciate your testimony. Thank you for your patience, and thank you for sharing your important words on behalf of your friends. Thank you, and beyond.
Thanks for having me.
And before we take the next speaker, we've been doing this for over 9 hours. Usually when we are in person, we move around a little bit, and in Zoom, we don't have the luxury of moving around as much. So please move your legs, don't develop clots, don't get sick, please stay well, and just move around. This is 9 hours, and we are just also not only physically tired at times, but emotionally too, because this is a very important and difficult conversation. And I'm so proud to be part of this committee where each and every one takes this so seriously and listens to all views, emotional views, irrespective of where they may be. And that's a blessing to be working with my colleagues with that mindset. Next is June Vendetti, followed by Dr. Thomas Finn after that. Ms. Vendetti. You're not unmuted yet. So no, you're still not unmuted. So if you look at the lower left side of your screen, you will see a mic. press that. Good, you got it.
Thank you. I got it. Good evening, all committee members. This is my first time doing this. I've been listening to all the testimony all day long, and it's been very eye-opening. My mother, when she was coming to the end of her life back in 2018, her one remaining kidney wasn't functioning, and it was failing pretty quickly. She also had emphysema and COPD, and she had been in and out of the hospital over the course of the prior 10 years, up until the day she died. Her condition had worsened, and on May 21st, it was decided the hospice would come in to take over her care. Now, my mother had a high sensitivity to drugs, and on one of her hospital visits, she had some pain. They gave her morphine, and she was very, very deathly sick from it because she hadn't eaten anything. And so it did a number on her stomach. And I had left her one way the night before. And when I went back in the morning, she looked terrible. She looked like she was going to die. So in that respect, these drugs, knowing what they did to her system, and I knew what hospice had and was going to do, I had prayed. I'm very religious, and I called on God to intervene because I didn't want my mother to have to take these drugs. And I prayed with her at 10 o'clock that night, and she was at that point, after I finished praying, she had fallen asleep. And at some point I did too. Now, knowing that my mother was very vocal when she was in pain, so I felt that, I would have hurt her if she had been really, really bad. So I had woken up at 12:40, and I looked over at her because I was sitting opposite her. I wanted to keep an eye on her breathing. And I noticed she had the oxygen hose in her nose, and I noticed she wasn't breathing. So I went over to her, and God had answered my prayer at that point. He had taken her before she had to take those drugs. Now, as a Catholic, I believe in life from conception to natural death. And God brings us into this world, and he takes us out according to his holy will. Feeding my mom.
Excuse me, Miss Vendetti, your time is almost up. If you could summarize. Thank you.
Yes. So I know society seems to be hung up on the quality of life issue. How does one measure the quality of life? What does it even mean? By whom standard is quality measured? Society thinks that if you are no longer able to contribute to it by their standards, that should be the end of your life, and not at all true. While those who have entered their golden years decide to enter second careers, they are still able-bodied and willing to give of themselves. But when sickness strikes, sometimes it's hard for anyone. So sometimes it's a temporary thing, and sometimes not. In any case, it's not for us to determine when our lives are deemed
Ms. Vendetti, you want to, you've gone over the time. I'm so sorry. But thank you so much for your testimony, and you spoke so well. I truly could experience the thoughts that you had, and it was very important that you shared that with us. We appreciate your time. Thank you.
Thank you.
And seeing no other questions, we're going to move on to Laura Billand. I'm sorry, I did not mention you earlier. And then following that is Dr. Thomas Finn. So Ms. Belland.
So my name is Dr. Laura Belland. I am board certified in family medicine, geriatrics, and hospice and palliative medicine. And I am here today in support of SB 88. I'm here on my own accord. I am currently an inpatient palliative medicine consultant at a hospital in the Yale New Haven system. And this means that I am seeing terminally ill patients on a daily basis with a focus on trying to improve their quality of life. I am often asked by patients and families how I'm able to do the work that I do and how I can face death and dying every day. Nothing gives me greater satisfaction than to help ease a person's suffering, especially those who are in the last stages of their lives. And while I'm very proud of the work that I do and the work provided by hospice and palliative clinicians around the state, I know that it is imperfect care, and that for some patients, their suffering cannot be controlled, or if it can, it comes at a great cost to their quality of life. Take, for instance, a patient I had recently with stage 4 lung cancer who was struggling to breathe. The amount of medication needed to control her symptoms simultaneously sedated her to the point that she was no longer interactive with her friends or family or awake enough to enjoy food or drink. She passed away without her family being able to say goodbye. It's understanding that outsiders who aren't the family members of these patients or the clinicians caring for them would misunderstand what the actual dying process in the last 6 months may look like. What I don't understand is the baseless claims against aid in dying, such as the slippery slope argument, concerns that minority or vulnerable populations will be targeted, or access to care is limited, when none of these claims have any evidence backing them. I practice evidence-based medicine, and actually the evidence over the last 20 years is quite clear. It has been proven to be safe, and laws across the country have worked as they were intended. Perhaps most egregious is the constant conflation of aid in dying with suicide, despite multiple national organizations, including the American Association of Suicidology, rejecting the term assisted suicide. Suicide, as we conventionally know it in American society, is characterized most often by a person with a mental illness, done secretly and often compulsively and violently, and leaves loved ones traumatized and reeling, trying to understand why. Unfortunately, I know this all too well. My youngest sister died by suicide in 2018 while I was in fellowship training. Her death happened in the backseat of a parked car in an empty parking lot after she lied to her boyfriend that she was working. Her death was not like the deaths that have occurred with aid in dying, with the overwhelming majority occurring in the patient's home, planned ahead with loved ones all around, as Linda Bluestein described. In fact, data shows that the bereaved of aid in dying patients grieve similarly to the bereaved of other deaths, while suicide survivors, as we call ourselves, have higher rates of complicated grief, PTSD, and even higher rates.
Excuse me, Dr. Ballard, your time is almost up. If you
Thank you.
summarize. Thank you.
My mother, who was diagnosed with ALS 3 months after my sister died, understood the difference between aid in dying and suicide. If she, as a grieving mother, could understand the difference, I think the rest of society can too. My mother passed away peacefully in her sleep before her disease was in the final stages, but if she had lived, I would have supported her choice to use medical in dying. I have one thing to point out, that the American Medical Association's Council on Ethical and Judicial Affairs confirmed in 2019 that physicians who provide medical aid in dying are acting well within the Code of Ethics. Physicians may disagree, but whether they provide aid in dying or not, they are acting ethically and within the best interest of the patient. Additionally, AAHPM, my organization for hospice and palliative medicine, are actually neutral, and the American College of Family Physicians are in neutral, if not support.
Thank you.
I
Thank you
welcome
so
any
much,
questions.
Dr.
I have a lot to say about
Yes.
things that have been said here.
There are a lot of people with a lot of questions, I believe. So, Dr. Bellin, thank you for your testimony. I'll start with Representative Foster.
Dr.
Go ahead,
Bellin, thank you.
Representative.
Thank you, Mr. Chairman, or Dr. Chairman, we say today. Dr. Bellin, thank you so much for joining us today. You brought up a really interesting, different perspective from many of the people who have testified today, saying that they had never met with someone who needed aid in dying, that they never suffered, they never had patients suffering at the end of their life, that palliative or hospice care was insufficient for. And I find it an interesting sort of juxtaposition that someone could advocate so passionately in the same field, in the same practice, as folks who say, like, this isn't a need, everything is mostly fine and handled within the system that we have. Do you have any way to reconcile what you view as those differences? I'm not sure if you've seen any of those testimonies that I'm referencing, but do you have any?
I've seen a few, and I implore everybody listening today to all the testimonies today to take everything with a grain of salt, including my testimony. I think there are some things that have been said that I've heard that are not true. So I want to talk about, the inpatient versus outpatient hospice dilemma, because hospice gets painted as this place where people can go. They can get palliatively sedated, which is not a thing. We don't do that regularly. And that people can get quite good symptom control. When the reality is most hospice is provided in the home. It is up to families and friends to take care of the patient. They do have 24-hour hotline they can call, but the nurse cannot come out immediately. There are a few cases where they can get 12 hours, 24 hours at home care, but that is rare. I am always counseling families before they go home with hospice that the care is going to fall on them and that they are going to have to be providing the medications. I'm not sure why some people say that palliative care and hospice can fill the gaps. When I have seen cases where I think had I not stepped in as a clinician and administered high doses of medication, I think that person would have suffered.
So another sort of along that sort of line is that people's definitions of suffering seem to be subjective. And to me, it seems like a bill like Aid in Dying puts the onus of adding that subjective definition of what is dignity, what is comfort on the person experiencing pain. It's their choice, their decisions. And pain scales are subjective and flawed in certain ways. We have heard a lot of people reference the number 3 as the point in time where they're allowed to suffer up to 3, but what 3 is for different people might be different. And so I'm sort of curious about what you think about these folks who are like, well, that's an acceptable degree of suffering. We have defined like that amount is okay and acceptable. Have you sort of observed differences in what people are willing to tolerate from a pain scale perspective and what that means?
So yes, I have seen differences in people's ability to tolerate pain. I've seen differences in their desire to tolerate pain in so that they can be more awake. There does come a point for some people where the amount of medication it's necessary to control their pain ends up making them foggy, ends up making them sleepy, tired. They may not want to do much. And so I have seen people who are willing to tolerate a bit more pain. I'm glad you brought up what suffering is, because another panelist said something about existential distress and seemed to dismiss it, when in reality, what we know in palliative care is that there is a subset of pain called total pain. And what it means is that the existential, the spiritual, the emotional pain of this person knowing that they are dying, that there's nothing they can do about it, and that it's going to happen, it actually accentuates any physical suffering or physical pain that they have. And if you don't treat the existential suffering, if you don't treat it with multidisciplinary effects with such as a chaplain, a social worker, we know actually that it makes it much harder for the physician to just throw opioids at it or medications at it. And so to dismiss existential distress as just something like, oh, well, they don't want to lose their autonomy is really not understanding the process of dying.
Thank you so much.
Thank you so much. Thank you, Representative Foster. Dr. Pettit. And Dr.
Thank you, Mr. Chair. Thank you, Doctor, for your testimony. A two-parter. A subject frequently today has been hospice and palliative care, and I'm wondering if you think there are significant changes, additions that need to be made under the current policies, regulations of the things that can be done and can't be done that would improve care there, number one. And number two, what I asked Professor Rizzolo, in many of the situations we've heard about people with ALS, swallowing problems, et cetera, in terms of administration of a dose in Aid in Dying, how would you approach that issue?
So going with that one first, we don't have a solution for ALS. That's just where we are. You may have seen there was an op-ed recently in the newspaper by a woman with ALS commenting that she's going to have to end her life early before she loses her ability to administer her own medication. So I don't have an answer for that. My mom, that's what she had. So that is what it is. So this bill isn't going to be able to help people with ALS in the last 6 months of their lives unless it's bulbar. Bulbar is where it starts in the throat first and they aren't able to breathe. If that person decides they want to take off their breathing machine, they will die in 6 months. They may still be able to give it to themselves. Otherwise, we can't. I think there's so much that could be changed about hospice and palliative care. I think the number of organizations needs to increase, the number of hours that the organizations are willing to give, and this all comes down to Medicare. Medicare only pays a certain amount per day, and the hospice then has to take that money and distribute it as it can. And so the reason that some hospices don't provide things like radiation oncology is because it's too expensive for them, and they decide that's one thing they're just not going to be able to give. So if we were able to get Medicare to actually step up and give more dollars, give more monies for hospice care, I think we would have such a much better system. Would we be able to fill the gap for patients who are symptomatic, who still wish to take medical aid in dying? No. And I think that that is because for a certain number of people, and it's a small number of people, a certain number of people, they get to a point where they have peace with their life. They have peace knowing that the disease process is taking their life. They have peace knowing that it is time for them to go and that they can do it in a controlled manner and it's in their control. And on that basis, I wanted to bring up a couple of things. There's been a lot of talk about the medications that are given. So I wanted to dispel a couple of myths. I have a good friend who practices medical aid in dying in California. And they actually, a lot of the medical aid in dying doctors actually get together over whatever, email, whatever, and they share ideas. They actually share what works. They share the number of people, when they die, how many hours. In her practice, in the practice of her colleagues, 85% of patients die within 2 hours. Only less than 3% are alive more than 5 hours, and only one patient was alive up to 10 hours. It is a mixture of 4 medications right now that most people use, something called digoxin, which is a heart medication. They use a tricyclic antidepressant. They use 2 grams of diazepam. If you think about that, we usually talk about milligrams of diazepam, 2 grams, and 15 grams of morphine. It ends up making a slurry. So there's no way a person would be able to put it in some apple juice, hand it to their mom and say, drink up, mom, it's just apple juice. It tastes very differently. It makes the consistency very different. For anybody who has GI issues, let's say that they have slow motility and they may not process it very well, the doctor gives them medications beforehand to make sure that they're not going to vomit it up. And there doesn't seem to be any issues. They're not vomiting all over themselves and aspirating. And if there is any concern, you can give it rectally.
Mr. Chair, if I could have one follow-up.
Yes, please.
Doctor, in the current environment with the regulations for Medicare and people that follow it, are you able to administer intravenous a morphine drip at home, or is that clearly not allowable under the current regulations?
Under most hospices, you can't do it. So I know the lady who was in charge of the hospices mentioned subcutaneous. Subcutaneous is the best that I've ever seen. The issue with subcutaneous is you can't go above a certain rate. It literally just can't get into the skin and do above a certain rate. And the other thing is it's not as fast acting. It takes up to 30 minutes to actually take effect. So that's 30 minutes while you're waiting for your loved one to stop breathing so heavily or have whatever have you. So most cases, if they need intravenous, they have to go to inpatient. The problem with inpatient is Medicare limits the number of days they're allowed to stay there. And you have to be actively titrating the medications in order to qualify. So this becomes an issue when people stop being able to swallow and the subcutaneous may not be enough or patches may not be enough. What do you do with them? I am stuck in a lot of cases. I can't tell you how many cases I have here in the hospital that when they're ready for discharge, their loved ones cannot take them home. They are not able to care for them in what they need. They can't turn them every 2 to 4 hours to avoid pressure sores. They have to work. They can't do FMLA for whatever reason. And so I am stuck with the care coordinators trying to find a place for these people to go. And luckily, Branford, run by Connecticut Hospice, is a wonderful organization, and Yale has a contract with them that if we think a person will die within 30 days, they're willing to take them. Yale will pay for the bed. But if they live more than 30 days and they're not meeting hospice criteria, they have to find a different place to go to.
Thank you, Doctor. Thank you, Mr. Chair.
Thank you, Representative Pettit, Dr. Pettit. And next is Representative Berger-Chivalo. Please go ahead.
Thank you once again. And thank you so much, Doctor. I just have one question for you on the Council of Ethical and Judicial Affairs statement. What does that mean to you? And has that impacted your views, specifically your views on this issue?
So as you all probably know, medicine is not always with the times. Medicine often lags behind society. It has been hard for medicine to get on board with transgender patients. We are not the people to look towards for what society may want. So yes, it does help me when I hear things like this, but I also actually don't look up to a lot of these organizations. And the reason is because, similar to some of the testimonies I've heard here, there are a lot of people who are not on the ground. They are not treating patients. They are in offices, or they are radiologists, as one of our past panelists was. I'm not sure when they've been seeing patients on the ground and actually treating them. And so when they put out statements, yes, it can help, but if they were to ever say anything else, I don't look to it as my guiding light. I am constantly evaluating what's happening on the ground. I'm talking to my colleagues, what they're seeing, looking at the evidence, like I said, with all the other states that already have it in practice without difficulty there. That's what I look to.
And I appreciate that you clearly have a curiosity about what is going on, not just in your own space, your own space, but also elsewhere, and talking to colleagues that are in other states and administering this. And so thank you for sharing all of that and from such a broad perspective. Very much appreciate it.
Thank you, Representative. So I had a couple of questions as well. First, I wanted to just say that thank you for the work that you're doing. It takes a lot of special gifts an individual has to do that. And I can tell that you do it with a lot of empathy and care. So I wanted to thank you for that work. And it takes a lot out of an individual when you're living in that space, but at the same time, you can give so much care to a patient, and that's rewarding in that situation. When you cannot do anything, you can at least make them comfortable. I wanted to clarify a couple of things. One is there was a comment that was made that these medicines are not FDA approved. And as I look at the medicines, I think they are all FDA approved. So that's more of a yes and no question. I wanted to clarify that. I know that they are, but I want you to be able to say that. Are they FDA approved?
I almost laughed when this was brought up. I have to be very honest. The number of times that people take non-FDA approved medications on a daily basis, it's happening all the time. And that's because the FDA is a very arduous, they have a very arduous process, and they recognize that there are lots of medications that can be taken for off-label purposes that are just fine. So yes, all of these medications are FDA approved in themselves. Of course, the FDA has not looked at this cocktail and approved the cocktail.
Okay. The other question I wanted to ask you was, there's almost a sense of dichotomy that I'm sensing in the legislators right now. One is that let's fix palliative and hospice, and then we won't have to worry about this. And I don't think it has to be dichotomous. We have to improve that. But that doesn't take away from the need of this specific need for some of the patients that require aid and dying.
Yes. So actually, if you talk to some of the physicians that are actually administering aid and dying, they all recommend that their patients do go into hospice. So it is not this case where a person comes into an office and it says, hey, I have a terminal disease, I want this medication. And the doctor just says, okay, it is that doesn't exist. What exists is we're going to start with hospice, we're going to start with palliative care, we're going to make sure you're not depressed. If then, despite all those things, that person is still requesting it, which is why the safeguards exist, then that is where it's not that palliative care failed. It's that the person is desiring something that palliative care cannot provide, or that hospice cannot provide. And I wanted to make a comment about the safeguards. There are safeguards everywhere in medicine. Somebody mentioned that because there are safeguards, this must mean this is a really dangerous thing. You have to go through an entire checklist when you go into the OR. Atul Gawande wrote an entire book about this because people were cutting off the wrong limbs. Yes, there are dangerous things in medicine and the risks are real. And that's why we have safeguards to protect against cutting off the wrong limb or allowing a person with mental illness to get medical aid in dying. And sorry, one more thing, but the doctors about, the people who say in Yale who said, yes, I would want to do it. But when it got down to, would you do it? I would question, well, what doctors are we talking to? Orthopedists, plastic surgeons? There are many doctors who will never, ever be in a position to do something like this. So I wouldn't blame them. Then they shouldn't be offering it. It should only be people who are going to commit to being experienced, knowledgeable, study, understand what's happening. And that's going to be a very small subset of physicians. I'm not surprised by that.
Thank you so much. I think in my line of questioning, I was trying to allude to that very fact earlier as well. I have another representative who has a question. Representative Carpino, please go ahead.
Thank you, Chairman. And Dr. Bellin, thank you very much. As a non-medical provider, I've appreciated your testimony. So please take this question for what it is. It is a layperson asking. Knowing that this is such a specialized position for a medical provider to be in. And I agree, if this bill passes, I wouldn't want my orthopedic, as wonderful a fellow as he might be, involved in a decision like this for anybody. With that said, how much training, experience, specialized training, education should a provider that's going to have the ability to write such a prescription of magnitude have before they're given that right?
So I think we are in uncharted territory. As I imagine Oregon was and Washington was, I would be very interested to see how those physicians started out. I am not going to say that every physician who needs to do this needs to do a palliative care and hospice fellowship. The friend that I mentioned who practices medical aid in dying in California is not fellowship trained. She actually trained to do medical aid in dying under one of the more famous experienced doctors in California. So perhaps that needs to be written into the legislature. I would be in favor of that. I agree. I think there's got to be some sort of oversight and training so that when something may not go right or something unanticipated, the physician is not caught and doesn't know what to do.
Thank you. And regardless of where I ultimately end up on here, I do want to make sure that we're truly protecting our patients until that very end, and their families and their caregivers who are already in a very emotional state, and want to make sure that the physicians that they're dealing with are able and qualified to do that. So I appreciate your perspective. Thank you, Mr. Chairman.
Thank you for that very important question. I will just end. If you have any thoughts about the bill, how it could be better, please feel free to reach out to us because you live in that space and you have an understanding. So it would be truly appreciated. And we cannot thank you enough for your time this evening and part of the day.
Thank you so much.
All right. Of course. Thank you. And we'll move on to our next speaker, Dr. Thomas Finn, followed by Sharon Hines. Dr. Finn. There you are. Hi.
Hear me okay, I hope. Good evening, chairperson and committee members. My name is Dr. Thomas Finn. I'm a resident of Southington, where I've worked for almost 40 years as a psychologist. I am very acutely aware this year of the dying struggles for the person who's been ill, for their families, for their caregivers. I'm walking this road with my mother-in-law right now, as Alzheimer's. I've lost a friend to cancer this year. And having walked this road, even though I've walked it before with both my parents, other friends and clients who've died after struggles with long illnesses, I am opposed to Bill SB 88. One of my concerns continues to center on determining who really can qualify for the bill. As it stated, qualifications include patients who are able to competently make informed decisions. And I share the opinion of many health care providers that it is often very difficult to determine who can truly be identified as someone who's informed because of the reality of how much emotional pain there is in that process. The desire to end one's life has always been associated with higher levels of psychological distress and depression in terminally ill patients, which impairs that ability to make truly informed decisions. The capacity to assess a medical situation is very much distorted by a depressive cognitive state and the feelings of helplessness or guilt or worthlessness that can go along with that. What happens is that state distorts the ability to process objective information, and it ends up with a distortion of the sense of the quality of what my remaining days may be like, the number of which those days are often underestimated. And it definitely can limit our ability to perceive benefit from palliative treatment. So given the frequency of depressive symptoms in patients with terminal illness, the frequency with which those symptoms are often missed by medical practitioners, and especially the historically low rate of psychiatric evaluations being performed on people who are seeking physician-assisted suicide in states like Oregon, it's usually, if we're lucky, about 1%. There's
Excuse
just
me, Dr. Finn, your time is almost up. If you please summarize. Thank you.
Very well. So that's one concern that I have, that there is going to be a mislabeling of who's qualified or competent. The other is just in terms of my work as a psychologist. I do think that there will, this afternoon I talked with a couple of people who are considering suicide, and my role is to prevent that. And there is going to be a greater challenge to that, I think, if we as a state hold out a message that says that ending one's life is a viable pathway for certain types of suffering. I also think that there, in terms of like the sense of research or what we know from other states, I think it's so important the committee realize that we really don't know what's happened in other states in a very clear way. The kind of research that needs to be done to truly answer questions like why are there disparities in the racial dimension, socioeconomic dimension of utilization, particularly in terms of complications. Last year in Oregon, I think 245 people were prescribed medication, or 245 people actually died, but there were missing data on complications from over 170 of them. So it's very difficult to know exactly what's happening given the way that data is collected and analyzed. So in
Dr. Finn,
conclusion,
thank you so much for your testimony.
In conclusion, I would just hope
thank you.
Not institute this bill.
Thank you so much for your testimony, and seeing no questions, we will, Representative Carpino.
Sorry for being late. It's late, and I only want to ask questions that I think would be helpful. Dr. Finn, thank you for testifying. I struggled with one of the concepts we discussed at length earlier about social workers definitely being an important part of our mental health system, but being able to determine competency and talking to patients about this. As a psychologist, can you add a bit of context to us? I look at all of this as consumer protections and protecting patients.
Yeah, I would have two levels of concern. One is when it comes to questions of competency, that is a very specialized process of evaluation that is typically the standard that we go to. It's not just someone with a degree giving an opinion. There's specialized training, there's experience, et cetera, to be able to be someone who is looked at as a credible source of judging competence in somebody to make informed decisions. So that's not something that happens in I'm no expert on this, but it certainly doesn't look like something that happens in other states where questions of competence are on the table. The other thing is, in many of those states, I think Oregon is one, the people who eventually do those evaluations, if a physician does refer someone, which again is a very, very low percentage. I think this year out of 245, there were 3 referrals. Those are often done by the same person in the state. So it's not, in my mind, a kind of generally objective process. The other dimension on the competency question would just have to do, I'm trying to think of the best way to say it, but the assessment of what someone might do in an office, let's say a general practitioner, is often limited in a way that I saw it happen with my mother, for example. So she passed away from breast cancer about 12 years ago. So I remember being at a doctor's appointment with her where she was being given the diagnosis and talking about treatment plan. And so the doctor explained it, said to her directly, "So Mary, do you understand what I'm saying?" And she said yes. And so we completed the appointment. We went out into the car, and she turned to me and said, "Now, what did he say? I really didn't understand what he was telling me." But she was too afraid to say that. It's kind of how my mom was. So I do think that there are just huge risks in the assumptions that get made around competency assessments. And I'm very worried about what can happen as a result of that.
Thank you.
Thank you.
Thank you, Mr. Chairman.
Thank you so
I'm all
much,
set.
Representative Carpino and Representative Giraldo.
Thank you so much. And thank you, Doctor. I just have one question for you. You were talking about the low number of patients being referred for mental health assessment. To me, that suggests that the system is working. Would you say that patients who clearly don't qualify never enter the process? Is there a reasonable explanation for that?
Well, see, I think, again, if we look at the research on people who are diagnosed with a terminal illness, depression is an extremely high, it's at an extremely high rate for those folks because, and we can understand why. It's so frightening and it's so heavy. So, the way a lot of these laws seem to be written is if a physician suspects depression, then they would be referred. I couldn't imagine how anybody wouldn't be depressed. So that's my concern, that there's an assumption that if I say, "Are you depressed?" and you tell me no, that's an accurate answer. When I think there's a much greater depth to the process of figuring that out.
Mr. Chair, may I just follow up with one related question?
Yes, please.
Thank you. I'm sorry, and I know we're all exhausted, so maybe I'm just kind of oversimplifying what it is that you're saying, but are you saying that all people who were terminally ill are also mentally ill?
No, I'm saying there's a very high level of depression, high rate of depression in people who are diagnosed with a terminal illness.
Okay. All right. I appreciate the clarification. Thank you.
Thank you so much. Dr. Finn, I just wanted to quickly ask you a question. On the competency, every single day physicians are actually assessing the patients, getting permission. The surgeons are getting permission for surgeries, central lines, procedures, and you're saying that they are not equipped to get informed consent at this time for any of those procedures?
No, I'm talking about a psychiatric and emotional evaluation.
Okay, so but the informed consent they are able to get, but with respect to, and then again, does every depressed person become suicidal?
No.
Okay, just wanted to clarify. Thank you so much for your testimony. I appreciate your time today.
Thank you all very
we'll
much.
move on to the next. Thanks. I'm going to move on to the next person on the list. Is Sharon Hines, followed by Jennifer Mizzoni, and please forgive me if I don't pronounce your last name accurately. So Sharon Hines. I think Sharon was here. Well, while we are waiting for Sharon Hines, we are going to move on to Jennifer Mazzoni, and we can come back. Go ahead, Ms. Mazzoni. Did I pronounce your name inaccurately? So forgive me if I did.
It's Jennifer Mazzone, but that's fine. You came pretty close. Members of the Public Health Committee. Hello, my name is Jennifer Mazzone from Orange, Connecticut, testifying in support of Senate Bill 88. I begin with the same question that has yet to be answered that I mentioned before in my testimony in previous years. Why does someone with ALS in Orange, New Jersey have more options at the end of their life than someone in Orange, Connecticut? A terminal illness. Listen to those words. An illness that is terminal, with 2 doctors willing to put their license on the line to say that within 6 months, this person will pass. Please do not be swayed by fear-based, untrue, or hypothetical statements that scare people that you are listening to today. My late husband, Michael Mazzone, wanted to live. He fought to live as long as possible with a full, vibrant life with his children and me, yet it weighed on him how the end would come about. He wanted this bill to pass and testified before this committee himself. On July 15th, 2019, Mike passed of asphyxia. The quality of his life was a nightmare towards the end. He was in hospice and they did not come through on many occasions. He suffered unnecessary mental anguish. Sometimes the vessel that helps us move and think does not give out with precision and in a perfectly wrapped package. Our children, including 2 minors, watched their dad deteriorate in front of their eyes. To attend your father's funeral at the age of 11, help daddy tie his shoes, help daddy get his arms through his sleeves, help daddy zip up his zipper. So he feels like he's helping dad. In his mind, does he think he's helping dad get better? He has forgotten that dad's going to die with absolute certainty. They forget the end is coming. They just want to help dad. Come watch a movie with dad. Dad's building memories so he's not forgotten, cherishing every moment. Whose needs come first? My ailing husband's? My children? Did he pass peacefully? No. Not a single person to date has survived ALS. Do you know how one passes from ALS? Not when your hands cease to move or when your bowels lose control. You die from ALS not when your breathing drops from 98 to 80 or even to 70. You died a slow, gasping for air kind, the kind like when your breath is taken away or we choke for a few seconds and our life flashes before our eyes. That kind, every day until you die. Can you imagine knowing this and being constantly scared? Please do better in Connecticut. Thank you for listening.
Thank you, Ms. Mazzone. Thank you for your testimony and thank you for sharing some of your pain. I have Representative Kennedy who wants to ask you a question. Representative Kennedy.
Thank you, Mr. Chairman. I just wanted to say hello to Jennifer and thank you for sharing your story. I know how difficult it was for you. And I do sincerely apologize again for your loss, but thank you for coming and sharing your story today.
Thank you. Thank you very much.
Thank you, Representative Kennedy. Thank you, Ms. Mazzone. And we will move on to Sharon Hines. I can see her. She's here now, followed by Diana Bernard. Ms. Hines.
Good evening, everyone. My name is Sharon Hines, and I have testified to this committee before in support of medical aid in dying. Thank you for the opportunity to do so again today. I have stage 4 lung cancer. I'm also a nurse practitioner with more than 30 years experience caring for people with terminal illness in both hospice and oncology. I've been a lifelong resident of Connecticut, and I currently live in Branford, but I also established residency in a state that offers medical aid in dying. My plan is to relocate there when I run out of acceptable treatment options, because without treatment, my prognosis becomes weeks to months. I've been fortunate that I've had the time, energy, and resources to plan this move, to find housing and a new oncologist who supports my wishes. But honestly, no one should have to leave the place they call home, their loved ones, or their medical team to gain access to this option. When I was diagnosed, I knew all the possibilities that could come with this disease. Like so many with advanced lung cancer, my disease has spread to my brain. Lung cancer carries a higher symptom burden and lower quality of life than other cancers. With progression of disease, there frequently is worsening pain and trouble breathing. You just heard Ellen Abrams' heartfelt story, not only her own, but about her friend with end-stage lung cancer who described her difficulty breathing as a feeling of suffocation. This stuff is real. Growing tumor can obstruct airways, it can lead to intractable coughing, and fluid can build up in the lungs. The inability to raise secretions can lead to choking, aspiration, and pneumonia, things that all can further compromise breathing. Sometimes a tube has to be placed in the chest and requires frequent drainage. The procedure of draining fluid can be very painful, even in the hands of the most skilled practitioner. And then the progression of brain mets can cause headaches, nausea, vomiting, seizures, imbalance, loss of mobility, loss of vision, speech impairment, difficulty with memory and understanding, personality changes, delirium, and hallucinations. Prospects don't look very good for me. This is about me. It's about my death. It's about autonomy, patient autonomy, my autonomy. It's about having choices. I want to know who I am, where I am, and be able to say my final goodbyes to my family and friends. Medical aid in dying should be an option. It offers a more humane, gentle, and peaceful ending to the one I face without it. And there's a reason this bill keeps coming before you. I commend those who worked so hard to vote it out of committee last year, but you need to do more. It may be something you would not
Excuse me,
choose
Ms.
for
Hines,
yourself.
your time is almost up. If you please summarize. Thank you.
Thank you. Medical aid in dying may not be something you choose for yourself, but don't deny those who are opting, who want to have this option. And thank you.
Thank you so much, Ms. Hines. Thank you. I shouldn't say it's good to see you because we'd rather not have to see you in this setting. We want to see you get better and not have to testify and be with your family and friends. But thank you for your strong words and they echo what you had said about a year ago as well. So we cannot thank you enough, and we are praying for your well-being and complete health. Thank you.
Thank you.
And we'll move on to the next person on our list is Diana Bernard, followed by Stephanie Packer. Ms. Bernard.
Thank you. My name's Dr. Diana Barnard, and I really welcome the opportunity to share my experience and why I encourage you strongly to pass SB 88. I am board certified in family medicine as well as hospice and palliative medicine, and I practice in Vermont, where medical aid in dying has been legal since 2013. I regularly assess patients for their suffering, and I also prescribe under the law, and I counsel and educate other physicians who choose to participate in the law. I want to tell you the story of Willem Jewett, who was a lawmaker that I actually worked with to help pass our law several years ago. Willem never would have imagined that just a few short years later, he would be diagnosed with metastatic melanoma. After less than 2 years of active treatment, Willem's disease started to rapidly progress and he had a physical decline. In my experience, people who are facing the end of life often have 3 simple wishes. They want to be at peace, whatever that means to them. They want to be in their own home and they want to be surrounded by family. And yet the sad reality is that many, many Americans do not get those simple wishes. Willem, at the age of 58, did get those wishes. He was on hospice and he used medical aid in dying to hasten his death. And he did so in his own home with his family surrounding him. My written testimony, which was submitted to you, includes some media coverage that talks about this death, which was one of the most beautiful deaths I've ever seen. And it also includes a link to a video with Willem's own voice recorded just a few days before he died. And this former legislator spoke so well that I want to read a short quote from him. "It," meaning medical aid in dying, "has given me peace of mind all the way through." Do people really think that patients in our condition haven't thought about this a lot and that their decisions are not well reasoned? At the end of the day, if it's between public policy and patient control, let's side with the patient. There was a recent report in Vermont that showed that our law is working as intended. Over 8 years, 116 Vermonters have availed themselves of the law without a single episode of abuse. The vast majority of them had cancer. Our experience mirrors that of other states. As a practicing palliative care physician, I can tell you that most patients want to live as long as possible, almost without exception. But when time is short and illness is advancing and their treatment options are limited, they want a say in how they die. And many people will have a peaceful death without the need for hastening, which is
Dr.
wonderful.
Barnard, I'm sorry to interrupt, but you need to summarize. Thank you.
Yes, and others will have difficult deaths with unimaginable pain. Medical aid in dying is always a personal choice. No doctor, no patient must participate. I really urge you to make this option available to the citizens of Connecticut who clearly want to have it as an option. Thank you very much.
Thank you so much, Dr. Bernard. We have Dr. Pettit who has a question, and I have some too. So Dr. Pettit, go ahead.
Thank you, Mr. Chairman. Thank you, Dr. Bernard, for staying here in the 10th or 11th hour. I wondered if you could comment on what impact the law in Vermont has had on the disability community, if any, and if their attitude towards this has changed over time since it's been law.
You know, it's interesting. Across the country, there are, like with other groups of people, a disability community has a range of beliefs on this. And in Vermont, some disability rights were opposed to the bill, and I don't believe that there's been a lot of movement in that regard. You know, I can't say often enough that it's all voluntary. And, you know, our job is to hold the range of what people find brings meaning to life. For everybody. And so in my own mind, that includes the disability community. You know, it's up to the individual to determine if they're suffering. And my job as a physician, and a hospice physician especially, to listen to the patient.
Thank you, Doctor. Thank you, Mr. Chair.
Thank you so much. So Dr. Bernard, today we have heard a lot of doctors and individuals who have opinions about this issue. You have a unique perspective. You're the only one that I've listened to today who has actually prescribed the medicines. Could you walk us through step by step that entire process, if you could, in Vermont?
Yeah, so, you know, our law, which is very similar to other laws and the law before you, has a carefully laid out process with safeguards. So a patient, first of all, to be eligible for the law, they have to be a resident and over 18 and capable of understanding what they're asking for and have a terminal illness with less than 6-month prognosis. And then they have to go through a series of steps. They have to identify a physician who is willing to prescribe and make a formal request. And then more than 2 weeks later, they have to see that same physician and make a second request. During that second request, the physician has an obligation to make sure the patient knows all of their treatment options and specifically is given the option of stopping the process at any time. There is a need for a second consulting physician to confirm that the patient is capable and that they have a terminal illness and are eligible for the process. The patient also has to make a written request to clarify their illness and their desire for medical aid in dying, and it has to be witnessed by people who will not benefit from their death. In our state right now, we then have an additional 48-hour waiting period before I could even write the prescription. And then I need to contact the pharmacy directly to let them know that I'm sending a prescription and what it's for, and specifically who will take hold of that medication.
Thank you so much. I think Representative Carpino had brought about a point of training an individual physician to get to a point where they would feel comfortable. We don't want, not to pick on orthopedic surgeons, but any surgeon or any other doctor who's doing different types of practices to start to prescribe these medicines. So what kind of training do you think is needed? And then the second part is, should there be some kind of an oversight to see every few, whatever time frame, to see how things are going? Is there been a problem tracking things as well?
Okay, so the second part of the question first, I should have added that there is paperwork that has to be completed by the prescribing physician and the consulting physician, and also a follow-up form about how the patient died and what happened with the medicine. So Vermont has data that we collect to be able to track those things. And that's how we know how many Vermonters have used the law. In terms of training, I think, there is, physicians are trained broadly, and we are highly self-regulated only to participate in those things that we are comfortable doing. And I think it is up to physicians to seek additional training if they're interested in participating, knowing who your consultants are and what medications to use. That's a routine part of the care that we reach out to others when we have questions. It's also true that primary care physicians, whether you're family medicine or internal medicine, or an oncologist or a neurologist who practices with ALS, we are routinely trained to assess if patients are capable, to assess their suffering, to do everything we can to address it, to offer hospice when it's appropriate, and assure the patients have all of the tools available. So we don't want to undermine that physicians are well trained, and perhaps that's why in Vermont we've chosen to limit prescribing authority to physicians to be able to assess all of these things.
Thank you. And we have discussed about hospice and imperfections of hospice that need to be fixed before we go in this direction. Do you have any opinion or thoughts or experience that you can?
Working with people with serious illness is so humbling, and everybody is an individual. I just can't say that enough. We are always learning and wanting to do more. So it's an and situation. Dying looks different now than it did even when I first started practicing. People live longer with more advanced illness. That's good because they're living longer, but it can complicate the end of their life. And so we need lots of tools, and we should constantly be looking for ways to improve end-of-life care. I am, as I like to say, a hospice junkie. I work as a hospice physician. I believe it is a wonderful tool. I also think it's really important not to overpromise. And I encourage everybody to ask their own questions of patients and families who've been with hospice about how symptoms can be treated and how sometimes even with the best intentions, they cannot. I will defer you to Dr. Bellin's comments about how the ability of hospice to provide 24-hour care is driven by people that have uncontrolled physical symptoms, largely pain or dyspnea or others. If we look at the data in Oregon, and this is mirrored in my experience as well, the people who are interested in medical aid in dying, it isn't always about pain or shortness of breath. It's about losing your ability to participate in meaningful life activities. It's about what is the meaning of suffering and living in a very compromised position in those final days and weeks. And those are tougher symptoms of suffering to address. They're determined by the individual, and we have to be honest about what we can do and what we can't do. In Willem's case, for example, he had very good symptom management. He had a wonderful medical team, but it wasn't enough to keep him from suffering in his final days.
And my final question, I'm sorry, because you don't get a physician with your experience very frequently. If you were to go back in time to the time when the law was passed in Vermont, and then experiencing and then working within that framework, what would you have done differently? Or what would you do differently now?
Well, I think the issue of the balance between safeguards, which then become barriers or burdensome, is a very delicate balance. So for example, in Vermont, that additional 48-hour waiting period that I talked about, we've really seen there is really there's no purpose to that. And it has definitely created additional burden. So we are proposing an updated law to eliminate that extra 48-hour waiting period. I think the 15 days that has to happen between the first request and the second request is a long period of time. And I cannot emphasize this enough. People worry that someone might race out and hurry to hasten their death. That does not happen. People want to live and they wait very late. So I understand why some people feel that more than 2 week waiting period is necessary to think about it. But in the words of Willem Jewett, it's a little bit of a slap in the face to assume that patients have not given the end of their life a lot of thought. And I think it's an interesting question about the length of time that we make patients wait. And we should really think about the usefulness of that waiting period. The other safeguards, a second opinion, a written request. If you believe there's a question about capacity, then of course you refer. But I can tell you many times when I evaluate a patient, I know they don't have capacity and the process simply stops. And I look for other tools to address their suffering. So I think there are very adequate and good safeguards in that aspect of the law.
Thank you so much. Your testimony has been very helpful to me, and I'm sure many of my fellow legislators have learned a lot. So appreciate your time and appreciate your time for waiting.
Thank you for your compassionate presence.
Thank you. And next speaker is Stephanie Packer, followed by Joy Cipolo, if I said that correctly. Ms. Packer.
Thank you. My name is Stephanie Packer. I'm a Latina California mother of 4, and I'm testifying in opposition to SB 88. In 2012, I was diagnosed with a terminal form of scleroderma and given 3 years to live. As you can see, I've outlived that prognosis, and I am incredibly relieved that I'm alive to care for my 4 children. Shortly after California passed its law to legalize assisted suicide, my doctors prescribed an expensive new treatment. When I asked my insurance company about coverage of the treatment, my request was denied. I was also asking about coverage for a lethal dose of drugs under the new assisted suicide law, and was told that they would cover those drugs for a copay of a mere $1.20. I was stunned that much cheaper lethal drugs would be available to me rather than treatment that could save my life. Nothing can describe the air that's forced out of your whole being when someone tells you that your life is not worth saving, that my worth was $1.20. That was my price tag, and that was my value. Fortunately, I received that coverage at that time. My health journey hasn't been easy. I've been in and out of hospice for the last 5 years with predictions that I only had 6 months or less to live. Each time I qualified for lethal drugs, and I'm constantly living in fear that with my next prognosis, treatment will be denied in favor of cheaper lethal drugs. You can see that doctors have not been able to accurately predict how long I would live on numerous occasions. I was so sick last summer that I was on a ventilator and in the ICU. My children were told that their mother would not be coming home. Because of my health, I was unable to see them for 2 months. I've never experienced darker days, and I thought that I should just end everything by asking for a lethal prescription. I could have taken the drugs in the stage of the darkest despair without enough time to really reflect on what I was doing, and there would have been no going back. I'm grateful that I continued on as difficult as it was. And I'm so thankful that I'm alive and not missing all of these moments I have with my children now. My children need me, and as long as I can, I want to live, and I want to have every option to help me do so. Please don't place mothers and other people in Connecticut in the horrible position I find myself in. I ask Connecticut legislators to vote against SB 88. Thank you so much for your time and your attention to this unbelievably important issue.
Thank you, Ms. Becker, for your testimony, and thank you for waiting, and thank you for sharing some of your pain and difficulty. And I know it's even difficult to speak with your condition, and it takes a lot of courage. So I appreciate your testimony. I have some questions, but I'll start with the Representative Steinberg.
Thank you, Senator. I just want to focus for a moment on your statement about being offered an aid in dying cocktail for $1.20. Was that your insurance company saying that, or was that Medicare? I'm not clear.
That was my insurance company through the state.
My understanding is that they would not cover aid in dying. So that's inconsistent with, I think, what you've told others with regard to this. So it's very concerning to me about this particular statement, and I'd like to be able to verify that this is indeed factual. I hope you have some evidence that would support such a statement, because it does fly in the face of what we know both about insurance companies and with Medicare. It really simply does not add up. Thank you, Senator.
What was denied was a new form of chemotherapy that my doctors had prescribed for me.
Well, I'm sorry, I misunderstood. You're talking about the chemotherapy or the aid in dying drug? I'm not clear.
No, the chemotherapy was denied, and the aid in dying drugs were offered for a copay of $1.20, and I couldn't afford
By
it.
your insurance company?
Yes.
Okay, thank you, Mr. Chair.
And you have an autoimmune disease, from what I gathered, Ms. Packer. So it's
Yes.
not a neoplastic process, and with interstitial process and pulmonary hypertension.
Yes.
So
I have end-stage lung disease with pulmonary fibrosis is the
Yeah.
terminal part of my diagnosis.
Right, and my understanding is this current bill is not including such illnesses, so this law that we are looking at, it does not include illnesses like you have, and it's I think dealing with insurance companies, whether it's California or Connecticut, between the pharmacy benefit managers and their ways of identifying ways to deny people life-saving medicines, especially pulmonary arterial hypertension medicines and so on. It has been a very tricky process. And I think last year we passed a bill in our House and Senate, and it become a law, which does not make the PBMs control some of the medications, especially life-saving medicines that you need that you're not getting in California. So I'm so sorry that the industry is treating you in that manner. But I truly appreciate your testimony, and thank you for sharing your experience with us. With that, we will move on to I don't have any other questions, but thank you so much. And we'll move on to the next speaker, Joy Cipolo. Did I say it right?
Yes, that's
I
correct. Yes, it is.
Thank you.
Hi. Hi, my name is Joy Cipolo. I'm here today in support of the aid in dying bill. Kim Hoffman, who you heard her name many times today, was my wife. Many of you may know her and be familiar with her testimony and her advocacy in favor of this bill. Kim passed away just 5 weeks ago. The pain and suffering she endured still keeps me up at night. On November 3rd, 2021, Kim's worst fears came true when 2 separate oncologists confirmed that there was nothing more they could do for her. Her ovarian cancer spread throughout her body and even went to her brain. Each day, I would see Kim decline just a little bit more. She would wake up typically around 3 or 4 o'clock in the morning, breathing and crying in pain. She eventually lost motor skills. She couldn't even pick up the phone. When I think it couldn't get much worse, it did. The pain got so bad that an alarm had to be set every 3, 4, and 6 hours to make sure she was getting all of the medications to keep her somewhat comfortable. Even with 12-hour morphine, the pain would break through. There's been a lot of conversation today about hospice care, and I don't want to say anything negative about hospice. They were wonderful. I don't know what I would have done without them. They were at the house about 3 times a week, an hour to an hour and a half at a time. So it was up to me to administer and all of these medications 22 to 24 hours a day. They were available by phone, and I called hospice multiple times because I was questioned whether or not can I increase her pain medication. Kim is in pain, and they would guide me through that. Kim was an athlete. She was strong in every other way besides the cancer. Even the hospice nurses would tell me that she's young. She was only 59, and her vitals were strong, and she may linger longer than most. And she did. It was heartbreaking. This is not how Kim wanted to die. She fought so hard for this bill so she could go on her own terms and not put herself and family through this trauma. A few weeks before Kim died, I was holding her up with all of my
Excuse me,
might.
Ms. Capello, if you could please summarize, your time is over. Thank you.
I will, thank you. Kim whispered in my ear, "So I'm never going to take a shower again?" It broke my heart to tell her, "No, honey, I don't think so." She responded, whispering, "I wished we moved to Maine." Kim was so dedicated to this bill that she felt like she would be abandoning the people in Connecticut if we moved to Maine or New Jersey or Vermont that has this bill in place. Please don't abandon the people in Connecticut. Provide terminally ill people like Kim compassion, empathy, and choice. This is all about choice and how they spend their last days. Thank you.
Thank you so much, Joy, for your testimony, and thank you for sharing your pain with us, and thank you for sharing Kim with us in the last few years. And I'm sure you've noticed that Kim is very much part of the testimony today, and she continues to speak and touch our lives in so many ways, and it will continue to do so. So thank you for your testimony. I know Representative Dr. Foster has a question. So, Dr. Foster.
Thank you. It's not so much a question as a comment. I feel like you really did share your wife with us in the end of her life. And I am so incredibly grateful for you and for her contributions to this. I feel like her story was a pivotal example. And I feel like hearing from not just people who would choose aid in dying, but also their families has been really influential to me in the way that I hear and empathize compassionately with people as they talk throughout this process. So I don't want to ask a question that I find as upsetting to you, but you used a term that I feel like is important. You described that because she was young and this terminal diagnosis hit her at a point when she was so strong and vibrant that they told you she was going to linger ahead of time. And that's a really uncomfortable concept, but I feel like that juxtaposes how significantly different her choice was for folks versus when hospice really works and is wonderful and is everything that's needed. So can you describe a little bit about what made what she needed different than hospice? Because I think that's this comparison we're hearing over and over again. And again, thank you. And I'm so sorry.
Sure, I'll try. First off, it was the pain that would, I mean, she had tons of medication that was readily available. And I would administer the pain meds according to hospice guidance. You know, it was at this particular time or certain amount of hours that I can give her this medication. She would still break through. Another portion of this is spiritually for her, and also dignity for her. She was so weak from the pain meds and from the cancer that she crawled up the stairs several times so she could go up and take a shower. That alone was so exhausting for her that she'd have to rest for several hours before she could take a shower. I had to call the paramedics 3 times because she would fall and couldn't get into the hospital bed. Hospice was there, like I said, an hour and a half every couple of days. Sometimes Omicron was really rampant. Sometimes it was only twice a week. They can't be there for 24 hours a day. That's what we heard earlier in some of the testimony. It was awful to hear. Kim could barely whisper, but she knew what was going on. When she whispered to me, "You mean I can't take a shower?" You know, her cognitively was there when she was awake. She was sleeping a lot of time when I'd give her more meds. And I'd have to wake her up to make sure she got pain meds so she wouldn't wake up screaming in pain. Did I answer your question?
I think you didn't. I'm so grateful to you, but I'm also so sorry that you had to share your wife with us in this way at the end of her life. I just feel like, you know, I wish that every one of these issues that was hard, that people testified before us on the Public Health Committee and any other committee, that people didn't have to pause their lives to advocate on issues so important and share their loved ones with us when things are so tragic. But I'm grateful to you. Thank you.
Thank you. Can I share one more thing?
Yes.
Because of the brain mets, Kim did have a couple of seizures. It was terrifying. And it happened to be in the middle of the night, both times. There was no hospice nurse around. There was no time to call them. I had to react to give her some medication to help her calm down. The second time it occurred, it was far worse than the first time. I had to administer the Ativan twice. I called 911. They were there within 3 minutes. They were wonderful as well. But no one should have to go through that. I mean, absolutely terrifying. And Kim, the next day, she was at the hospital. She was admitted. When she finally woke up about 24 hours later, she whispered, "I had another seizure." She knew what was going on. She was aware of it. And it was horrible, horrifying. No one should have to go through that. Thank you.
Thank you so much. Thank you, Joy, for sharing that with us. And I think your last statement is what we are hopefully going to be able to achieve in respect of Kim. I'll ask our next speakers to come in. It's Jill Eikenberry and Michael Tucker, followed by Lee Hutchinson. Go ahead, Jill.
I'm sorry. There we are. Sorry.
Michael.
Hi, we're here to testify in favor of Senate Bill 88. We first became interested in the aid in dying question when our dear friend, Renee Aubergenois, wonderful actor, extraordinary actor and artist and photographer, was diagnosed with terminal lung cancer. And he lived in California. And he had 3 years, relatively good years, and then the cancer went to his brain. And he had a lot of time to think about how he wanted to have his death be. And he was very worried about the fact that he could at any moment have a seizure or something that would impair his mental facility. So he made a date. He had his wife, his 2 grown children around him, around the bedside. He had the hospice person there. And he was a photographer, as I said, and he had a slideshow that he had created of the 50 years of their life together. Hundreds and hundreds of photographs of their life together, accompanied by Beatles music and all of his favorite music. And they sat together and cried and laughed for hours and talked about how they felt, how each of them felt. And when it was time, he took his medication and said goodbye. And I spoke to his wife that night, and she was absolutely filled with the beauty of what had happened that day. That was overwhelming to her, the beauty of it. And so were his children. And what a remarkable thing it was for us to be able to experience their euphoria at how this had happened. So we were able to be inspired by that and to think about our own, the ends of our own lives. And I don't know how I'm going to die. I could die very suddenly and have no choice at all. But if I do have a debilitating terminal illness, I would like to have choices in the way that happens and the timing of that. And I would like to manifest those choices in my home in Connecticut with my family around me. So we are very supportive of this aid in dying bill. Thank you.
Thank you so much. You guys speak so softly and kindly. You're the kind of people I want to have coffee or tea with.
We love
that. Representative Berger-Geraldo.
Thank you so much. And thank you both for being here. I actually don't have a question for you. I'm breaking the rules and I want to comment, but the reason that I want to comment is because I remember so clearly your testimony last year, Michael, and to hear both of you say what is essentially the same thing a year apart. And it was a positive tale of how this affected Renee's family and how they were able to be with him, and for you to paint this picture, it just, as sad as all of it is, it doesn't feel nearly as tragic as so many of these other stories are. And so I just want to thank you both for continuing to do this, continuing to come forward and tell this story, but also kind of giving us the lift that we need at the end of the night. So thank you both very much.
We would like to thank you. Thank you.
well.
Thank you all for what you're doing.
Thank you. And I'll just make a quick little comment. Earlier somebody made a comment that if this bill passed, then there will be no closure for people. And I think they may have been inaccurate in that, because the closure is not necessarily related to that. The closure is related to so many other things. And sometimes staying awake allows an individual to have a closure with their loved one as well. So
absolutely.
Thank you so much for a testimony and waiting for us. We will be working hard on our end. Thank you.
Thank you so much.
Thank you.
Thank you.
And we'll move on to our next speaker, Lee Hutchinson, followed by Ted Lowenthal. Lee Hutchinson. I see Ted Lowenthal there. So, oh, there you are. Number 116, Lee Hutchinson. So go ahead, please.
Hi. Can I be heard now?
We cannot hear you that well, and we cannot see you either. And it's up to you if you want us to see you, but I just want you to be aware.
I'm sorry if you can hear me at all. I don't know what the issue is.
Well, we can hear you, so go ahead.
Okay, just please interrupt me if there's something wrong with the transmission. Thank you. Distinguished members, my name is Leanne Hutchinson. I'm from Andover, and I'm a lifelong Connecticut resident. I'm submitting this to urge you in the strongest possible terms to support this bill. Please let us remember that this is about individual choice. This involves as personal decision as can be made in someone's lifetime and not one that anyone would make lightly. Please be constantly reminded that the bill contains many safeguards, both regarding its implementation and also for any suffering individual who wishes to utilize it and his or her suffering. These safeguards include involving more than one physician, parameters and conditions for its use, counseling, more than one request for its use by an individual seeking to take advantage of it, and restrictions on who else can be involved, such as anyone involved in the person's estate, for example. I personally feel that even the 6-month requirement contained in this bill could be very harmful to the patient. Section 4, page 5 of the bill talks about a sample or suggested form for a written request for aid and request for medication to aid in dying, which an attending physician has determined that the person has an incurable and irreversible medical condition that will result in death within 6 months from the date of the document if the disease follows its normal course. Please keep in mind that this 6-month projection of illness could still take place after the start of the condition, and that the patient has now suffered for so long that they've had time to arrive at this stage in their medical aid and dying decision in the first place. As far as concerns by some individuals with disabilities, some individuals with disabilities might be at a disadvantage if caregivers or family members no longer wish to care for them and instead urge them to employ the use of this act. Please consider again how many advocates these individuals have and how isolated the chances of this happening are, given the language of the bill and the safeguards included here. If anyone is opposed to this because they are unwilling or squeamish about doing it themselves, please do not use your vote and your voice to deny it to others who don't have the same reservation. Please let them have that opportunity and do not impose your beliefs and your decision about what you would do onto them. I've been listening for most of the day, and I think it's crucial to note again that it's been mentioned several times that most of us would not treat an animal in our care this way. I feel that the bottom line is that if an individual is not comfortable with this concept, then they don't have to use it themselves or support a loved one using it. However, it is inhumane not to allow someone else who wishes to use this opportunity to have this chance. I feel that opposing this bill is imposing any doubts, fears, or religious beliefs you may have onto a suffering person when that could have been avoided. People do
Excuse
not
me,
want
Ms.
loved ones to
Hutchinson, your
suffer.
time is almost up. If you please summarize. Thank you.
Yes, thank you. However, some people are uncomfortable with their loved one taking advantage of this opportunity because of their own reservations. If you really love a person, why do you want them to suffer? Please remember that it is their fight, not yours, and their wishes should be honored. Please consider wishing them the best and supporting their decision instead of trying to withhold this opportunity and cause them untold suffering. Thank you, and I appreciate your time and consideration and support of this bill.
Thank you so much for your testimony, and I will, there's no questions, so we'll move on to the next person on our list, which is Ted Lowenthal, followed by Jean Rexford. So, Mr. Lowenthal. You're on.
Thank you. Good evening, committee members. I want to thank you. I've been watching all day. This is very hard work which you undertake, and I want to thank all those who have testified from all positions. My name is Ted Lowenthal. I live in West Hartford. I'm speaking in support of Senate Bill 88. I want to thank the committee members who voted the predecessor bill out of committee the last legislative session, and I hope you can persuade your fellow legislators to pass this bill and give the governor a chance to sign it. I will be brief. Senate Bill 88 seeks to empower mentally competent, terminally ill adults with individual autonomy at the end of their life. It seeks to empower them with the autonomy to limit their own suffering. It does not empower anyone other than the affected individual to have this control. It is important to stress that the legislation under consideration here is modeled on the legislation passed in Oregon in 1997, which is now almost 25 years ago, not 15, as one of the previous testifiers said. And there is data from these decades of experience, and it demonstrates a process that works well, where the checks and balances work. There is no data from Oregon or from other states that have adopted similar legislation that this process has led to abuse. This seems to be a point which many people who testify conveniently choose to omit. I hope that if this committee considers the claims you may hear about the consequences of passing this legislation, that you bear in mind that there is objective data against which to weigh any such claims. In this regard, I'm particularly sensitive to the concerns raised by people with disabilities. The experience of COVID-19 over the past 2 years demonstrates vividly how real the concerns of those with disabilities are, as they have had to fight against being arbitrarily excluded from medical care. But I would submit that these two situations are wholly different, and the one does not shed light on the other. The rationing of healthcare, which has arisen in the context of COVID, was an abrupt process devoid of thoughtful safeguards and frankly represented the opposite of empowerment. In contrast, Senate Bill 88 codifies a deliberative process initiated only by the affected individual. It takes place over a period of weeks and months, leading to that individual empowerment. Finally, drawing upon the data from Oregon, I would draw your attention to the fact that very few individuals meet the rigorous safeguards built into the law, and among those who do meet the criteria, fewer still seek out aid in dying medication. Among those who do qualify and are prescribed aid in dying medication, most do not actually ingest the medications.
Excuse me, Mr. Lowenthal, your time is almost up. If you could summarize, please.
I will. Thank you for your help. About 40% die natural deaths, but with the knowledge they had an option to control their suffering had it become unbearable. In the years since the Oregon law has passed, only about 0.5% of all deaths in Oregon utilized this option. I know of many people over the course of my medical career who could only wish for this kind of autonomy over their suffering. I know I would feel the same, and I suspect most people would feel the same. Thank you for your attention to this issue. I hope Connecticut will join the 10 other states and Washington, D.C., which have passed similar legislation. Thank you.
Thank you so much for your testimony. I truly appreciate you waiting for the time that you have to share your thoughts. We value your thoughts, and we see no questions, so we'll move on to our next speaker, which is Jean Rexford. And this is also the time we will be switching the chairs back to the real chair, Representative Steinberg, who started this, and he will bring this entire public hearing home this evening.
I'm Jean Rexford, and I live in Reading, and I want to thank this committee today for the thoughtful discussion that has happened. I think we've all been moved by various testimonies. I'm here tonight in strong support of the legislation. I believe this is my 9th year testifying. And I think what I would like to emphasize this year is how important it's been for me to be at loved ones' deaths, my mother, my father, my sister, my very best friend, to be able to see the peace that they experience when they die and the end of their suffering. I want that for myself. I want to die the way I have lived, with my children and my grandchildren, should they choose to be present. There's a kindness to this legislation that really, it's a kind thing to allow people the closeness and the intimacy of that kind of death. I've just been struck by the quality of the experiences. And my sister, who had advanced Parkinson, was going to go to Switzerland or Oregon to end her life. She was a well-known international physician. However, she fell, and then she ended up in the system. She had an operation, and then she had to go to a nursing home. It was painful to touch her skin. She said, "Jean, I don't know how to die. Please help me." And I couldn't do it. So she wanted to be able to die, and she couldn't do it. So anyway, please support this bill. Thank you so much, all of you, for your vote last year. That was exciting, but I think this is the year that we can make it happen. And thank you for your time and the thought that you've all put into today's hearings. It's been really very impressive. And I don't want to come back for the 10th year.
Duly noted. Good to see you, Jean. Senator Moore has a question.
More of a comment to Jean. I've known you in all those years that you stood before the committee, even when I was in non-public health, and the early days of talking about this. I appreciate your commitment to the subject and staying the course. And there's been several people on here that I personally know, and listening to the story and the anguish that they've been through for their loved ones, that they have the stamina and the desire to keep fighting, even though their loved ones has passed on, is commendable. And I thank you. Thank you, Mr. Chair.
Thank you, Senator. We'll see what happens, Jean.
Thank you.
It's always good to see you, even under circumstances where you prefer not. But thank you again for being so patient and for providing your testimony tonight. Next up, we have Pamela Weil, followed by Taylor Benitez. We can hear you barely, Pamela. If you could up your volume a little bit, that'd be helpful. Pamela, are you working on your volume, or are you ready to speak?
I'm ready to speak.
Please proceed.
Thank you. I'm really thrilled to be here today. I'm a newbie to the whole medical aid and dying issue, although I've always supported it in theory. But I've been watching these proceedings since noon today, and I learned a lot. And I'm so glad I did. My question, my concern is I'm 77 now. I live in Hamden. And what happens if I become terminally ill? Based on the testimony today, it seems that hospice is my only option. And it's a fine option. And I have many friends who have enjoyed, not enjoyed, but been served by hospice. But it's clear after the testimony today that there are many gaps in the care that hospice is able to provide. And I would like to have some say, and pain is, it was said many times today, pain is subjective. And one person's pain is not another's pain. And I would like to have a choice at the end of my life to determine what is best for me. pain-wise, physically, emotionally, and spiritually. Around 2 p.m. today, a speaker, and I don't remember his name, suggested that we as a state ought to do two things. The first one was take another look at hospice and see how it could be improved and its services expanded, perhaps. His second suggestion was to pass Bill 88. And I agree with, I think those are both excellent suggestions, and that's the way what we ought to do. The one is not in opposition to the other. They both work hand in hand. And I'm also a quilter. And when you're a quilter, there's a saying that finished is better than perfect. So I look at this Bill 88 and it looks pretty good to me. There's been a lot of criticism of it, but there's not ever going to be a bill that everyone is going to agree upon. And a point was made earlier that the Oregon bill has undergone 19 revisions since it was passed. So why don't we go ahead and just pass this bill? It looks good. And then down the road, we can make adjustments. Thank you for listening and staying up so late, and wish all of you a wonderful life. Thank you.
Thank you, Pamela, for those sentiments. I think you've just described what the legislature does. We pass a bill and then we make changes.
You tweak it.
Yeah, we do that all the time. We feel it's really important in this case that we get it as much right as possible.
Exactly.
Straight out of the gate, given what's at stake. So I appreciate that the perfect can be the enemy of the good, but we need to come pretty close to perfect.
I think you can do that.
Thank you for that. Any other questions or comments? I don't see any. Thank you for your patience and sticking with us. We are approaching the end. Taylor Bionars, you think I'd be able to pronounce that better? There was another person by that name earlier, but I
My
didn't get it
father.
right.
Thank you. It's Biniars. Co-chairs Senator Abrams, Representative Steinberg, vice chairs, and the other members of the Public Health Committee. My name is Taylor Biniars. I am in Allington, Connecticut, and I'm testifying in favor of SB 88. My dad's brother was a major part of my childhood, as both of my parents worked full-time jobs with my mother traveling a decent bit. And when there were issues with our daycare, my parents offered him an opportunity. If he moved here and watched us, they would pay for his night courses at a community college. Once, when asked who raised us more, when both kids said mom or dad, I said Cliff. He was dubbed the Manny and was the only person who could get me to understand multiplication. The Manny I knew growing up and the man who died a slow and painful death last year are two different people in my mindset. He years ago was diagnosed with chondrosarcoma, a rare type of bone cancer which develops in cartilage cells. He went through a very risky surgery and then afterward had no one to help him, nowhere to go, so he moved in with my dad. My dad was the sole caretaker of his brother, helping him in every day in ways you cannot even imagine, which you heard about this morning. The spread and growth of his tumors was slowed and stopped for a few years due to an experimental treatment, which at some point stopped being effective. At this point, while they could maybe see if they could find another experimental treatment, it seemed better to just have palliative care. It didn't work. Even with lots of palliative care, he was in a lot of pain and discomfort, often nauseous and vomiting. He couldn't taste food, and between the pain and pandemic these past few years, he only left for doctor's appointments and his COVID vaccines. These rare trips were exhausting and painful. At some point, he had a wound in his leg, which started to swell to a large and uncomfortable degree. He got a phone call and they told him he had edema and an infection in his leg and that he would need to go to the hospital. An ambulance came and brought him in. He could not even go down the stairs in the way that he had been for the past few years, scooting on his rear. They had to bring in a chairlift for him to get down. After a stay, he was transferred to a rehab home where my dad visited once a day. After months of this, he was visiting several times a day, and before he died, he spent 3 days nonstop there sleeping in a chair. After a couple days after that, he died alone. I tell you this story so you can understand that for years he was terminally ill and in severe pain. He watched last year's testimony hearing, he supported this bill and has said several times in the past that if this were an option to him, he would have taken it. This bill would have saved years of excruciating pain and suffering from a person who truly did not want to go through that, who would have otherwise made his own choice about his own life. And who is anyone to tell him otherwise? This is not controversial. This is humane. I read opposing testimony and watched some this year and was struck by statements to call this what it is, suicide. He could have made that personal choice by himself over 5 years in countless different ways, and he never did. He did wish to have.
Excuse me, Ms. Bainenars, but if you would please summarize, your time is
Yes,
almost up.
I have
Thank
one
you.
sentence left. Thank you so much. He did wish to have this choice that would have been made consensually with his doctors. To call this suicide is political manipulation to attach the stigma of it to this bill. Thank you for your time.
Thank you for your time and for your patience. We appreciate hearing your personal story. We received really a lot of input today about how this has played out for all sorts of different people. So thank you very much. Senator Anwar has a question for you.
Not a question, but just wanted to say hello to you and good to see you and your dad today.
Thank
Stay
you.
well.
Nice to see you
Thank
as well.
All right. Thank you again. Next up is Justin Paulin, followed by Dr. Andre Sofer. Justin, we can see you. If you could unmute. There you go.
Hi, Justin Paulin on. And I've heard a lot of good testimony today. It's been very educational. I wasn't aware how vast this topic is, so thanks to everybody that contributed, and wish everybody well, and I'll keep praying for this good outcome to happen. I do, however, stand in opposition to this bill because of the slippery slope, which, despite the wishes of some, does not go away. It is a valid concept. To define a slippery slope means an argument which contains no internal logical constraints on sliding from one step to another step, hence the metaphor slippery slope. To illustrate that, I found a quote from Dr. Viktor Frankl, who was a concentration camp survivor, and I'll read it in its entirety here if I could. But today's society, that is in 1946 when he was writing his book, Man's Search for Meaning, is characterized by achievement orientation, and consequently it adores people who are successful and happy. It virtually ignores the value of all those who are otherwise, and in so doing blurs the decisive difference between being valuable in a sense of dignity and being valuable in a sense of usefulness. If one is not cognizant of this difference and holds that an individual's value stems only from his present usefulness, then, believe me, one owes it to personal inconsistency not to plead for euthanasia along the lines of a previously cited program. That is to say, mercy killing of all those who have lost their social usefulness, be it because of old age, incurable illness, mental deterioration, or whatever handicap they may suffer. I pray that this committee and this assembly will not go forward with this bill, but to protect the human life from slippery slope of exposure to future legislative or executive acts. That completes my testimony.
Thank you for your testimony, and thank you for being so patient to last over 11 hours. We really appreciate it. Seeing no questions or comments, again, thank you and have a good evening. Next up, I believe is our last speaker, Dr. Andre Sofer or Sofer, I'm not sure which it is. Thank you for being here.
Thank you. And thank you for allowing me to submit and read my testimony. The written testimony is referenced if anybody wants to look at that. I am a general internist. I'm a professor of medicine at the Yale School of Medicine. Over my 36-year career as a teacher and also as physician, I've taken care of tens of thousands of patients all over the world. Although physician-assisted death is now legal in 11 jurisdictions and under consideration in many more, as already articulated, the idea concerns me. And I just want to go through my 5 concerns. 1, our ability as physicians to determine the timing of death in the setting of illness is imperfect. It's not a perfect science. Many of us who've cared for patients diagnosed with terminal illnesses by multiple subspecialists have left inpatient hospice units to live many fulfilling years with their family. This point, I think, was articulated by Mrs. Packer, who spoke before me. And contrary, I think, to what was said, when I look at section 1.21, her illness, which is not a cancer or a neurological disease, but scleroderma with pulmonary fibrosis, would be covered under the bill. Secondly, safeguards I do not believe work. If we look at the long-standing Dutch example, which allows, of course, both physician-assisted suicide and euthanasia, 60% of cases were not reported truthfully to public health authorities, and 50% did not require consultations. And as alluded to earlier, there was a paper last year, Euthanasia and Physician-Assisted Suicide in Multiple Geriatric Syndromes. People with non-life-threatening conditions, including visual impairment, hearing loss, chronic fatigue, incontinence, or falls, were enabled to use the legislation to end their lives. Third, medical care has improved dramatically. We have better expert diagnosis, palliative, psychiatric, and hospice care, both at hospital and at home. And I personally, although others have testified otherwise, I personally do not see people who die in intractable pain or without dignity when given the appropriate medical care and supportive care. In my entire career, the only person that I saw that ever asked me to end his life was a gentleman in his 60s with lung cancer. And when we sat and we talked about it, his request went away. My brother-in-law had ALS, as has been discussed by many prior people. And he, I think, lived a very important part of his life when he was ill, allowing him to mend fences with his families and never went ask for aid in dying. Fourth, the qualification of a responsible attending physicians are not clearly specified in the bill. This is concerning, as physicians with limited experience in the practice of medicine would potentially be able to give medications to end a person's life. And this was asked as a question by Representative Cardino. And then fifth, I just wanted to articulate on the point raised by
Excuse
Dr.
me,
Pettis.
Dr. Sofar, but your time is almost up. If you could please summarize.
I'm just about done.
Thank you.
What of the patient who cannot self-administer the medication? Are we obligated to consider euthanasia to, quote, protect such an individual? So in closure, my opinion is that legalizing physician-assisted suicide or death is simply the wrong step in a perilous direction and will make patients suspicious of our intentions at the exact time that they need us most. Thank you very much for your time.
Thank you, Doctor, for your testimony and for hanging in the entire time. I don't see any questions, so again, thank you for your testimony. Before we conclude for this evening, we're now over 11 hours. I want to afford anybody a chance who has not had a chance to speak because we think we've got it covered, but it's possible we missed someone. I understand there's somebody on the phone who is not actually on Zoom who might want to speak. If you're there, the number is 860-798-3815. I'm not sure. Anyway, it sounds like we have concluded a long day of hearing some very passionate, focused testimony. I'm sure we have much to think about. Tomorrow we meet again at 2 o'clock. We have a committee meeting to raise bills. Yes, you heard it right. Raise more bills. It will be our last opportunity to do so. And we'll see you all there at 2 o'clock. If it's within my power, I grant you all the rest of the evening off. Thank you for your diligence and your perseverance today. And thank you to everyone who took the time to testify before the committee. We take everybody's testimony very seriously. And let me add that all the written testimony submitted will also be reviewed quite rigorously. So I want to thank my co-chair and our vice chairs for helping out today and for everybody for the good work they put in. See you all tomorrow. Have a good night.
Good night, all.
Good night, guys.
Good night,
Bye,
Ms. Henry.
Doc.
Thank you. Thank you for all your
Bye.
hard work.
Good night.